I request everybody to be seated. A very good morning to all. Welcome back to the day 2 of our conference, a day dedicated to the most delicate and divine of challenges, high-risk pregnancies, where two hearts, one mission, and countless decisions that matters in safeguarding two lives. A medical conference is where science meets experience, where questions find answers, where commitment to healing is renewed. It's a celebration of learning, growth, and the collective mission to advanced healthcare. We have a packed and insightful day ahead with a rich lineup of topics and speakers. We are on a tight schedule, so let's keep the energy high and clocks in mind. Time is precious and so is every topic today. Each speaker is given 15 minutes. Let's keep an eye on the clock and ensure everyone gets their moment to shine. May I request our esteemed speakers and chairpersons to please proceed to the gratitude desk for the felicitation after finishing the session. As we are slightly constrained on time, your cooperation will be deeply appreciated. We'll start with our first session.
We start with our first session, Early Implantation Failure by Dr. Madhura Banale. Before a heartbeat is heard, before an ultrasound reveals a sac, there is an implantation. When this delicate process fails, the dream of motherhood takes a pause. Today we explore the science behind this silent struggle. To shed light on this delicate and crucial aspect of reproduction, we have with us an expert, Dr. Madhura Banale. I now request Dr. Mangala Harwal, Dr. Jyoti Pavle and Dr. Sharanamma Patil to chair the session. I request Dr. Prerna to introduce our speaker and chairpersons.
Good morning, everyone. I welcome Dr. Madhura Banale ma'am, who has worked as assistant professor in GIMS and ESIC for 3 years. She is consultant at Banale Hospital and medical director at Vansh Test Tube Baby and Laparoscopic Center, Kalburgi. She is an active member of ISAR. She was past executive body member of Gulbarga Obstetric Gynecological Society and present GOG's treasurer. Her active area of interest are infertility, gynec endoscopy and reproductive immunology. I welcome Dr. Mangala Harwal ma'am. She is a senior most practicing gynecologist and obstetrician in Gulbarga since 45 years at Revappa Harwal Memorial Hospital, and she was a consultant in MRMC for many years. She was awarded Nari Shakti Samman Award by SRJ Group of Institutions. Dr. Jyoti Pavale ma'am, consultant at MRMC Kalburgi. She has actively conducted various health camps and laparoscopic and tubectomy camps under family and health welfare programs. Dr. Sharanamma Patil ma'am, madam is consultant obstetric and gynecologist at Nagesh Memorial and Maternity Hospital, an eminent FOXY member and executive committee member of GOGS for many tenures. I welcome you all, ma'am.
Very good morning to all my lovely people here. I bring in the greetings from the place of Lord Shanbasveshwara in this auspicious month of the Shravana. Let's begin with my topic, and I'm very happy to be the opening batswoman for today's sessions. My topic is overview of early implantation failure. Implantation failure is a very emotionally challenging condition, and many recent advances and so many debates are happening in this field of the reproductive medicines. Starting from the basics, implantation. Implantation occurs in the second week of the embryonic development. Now that there is a blastocyst is formed, it goes through the process of apposition, attachment and invasion. During the apposition, the blastocyst is coming near the endometrial stroma where the implantation is going to happen. During the attachment, it gets duode of the zona pellucida lever. That is, we call it as the hatching is occurred, and it gets itself attached to the implantation site. During the invasion, the blastocyst gets embedded inside the maternal stroma, and there are the syncytiotrophoblasts which are coming in the maternal circulation, where there are the presence of the blood vessels, natural killer cells and the macrophages. So to have a successful implantation, what do we need? We need to have a very good quality of an embryo, a good receptive endometrium and a good crosstalk between the embryo and the maternal environment. Lack of implantation after the transfer of the embryos in an IVF cycle is called as an early implantation failure. It can occur very early, even the beta HCG is negative after the transfer, or later stage where the beta HCG initially positive, but later when we do a scan, we are not able to find an intrauterine gestational sac. We call it as an anembryonic or a biochemical pregnancy. it is known that 70% of the conceptions, they are lost before they reach the live birth rate, of which 30% are because of the implantation failure. So what are some of the risk factors? We'll see one by one. Advanced maternal age. We know that as the maternal age is increased, there is a reduction in the ovarian reserve. I'm talking about the quantity of the oocytes. As in the antral follicular count is less, AMH is low. Even the quality of the oocytes, there is a mitochondrial dysfunction, shortening of the telomerase. All these changes in the oocytes leads to the formation of an aneuploidic embryo. Obesity, it's the most correctable risk factor, I can say. Both in the males and female, obesity has got an adverse reproductive outcome. In the female, there is an implantation failure, early clinical pregnancy and the live birth rates were reduced. In the men, there was an increased DNA fragmentation. Smoking, both as an active as well as a passive smoker, had a noxious effect. It was studied that in the lady who underwent an IVF cycle, there was a very low estradiol count in them. Because of the low E2 level, there were fewer oocytes that were retrieved. Because of the low E2, even the endometrium did not form better. Even in the male, there was an increased DNA fragmentation rate. Alcohol consumption, both in the male and female. In the female, it disrupts the hormonal imbalance. Both the oocyte quality and the semen quality was affected. Stress, this goes without saying. A lady who undergoes the fertility treatment, she has a tremendous amount of the stress. So here the play of a lifestyle changes, yoga, meditation, psychosocial counseling, we have to keep doing before IVF, during or after that. It was studied that in the lady where there was a higher cortisol level because of the stress, it had a negative IVF outcome. And when there was a low cortisol, there was a significantly pregnancy rate was higher. It also alters the hypothalamo-pituitary ovarian axis, leading to the reproductive dysfunction. Male factor, what would you like to see here in the semen analysis? More so, we want to look at the morphology and the DNA fragmentation. Karyotyping is advised, especially when there is a severe oligoasthenoteratozospermia or there is a primary testicular failure. In cases of an azospermia, we would ask for a karyotyping. In the karyotyping, there is an inversion and translocation is most commonly seen. Paternal age is also an important factor. Etiology will go one by one. When it comes to the anatomical abnormalities, fibroids, anything which distorts the cavity, that goes without saying, we have to remove it. Submucosal fibroid, straight away do the hysteroscopic myomectomy. But when there is a subserosal or intramural, depending on their size and their location, whether it is indenting the cavity, it is disturbing the cavity or not, we need to take call. Polyps, yes, we have to do an hysteroscopic polypectomy before we go for an IVF and ET. Intrauterine adhesions or Asherman syndrome, this is very tricky. No matter what we do, endometrium remains very thin. So hysteroscopic adhesolysis needs to be done. Hydrosalpinx can be seen both in HSG as well as in the scan. But when picked in the scan, it is an quite evident hydrosalpinx. Why are we so much worried about the hydrosalpinx? Is the fluid in the hydrosalpinx can be toxic to the growing embryo. So we need to do a salpingectomy. Not just clipping of the tube would help, rather than go and do the salpingectomy. Other anatomical abnormalities like Mullerian abnormalities, adenomyosis and endometriosis, they will affect the pelvic anatomy, leading to the implantation failure. How do we diagnose? By the simple 2D transvaginal scan. If we want to have a better picture, 3D ultrasonography, diagnostic hysteroleproscopy. Hysteroscopy acts as both diagnostic as well as the treatment tool. These are some of the hormonal evaluation we do as a routine before we start an IVF cycle. Chronic endometritis, very common in a developing country like India, which leads to the alteration in the immunology of implantation. What happens here is the normally endometrial microbiota has got dominance of an lactobacillus, and when that has been abnormally shifted with other microbiota like Gardnerella, Streptococcus, Staphylococcus, leads to the endometrial dysbiosis, which is going to cause an altered immune response. There is an impaired endometrial receptivity, also has got an embryotoxic effect. How do we treat the chronic endometritis? With our simple antibiotics, which we routinely give to both the couple at the starting of our workup: doxycycline, metronidazole, and clindamycin. Along with the antibiotic, it's very important to give the probiotic, which is going to improve the vaginal flora. So how the antibiotic was given, and there was an improvement in the live birth rate, clinical pregnancy rate, and an implantation rate. Endometrial thickness. This is one thing we will assess, reassess before we go ahead to an embryo transfer. We all are striving very hard to form a good triple line endometrium and a vascular endometrium, because that is what is going to decide about the endometrial receptivity. Anything less than 7 mm or even more than 14 mm doesn't give a good pregnancy rate. So we have to be careful in preparing the endometrium. We call them again and again. We don't want to take any chance here. So how do we prepare the endometrium? It can be by the natural cycle, modified natural cycle, or an HRT cycle. To improve the receptivity, we prefer to do a frozen embryo transfer. Platelet-rich plasma is injected both intrauterine infusion, or when we do a hysteroscopy, we prepare a good PRP and do an subendometrial injection of the PRP, which causes the cell proliferation. There is an increased vascularity, and also the immunity is better when we do an PRP injection. GCSF, granulocyte colony stimulating factor, can be injected both as subcutaneously and also intrauterine. GCSF has also been tried, which helps us to have a better receptivity. Endometrial scratch or intentional endometrial injury. This is a good old theory which has been followed. So much good old that even patients will tell us when they have an infertility for a very long time, do something with my endometrium or do an DNC so that I might conceive. So that good old saying goes with the endometrial scratch. Coming to the immunological cause. We are talking a lot about the reproductive immunology these days, right? So as I told you, during the invasion phase of the implantation, now that this blastocyst is entered the maternal stroma, okay, this has got an HLA antigen which is of the paternal origin. From the father, this embryo has got this HLA-G gene, which is presenting itself to the maternal uterine natural killer cells. They have something called as an KIR receptors. So when there is a maternal fetal immune tolerance, it leads to the release of an anti-inflammatory cytokines. There is a low cytotoxicity. There is a better spiral artery remodeling, leading to the successful implantation. I think nature is also trying very hard. From the beginning, they want mother to be tolerant to the fetus. So when she is tolerant, there is a successful implantation. When she is not tolerant, that leads to the implantation failure. As in here, the HLA gene from the fetus, from the embryo, is not tolerated by these uterine natural killer cells. So there is an increased high cytotoxicity. There are a lot of uterine natural killer cells. These are the uterine natural killer cells. And then there is no proper spiral artery remodeling and leads to the implantation failure. So this is the pathophysiology of the immunology, how the immunological causes can lead to the implantation failure. What are the natural killer cells? They are the type of the lymphocytes. Unlike the T lymphocytes and the B lymphocytes, they are the type of the lymphocytes. There are two types of the natural killer cells. One is the peripheral natural killer cells, or they are also called as the CD56 dim, or uterine natural killer cells. They are also called as CD56 bright. So the peripheral natural killer cells are having a high cytotoxic effect. It can be tested by simple our peripheral blood immunohistochemistry testing, whereas the uterine natural killer cells are less cytotoxic. We have to do an endometrial biopsy during the luteal phase, that is day 18 to day 22 is preferred to do an endometrial biopsy and look for the activity of the uterine natural killer cells. This was one meta-analysis done and shows that natural killer cell activity was very high in the people who had an recurrent miscarriage. Coming to the T helper 1 and T helper 2. We know that the T helper 1 is highly cytotoxic, right? It's a pro-inflammatory, I can say, whereas the TH2, it's an anti-inflammatory. When there is a ratio of the TH1 and TH2 is increased, leads to the implantation failure. We want the other way around. We want higher TH2 ratio in the early pregnancy. But in the second trimester, there is an other thing happens. There is a dominance of the TH2 over the TH1. Even the tumor necrosis factor alpha concentration higher led to the implantation failure. These are some of the immunomodulatory therapies that are coming in play these days. Lymphocyte immunization therapy, even this is not very new. Senior Banale madam, she used to share her experience with me. She told me when there was an recurrent pregnancy loss in one of her patients, how she tried giving her relatives blood and then led to the formation of antibodies that itself acted like an LIT. But now there are more specific studies come how the LIT is prepared is the lady who doesn't like her husband, she likes getting an LIT done because it's like husband's blood chusna. Around 80 to 90 ml of the blood of the husband is taken and the proper lymphocytes are prepared. Those lymphocytes are injected into the mother. That acts as forming an antibodies in her body before we transfer the embryo, which is the semi-allogenic graft. So mother is well prepared with those antibodies. So LIT, but only thing is it's very expensive and still into the research mode. Steroids, yes, well used, and there are a good data as a good anti-inflammatory and immunosuppressive therapy. Intralipids, these are like in para-enteral nutrition. We use a lot of intralipids in our practice. What it does is it reduces the elevated natural killer cell activity. IVIG, again into the study and little expensive. HCQ, yes, we can use. It helps in the remission of the autoimmune disorders. Thymosin alpha, it is doing a lot in the market. But what is not very clear about the thymosin alpha is the dosage, how we are supposed to give. Some gives as an alternate day, day 1, day 3, day 5, day 7. Some give as weekly thrice and they even continue during the pregnancy. Up to 9 weeks, there are the studies of continuing the thymosin alpha, which is basically modulates the immunity. Presence of an autoantibodies in the form of APLA, anti-TPO antibodies, anti-nuclear antibodies, SLA and rheumatoid arthritis. There was a higher presence of autoantibodies in the patient with implantation failure. Antiphospholipid antibodies is normally evaluated by all of us when there is a recurrent pregnancy loss and a recurrent miscarriage. The prevalence was around 9% and also the implantation rate was only 14% in people with APLA. Coming to the thrombophilias. Thrombophilias can be of two types, inherited thrombophilias and acquired thrombophilias. What does thrombophilia do? It's an hypercoagulable state. The microvasculature of the decidual vessels are not functioning properly. There is a clotting in them, so leading to the implantation failure. This was one study which showed that the inherited thrombophilias were also a cause in case of the repeated implantation failure. It's very clear to give the antithrombotic therapy, our good old favorite ecosprin, which we start from the beginning, and the low molecular weight heparin. Ecosprin is started before the pregnancy and low molecular weight heparin started once we do an ET and continue throughout the pregnancy. So they have shown improvement in the live birth rate, few slides more. Live birth rate and reduction in the miscarriage rate. To have an optimal implantation, we have to have an optimal IVF treatment from the beginning. What is an ovulation induction? There are long-acting agonist as well as antagonist protocol. We have to choose according to the case, whether she's a high responder, normal responder or an hyper responder. Or there is an associated endometriosis, we prefer using long-acting GnRH agonist protocol, which improves the live birth rate and the clinical pregnancy rate. When the antagonist protocol is preferred, we want to avoid the risk of OHSs. Frozen or a fresh embryo transfer, these days we have moved to do a frozen embryo transfer. We don't want to take any chance in preparing the endometrium. We take a lot of time, even though the patient lose their patience. Till how long you want to prepare, but till we are satisfied, we prepare an endometrium. We don't want any supraphysiological hormonal levels which occur into the fresh transfer. We want a better synchronous endometrium, so we want to do a frozen embryo transfer. Cleavage or a blastocyst, it's a standard protocol to take our embryos to the blastocyst stage. You have done a cleavage transfer and there is a pregnancy, okay, done. But there was an implantation failure with the cleavage cell or the day 3 transfer. Next time, we have to do a blastocyst transfer. ASRM has suggested some recommendation about the endometrial transfer protocol. We will do it under the ultrasound guided. We remove the cervical mucus. We want to place these embryos at the MIP, that's the maximum implantation point, which is 1 to 1 centimeter below the fundus. Luteal phase support, we don't want to take any chance. We support it well with all the luteal phase support. I'll not go in detail of it. Progesterone, we are giving a lot of progesterone. What does this do? It prepares the endometrium both morphologically and functionally for the implantation. It also has got an immunomodulatory effect. Endometrial receptivity era, when we want to do a personalized ET, we want to know the window of implantation. Window of implantation is very short. If the embryo goes and sit at that point, we are going to have a proper implantation. We prepare the endometrium as preparing for an FET cycle, and we take an endometrial biopsy day 7 after giving an HCG or day 7 after the LH search, and want to know when exactly is this endometrium receptive. This was one study which showed that the implantation success is largely dependent on having a genetically normal embryo, that is an euploid embryo. So because of that, there comes a role of PGD, which tells whether the embryo is an euploid, mosaic or aneuploid embryo. Done. Last slide. These are some of the indication to have an PGT. Artificial intelligence, this is coming in all the fields. So why should we be behind? Even in the field of IVF, there is a role of artificial intelligence which tells us select the good gamete, treatment protocol and the embryo selection. It's a multifactorial. We have to properly do an investigation, individualize the treatment. The focus needs to be in preparing the good quality embryo, receptive endometrium, and restoring the anatomy is a key. Immunomodulators needs to be taken a back seat only when there is a repeated implantation failure. Thank you. Thank you, Uma ma'am, for giving me this opportunity. This is a very vast topic. I hope I've taken from, I tried to do from basics to advanced. I would like to tell that once Test Tube Baby Laparoscopy Center, we are conducting an IUI workshop. Interested people can enroll for the same. Thank you so much. I'm here to take up any questions if anybody has. Thank you.
It was a very informative talk, Madhura. You spoke very well. So many of our questions and queries were solved here only. So I don't think there are any more questions. Thank you very much.
Thank
Very
you, ma'am.
nice.
Thank
Very
you.
informative talk.
Hello.
Madhura spoke very well on early embryo failure. We never knew so many causes are there for the early embryo failure. All our doubts were cleared. I think we can ask many questions on this. Thank you.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you for shedding light on the silent barrier to conception, reminding us that sometimes the earliest steps determine the longest journeys. I now request the speaker and chairpersons to proceed to the gratitude desk for felicitation. I now call upon Dr. Uma Madam and Dr. Rajlakshmi Chanda ma'am to felicitate the speaker and chairpersons.
Our next session is on peripartum cardiomyopathy by Dr. Nitin Gudge. We now shift our focus to rare but life-threatening condition, peripartum cardiomyopathy. She may appear as just another breathless woman in late pregnancy, but behind that breathlessness could lie a failing heart. Peripartum cardiomyopathy is one such masquerader that requires the high suspicion, quick diagnosis and multidisciplinary care. To throw light on this clinical presentation, diagnostic challenges and evidence-based management of peripartum cardiomyopathy, we are honored to have with us Dr. Nitin Gudge. We request Dr. Shakuntala Banale ma'am, Dr. Indira Virbadrappa ma'am and Dr. Jyoti Erolkar ma'am to chair the session. I call upon Dr. Kavita Patil to introduce our speakers and chairpersons.
Our speaker, Dr. Nitin Gudge. He is Chief Interventional Cardiologist at Gudge Hospital, Bidar. Sir was University Gold Medalist in Medicine in BLD, Bijapur. Sir has worked as Assistant Professor in Jayadeva Hospital, Bangalore and Mysore. Sir is interested in pregnancy and cardiovascular diseases and complex cardiac coronary interventions. Our first chairperson, Dr. Indira Veerbhadra ma'am. Ma'am is senior consultant at Ashirwad Maternity Hospital, Kalburgi. Ma'am has worked in MRMC for 32 years and retired as a HOD guide to many postgraduates. Ma'am has got Sri Ratna Award 2022 by Sharanabaswa University. Our second speaker, Dr. Shakuntala Banale ma'am. Ma'am is the senior most consultant from Kalburgi. Ma'am was HOD in MRMC KBM GIMS Hospital for more than 20 years. Ma'am was speaker in many national and international conferences. Ma'am was PG guide for many years. Our third speaker, Wing Commander Dr. Jyoti Erolkar Kheni ma'am. She is consultant obstetrician and gynecologist in Military Hospital, Sikandarabad.
Very warm good morning to everyone. I am the odd man out for the more of peripartum cardiomyopathy. So we'll start. So as we know, first cardiomyopathy, the word refers to the weakness of the cardiac muscle. So peripartum cardiomyopathy refers to heart failure, and the etiology is not clearly understood till now, occurring either during the last month of gestation or immediately following the delivery. Basically, it's a diagnosis of exclusion, and of course, it's potentially a life-threatening condition. So in order to label a patient as a peripartum cardiomyopathy, we need to have 4 basic criteria to fill out. First is the time, either during the last month of gestation or first 5 months of the postpartum, and 2D echocardiographic evidence of LV dysfunction, ejection fraction less than 45%, irrespective of the LV dimensions, and absence of pre-existing heart disease, no identifiable cause of cardiomyopathy. So I'd like just tell you how the cardiomyopathy heart looks like. So as you can see on the screen how the heart pumps. So if we take a 2D, this is a 2-dimension 4-chamber view where we can see how the heart is contracting. This is the normal contraction of the heart. So what happens in peripartum cardiomyopathy is, as you can see, the heart is contracting but not force enough to pump the blood. So basically the ejection fraction is decreased. This is what happens in peripartum cardiomyopathy. Coming to the scenario in India, it has got an incidence of 1 per 1,340 live births, and in India the mean age presentation is 27 years. 60% occur in the postpartum period. It has got a high maternal and fetal mortality of 11% and 14% respectively. It has got a variable outcomes, right from complete recovery to heart failure, arrhythmias, complications, thromboembolic events, and death. Even the fetal has got a variable outcomes, distress, abortion, and death. There are certain challenges in the Indian because of the delayed presentation, inadequate follow-up, low awareness among practitioners, financial constraint, and lack of national registry. Coming to the etiology and pathophysiology, basically it's a multifactorial. Multiple pathophysiology have been proposed, like genetic, hormonal, vascular, nutritional, autoimmune, and environmental. So the most accepted is the 2-hit hypothesis, where the first hit is because of genetical or environmental predisposed individual is exposed to the second hit, that is the pregnancy itself. Once the pregnancy is because of the first hit, because of the pregnancy, there will be vascular and hormonal stress, especially during the last trimester or last month or first 5 months, because of the oxidative stress, and that causes the cleavage of the prolactin hormone. That the prolactin hormone toxic fragment is the major driver for the myocardial damage in PPCM. So we had a case, this was around 4 years back. So we had a case of 26-year-old primey, term pregnancy, preeclampsia, in labor, unexplained breathlessness, and she was presented in the full-fledged heart failure with BP 160, heart rate 130, room air saturation was 82%, respiratory rate was 42, and bilateral clefts and bronchi was there. She had a pedal edema. So how to suspect a patient with peripartum cardiomyopathy itself is a challenging. So in order to suspect, we need to have 3 basic things. One is the risk factors, next is the clinical presentation, third is the investigation. The risk factor, which is the high risk group, we need to suspect a patient with peripartum cardiomyopathy. This is the standard risk group. We know all that advanced age, multiple gestation, anemia, obesity. Can be found in any textbook. But this is not the case in Indian scenario. In Indian scenario, as I told, the mean age presentation is not more than 30. It's around 26 or 27 years. And not the multiple gestation. It's the primigravida. This was a study which around 20 studies they have done, and they have done the pooled analysis where they found in India it was more of a primigravida which has got acts as a risk group. Next was the anemia risk factor. Third was the preeclampsia. Later, compared to Western countries where multiple pregnancy and advanced age was the risk factor, in India it was not so. So clinically, next to the risk factor, clinically how to differentiate whether it's a normal pregnancy or PPCM, really it's very challenging. Even for the cardiologist it's very challenging. Because most of the symptoms are very overlapping. Because like fatigue, dyspnea, edema and tachycardia, these are there in both in normal pregnancy and PPCM also. Some of the tuning points like PND, orthopnea, cough, chest pain, hemoptysis, these help to differentiate whether it's a case of PPCM or a normal pregnancy. Of course, 2D echo can really give a differentiation to whom we are dealing with. Other than, as I told, risk factor, clinical investigation, third comes the most important, that is investigations. As routine ECG, it will show that the patient will have sinus tachycardia. The most important diagnostic tools, one is the 2D echogram and there is the NT-proBNP blood. In 2D echogram, we need to see the ejection fraction. How much is the pumping? It's ejection fraction less than 45%, irrespective of the LV dimensions. Of course, chest X-ray also cardiomegaly, pulmonary congestion, and even the most important is the NT-proBNP. As a rapid diagnostic tool, in order to act how to fastly detect PPCM, the most two important things are the 2D echogram, LV ejection fraction, another is NT-proBNP. If both are abnormal, definitely we are dealing with PPCM. Coming to the management. The management, it's a routine heart failure management for us, but how it differs from the routine for the peripartum cardiomyopathy is board management. The B stands for bromocriptine, oral heart failure drugs, anticoagulants, relaxants, diuretics. So as I told already that because of the prolactin theory, bromocriptine has shown a very good outcomes, especially now is a class 2 indications for peripartum cardiomyopathy, and another is the anticoagulation. This from our routine heart failure management, these two things we don't use routinely, especially bromocriptine and anticoagulation. I don't want to go into the details of the drugs and how to manage it, because I feel it's purely a cardiologist's job to which drugs to use and which not drugs to use. But in our fight regarding to decrease the mortality and morbidity for peripartum cardiomyopathy, the previous old known drugs like diuretics, beta blockers, these are all available. But what's new? What's our fight? Which one has gone to the newer things which have emerged to fight against to reduce the mortality and morbidity for peripartum cardiomyopathy? Newer two important drugs have come into the picture. These we call as 4 important pillars of heart failure. That is, we already know beta blockers and MRA. Other than that is ARNI and SGLT2. ARNI, that is sacubitril/valsartan combination. These have shown a favorable results and outcomes in patient with PPCM. But limited studies are available, especially during the use also in lactation, even during the pregnancy also, because the data is limited. But still, if the patient is postpartum and it's non-lactating, it's a very good drug to be used, including the anti-diabetic drugs, that is SGLT2 inhibitors, empagliflozin, dapagliflozin. These also in the trials it has shown is a very good outcome. This also similar to the ARNI, where the data is limited to be used for the use in regarding the pregnancy, also during the lactation. I remember my OBG postings always, my HOD used to always tell that iron, iron, iron and iron. And it's the concepts still hold good even in patient till now, even in dealing with heart failure patients, even also patients with the peripartum cardiomyopathy. But the difference here, the game is different here. Irrespective of the hemoglobin levels, we need to target the serum ferritin levels. So we need to see not the hemoglobin, we should see the ferritin. If it's less than 100, if it's 100 to 200 with a TSAT saturation less than 200, it is a class 1 indication to go for ferric carboxymaltose correction. So this wonder drug I could call, this has got a very good outcomes. It not only corrects the iron deficiency, pregnancy and lactation, also improves the cardiac function, enhances the symptom relief, and supports the faster recovery in the ejection fraction. Various trials are there which have shown very good outcome. Some of the advanced therapies like device, mechanical therapy, and of course heart transplantation is the last therapy in refractory and recurring cases. So our patient with these things, we managed her very well, and our ops team was also dynamic to operate for that. So we had, now next question comes, whether to go for a Cesarian section or vaginal delivery. This is a very big question. So of course vaginal delivery is the best route of delivery until unless patient is hemodynamically unstable, or because any obstetric indications are there, or any severe heart failure is there. So because what are the advantages being the minimal blood loss, lesser infections, lesser pulmonary complications. Caesarean section has got high risk of infection, thromboembolism and hemorrhage. So if you go for a Caesarean section, the question comes about the anesthesia, which anesthesia to take. Of course, the goal is to maintain the hemodynamic stability, either avoid tachyarrhythmia, hypo or hypertension. So combined spinal and low dose epidural anesthesia is the best. Another is also general anesthesia. Coming to the monitoring and follow-up. Once we diagnose, we treat, baby is delivered. The most important period where the patient gets worsens, especially during the first post of day 1 to 3. As we know, because of the physiological autotransfusion, there will be pumping of the blood around 300 to 500 ml into the systemic circulation. This acts as a hemodynamic volume overload to the already failing heart. So this is the period where the patients usually worsen. We need to have a strict vigilance over there. So of course it's a guideline directed medical therapy. We need to give the diuretics and supports for that. Next makes the important question before discharge, whether the patient can continue the breastfeeding or not, because most of the drugs are like they will be secreting in the mother's milk and all. So but still now there is a no definite consensus whether to continue breastfeeding or not. But still some studies like IPAC study, they have shown no difference if the patient is giving breastfeed to the children or not. But of course like ESC guidelines have told, if the patient is having severe LV dysfunction and severe heart failure or like severe breathlessness is there, the breastfeeding should be discouraged because of the prolactin theory which I told already. And one more rebirth study is awaited. Coming to the one more important, that is contraception. Because of the peripartum cardiomyopathy, pregnancy and everything, they have got a high thrombotic milieu. So they should disavoid the use of estrogen containing contraceptives. Progesterone releasing subcutaneous implants or the Mirena IUD are safe and effective choices. Non-hormonal barrier methods are less effective. Tubal ligation and vasectomy are other options. We need to do a recovery score before discharge. We usually mention our 2D echogram report where we do IPAC or ESC ERP. This helps us to detect how much there is a percentage of chances that patient will have improved ejection fraction over a period of 6 months. This helps to tell us how much we need to frequently follow up and how to optimize the medications. So this was the baby which we got delivered in our ICU. Vaginal delivery was done. So this was the first baby which got delivered around 4 years back. So coming to the follow-up, so as I told, 70% people will have improvement, 25% will have chronic heart failure, and recurrence is possible in the subsequent pregnancy as ejection fraction is less than 50%. So next important question is what about the subsequent pregnancies? Whether the patient has got peripartum cardiomyopathy diagnosed, now patient has got recovered and everything is fine. Now once again she wants to conceive, whether she can conceive or not, it's a big question. So yes, of course she can conceive, but it depends all on the 2D echogram ejection fraction. The ejection fraction has improved. Even if the ejection fraction has improved, as per the guidelines, we need to wait at least for 5 years. So what if that happens if the patient gets conceived accidentally is less than 5 years? Even if the ejection fraction is normalized, even if you are given the best of the best treatment, everything is fine, there is a still 20% chance that patient will have recurrence of the entire scenario. Of course, if the ejection fraction has not improved, definitely one more pregnancy is contraindicated and should not go ahead with that. So this is how we follow up by the end of first trimester, second trimester, the 2D echogram screening we do after delivery, 1 month after the delivery. Coming to my last slide, so take home message that even now, even for the cardiologist, until without echocardiogram and the NT-proBNP, clinically diagnosis of PPCM remains still challenging. And Indian risk group population varies compared to, as I told, where maternal age more than 30 years and multiple pregnancy was the risk. but it's not the case of Indian. And I would like to tell, we should introduce as a screening pseudoechogram as a routine, where we usually do as a you do ECG, you do CBC, RFT, serology. Especially in the high risk group, we should do at least a screening pseudoechogram, which help to identify the high risk group, and we can modify the therapy, and we can take the utmost precautions. This we usually do in the Bidar. So most of our all gynecologists, Dr. Uma ma'am, Dr. Shada, Dr. Josna ma'am, everyone will send us for screening pseudoechogram. So lactation is not contraindication. So there must be strong counseling regarding the subsequent pregnancies. Thank you.
Good morning. This peripartum cardiomyopathy, very important. We have a case series of 55 cases. We are shortly publishing on this. Tamil Nadu has made 3 times echocardiography mandatory. First in the first trimester or middle of the early second trimester, second time in the late 28 weeks, and third it is in the third trimester. But if there is a preeclampsia, it should be done again. And we have published one article on diastolic dysfunction in preeclampsia versus normal pregnancy. Normal pregnancy also there is a diastolic dysfunction, and this is it is increased in preeclampsias. So if we want to further reduce maternal mortality, our steps need to be improved in this direction. At least a second trimester or at 28 weeks, where the circulating volume is highest, whether the heart is able to manage this. That's the point I just wanted to share. All OBGYN, please ensure at least one echocardiography of your patients in order to see that your patients are fine. Thank you.
Much, sir. Morning to everyone. The obstetricians are always aware that what we should do to avoid these complications, because we go more for a prophylactic base. As sir said, I think it's better to go for a echo, especially around 39 weeks. At least if the patient cannot afford for so many times, or there is no risk factor, can delay it for one at least. Nowadays, I think we should put it as a routine, like how we do CBC in the last trimester. We should go for an echo. And if we insist the patient, I think probably they'll definitely agree for that, because it is good for them also and for the obstetrician who is managing. And you said you are a odd man out. No, for odd man in. Because we want all the specialties to be with us, because the whole body, how it responds to a pregnancy and delivery, it's an individual variation. We have to take care of the patient, the pregnancy, in the labor and peripartum time also. And really we have seen some people losing with peripartum cardiomyopathy, and we really feel bad, because everything went through so well, and suddenly first day or second day she has a breathlessness. Then we hurry for the investigations, and then we go for the other specialties, and we find that LVF, their function is low. We really get disheartened, because we always think that we are partly responsible for all the things, whatever happens to a woman who is pregnant, who comes to us for a ANC and follow-up. So definitely we need all disciplinaries to take care of our patients and do well. Doctor, you did extremely well. Really, we came to know so many things, and you completely everything from ANC to delivery, type of delivery, and postpartum, lactation and counseling. Really, it was a wonderful lecture. Thank you.
Thank you.
Dr. Nitin, your presentation was very to the point, as all my gurus have already said here. Yes, the obstetrician should always keep in mind, somewhere at the back of mind, the cardiac causes of breathlessness. Most of the time we do neglect. And you're always a part of the obstetric team and in saving. Good presentation.
I'm Dr. Aarti Sharma from Gulbarga. I have a question for Dr. Nitin. Doctor, you said that we should discourage pregnancy in patients who have got cardiomyopathy. Suppose she is a primigravida She has only one child. She insists to have another child. What precautions do you advise for her?
I didn't told to discourage the sex
You
subsequent
said-
pregnancy. It basically depends on the how much the ejection fraction has improved. Suppose the ejection fraction has improved, we need to wait at least for 5 years.
5 years.
5 years. Because within a period of 5 years, as I told, accidentally if the patient becomes pregnant, there is a still 20% risk of relapse of the entire PPCM scenario. Of course, if the patient is ready to take the risk, then definitely with the both cardio and upstream, with the regular ANC follow-up and regarding the cardiologist follow-up, will have a very good outcome.
What precautions what precautions should be given?
What I would like to tell, as sir has already told, that if the patient becomes pregnant with already diagnosed and the ejection fraction everything has recovered, the beta blockers are the best choice of drugs to be added and should have continue whenever the ANC checkups are there. Serial 2D echograms need to be done to see whether the ejection fraction is maintained or it's deteriorating.
Thank you. Thank you.
Thank you.
Thank you, Dr. Gudge, for your
I have a
nice
doubt.
presentation.
We have seen the cases of PPCM many, and retrospectively when I went through, there are high-risk cases like who are at prone of developing the PPCM, especially like multipara, multiple pregnancy, and previous history of respiratory tract infection also is a triggering factor for the development of PPCM, what we have observed in our institute. And definitely PIH is a risk factor for PPCM. So I feel that for all high risk cases, it's better to get it done the echo.
2D echogram.
Yeah.
We have used bromcriptine and cabergoline. We have used and we have got good results. Actually, I agree with that because practically we have seen and they really improved from 30% and less than 30% to they became normal. So that's one thing.
In our center, we had till now since past of 4 years, 14 cases we had.
Yeah.
3 had a mortality. So this is a very dilemma peripartum cardiomyopathy. We have seen out of 3 cases, patient recovered well, everything is fine. We are about to discharge tomorrow. Patient expired in the ward. So this has got a very high mortality. Even with the best of the best hands also, the variable outcomes are there.
Only if we give that, we definitely put them on low molecular heparin. And one more thing, post-COVID, we saw lots of cases. There was a huge rise. Now it has again come back. But do you also had that experience?
Post-COVID, I didn't had any much experience with that.
In our hospital, we saw lots of cases of PPCM post-COVID,
Okay.
even when there was no PIH also.
Okay. What I feel it was, I think because of the early detection, because of the more screening echocardiograms, it's detecting, maybe that might be the
Let's
thing.
see.
Thank you, everyone.
Thank you, Dr. Nitin Gudge, for guiding us on timely diagnosis and management. I request our speakers and chairpersons to proceed to the gratitude desk for felicitation. I request Dr. Prakash Korwar sir and Dr. Sharda Gudge to felicitate our speaker and chairpersons.
We now move on to our next session, the presidential keynote, Cesarian Scar Pregnancy by our Ksoga President, Dr. Durgadas Asrana sir. Every scar tells a story, but in obstetrics, some scars write new and dangerous chapters. Today we explore one such rare yet rising challenge, Cesarian scar pregnancy. When routine surgery leaves behind uncommon risks, awareness becomes our strongest tool. I now call upon Dr. Durgadas Asrana sir to illuminate the challenges and advances in Cesarian scar pregnancy, a topic that deserves our attention now more than ever. I request Dr. M.G. Hiremat sir, Dr. Nagaraj H sir, Dr. Mahadevi Dama ma'am to chair the session. I request Dr. Preeti Birada to introduce our speaker and chairpersons.
Good morning, everyone. It's my honor to introduce our speaker, Dr. Durgadas Asrana sir. Sir is the president of Karnataka State Obstetrics and Gynecology Association. He is member of IMS, member of ISOBURB. Sir is a past president of Tumkur OBG Society. Sir is associate professor in Siddhartha Medical College, Tumkur, and consultant in Kasturba Hospital, Tumkur. And chairpersons for today's sessions are Dr. M.G. Hiremat sir. He is Chief Patron and Founder Secretary of Ksoga. Sir is a Director at Hatch IVF Center and Matoshri Women's Hospital, Vidyanagar, Hubli. And Sir has received Millennium Fellow Award for Excellence in Academics by Foxy in 2000. Dr. Nagraj H. Sir, he is Patron Ksoga. He is Founder and President of Shimoga OBG Society. And Sir has received BC Rai Award on Doctor's Day this year. Dr. Mahadevi Dama Madam. Madam is a consultant since 2001 and running her own private hospital in Solapur. Thank you.
Good morning, everybody. At the outset, I thank the organizers, especially Dr. Uma Deshmukh Madam, Dr. Savita, and the whole team of BIDA for inviting us. Thank you, chairpersons. Today I am going to talk on Caesarean scar pregnancy. Caesarean scar pregnancy is an ectopic pregnancy implanted in the myometrium at the site of previous Caesarean section scar. It was first diagnosed in 1976 in South Africa. The rising incidence of Caesarean section CSP is because not only of exponential increase in the Caesarean section rate, but also increase in the improvement in the diagnostic tool like 3D ultrasound, MRI, etc. The ultrasound criteria for Caesarean scar pregnancy are empty uterus with the end cervical canal, gestational sac at the Caesarean scar site, thin myometrial tissue between the gestational sac and the bladder, perivascular flow is seen around gestational sac. The debate always lies between whether it is an ectopic pregnancy or intrauterine pregnancy. To call it as an ectopic pregnancy, here the urine test is positive, uterine cavity and the cervical cavity are empty. If untreated, it can rupture leading to severe hemorrhage. To call it as an intrauterine pregnancy, CSP is always within the uterine boundaries. Occasionally, if CSP is allowed, it can grow as intrauterine pregnancy only to present as placenta accreta syndrome. Professor Timothris rightly called it as a man-made disease. It occurs only in the scarred uterus. It occurs because of the improper healing of the Caesarean section scar. Like in cases of preterm Caesarean sections, we take the incision in the lower part of the upper uterine segment. If the Caesarean is performed as an emergency procedure with the prolonged labor and full dilatation of the cervix, it has been postulated that single layer of closure with the interlocking stitches increases the incidence of Caesarean section scar, CSP. So, it is advisable to close the uterus in 2 layers with the running stitches. Coming to the classification, it is based on the site of CSP and the residual myometrial thickness. Type 1, the endogenic type. Here it grows towards the endometrial cavity. Type 2 is the exogenic type. It grows outwards towards the serosa. Type 3 is also an exogenic variety. Here the gestational sac is completely outside the serosal layer. So, the endogenic type or the type 1, the G-sac is superficially implanted over the gestation section, over the Caesarean section scar. It grows towards the uterine cavity. Occasionally, it progresses to intrauterine pregnancy and it can give birth to a live baby. Whereas, with respect to type 2, here the gestational sac is implanted deep in the niche of the Caesarean section scar. It grows towards the bladder and the abdominal cavity and it can cause uterine rupture and severe hemorrhage. What is crossover line? An imaginary line is drawn from the isthmus to the fundus. It is called the endometrial line. Another line is drawn perpendicular to it, transecting the gestational sac. If the gestational sac is above this line, it is COS1. If it is below this line, it is COS2. If more than 2/3 of the gestational sac is below this line, it is 2 plus. If it is less than 2/3 of the gestational sac is below this line, it is 2 minus. COS1 is always a life-threatening condition because here residual myometrial thickness is very thin, so it should be referred to the higher center or operated as early as possible. COS2 These are the cases which are prone for developing morbidly adherent placenta in the second or the third trimester. So continuation of the pregnancy should be discussed with the patient and the relatives. Residual myometrial thickness, it is the distance between the outer border of the niche to the serosa. It is one of the most important prognosticating factor of CSP. If it is more than 2.6 or 3 centimeter, then it is safer. If it is less than 2.6 or 3 centimeter, they are likely to go to uterine rupture at the earliest. What are the differential diagnoses? Cervical stage of missed abortion, cervical pregnancy and cervical polyp. Here, the pregnancy has occurred in the upper segment. In the process of expulsion, it has dropped and lying down in the cervical canal. Here, the ultrasound is showing echogenic mass in the cervical canal. There is no peritropoblastic blood flow. The sliding sign is positive. Cervical pregnancy. Here, the pregnancy has occurred in the cervical canal. So, the uterine cavity is of normal size, and you can see the ultrasound is showing the gestational sac within the cervix and the empty uterine cavity. The gestational sac is within the cervix with an intact part of the cervical canal is existing between the gestational sac and the gestational sac and the closed internal os. Peritropoblastic flow is present. The ultrasound is showing an hourglass appearance with the closed internal and the external os. CSP, it is a low-lying gestational sac is seen in the transabdominal image. The transvaginal scan, the gestational sac is seen in the anterior part of the lower uterine segment with thinning of the anterior myometrium. Cervical canal is empty. Peritropoblastic flow is seen. So, in comparison, CSP, the gestational sac is in the anterior part of the lower uterine segment. The overlying and myometrium is thinned out. Sliding sign is negative. Peritropoblastic flow is seen. Cervical pregnancy, the pregnancy is within the cervical canal. The overlying anterior myometrium is normal. Sliding sign is negative and peritropoblastic flow is present. In case of cervical stage of missed abortion, the gestational sac is lying in the cervical canal. Anterior myometrium is normal. Positive sliding line and there is no peritropoblastic flow. Coming to the management, the principle of management is to excise the gestational sac and to repair the defective area. It may be by expectant management, medical management, surgical like curettage, resection of the scar by vaginally, laparotomy or laparoscopy, evacuation of the CSP by histoscopy. Non-invasive measures, uterine artery embolization and HIFU. There is no role for expectant management for CSP once you diagnose it. But if the patient declines termination and wants to continue the pregnancy, risk of severe hemorrhage should be explained to the patient. Medical management, it is done using injection methotrexate. The candidates are the pregnancy should be less than 8 weeks of gestation. Fetal cardiac activity should be absent. Patient should be stable. Serum beta HCG should be less than 5,000 international units. And residual myometrial thickness should be more than 3 millimeters. Combination of systemic and local injections of methotrexate are used. There are two regimes. Timor-Thrish regime. Here, the 25 milligram of methotrexate is given into the gestational sac using the ultrasound. Another 25 milligram is given at the placental site and 25 milligram is given intramuscularly. According to University of Illinois regime, the total dose given is 50 milligrams per square body meter area. Half the dose is given into the gestational sac and half the dose is given intramuscularly. Remember, methotrexate will kill the trophoblastic tissues, but it will not expel the product of conception because there is no uterine activity. So, other modalities like histoscopic excision or other modalities should be combined along with this method. Once the patient is subjected to serum injection methotrexate, serial monitoring of serum beta HCG should be done till it reaches the baseline level. It may take 1 to 3 months. Suction curettage, it should be performed in type 1, that is endogenic CSP, with residual myometrial thickness of more than 3 millimeters. Suction curettage should be done under ultrasound guidance to ensure direct visualization of the sac during the procedure. When suction curettage is being performed, plan for meticulous hemostasis using adjuvant interventions like intracervical balloon tamponade or uterine artery embolization or cervical encirclage by Shirotka stitch or ligation of the uterine arteries is advisable. According to ASRM 2016, hysteroscopy should be used to remove the CSP via the direct visualization or under ultrasound assistance. The methods used are either suction aspiration of the gestational sac or by using resectoscope. If required, adjuvant treatment by using methotrexate or uterine artery embolization will help in reducing the amount of hemorrhage during surgery. Hysteroscopy is useful in type 1 CSP with residual myometrial thickness of more than 3 millimeters. Laparoscopy is the gold standard in the management. It is used in minimally invasive procedure. Direct visualization of the pregnancy is possible. The complete removal of the scar tissue can be done. The success rate is 97%. Faster resolution of serum beta HCG. The long-term outcomes are higher rate of subsequent successful pregnancies and recurrence of CSP in the subsequent pregnancy is very less. The best method, it is best used in type 2 CSPs. The steps are laparoscopic wedge resection of CSP and previous Cesarian section scar is done. Then the raw area is repaired. During surgery, temporarily occluding the blood supply to the uterus by either injection vasopressin or ligation of the uterine artery with or without ligation of the internal iliac artery will help in complete resection of the CSP and to attain hemostasis. Transvaginal removal of the CSP. The approach requires familiarity with the vaginal surgery as difficulties may be encountered. These include adhesions between the bladder and the ectopic mass, making the separation of the bladder and the cervix difficult and increasing the risk of bladder injury. Remember, it is a case of previous Cesarian section, so there will be adhesion between the bladder and the cervix. In addition, the vaginal approach has a narrow field of vision which can make the hemostasis relatively difficult. Uterine artery embolization is always used as an adjuvant therapy. It is used in combination with suction evacuation or DNC with hysteroscopy or DNC with methotrexate. Double balloon catheter. The cephalad balloon is tightly fits into the endometrial cavity to prevent it from expulsion, whereas the lower balloon interrupts the CSP via mechanical pressure to prevent any potential bleeding. The compliance of this is very less because the lower balloon which presses the cervix should be kept for 3 to 4 days, and the pain of stretching the cervix may not allow the patient to tolerate this for too long. The take-home messages are CSP is a precursor for morbidly adherent placenta. The primary prevention is to give a clear scar of Cesarian section. The secondary prevention is by early diagnosis, that is, diagnose it within 6 to 8 weeks of gestation. If it is diagnosed after 9 weeks, it is associated with increased complications. So, any patient of previous Cesarian section, while you are discharging the patient, advise them to report to the doctor as early as she has missed the period and the urine test is positive. That is better before 6 to 8 weeks of gestation. Proper localization and classification of CSP will be beneficial to diagnose and early referral to higher centers. In cases of missed abortion and the gestational sac is sitting in the cervical canal, one should rule out CSP before performing DNC. Thank you.
The opportunity. The speaker has given all the parameters of the scar pregnancy. It is a burning issue now because injudicious use of Cesarian sections, proper technique is most important so that we can prevent scar ectopic, and judicious use of Cesarian section is most important. So we have to think twice before performing a Cesarian section, and detect proper technique, and infection has to be prevented. I would like to congratulate the Wither Society for the wonderful conference, and I am part of it. Thank you very much.
Thank you. Beautiful presentation, sir. And last year I had one case. Usually these cases are nowadays diagnosed very early because of the early scan. 6 weeks missed abortion, and we could do it a USG guided evacuation, and patient went uneventfully. There was no problem. That's why it's a very good presentation, and closure of the scar, Cesarian section you are telling as 2 layers we have to do. Nowadays we are usually doing a single layer closure only. What exactly to be done we don't know, and this is a very rare case also. Yeah. Thank you so much.
Only two things. One is, once you are going to touch a missed abortion, think twice. Second thing, you are discharging a Cesarian, you have performed a Cesarian section. While discharging the patient, tell them that as soon as you miss your period, get a UPT at home. Once it is positive, immediately report, because the management is very simple once it is diagnosed within 6 to 8 weeks. After the complication increases after 9 weeks of gestation. Thank you. Sorry. Tumkur is hosting the state annual conference of Ksoga on 31st of October and 1st and 2nd of November. I request everyone, kindly come to Tumkur, enjoy your hospitality. We will try to come up to the level of Uma Madam. Yes, we are really amazed to look into the arrangements. We will try to come to up to this expectation. Please come to Tumkur. It's going to be an excellent program. We are expecting a delegate of 1,200 to 1,500. We are getting the faculty from outside, like BC Mahapatra, Bhaskar Paul and all. We have nearly 12 to 15 outside faculties we are expecting. We have already invited. Please come to our Tumkur for our state conference. Thank you.
Thank you, sir. Though rare, Cesarian scar pregnancy is growing reality in the age of rising Cesarian section. Timely detection, accurate diagnosis and multidisciplinary management are key. Thank you, sir, for enlightening us. Now we request the speaker and chairpersons to proceed towards the gratitude desk for felicitation. I request Dr. Uma ma'am and Dr. Lalitama ma'am to felicitate our speaker and chairpersons.
We move on to our next session, Gestosis score for prediction and prevention of PIH by Dr. Shobha Gudi. Screening isn't enough. Prediction must be personalized. That's where Gestosis score steps in. It's a valuable clinical tool that helps us predict, monitor, and manage hypertensive disorders of pregnancy with greater precision. By integrating early warning signs and risk factors, this score aids in identifying women who are at greater risk, helping us intervene before the complications arise. To take us deep through this topic, we have with us Dr. Shobha Gudi ma'am, who will explain the relevance of Gestosis score for prediction and prevention of PIH. I request Dr. Vidya Thobi ma'am, Dr. Shailaja Bidri, and Dr. Sujata Daded ma'am to chair the session. We call upon Dr. Sangeeta Halmangi to introduce our speaker and chairpersons.
Good morning all. Dr. Shobha N. Gudi Madam, we all know her. She is Professor HOD at St. Philomena's Hospital, Bangalore. She is a postgraduate teacher and examiner. Madam is chairperson for FWC FOXY 19 and 2020. She is President Box for 2018 and 90, now Secretary General Ksoga 2025-27. Madam has many journals and publications to her credit, national and international awards. She is a distinguished DNB teacher by 2019, Best Society BSOG at Ksoga 2018. MS Signature for Unparalleled Contribution 2020. Welcome you, ma'am. Now I'd like to introduce our chairpersons, Dr. Vidya Thobbi, madam. She is the past president, Ksoga 2023, and she is a member of State Advisory PC-PNDT Board, Karnataka. And she has Best Committee Foxy Award, Dr. Miru Dhara Hansotai 2020. Madam is a postgraduate, undergraduate teacher for last 30 years. Dr. Shailaja Bidri, madam, Professor HOD, BLD Medical College, Vijaypura. She is the EC member for North Zone, Ksoga, and she has many publications to her credit. She is also the president of Bijapur Obstetric and Gynecological Society. Welcome you, ma'am. Dr. Sujata Dhadet, madam is HOD professor at KBN Hospital. She is experienced for last 23 years. Her area of interest are high risk of pregnancy. Welcome you all.
Thank you very much. I must congratulate either OBGYN Society for conducting such an academic event. Now Dr. Shobha Gudi, over to her, and already she has been introduced and everybody knows her. And this is very important topic she is going to talk on, that is Gestosis score. Everybody has got this Gestosis app, but she will be throwing more light on this. And if you have any queries, definitely call on us. Thank you very much. Over to Shobha.
A very big thanks and a lot of gratitude to the organizing committee on behalf of Ksoga. I'm sure Dr. Durgadas Asrana joins me in extending our heartfelt gratitude to this society which has worked so hard for 3 months and more to bring this magnificent feast of academic, culinary and culture and ambience and togetherness for all of us. So thank you very much, Dr. Uma Deshmukh, Savita Badigare and team, and here goes. So my time starts now. Time starts now. Yeah. Time please. Okay. Okay. So preeclampsia is the most complex disease which obstetricians have to handle, and also it is something unique to human pregnancy, and also we need to be very, very, very apt in not only managing but also in preventing it. Now these are thoughts which are there already in your minds. What we need to understand that this disease has been understood very long back, 2400 years of history. Even Hippocrates identified convulsions in pregnancy, and then subsequently many people tried to work on it, find out what is the cause. J. Simpson even published, it was the first publication. And then there is this man, Leon Cheesley, who worked for 43 years in the field of eclampsia, and also began one of the earliest familial genetic studies, but none of them could identify any method of preventing this calamity. The ISSHP, USP, STF revised criteria of preeclampsia diagnosis, everybody knows, so I will not go through it. But if these criteria, any of them are missing, then it is also thought that in the absence of proteinuria, suppose there is no proteinuria, even then we can diagnose severe preeclampsia. But what we need to understand that if we think of the levels of prevention of preeclampsia, then there are 3 levels. Actually, there are 3 levels, and today what we look at, most commonly only tertiary prevention is possible. Today what we are going to do also will give us only secondary prevention. Primary prevention actually is prevention of pregnancy and a preconceptional care of modifying lifestyle, which will improve the outcome of pregnancy and decrease the chances of getting preeclampsia. So Gestosis score is a tool which actually aims at secondary prevention of preeclampsia, because it will help, like other biomarkers and other tests which have come up, in interruption of the known pathophysiological mechanisms of the disease in a very structured way by the use of timely aspirin. Okay? All right. Challenge me. Yeah. So this has been understood as a systemic disorder. The pathophysiology is poorly understood. The incidence is around 10%. The second most common cause of maternal mortality and morbidity apart from hemorrhage, and prevention is very challenging because the cause is not known. Now, Many statutory authorities, including the ACOG, actually recommend that a detailed medical history should assess the risk not only for preeclampsia but also for FGR, and then no need of doing elaborate laboratory and imaging screening test, which the current the screening tools advocate very, very strongly. The prevalence in the general obstetric population is not considered very high. It is considered 8 to 10%. And a test which is required to pick up this will require very, very high sensitivity and specificity, which none of them offer anyway. This is from the RCOG guideline, which gives us in majority the booking assessment of the first trimester. You can see the booking assessment of the first trimester. It's almost like the Gestosis score, which I'll come to later on. And only if there are risk factors, they go on to do the biomarkers, etc. Okay. So Gestosis score is not very far from here. We may start ecospirin without doing the biomarkers. That's it. This is the NHS scoring, which is currently prevalent in NHS in UK. And this also shows the interventions during pregnancy when risk assessment should be done. And this also emphasizes on taking a detailed history in the first trimester for preeclampsia. So what is Gestosis score? To understand it, to build the context for it, we need to understand that there are about, I'm sorry about the 2 to 2.5 million incidents of preeclampsia is what is kind of is a rough figure, because we have 26 to 27 million deliveries per year, and out of that 10% is actually preeclampsia. So if we start screening all women with the biomarkers which are recommended and the imaging modality which is recommended, the cost is going to be very, very high. So we need some tests, because we still remain for many of these conditions a low resource setting only, and therefore many tests and challenges have been there, but it is the challenges are, one is cost and the second is implementation of any program, because the pregnant women may not report that early to the antenatal clinic, and in rural areas etc. they tend to report late, and therefore we lose the opportunity of predicting it. The change of mindset is needed so that they report early, or this risk scoring assessment can be done at their homes. When a pregnancy is reported, the ASHA worker can also implement the Gestosis score. That is the beauty of it. Now, taking you through the current recommendation for preeclampsia prediction, the ACOG says history. The SMFM, Society of Maternal Fetal Medicine, same as ACOG. This is the US SMFM. And then the National Institute of Health and Care Excellence, NICE, says history, demographical risk factor. But the FMF of UK, the one which was led by Nicolaides, that is the only one which says that there has to be demographic plus clinical plus MAP plus UTPI biomarkers, etc. But then we need to look at the FIGO guideline. The FIGO guideline also says the biomarkers, but when not possible, the demography. SOGC Canada says at minimum clinical risk factors, if available only, then the UTPI plus PLGF, and the internal ICOG also says imaging. WHO says same as ACOG, that is clinical and demographic. So the clinical risk factor based screening is actually recommended across the world. That's what we looked at just now. So Foxy Gestosis ICOG GCPR recommends this. The United States Preventive, this is called USPSTF, also recommends it. The Australian guideline also in the NICE guideline 2020 also. So prediction in low resource setting, it's a newer concept, but it is not old across the world. It's maybe a newer concept for India, but also now it has been there for almost a decade, because the concept was floated by the Gestosis team, Dr. Gupte, Dr. Mandrupkar, Dr. Gandhi, Dr. Wagh, Dr. Pandit. They developed it, and now there's one study which was published in Jogi 2022. Please look it up. We also have some data in our hospital which is giving us more than 85% sensitivity of this score for picking up preeclampsia. It is a risk scoring system that predicts likelihood of developing hypertensive disorder in pregnancy, and so you can do something about it. At the first visit, a careful history is taken. The risk is categorized as 1, mild risk factor, moderate is given 2, and severe risk factor is given 3. If the sum total is 3 and more, just look at the cutoff. The cutoff has been kept very less. It is just 3 and more. You can start her on low dose aspirin. 75 milligram is what is recommended. The process is The score involves all the existing risk factor and the emerging risk factor. That is why it is a dynamic score. I'll tell those emerging risk factor is also important. Whereas if you implement the UK FMF, the method, then the opportunity is only in the first trimester. After that, you don't revisit it unless the woman develops preeclampsia. Then you put in other biomarkers. So here the opportunity is every visit because it's a dynamic score. So with careful history assessment, a total score is obtained early in pregnancy and then time to time. So when the total score is equal to or more than 3, she is at risk. So this score involves, So all risk women should be started with aspirin and low dose aspirin, good maternal safety profile for the fetus also, and 75 milligram is what we use, but calcium also should be started. At least 2 gram calcium per day, out of which 1 gram comes from the diet and 1 gram comes from the supplement along with vitamin D. So when to start? Better earlier, that's the earliest possible, earlier than 12 weeks. That's why risk assessment should be very early. And this, because defective placentation is the causation, pathophysiology. So early aspirin balances the levels of TA2 and PC, prostacyclin maintains adequate uteroplacental blood flow. Therefore, so it is an intervention based score. That is why there is more logic to it. Therefore, it appears safe to use as a prophylaxis to prevent and throughout pregnancy or at least till 36 weeks. So every visit, do it, identify risk every visit. On every visit you have an opportunity to reduce the risk in the rest of pregnancy, and should be scored minimum 3 during pregnancy. Only thing is the value of intervention is only there in early pregnancy. Later on what you can do is you can step up the vigilance. You can recruit her to high risk pregnancy clinic, get her often, and then apply other screening methods like correct BP measurement, proteinuria, etc. Minimal training is required. It is very valid. Early identification, it integrates clinical and as well as basic antenatal investigations. It's a checklist. Structured printed history sheet can be made by a team of experts. I'm very, very proud to say that Dr. Durgadas in his presidential year has already created a Gestosis cell, and it is going to be implemented across societies, the scoring system. So more and more practitioners will start doing this score. Please join that gang. So train postgraduates for this. All high risk factors should be circled whenever you check, because other risk factors may emerge apart from the value of Gestosis score. So please understand that it will give you more dimensions for prevention than just the hypertension. Such women should be given high risk tag. It helps in highlighting factors. Then intervention I have spoken about. So this is how the score looks like. The score 1 is there for, you can see up till MAP 85, it is score 1, obesity, nulli gravida, short duration paternity is available on the net. Please download it and keep it in your clinic. PCO, interpregnancy, less interval, ART, hypothyroidism, dyslipidemia, more weight gain, TDM, more than 40 obesity, multiple pregnancy, hypertensive disease during previous, etc. get 2. What gets 3 is pregestational diabetes, chronic hypertension, mental disorders, inherited thrombophilia, autoimmune disorders, and like that. Okay, so the different studies showed that with Gestosis score, positive predictive rate of eclampsia is 82 to 84. This is mirrored by what we have done also, and it is equal to prediction with the use of maternal history, demographic markers, the MAP, the uterine artery pulsatility index, and the biomarker. So that is how the Gestosis score is poised just now. This is how it is positioned. But please remember that every clinical intervention or any antenatal care addition is something which is like a station. It is not the absolute. It is just a work in progress. So you need to build up data to convince yourself, to convince women that this works. So that is why please generate data around it, record your own patients, see the development of preeclampsia in the low Gestosis and high Gestosis score, and we'll get somewhere. So there is a meta-analysis which is already published in BMJ, and where the 27 countries, and this is the meta-analysis of this number. I think this is 2,53,000 something, and this relative individual risk, when you see, then the clinical risk factors emerge as the strongest predictors of preeclampsia. relative risk which is attributable to the population. Again, the clinical risk factors are the highest predictors, and that means if you go clinically, you will not miss. There is an Android app also of Gestosis score which you can download, and that will facilitate your scoring. So in low resource setting, it seems to be the way forward. What I wanted to highlight here is that you perform Gestosis score in every woman, and you will conform to the latest new inverted pyramid model of prenatal care. So that indicates that more and more interventions put earlier and earlier pregnancy will give you a better outcome. So the risk stratification of a very high degree can be done with in 12 weeks, by 12 weeks of pregnancy, which is contrary to what we did earlier, because we kept basic interventions or investigations in the first trimester and higher vigilance and testing in the later part of later trimester. So now put in everything good you have got in your system into the first trimester screening, and that the most powerful tool is history taking, and that is how you will score your women. And at 22 weeks reassess the risk, and 36 weeks you will be ready with the plan. So this is something which you all need to know, that there is a grade 2C recommendation for the biomarkers and the biophysical combined, because there will not be time to cover this. So I'll just fly through these slides. What happened with the ASPER trial, that people began to understand that the biomarkers get generated in the way that they get generated because of the changes in the trophoblastic invasion, and that creates a difference in women who will develop preeclampsia and IUGR later on, because then the PAP-A does not get reflected enough, and then the invasion failure also predicts, kind of reflects in the abnormal uterine. The trophoblastic invasion failure is seen in the uterine artery resistance, and thereby you can structure in MAP, you can structure in PAP-A, the first trimester PAP, and the second trimester S-FLIT PLG could predict late onset preeclampsia also, and the first trimester PAP-A and PLGF can predict the early onset of preeclampsia also. So the pro-angiogenic markers and the anti-angiogenic markers need to be understood and then utilized in your clinical practice if you have a clientele who can afford everything. But Gestosis score parallels with this. And therefore, I think I put this slide only to say that maybe this is cost effective for some populations, maybe the very urban and very evolved population, very rich populations, but then for the majority of women delivering in India, Gestosis score is what is more important. All right, so this was the detail of the ASPER trial, which I cannot take you through, but I can just say by logical conclusion that there is no catch-all predictive test so far available, and Gestosis score catches as well as the biomarkers, etc. So the prediction of preeclampsia remains a challenge, and we have women who report with blood pressure more than 140/90, no premonitory symptoms, right? We have women who report with more than 140/90 with premonitory symptoms, and then we diagnose them as mild and severe, non-severe and severe preeclampsia, and we manage them. The onset of proteinuric hypertension before 34 weeks of gestation also is something to be watched for very, very keenly. The onset after 34 weeks of gestation, the complications are less severe, so proteinuria is a less challenging one, less significant today. So the universal screening is recommended, but there is no single effective screening test so far. No single effective screening test. None of the tests proposed till date to predict the at-risk population for preeclampsia qualify to be recommended for the general population screening. That we need to understand. Assessment of clinical risk factors helps us to be more vigilant. A careful history taken early in first trimester can warrant attention for effective prediction and prevention towards mother for at risk very early, because if you go with a drive for risk assessment by history, if you go with a drive, as I said earlier, it is a more perfect antenatal care, because many times when you write off ultrasound with uterine artery Doppler, you write out a double marker, then it's possible, in your mind some complacence that, okay, this will pick up for me, this will pick up the risk for me. Instead, if we spend more time in history, it is more productive. This can be done by any healthcare worker by using the HTP Gestosis score. So I hope that I have given you the perspective on Gestosis score. I hope it will get implemented in your practice. Thank you very much.
Madam, for your more informative elaborative on for a PG thesis also in this our institution, and I would like to ask almost all primaries whether to mandatory for a Gestosis score chart.
Pardon? What was the question, Dr. Chaitra?
Primaries, because most of the time they'll come with a pre-eclampsia and
Yeah. It is for all pregnant women. Every pregnant woman should take the Gestosis. Yeah. You just sensitize your postgraduates, give a thesis. That's what we did.
Yeah.
Give a thesis topic and then see the outcome in the next year only. You will know the outcome.
Yeah. And we need a robust data from all the medical colleges, and as you told that Dr. Durgadas has already done, so let us project it. And even as a technical expert on maternal mortality, Dr. Bellad is here, myself and Dr. Sheila Mane. We have incorporated this Gestosis score in every patient, and in every primary health center we have circulated.
Yes.
The healthcare workers, staff sisters can be trained and they can download, and it is very easy to operate.
Even Ashas can do this.
Ashas can do this.
ಕನ್ನಡದಲ್ಲಿ ಮಾಡ್ಬಿಟ್ಟು ನೀವು ಅವ್ರಿಗೆ ಕೊಟ್ರೆ ಅವ್ರು ಮನೆಗೆ ಹೋಗ್ತಾರಲ್ಲ UPT positive ಆದ ನಂತರ they can do it.
And we can take a pilot studies in various institutions as well as at the periphery. Correct. And this we have already taken, and it is very simplified, and some of the postgraduates also have taken the dissertation in the low resource setting, and it is a wonderful app. And I must congratulate our Gestosis team, yes. Which we both are a part of it, and even we congratulate Dr. Gorak, Dr. Suchitra, and Dr. Girija. Absolutely, they have done this is a wonderful, because we cannot afford to do other biomarkers as such. So thank you very much,
Every
Dr. Shobha.
woman cannot afford, and sometimes we tell and they follow us and they do, but you know, it's possible that the same money can be utilized for better medication and for what is to come in pregnancy.
And we all know that hypertensive disorders is again coming up as a maximum maternal mortality and morbidity.
Absolutely.
It is a tip of iceberg, I must say. So let us prevent, let us, and now Dr. Bellad wants to talk, I know that. So he has to give his comment.
Morning, Madam. Excellent. Please don't say that we are not affordable. It's a developing world. Wait for 1 year. Like urine pregnancy test kit, you will get the PLGF value with 1 drop of blood. Like a blood glucose, you can do it, and you can do at different time wherever you are suspected. So PLGF level less than 12 is severely abnormal. 12 to 99 abnormal, and more than 100 reassuring. So wherever you suspect preeclampsia, this is a place where, you know, because many of the Gestosis score or FMF score, there are so many things. All obese women will not develop preeclampsia. Yeah. Whom will develop? All risk factors are there. So this is the best method. We are going to start the study now. Yeah. And that Lebzi device, which we have asked for, we are testing that, and it is a 5-country trial, and I am the lead for the Belgium site in India, so it will be shortly available. You will be very happy to know that, and these devices are quite economical. Maybe it will be costing maybe 100 or 150 rupees. Thank you for that.
As I said, everything is a work in progress. There is no absolutes in this. So let us follow the Gestosis score till the PLGF comes through and it is affordable. Thank you.
Thank you, ma'am, for your commitment to improve maternal health. May tools like Gestosis score guide our journey towards safer pregnancies and healthier outcomes for mothers and the babies. I request the speakers and chairpersons to proceed towards the gratitude desk for the felicitation. I call upon Dr. Uma Deshmukh ma'am and Dr. Lalitama ma'am to felicitate our speakers and the chairpersons.
We now move on to our next section, placenta accreta diagnosis by Dr. M.B. Bellet, sir. From silent scans to surgical surprises, placenta accreta is a condition we must catch before it catches us unprepared. As obstetricians, the power lies in our ability to anticipate it, and that begins with diagnosis. Stay tuned as we explore the depth of placenta accreta from suspicion to confirmation. It is our privilege to welcome a stalwart in the field of obstetrics and my teacher, a clinician par excellence, Dr. M.B. Bellet, sir. I request Dr. Rupa Pastapure, Dr. Meenakshi Devarmani, Dr. Sarita Badbate to chair this session. I call upon Dr. Pratibha to introduce our speaker and chairpersons.
Connect.
Morning. Morning. Let me introduce Dr. Bellet, sir. He is professor and former head of the department OBGYN, KAHES Jain Medical College, Belgaum. He is President Ksoga 2018 and 19 and Secretary General Ksoga 2012 and 13. And sir has 36 years of teaching experience. And sir is done 80 plus publications in high impact factor journals, and he has written 2 books and 18 chapters. And sir has got many awards: MS Signature International Award for Phenomenal Leadership and Excellent Academician in 2020. And he has bagged Newton Baba Award from MRC London and DBT for Cradle Trial Team. And recently he has got Legions in Gynecology Award from Bengal OBGYN Society 2024 and Torchbearer Award in Gynec Endoscopy from IH Award at Bangalore. Over to you, sir. Let me introduce the chairpersons. Dr. Sarita Badbade, madam. She is senior retired associate professor from PRIMS, Bidar, and she is consultant at Badbade Hospital, Bidar. Dr. Meenakshi Devarmani, madam. She is professor and head of the department, MRMC, Kalburgi, and she is also chairperson, Family Welfare Committee, Ksoga. Dr. Rupa Pastapure, madam. She is IMS member and consultant at Pastapure Hospital, Kalburgi. Over to you, sir.
A very good morning and wish you all a very happy Friendship Day. At the outset, I must congratulate and thank the Bidar OBG Society and the PRIMS for organizing this fantastic conference. Though it is a Sunday, we see quite a lot of heads here. Very nice to see that. And amazingly, all the organizing team have done wonderful work. I must thank Dr. Uma Deshmukh and her team. Many of my students are also here. And thank you. And thank you for that great introduction. So, I'll do it. At the outset, I bring greetings from my esteemed institution, from the Department of Obstetrics and Gynecology, Jain Medical College, Belgavi, placenta accreta spectrum disorders, an obstetric nightmare, human created problem. My presentation will be under these headings. I am not covering the management as my presentation is restricted to 15 minutes, and my title also is diagnosis. Placenta accreta. It's a morbidly adherent placenta, is one of the most dangerous conditions, also known as morbidly adherent placenta, placenta accreta spectrum disorders, derived from the word accres. Accres means it is attachment or invasion. So why we must learn this? It has a considerable maternal morbidity, fatal hemorrhage. I tell you why there is a fatal hemorrhage, and it can lead to DIC, multi-organ failure, large volume of blood transfusion is required, and need for the hysterectomy, intensive care unit admission, and infection risk, prolonged hospitalization, including the death which can happen. The average blood loss associated with this delivery is around 3 to 5 liters. There are other risks like surgical injuries to the pelvic viscera, fistula formation, bladder injury, ureteric injury, transfusion related issues like TRALI and cardiac disease, TACO. Fetal risks are also considerable due to prematurity. The challenges. Because of alteration in the uteroplacental unit, the management of morbidly adherent placenta is equally complex. There is often distorted anatomy due to the placental invasion and neovascularization that varies in degrees. So, challenges are the potential for torrential bleeding demands high level of planning and organization, surgical and procedural skill, detailed multidisciplinary attention to the timing of surgery, maintenance of hemodynamic stability, integrity of the coagulation system, and intensive care support. I just want to share, in the last 32 years, I had seen only one placenta accreta case. In the last 5 years, we have operated more than 55 cases. So that shows that incidence is on the rise. If you see that, it used to be 1 in 2,500 cases to 4,017 cases in 1982. Today it has come to 1 in 272 pregnancies. Somebody was telling scar pregnancy is rare. Don't say please. Scar pregnancy is quite common. Don't give. This is the example. Because Dr. Durgadas was presenting, there was a keynote address, so that's why I could not share some of my views on this. Cesarian scar pregnancy. My humble request to all the obstetrician and gynecologists, don't give any medical abortion drugs without doing an ultrasound. And this is a very important thing, because recently only we had to do one patient. She was a scar pregnancy, presented, taken after the mifepristone and misoprostol, came in shock. She was in DIC, lot of blood transfusion and hysterectomy could save her. So please, this is a message I am giving about cesarean scar pregnancy. Don't give medication for medical abortion without doing ultrasound, because the recommendation doesn't say that, but because of this higher incidence of scar pregnancy, it is quite common. Accreta is 75 to 78. Increta is, fortunately, these two are comparatively less morbid, and percreta. We have devised a stitch in increta and percreta, wherein you don't have to remove the uterus, because you have to take a bite within the uterus. So these are the risk factors. So please note that placenta previa, uterine anomalies, prior Caesarean section is the important factor. Prior Caesarean section, in vitro fertilization cases, please understand embryo transfer, ART pregnancies are challenging pregnancies. Please, those who are much involved in IVF, please be careful on these, because embryo implantations do affect an abnormal endometrial pattern, and there is an increased risk of placenta accreta and increta. Uterine surgeries, prior, elderly age, and most importantly, previous Caesarean and placenta previa. So this is what is, you can see, if as the number of Caesareans increase, the incidence of Percreta or Increta increases. So this is the message I wanted to give, that histopathologically the absence of Deciduea basalis is the criteria. But more importantly, I want to convey this message to all the OBGYN that why there is a torrential bleeding. Normally the uterus, the baby gets the blood supply from the spiral arterioles, which are the fourth division: uterine artery, arcuate artery, radial artery, basal artery, then spiral. But unfortunately in placenta or Cesarian scar pregnancy, when you are attempting to do MTP without diagnosis, moment your instrument touches, it torrentially bleeds, because this is the blood supply either directly receiving from the arcuate artery or radial artery, which has got a high pressure. So the flow rate is more than 150 ml per minute. So that's why within a fraction of time, like 5 minutes to 10 minutes, patient will be in the pool of blood and in shock. So that's why we must be worried about Cesarian scar pregnancy as well as placenta percreta. Left alone, the Cesarian scar pregnancy can move. It is a precursor of placenta percreta. So we should be careful on this. There are 3 grades, FIGO classification, grade 1, grade 2 and grade 3. What we are worried more is grade 3A and grade 3B, where it is extending beyond the uterine serosa. So this is a FIGO classification, you all know about it. A, B, C, or A is limited to the uterine serosa, B is it is invading into the bladder but not other organs. Clear surgical plane cannot be obtained, and this is the one which we cannot conserve the uterus. Where the bladder invasion is there, we cannot. Otherwise, the other ones where it is up to involvement, we can remove the segmental part of that and conserve still the uterus. So other pelvic organ invasion is stage 3C. So these are the diagnoses where you clinically suspect. All previous Caesarean sections, early ultrasound is mandatory. And secondly, a scar pregnancy or lower anterior implantations must be always thought as a scar pregnancy. If you diagnose scar pregnancy, counsel them, and we have a beautiful video of how to inject ultrasound guided the methotrexate and potassium chloride into the heart. So we have done quite number of cases on this, and we have been able to conserve. After that, you need to remove the isthmocele or the resect that weaker scar and can ask them to continue. So this is very, very important clinical suspicion. Most important modality is the ultrasound. So ultrasound has a very high diagnostic accuracy and specificity is almost about 96 to 98%. Only you find the help of MRI is in case with posterior placenta accreta or increta suspected or fundal areas. So gestational sac implantation in the lower segment, multiple irregular vascular spaces in the placental bed, and then these are the important things I just wanted to show you. The picture, the lower segment, you can see the bladder there, and these are the pregnancy which can move into the Cesarian or percreta. So this is where the Cesarian scar pregnancy implantation, and see this is how it is, we are going to make the diagnosis, how it is going to help us. So please note that abnormal placental lacunae, which are the, I will show you the video of these in the next few slides. Retroplacental thickness, hypoechoic area is lost here. Nitabux layer is lost and directly there is invading into the myometrium. So this is a very important thing you see there. If you observe there, see this is the point where the retroplacental myometrial thickness. If it is less than 1 millimeter, this is very, very important. Normally it is around 2.4. So this, if it is less than 1 mm, it is the one which should suspect that. So thinning of the myometrium, and see this uterine serosa bladder interface abnormality. You can see all these bladder abnormality, and this is the vascularity where it is invading into. So I am blessed with a fantastic sonologist colleague who can diagnose. Even MRI reports by the radiologist were not comparable to what the person who diagnoses this. So I just want to show that ultrasound diagnosis, accuracy of diagnosis is very, very important. There are 2 types basically, that uterus bulge will be there, and there is this utrovesical vascularity, hypervascularity, and subplacental hypervascularity, bridging vessels, placental lacunae, feeder vessels. So these all can be diagnosed looking at these areas. And please understand, this is how the vascularity will be. I told you why so much, and this is in the early pregnancy. I request everyone who is interested in this, there's a beautiful monograph by Robert Silver who has written on placenta accreta spectrum disorders. So there in scar pregnancy which continues, you can see there the video, and see, this is how we diagnose. This is a scar pregnancy, and this is the what we had injected into the potassium chloride, methotrexate. So loss of retroplacental tissue, see retroplacental loss, see blood vessel is very important, bladder and serosal demarcation is lost. So much vascularity you see there, it's amazing to see there. And these are the placental lacunae because there is a high flow because of the radial vessels, arcuate vessels, they feed this, so that is why it's very, very dangerous. And this subplacental vascularity is also very high. So if you look at this amount, you compare with the normal blood flow, and when you see this, and this is a per creta, see, look at that, bladder and placenta. And this is very important, and MRI is complementary, but it's helpful more in the posterior placenta. Biomarkers are on the experimental stage, and see the Doppler pattern, how it is in normal is non-pulsatile and velocity venous flow, whereas it is in invasive placenta, pulsatile turbulent flow. So management I am not covering entirely, but what should be important is to see that we should decrease the morbidity related to this. So there are different approaches. So timing of delivery, see, we have to balance between the gestational age, and most importantly ensure that the woman is more than 11 grams. So we routinely give the IV iron to ensure that the woman is not anemic. And number one, and number two is that we give the progesterone to see that uterus is quiescent so that they don't bleed, and always treat urinary tract infection. Urinary tract infection is the important cause for the uterine activity. Placenta previa placental bleeding is the infection which motivates the uterine contraction, and that leads to bleeding. The preoperative preparation is very important. To minimize the maternal morbidity and mortality, multidisciplinary team management, preoperative team meetings with review, imaging findings and operative planning to optimize the outcomes. To schedule the time of delivery at the best time where all the team is available, blood bank is fully functioning, your anesthetist team is there, pediatricians are there. To maximize the preoperative hemoglobin values, I told you IV iron is the best on this. Preoperative imaging, timing of surgery, early morning, preferably everyone is active, blood products must be arranged. And these are the things preoperative counseling plays a vital role. Team of preterm delivery, hysterectomy, obstetric hemorrhage, operative risk, preoperative placement of I don't clip the ureter catheter, but some do recommend on this, or balloon catheters in the vasculature, but we do internal iliac ligation after the baby's extraction, and we have done quite a few conservative procedures of segmental resection of that. So accreta team checklist, on the day of scheduled delivery, a preoperative checklist should be utilized to prepare the operative room and the team. Counseling about these risks, all about this must be explained. Please understand, in the era of today, government is also behind us. So we explain all this. This is a very important thing. And don't forget to do ultrasound and referral for ultrasound. What you want in previous Cesarian section and placenta previous should be seen. What we follow in early is our early pregnancy, low and anterior implantation of the gestational implantation, we are worried, and confirm the anti-scan, correct the anemia with parental iron, confirm at anomaly scan, counsel about the stay near and about the hospital, and prevention of infection and contractions and use of progesterones. Plan delivery at around 30, we are delivering at 36 weeks, but in US and Europe they deliver at around 34 weeks. Earlier if bleeding occurs, ensure hemoglobin is more than 11 grams. So this is how we have planned in our thing. We use the central line so that we don't overload, arrange adequate blood fluid, and vertical incision we were initially taking, now we are taking transverse incision. The most important thing is prerequisites like blood must be arranged adequately. So anesthesia preparation is very, very important. I am very happy to say that during the COVID time, one patient outside operated came and she was in DIC and shock. And because of the procedural delays of the testing and all, we lost one patient. Otherwise, we have not lost a single patient with this, and we have done four conservative procedures where we have saved the uterus, and in most of these we have done the peripartum hysterectomy. I thank you for the wonderful opportunity that is given. These are some videos were there, but I am not covering this. What is important to take home is pregnancy following a previous uterine surgery is you must suspect. Placenta previa with the previous LSCS, please carefully do the ultrasound. Earlier the diagnosis, better is the outcome. Ultrasound is the best mode. Need MRI sometimes, especially posterior placenta. Attempting medical termination of pregnancy in early pregnancy is also risky. Undiagnosed intraoperative, the abnormally invasive placenta is dangerous to handle in the periphery. And if you find that, close the abdomen and refer to the place where it is. And well-planned management will have the best outcome on this. And thank you for this. Please note this. Excellence is an art won by training and habituation. We are what we repeatedly do. Excellence, therefore, is not an act, but a habit. Aristotle. Thank you everyone for the fantastic opportunity. I sincerely thank the Bidar OBG Society and the BRIMS and all the Ksogians and my colleagues from KCOG. Thank you very much. Thank you once again, everyone. You have any questions, I'll be more than happy to answer.
Which is simplified so that it is understandable by everyone. And as we know, he has told there is, with the increasing trend of LSCS and also the ART techniques, we have to be alert. We have early diagnosis has better outcome. So, and he also has told why we must learn about this so that we will be prepared, and a team approach is what is very important. Institutional deliveries should be encouraged to deal with such patients. Thank you, sir. It was very excellent.
Thank you.
Sir, many patients come for termination in early pregnancy as early as 5 weeks when we like to give medical termination. So is it possible to diagnose Cesarian pregnancy at that so early stage by 5 weeks?
I just want to convey that 35th day gestational sac is visible in the ultrasound by transvaginal scan. So 5th week means 35 days. So the implantation you must see. There is a small ring you see. If it is near the fundus, don't have to worry. But if it is in the lower area, you should be worried about it.
But patients will not be agreeing to wait. So
no, don't wait. You just make a diagnosis and say that you are not a simple case. You are not fit for medical abortion. See, please convince. The convincing and counseling skill is with you. If they want you, they will listen to you. And please understand, counseling is a very, very important tool what we have got.
So that they only give the reports like placenta planted in the lower part. So it can be Cesarian, pregnant, may not be. It may also.
Madam, you want to take risk?
No,
I am just asking
ask you.
Because it is somebody's life. So if you want to be telling her that if it is not after 2 weeks, see, you are doing MTP at 5 weeks or 7 weeks. Even the MTP is permitted up to 7 weeks if you are giving medical methods. So no need to worry about another 2 weeks. And later on at 2 weeks, it will be very clear.
So we can wait and we can
wait. Please wait.
Sir, I think we can, when they give the report like this, the radiologist, better we should have a talk with them and we should specify what we want them to
that
see.
Is why I told when
that
you
is
send
very important.
When you send for referral for a radiologist on ultrasound in a pregnancy, please mention what are you looking in this patient, because generally you just send for ultrasound. Don't do that. I am interested about in these points, because even radiologists are not the best sonologists, I personally feel, because in these, I am not hurting any radiologist who is here, but we find more appropriate if you are trained your own colleagues, because MFM training will definitely help us. And that cross line Dr. Durgadas mentioned on the pregnancy, lower anterior implantations you must be worried about. And that is the message I want to give. Don't hurry to give medical methods. You want to lose the patient, it's not good from the obstetrician point of view. And patient is going to another doctor, you also convey that if you even go to other doctor, you better tell that the reason why you have deferred the procedure. That way even that other doctor will be also alert. So this was the medical representative who gave himself medication from his friend's company. The unwanted kit was, the pregnancy termination kit was given and this patient came in shock. So please understand, we have to, that is the message we want to give is, Cesarian scar pregnancy is a precursor of placenta accreta. So diagnose it early, and you want to terminate, give a simple injection, IM methotrexate is fine. We are showing that video of where to inject with the methotrexate. But after this, you need to do the procedure. This weekend I am doing one patient wherein scar pregnancy was diagnosed and she was attempted for MTP and which was incomplete and she was in shock. We just stopped that bleeding and after that we opened about 6 weeks later of the methotrexate. And then we closed that segmental resection and closed. After that, she is carrying now second pregnancy. Second one also we did cesarean and she is fine. Now it is a second pregnancy after that repair of the scar pregnant area. So please don't be in a hurry. Counsel, because we have reached 63 maternal mortality now. We want to reduce further. We should diagnose early. And pre-treatment of anemia before pregnancy reduces preeclampsia, PPH. Last time only I told how anemia can cause PPH. So let us prevent anemia before the woman is. See, we prepare so well for the Pahalgam retaliation from India, well prepared because we didn't immediately act. We waited for 10 to 12 days. So our pregnant woman nowadays, marriage is in India fortunately all women become pregnant officially after the marriage. So please treat that after pregnancy before they become pregnant and give IV iron. This is the best message. I see many obstetricians and treat them with IV iron. And even your mothers which are anemic, give them restless leg syndrome will disappear. So please check for iron levels. Iron deficiency anemia is a severe spectrum of iron deficiency. First iron deficiency happens, then iron deficiency anemia. So my aim is all placenta accreta patients must have 11 grams.
Cut off FCM during pregnancy.
I don't, madam, I even treat the patient with more than 12 gram hemoglobin. I do the iron indices. If they are deficient, we must treat that. Because if you want your next generation to be smart and intelligent, because the brain formation, networking, we are doing a study on IV iron versus oral iron and the impact on the neuroimaging. MRI scan of the pregnancy, we have done 50 fetal MRIs and we are looking at this, hippocampal development, which is an area of IQ and memory. And also, the autism is more common amongst the anemic women who are anemic in the first trimester. So we should treat, that's why I am insisting. I request all of you to read my article in Hindu on the treat anemia before the woman becomes pregnant. Hypothyroidism is the another condition. And third one is diabetes we should look before pregnancy.
Lecture. I have one question. Our patients are very smart. Go to the medical shop, they get these tablets and they take sometimes. And what is the move on this? Or how to curb this, sir?
Actually, if you have come that this patient must be made medical legal, MLC case was done and the police inquired about where this woman got the medication. And we as a Ksoga should bring this to the Drug Controller General of India, Karnataka, that this is what is happening. Medical method of abortion must bring a guideline now that it must be given with the prescription of the OBGYN, not by the general practitioner. Currently, a general practitioner also can give, so we should avoid giving this because we don't want to lose. This patient was nearly, we would have missed her. She fortunately 12 pints of blood products we had to give, and hysterectomy was done. You imagine on a Sunday morning this patient landed in our hospital. So please think about yourself. Giving a medication, medical abortion without doing a pregnancy is a criminal act. Thank you.
Hello, good morning everyone. Sir, you have covered the topic very well, and sir, I am happy to tell you that in last 8 to 10 months we have done almost 8 cases of adherent placenta accreta and percreta. 2 cases where bladder involvement was there, and with multidisciplinary team approach we have saved the patient, and as you have told, we have done internal iliac artery ligation after the baby extraction, and the patient went home without any complication. And as you have told, MTP drug should not be given. In Bidar, actually, we have, with the help of district health authority, DHO and everybody, we have seen that the MTP drug should not be given by the pharmacist, it should be with the consultant. So even I think it should not be prescribed also, because we have seen, sir, when we have prescribed the same chit they will take and they will go to the medical shop. So that is why we have taken some efforts, and to some extent the MTP, this unsafe abortion with medical method has come down in, sir. Thank you, sir.
Hello, good morning everyone. First of all, sir, I salute for your commitment and dedication towards teaching. Proud moment for me to chair this session for my guru. Thank you so much.
Thank you, sir. Timely diagnosis saves lives, and today's session has reminded us that. I now request the speaker and chairpersons to proceed to the gratitude desk for felicitation. I call upon Dr. Sushila Holkunde ma'am and Dr. Vijayshri Bashetti ma'am to felicitate speaker and chairperson.
We move on to the next session, Preventing and Managing Hospital Violence by Amol Annadate, Dr. Amol Annadate. Hospitals are meant to heal, not to harm. Yet today, more than ever, our healthcare workers stand on front lines, not just against disease, but against violence. Violence in healthcare settings is not just a breach of peace, it's a breach of trust. Today, let's explore how we can restore both safety and dignity. May I now invite Dr. Amol Annadate to share insights on the topic Preventing and Managing Hospital Violence. I request Dr. Shobha Gudi, Dr. Anand Rao and Dr. Shailesh Erolkar sir to chair the session. Now I call upon Dr. Priyanka to introduce our speaker and chairpersons.
A very good morning. Myself, Dr. Priyanka. I welcome our next speaker, Dr. Amol Annadate, sir. Sir is a pediatrician and neonatologist. Sir is a founder of Anand Group of Institute, which includes Postgraduate Teaching Institute, Vijayapur Academy of Higher Education. It includes Anand Multi-Speciality Hospital, Ayurvedic Medical College, Homeopathy Medical College, College of Physiotherapy, and College of Nursing. Sir regularly writes a leading newspaper like Indian Express, Hindustan Times and Dainik. Sir has, to his credits, 3 bestseller books. Sir is a famous orator and a motivator and is invited worldwide for famous various talks. Sir is a national as well as international faculty in medical conference. He is also the youngest recipient of prestigious Arogya Dhyaneshwar Award and Ramnath Goenka Award for Journalism. Sir runs an NGO, Das Trust, working for the betterment of health in rural area. Sir is a popular social media figure and active on YouTube with huge viewers all over the world. I welcome you, sir, and our chairperson. Dr. Shailesh Erolkar, sir. Sir is Director and Consultant of Sanjeevani Maternity Nursing Home at Udgir since 20 years. Sir is current President of Association of Medical Consultant, Udgir. I welcome you, sir. Dr. Anand Rao, sir. Sir is a pediatrician, past IMA President, IFP, Bidar branch. Sir is a consultant, Anand Rao Hospital, Bidar. I welcome you, sir. Once again, I welcome Dr. Amol Annadatte, sir. Stage is all yours.
A very good afternoon to everyone. Nice to have a pediatrician as a chairperson. So, two pediatricians joining hands among all prestigious obstetricians and gynecologists. Although today is Friendship Day, but a bit of paradox that I have to talk on a topic like violence, so that our hospitals become violence prevention friendly, I would say. So, sir was talking of Pahalgam, but I don't know how many of you realize that every month there is a mini Pahalgam happening in the hospitals all over the country, and many of the incidents even they are not reported. All senior people will be astonished that they must never have thought that a time will come that a 45-minute talk will be there on, meaning I think we have a senior most gynecologist sitting in the first row, but the time has come. And there is a 2017 study which says that 75% of doctors, so maybe rest of 25% I would say that they are not reported. So I would say almost 100% of doctor, if not physical, even a verbal abuse is also a form of violence. Mahatma Gandhi said that even thinking about violence is a violence. Here we are facing physical violence in and out every day. The history of this violence was not very common in medical field before 2000, but sometimes it happens in society that the trend is set. We say in meaning a thing that starts somewhere and people get instigated, and when they see, and one striking thing about hospital violence is that the conviction rate, please mind you, the conviction rate of hospital violence is 0%. There is not a single case in the entire country. We are talking of law. So law is not going to protect you. It is yourself, and probably this 45 minutes talk that will protect you if you are attentive in next 40 minutes. I know that this is non-academic, but if we are not protected, we will perish. So to practice academics, we should exist first. So I think in this jam-packed session of academics, the talk on hospital violence deserves a lot of attention. So Dr. Vasant Jaikar, a known physician, he was shooted by a relative who was admitted in ICU for around 40 days. He was shooted in front of his home. Dr. Jaikar madam is a pediatrician. She was from Nair Hospital, now shifted to New Zealand. And one striking incident, in 2001, famous politician Anand Dighe, who was guru of Eknath Shinde, the past Chief Minister of Maharashtra, when he expired, Singhania Hospital was in this condition, and it was totally shattered by a crowd of around 2,000 to 3,000 people. And Singhania Hospital is in the same condition today. I think it is a monument. It is a living monument of how a hospital violence can destroy a hospital. This is my friend. I took permission and he said that you show my photo. I thought that I should not show his photo. He said, Amol, show the world. And this doctor has lost eyesight in one eye. He has gone blind after an attack on a government hospital in Dhulia. So bad. So I think it is high time we all come to the terms, to the fact that yes, we are very vulnerable. Doctors can be attacked, and why only doctors? I am researching since such a long time. We have rich CAs, we have rich advocates, we have rich judges, we have rich politicians, but the anti-incumbency against a rich doctor is highest among all the people, because I think, meaning people don't like if they see photos of doctors' families having vacation somewhere in Kerala or Singapore. I think the reason behind that is people have a deep feeling inside that the earnings of a doctor comes out of sufferings of people, and I think that is the mentality that doctors are the most vulnerable among all the white collars. So what has happened in these last 25 to 30 years? Who has changed, doctors or patients? I think both have changed. The aspirations of a doctor from his life has changed, and the expectation of a patient from a doctor has changed. So I think time has changed. It is the time that has changed, and we have to change with this time. And as I said, if we don't change, we will perish. So patient no longer sees doctors as demigods as it was in previous time, but they see as mere service providers wherein they pay a money and they get a service out of it. So every patient can be a potential petitioner, and a gathering of around 3 to 5 people can become a violent mob. So you have to be very vigilant in your hospital about these things. So let us talk about now, since we are convinced that this is ultra important, very important, as the worst nightmare in the life of a gynecologist is a maternal mortality. But worse than that can be a hospital violence, which can deeply harm your self-respect. So ABC of hospital prevention: first is availability, second is behavior, and third is communication. Before going to the ABC, let us see common causes. These are the common instigating incidents wherein hospital violence is instigated or it happens in the hospital. First is sudden death of the patient. Either it can be expected or it can be unexpected sudden death. Expected sudden death meaning you have counseled the patient enough, and the patient is coming up, he is recovering, and then there is something that happens and there is sudden death of the patient. Second is patients are very smart. They know for which points the doctors are vulnerable. So when the discharge card is filled and the bill is produced, they start some planning to get away from the billing. So this is a very smart planning that is happening with the patients, that if we create violence, we will get away with that day, and then nobody is going to come to our home for billing. So this is a common practice. In fact, in Nanded, there was a racket of people which was caught by the superintendent of police and the commissioner, that they used to give offer to the patient that if your billing is 1 lakh, we will bring our people, create a scene, create a violence, and we will decrease the bill up to 60 to 70%, and you pay 30% out of that. This was a professional racket, professional thing officially going on in the society. Just think to what level people are going, and this is truth. I am not telling anything from my mind or anything imaginary. When a patient, serious patient, or a patient becomes serious and you tell the patient to shift, who is admitted for less than 24 hours, is a common cause for violence. Again, this is one case which will shock you, but I have seen a case. Planned violence by a rival. Please don't do this. Even if a thought comes to your mind, go to the Gurudwara and वहाँ मत्था टेको, माफी मांगो और घर आ जाओ. Never do this, and it has happened with a person who is known to me. So just to decrease a practice or to demoralize a rival, violence is planned at some doctor's hospital. So whenever a patient comes, these are 3 golden, I would say a bit cruel sentences, but you have to say them politely but very firmly. आपने आने में बहुत देर कर दी है. You are a bit late to come. Patient बहुत serious है. Patient is very serious. आप चाहे तो मरीज को बड़े अस्पताल में ले जा सकते हैं. You may take the patient to a higher center if you wish. I don't claim that I am best in the city. I don't claim that I am best in Bidar or Karnataka. You have a choice. If you want, you can shift the patient. Because these 3 recorded CCTV, audio, video recorded sentences will save you from a potential violence when a mob comes to argue with you. After that, fill a bunch of consent forms. I hope most of you must have taken loan. Do you remember how many papers you signed for when you took loan from the bank? And have you read all the bunch when you signed? And why loan is so much mentally pressurizing? It is because you have signed something which you haven't read. वो देते हैं ना, एक 40-50 पेजेस देते हैं फाइन प्रिंट में. So I think go with the same strategy, bank loan strategy, and take all the consents when the patient is admitted. One of my doctor friends, he told me, Amol, you are preparing an agreement for divorce when the couple is getting married. I said, yes, for patients, you have to keep the divorce papers ready when you are taking the patient in your hospital for admission. He said, Amol, what is this? What are you telling? Yes, this is the need of the day. If a bank can get signed around 250 papers from a doctor, when you are playing with, when we are saving someone's life, why can't you get signed at least 25 papers? And if the patient is refusing, refuse admission. Tell them, sorry, if you are not giving consent. I think you can take photograph, or I can share the presentation afterwards. You can share on your groups. There are different things that can happen. Very simple, guarantee of good behavior with female staff. Let them read. Let them read that if you are misbehaving, we have taken a consent and we are going to take action on this. In case of sudden death, first thing you should do is inform the police. Call and have a very good, I think I'm going to come to that point, that have meeting with the police commissioner, SP, the inspector of your area. Let the association have a meeting and tell them, give them some free checkups every year to the police families, and tell them that whenever there is a sudden death, you have to come and report to our hospital. As soon as the police comes in the uniform, 50% of the environment, it gets settled down. Because even now there is a fear of police in common people. Call for extra help from colleagues. Break news whenever there is a problem, whenever there is a sudden death. Just don't go out and tell that patient is no more. Break the news in a gradual way. Start resuscitation, and all these things should not happen that you are resuscitating the patient, something is happening, people are silent outside, they don't know anything, and then after 3 hours you meet them and you remove the gloves and you tell them, no, we have tried a lot but the patient is no more. No. One person from the team, he may be a non-medico, but train one of your staff for counseling who will go take the relatives, place a hand on their shoulder and tell that, see, this unwarranted situation has come up. Other doctors are also coming from help. Have patience, we are trying our best, and prepare their mind over 3 to 6 hours for a news breaking of a sudden death. I think news breaking is itself a very big topic of around 1 hour, and we doctors are very weak. We take granted कि अरे उसमें क्या है, ये तो होता है. No. Billing of a dead patient, it's very important. I have a policy in my hospital that once the patient has expired, you may produce the bill, give the bill, but don't force them to pay the bill. See, meaning it's not that there are 2 or 5 deaths in your hospital every day. It is going to happen some time or the other. So don't force them for billing. Let them go. Tell them that we have a policy that, but produce the bill, because not producing the bill will again create an impression that there was some major mistake and you are trying to cover up that. Tell them that it is your choice to pay. And I have seen that when you produce, there are many patients who pay the bill in fact. Shifting a serious patient. What happens is, when we shift a patient in emergency, show them that it is not your need to, you are not trying to get away, or what we say in medical college, bat the patient. Don't be aggressive. See, whenever you smell a violence, it is always better to refer the patient. So, and alert the city, put a message on the WhatsApp group that there is such and such patient who has created violence. So, tell them, convince them that it is for their goodness and not because you want to get away from the situation. About billing, I think most of you must be doing this, but don't talk yourself. The doctor should not be one who must be discussing the bill and the concessions. Tell them that I have a dedicated and people are bound to come in small hospitals, that thoda paisa kam karo, just give some concession. Tell them that I have a committed department who is dealing with this. I am a clinician. Let me do my work and keep a 5% margin for giving concession with the department too. The thing should never come to you. Appoint a very good person for negotiations of the billing. Let them sit, order tea, give them water, talk some other things from where they are, whom they know, and kill time in the discussion. When they come, tell them that we have a negotiation time of around up to 4 to 5 p.m. See, usually people who come from other places, they want to go home by 6 o'clock, and all the rickshawalas and vehicles, they are waiting for them. So around 6:37, tell them that we discuss all the billing in the evening after 6 and do the discharge in the morning. So you kill the time, and then patient will not wait and they will leave the hospital by around 6:30, as all the transport services, they close down by 7 o'clock. So these are all the strategies that you have to give, practice. About availability, it happens sometimes that we are over available and at times we are under available. So there should be, you should be striking a balance of genuine availability. About communication, some common things and common mistakes. It should be strictly in a room with audio and video recording, and mind you, it has happened in many hospitals that when you want the recording of the patient for medical legal purposes, you tell that, Arey, when that patient has come, he had come on 30 March, and your staff tells, sir, त्या दिवशी lightच नव्हती. So at least the audio video recording system, computer, it should have a separate backup, separate power backup, not at least generator, at least an inverter backup in case the central power supply goes off. We have a very good practice in our hospital. We have a phone which is dedicated to only for recording the counseling sessions, which is mounted on a stand, and we record the session. We take the mobile number of the patient and send the entire session. Even if it's a 10-15 minutes clip, it is very easy to send on WhatsApp, because relatives keep on coming. Sir, my cousin has come. Sir, this has come, and they want to listen the same thing again and again, and what happens is you get irritated telling the same thing. So what you do is you call them, show the phone, give them, open the recording and tell them, please listen this. Go outside and listen as many times as you want the same counseling session. Have a session with every family at least once a day. Wrong or loose communication at wrong place. When you come outside the ward round and one relative asks, how is the patient? And you say, ठीक आहे. ठीक आहे, it means he is ठीक for that time, but he is bad. See, we think that we have counseled him for the previous days and he knows that he is bad. I think I have 45 minutes. Yeah, 17 minutes. Yeah, 17 minutes have gone. I have a timer, so I won't cross. You should avoid communication by unaccountable staff. Your staff nurse, call them, take a meeting and tell them that nobody is going to tell the patient about the patient's situation. Only the main doctor and the designated doctor, only and only they will talk about the patient. Whenever you are explaining the risk, this is very important. Many times patients have small complaints that the fan is not working, the tap in the toilet is not there, or it is leaking, or there is no container in the toilet. These things are there. So please take this very seriously and make improvements and give feedback. Fill feedback form every day from the patient, because feedback form is the place where they can express their anger. Tell them whatever you want to write, you can write on that feedback form, so that they vent out their feelings, that the staff is very arrogant, somebody came and they talked very arrogantly to me. Call them, have a session and give and genuinely make improvements. And my practice is, whenever I get time, at least once or twice in a month, I just check the feedback forms, and we get excellent things that you are not watering the trees around, the flowers have, see, these are the things that, because patients are ideal, they are just sitting there watching here and there what is happening. So they will give feedback even about your dressing, that you are not tying your lace. They are excellent observers, and and people like to criticize doctors. So let them criticize simple things. If it is going to prevent violence and it is helping to vent out their anger against the doctors and the anti-incumbency, as I said, that the feeling that these doctors are enjoying, they see our family going in the Mercedes Benz and they see my patient is suffering and this doctor is going for a walk and he's going for a dinner with his family. So these are the natural feelings. After, as I said, select many a times a group comes, 15-20 people. So you can make out one person whose body language is nice, who is a bit empathetic. You select that person and you tell him that I will talk to you, give some importance to him, ask him you want to have tea or something, give him some importance so that he becomes your spokesperson for the entire family. Okay, so he will explain, tell them that I think that you are wise among all the members, I admire you. So his ego is also pumped. See, all these things helps, I think. Keep these boards everywhere. You are under CCTV surveillance. Even if your CCTV is not working, I request that it should be working. At least put these boards in your hospital for today itself. For visitors is a very big problem in every hospital. So keep visitors passes, limit at least meaning 3 to 5 visitors, and beyond that if the visitors are coming, we have a system that we charge 10 rupees for a visitor pass. So even listening with 10 rupees, they go have tea in the canteen and leave. It's better that they think that I spend that 10 rupees on serving tea, because anyhow you have to serve the relatives who are coming to meet. And I tell you, the person who instigates the violence is never the first degree relative or not even a second degree relative. The person who creates nuisance and tells that, "Arey, I know this doctor has created many problems in the past," is a neighbor's distant relative who has just come to do time pass there and who has no work. So this is the way you have to limit the relatives. I think we should have, like we have a intelligence department by government of India. We have developed a very good intel, develop a good raw in your hospital, intelligence, wherein they will smell the trouble. See, whenever there is a violent attack, it gets discussed somewhere or the other. So tell the staff that whenever you have such, because see, a violent patient is violent from the security guard, meaning a violent patient is a violent unless proved otherwise. He will start the nuisance right from the security at the admission counter, at the reception, at the hospital, that laboratory, everywhere. So many a times people, we have on our hospital group, immediately the staff tells, ki, "Sir, ha patient ni medical la gundhal gatlay." So that is an alert for you. So you have a separate protocol to treat him. So, and what we do is, we have a coding system. We have a red pen and we write H. H is a headache patient. We write a big H on the patient. So whenever you go on the rounds and you see the H, you are on a high alert mode. You check your heart rate, you check your language. Okay, so this is the H grading. I think like your whatever gestational score, you have developed this score, I think. Behavior, attitude while explaining. For residents, it's very important. I don't know whether we have some residents here. Because see, residents are already very much frustrated, and in that they are talking, meaning that female resident is talking with her boyfriend, she's planning something and she want to explain the risk. I think please don't do this. Mind your behavior, because it is a very serious condition for the patient. Be very empathetic. The sorrow of the patient should be visible in your eyes. Have a touch them, tell them that we are like your relatives. So I think there should be a very good training to our residents and doctors and everyone. Use of mobile phones, please restrict. You are talking, you are telling something and you are telling ki, "Arey wo Swiggy pe se utna mere liye bhi ek pizza order kar de." No, this is not done. Put your phone on flight mode or silent mode when you are talking, you are counseling a serious patient. Whenever I feel that my heart rate is going beyond 120 and I am becoming impatient, stop yourself and shift the communication to a calmer person. Tell them that I want a break of 5 minutes, and then let someone else take over. Or even if you take, we know there is a amygdala hijack, which can be settled in around 7 to 10 seconds. So at least take a 10 seconds break, have a glass of water, move around, and then again continue the counseling. Because see, people are, as I told you, patients instigate us. They have a plan to irritate us. Believe me, they know on what things you are going to get irritated. After explaining all the things, in our Marathi they ask, "But doctor, we tell that the patient is bad, he is on ICU, is ventilator," and then they will ask, "But doctor, तसं काही नाही आहे ना?" अरे बाबा, तसंच आहे, सगळं तसंच आहे. नाही, पण बाकी सगळं ठीक आहे ना? Patient is on ventilator. What do you mean बाकी सगळं ठीक आहे? So see, these are irritating sentences. So you have to deal very patiently. Behavior of staff is very important. Every 3 months, 4 months, give some basic instruction, have small training sessions for them for about behavior. See, simple rural sentences which are abusing to the patient. So using non-abusive languages, not saying "अरे" meaning "ए चल ग, ए चल ओटीत तुला बोलवलंय, ए काय झोपली ग." So this language is not done. What policy we have in our hospital, because you can have meaning which is good for your cultural practices, we call every patient Mauli. Mauli is, we have Varkari Sampradaya, you know. So we call everyone Mauli. Every patient Mauli, येता का? माऊली, थोडं शांततेत बोला ना माऊली. माऊली, आपल्याला ICU मध्ये नाही जाता येत, खूप गर्दी होते ना माऊली. So the Mauli sentence itself creates a sense of meaning belonging with the patient. Learn to say no to the patients when you don't see faith in them. This is very important. This is one app that we have developed, and we are in the process of making it finer. We have developed a software app which will be there in the entire city, every doctor, and please involve BAMS and BHMS doctors in also this, because they have better relationship with the patient. Please involve the general practitioner of your patient when he is bad. Call the general practitioner, make him sit in a VIP room, serve him a nice tea if it is afternoon lunch, and tell him that please help me in communication of this patient, as you know the family very well. So we have developed one app where we have a default setting that if whenever there is a violence, any of the staff or the doctor, if he just presses a button on the screen of the phone, a siren will buzz on the phone of each and every doctor in the city, and a location will pop up, and immediately, just don't see the location, go and rush for help. Because whenever there is a issue, and within 5 to 10 minutes, you must have seen rickshawalas. If you start arguing with the rickshawalas, immediately 20, 25, 30 rickshawalas come and they shield him and they tell, "Ha, काय चालू आहे रे, काय म्हणताय, तू बाजूला हो, मी बोलतो." So this is the trend that we should have in medical field. 50, 60 doctors gathering in 5 minutes is a terrifying situation for the relatives. Believe me, and I don't know when we will when we will do these things. Why we run away? Why we run away? And you never know when the fire will come to your home. This is the thing. One thing I think every place, every city should do. There are constant violent defaulters who have created violence at more than one places. Notify the names of these patients to all the hospitals, and although you may not refuse treatment, but tell them that you have created violence and this is not done. We are not going to take this in any way. As we know that all insurance companies, they do this. They delist the hospital from all the insurance companies for if they have done fraudulence with even a single insurance company. Having bouncers or a group of bouncers who are placed at somewhere, who are lodged at some place, is also a good idea. Having 1 or 2 bouncers, it will cost hardly 25,000 to around 30,000 rupees, 15-20,000 rupees bouncers, or you catch hold of a good bodybuilder, you support his nutrition, give him protein powders, something, and tell that you work with me as a bouncer part-time at least in peak hours. And yes, for big hospitals, they have started this practice, and we have to, meaning because the time has come, meaning as I said, की वेळ चांगली नाहीये, माणसं चांगली असतात पण वेळ चांगली नसते. That is the problem. This is a modified code gray, wherein whenever there is a violence, you should have a huge alarm which can be heard on all the floors, all the places, and as soon as the alarm rings, all the staff, like we have a fire alarm, we should have a alarm for which I call as modified code grey, and a place should be designated wherein the assembly point for violence, and you write this in the hospital and let the patients understand that if something is going to happen, all the staff is going to gather here, and have a mock drill about the violence, as to which staff is going to do what. One staff is going to inform the police, one staff is going to click the button of the app which will ring to all the doctors, one staff is going to the staff who are a bit aggressive, they are going to take the charge. All these things we should do. There should be, I think there should be one WhatsApp group. If you don't have the app, that is okay, app is a very long story. At least have one dedicated group for notifying violent incidents in the city, and no happy birthday, no election, no vice president voting, nothing on the group, only message of violence. Pin the group, keep it up, and as soon as the message comes on the group, please rush to the hospital. Kolhapur, Dr. Abhyankar, Kolhapur model as I call it, they have done a very good thing. They have prepared a group with the local police station, the superintendent of police, commissioner of police, and as soon as there is some problem, even the commissioner and the SP gets the message, and few people come, and whenever there is a change of bar, whenever a new SP comes, whenever a new commissioner comes, they call the police people and they train them about this WhatsApp group. I think this is thing that we can do. Display of law and photos in the hospital. Next time you wish birthday to your colleague, don't give him bouquet or any gift, just give him this photograph. I give it to many of my doctor friends, and make a rule that in Bidar every doctor will display this photograph in huge letters. I'll read it in English because this is in Marathi. No physician, this is about great Alexander, King Alexander. This is photograph of King Alexander. When no physician was ready to treat Alexander the Great due to fear of punishment for failure, after the king issued an order that no physician would be punished if I died, they agreed to provide the treatment. Have good relationship with police, media, collector, politicians. I think call them in between for meetings, discuss the problem, tell them that if there are going to be violent incidents, this is going to be our action, and then we are not going to be in a mood to listen to any of you. I think mix with the societies, shed allergies for public programs, at least the representatives of the association, they should go for the major programs, any religious ceremonies, and make a presence and tell them that we are part of the society. Have staff from all communities so that on the festivals, your hospital doesn't have a deserted look. Like Diwali, all the Hindu staff goes, at least Muslim staff is there. Eid, if the Muslim staff goes, at least the Hindu staff is there. A common response that I see from doctors is strike, and I have never seen, I am against all these IMA strategies of strike and black ribbons. You are wearing a black ribbon. What nonsense. Who notices that? Who notices? The people even don't know that you are wearing a black ribbon on your thing. So these are all, I think these things are just creating a perception that we are doing something and they are not going to yield result. Strike, it will get more public dissatisfaction and more hospital attacks. Yes, if you want to do a strike, it should be a nationwide, just do a single day nationwide strike. But it should be so strict that all the countries, prime ministers and presidents should tweet that we request the doctors of India to stop this strike. Are we ready for that level of strike? If you want to strike, strike it so hard that the country breaks down. And if you are not going to do it, just don't do any natak. Just don't do it. Because it is, meaning I feel it becomes a laughing stock and nothing more than that. There is a strike meeting in the IMA and the wife of the IMA president is attending patient in the OPD. How the things are going to work? So I think this, I feel bad. So that's the reason I become so aggressive when I talk about these things. As I said, black ribbons, political representation and nuisance value is very important. And I feel that one doctor from the city, he should be funded in a small way by every doctor, and he should contest the election. He may lose, he may sacrifice his deposit, but at least you have a political representation. And I promise you, if you file, if you are going to file papers for the contest, all the political leaders are going to come to you and tell you that please don't do this, we will help you when you are in problem. So I think let us think about some ways, let us do some brainstorming wherein we have a nuisance value in the society. And at the same time, we have to pressurize government, bureaucracy, police, judiciary, media, everyone. This is Dr. Datta Samant, who was from my alma mater, and he led the biggest labor organization and the famous Girni Kamgar Sampa in Mumbai, which lasted for 15-20 years and which is a big story in the history of organization. And he was from KEM, GS Medical College, my institute, and he always said that workers join forces, building unions that yield real power. Doctors and intellectuals, too often divided, leave their unions frail and ineffective. Friends, I think it is the time that we all forget our intellect, follow a single leadership. See, what happens is when too many intellect come together, everyone is thinking in a different way, and so they never come together. So when we are coming together, just keep out your brains in your OPDs and follow whatever the leader says as it is done in the army. Only then, he may be wrong, your leader may be wrong, you may think of changing him after some time, but follow one single path that is given by the leader. And I think that it is a time we think when and how we will be taken seriously by all the system, police, judiciary, politicians, the rulers, everyone. Also, let us check our own moralities if we are going wrong somewhere. And in the last, I would say that silence of the truthful and the principled is more harmful to this world than heinous acts of the devil. So always don't be silent, raise your voice, protect ourselves, protect our fellow doctors, fellow beings against medical violence. As my idol, Hindu Hriday Samrat Balasaheb Thackeray, when he formed the Shiva Sena, he said that Aika ani thanda basa or Aika ani petun utha. That means don't just listen to me and sit silently in your hospital. Listen and arise and awaken against this heinous act of hospital violence and act in your own way and give a thought to the organization, whatever you feel. Thank you very much, friends.
Thank you, Anmol sir. You have a wonderful talk, but some words will disagree regarding the IMA. Because I request all the specialty doctors, first they should join the IMA. IMA is our mother. Afterwards, you can join your specialty and super specialties. As you told, most of the specialty doctors, they are not regularly or irregularly coming for the IMA out India. That we have to rectify. Then only you become the very strong body. We have to force the central government to implement the non-bailable warrant. That should be 7 years. Nowadays, state government are also giving 3 years. After the bail, he will come afterwards. Again, he will attack for our personal things. That's why should be very strong, and also should join the hands with the IMA. Is not a bad association. Will protect us.
Sir, yeah, I think I am misunderstood. I am a part of IMA Maharashtra. I am very active in IMA Maharashtra. I am never said that it is bad. But I think some strategies of IMA, sir, need to change. and I think it will change when we join hands, as you said. Definitely, we have to be very aggressive when something like this, and there are very good examples wherein many IMAs IMA Ratnagiri has done very good work. As I said, IMA Kolhapur. So we should have a very good action plan to protect our doctors from the law. Sir, as I said, there is 0%. Sir, people are not getting convicted even after gang rapes in India. What about hospital violence? This is the condition of Indian law. This is a fact. This is a fact. We have seen recently the case in UP where the 11 gang rape victims, when they came out of the court, they were garlanded and a procession was carried out. This is the condition of Indian law. So I think we have to protect ourselves. IMA has to take, I'm not saying take law in hands, but IMA, whenever there is a single attack, the action should be such that no attacks for next 100 years in the country. And I have a plan, sir. Please call me to Central IMA. I will give the plan and I will personally execute. I will be in front, because these, as I said, I am not against IMA, but these black ribbons, sir, they're not working. I'm sorry, they're not working anymore. People don't recognize these, meaning even what is happening, they even don't know. So we have to do something which creates a long lasting impression that this will no longer be taken by the doctors and by the IMA. I'm right, sir. Meaning, and definitely we all should attend meetings and we should join IMA. I'm of the
force the central government for the strong 7 years non-bailable rule.
Yes,
that is the most important. Then only the people will not attack on the doctors. It will come down definitely. Thank you, sir.
Hello. Yeah, it was a nice comprehensive talk given by you. It's a burning issue, and presently all doctors who have faced violence, who have not faced violence, there is always the fear in the mind that the next day or the next day, someday it may be you. And this fear has to go from our minds, and the ways you have suggested are good one, but my experience since last 25 years I am practicing, and in a small town like Udgir, what I am saying, why we have come to this pass. We see that the faith in the doctor community is going to the drains now. Nobody believes in the doctor. In front of us, they tell that you are a good doctor, you have good skills, everything, and behind your back, what they are talking, everybody knows. It all boils down to sudden loss and billing. These two things are there. And one more thing, what I think, in my experience, the celebrities who come on TV and give shows, they paint all the doctors in such paints. I don't name the celebrity, everybody knows.
No, sir, Amir Khan, I will name him. No problem. Yeah.
The media who are the supporters and bandwagon with them, the politicians, even the judiciary, they have a biased views towards the doctor community. Everybody is against us, everybody knows that, and every day there is some adrenaline push, and this is creating a havoc in the doctor's health. And they are mentally more fatigued than what they are doing. Exactly. And this is the actual situation today. And what you are suggesting is very good. But in practical and in implementation, I think there is a problem. Whenever a mob violence occurs anywhere, and even if there is no mistake of that doctor, still he is under so much pressure, so many doctors collect. Then also, if you call the police, if you call a local politician, they are all bystanders. They say you first settle between you and then we'll see. And this is the problem. Nobody wants to take a helping hand to the doctor, and doctor is left to fend for himself. And then the problem comes is out of court settlement. We'll give this much money, we'll give that much money, and he wants to come out of that. And this is how the situation is at present. I want to have your views on this. What do you have to do? Out of court settlement is a better option, sir, or you should go to the courts?
Sir, first thing, never go for out of court settlement. And as I repeat again, the conviction rate, even in our hospital, there is a case which is going on, which is, I am not going to, as I said, they are going to give you offer. And as you said, sir, the court conviction, you don't go for out of court settlement. No, meaning meaning there is no second opinion about that. But I am a very practical person. The court conviction rate is going to be 0% at least for next 100 years, looking at the situation now. So I think the most, as you said, that why the police are bystandards, why the judiciary is bystandards, why Amir Khan is a bystandard. When Amir Khan was talking against doctor, have we taken a single action telling him that no, you and your family is banned in the entire nation from treatment if you feel that we are unfit? Let him go to court. Let him go to court and fight against us. No, this is not going to happen. And as I said, see, ours are very small places. At least we have a local nuisance. In my place, there was a very big attack incidence. So we went, I personally, along with 100 doctors, went to the family of the patient, and we tell them that you will not be entertained at the doorsteps of entire fraternity of our place, Vaizapur. This created an impact. I think that, see, it is a mind game. Please believe me, it's a mind game. Till the time you create a terror, terror is a cruel world, and I'm sorry to say I have to tell that because the time has come, as I said. Till the time you create a planned nuisance and a planned terror which is planted in the subconscious of the people, that this will not be taken and it is going to harm us in a very bad way, these incidents are not going to stop. People have become very aggressive. People have no fear of law. They have fear of only one thing, and that is nuisance, nuisance and nuisance. That's the thing that I was trying to tell. If you want to create nuisance on the politicians, as I told, why we are citizens of India, why can't we have a member of IMA contesting Vidhan Sabha and Lok Sabha elections in the entire nation? Let them lose. अरे एक बार लड़ो तो सही, लड़के मरेंगे यार, ऐसे क्यों मरेंगे? शेर के बच्चे हैं. Sir, please, if you are active in IMA, please put this. I am going to contest the coming election from my area. I am going to contest. This will create, and आप जब चुनाव के लिए आप पेपर्स डालेंगे, सब पॉलिटिशियंस आपके पैर पड़ेंगे और बोलेंगे आपके ऊपर हल्ला नहीं होगा. This is the way. I have given a very nice action plan. Please execute it. I am going to execute it in my way. Thank you so much. Thank you so much.
Thank you.
Safety in healthcare is not optional, it's essential, because only when doctors are protected, patients are better cared for. Thank you, sir, for this fantastic presentation. I request our speaker and chairpersons to proceed towards the gratitude desk for felicitation. I call upon Dr. Prakash Korwar, sir, to felicitate our speaker and chairperson.
We'll start with the next session. In this world of maternal medicine, few topics are as delicate and complex as pregnancy in women with beta thalassemias and all hemoglobinopathies. Today, we bring light to this critical intersection of genetics and obstetrics. Even blood, which is very fluid, which will sustain life, when it becomes the source of risk, the pregnancy will be is a very high risk pregnancy, and the journey is very bad. So, to explore how beta thalassemia and hemoglobinopathies impact maternal and fetal outcome, we have with us Dr. Manjula S. Patil ma'am to enlighten us. And I request Dr. Usha Doddamani ma'am, Dr. Shivgeeta ma'am and Dr. Vrishali Banale to chair the session. Dr. Pallavi will be introducing our chairperson.
Good morning to all.
Dr. Manjula Patil Madam, she is a consultant obstetrician and gynecologist at OM Hospitals and an endoscopic surgeon. Madam is working in the field of OBG for last 20 years. She was a secretary of Chikmagalur OBG Society in the year 2017 and 18. Madam has a keen interest in preventive gynecology and have conducted many school health program, radio program and Facebook live news article on cervical cancer prevention. I would like to welcome Manjula Patil Madam. Let me introduce our speakers, Dr. Usha Dodmani, our chairpersons, Usha Dodmani Madam. Madam is a professor and HOD at JIMS Kalburgi and Honorable Secretary of GOGS 2024-25. Dr. Vrushali Banale, she is a consultant obstetrician and gynecologist at Ganga Hospital, Kokak. Dr. Shivgeeta Madam, she is a consultant obstetrician and gynecologist at Shiv Sai Hospital, Chincholi. Over to you, Madam.
Sorry for interruption. I call upon Dr. Shailaja Talwade ma'am, Dr. Sangeeta ma'am to felicitate our surgeons of the workshop, Dr. Siriak Papachan sir, Dr. Jaiprakash Patil sir and Dr. Anna Sahib Birajdar sir.
Good morning, ladies and gentlemen. First things first, hearty congratulations to whole of the OBGYN Society of Bidar as well as BRIMS faculty. It's been an amazing conference that we are looking. I bring notice from greetings from OM Hospital, Bengaluru. And we all know, I just want a sort of an opinion poll. How many of you are actually screening for thalassemia in pregnancy? Can someone raise the hands? I can hardly see 3, 4. So I am here basically today to ensure that how important it is. I know the moment we see and then everybody thinks I think it is a setup or it is a sort of practice that happens in Bangalore or the metropolitan cities. But then I am here to give you evidence what it should be. So my topics go along these lines. We all know thalassemia is a global disease. Not even any developed country has zero, but then there are very few places where it has been zeroed down, majorly a thalassemia major, and that's what we are aiming or achieving for. What exactly are these hemoglobinopathies? These are basically genetic disorders which are associated with autosomal recessive inheritance that affects basically a globin chain of a hemoglobin. And then 7% of the world population carry abnormal hemoglobin gene. There are about 3 lakh to 5 lakh born annually with a significant hemoglobin disorders, and then unfortunately majority of them, especially born in India, they may not even see their 20th birthday. I know nature has given a disastrous disease, but it is preventable. What is the irony behind it? Even now, every hour, there's one thalassemia major child is born. And then I am here to say that we need to really act because we as the OBGYN people are the people who really can make difference with this respect. That's why we need to really act, and then hopefully by the end of my session, I should be able to impress all the OBGYN people here enough that we start implementing these things. Going to a little basics of this. We all know red blood cells has a hemoglobin, which is an oxygen carrying molecule, and then there are about 4 iron content in the center which are interlinked by 4 globin chains. Okay, depending on the type of hemoglobin, these can be alpha or these can be beta. So in adult hemoglobin, these are basically, there are 2 alpha globin chains and then 2 beta globin chains, and in HbA2 it is alpha 2, delta 2, and then in fetal hemoglobin it's alpha 2 and then gamma 2. So in the adult hemoglobin, this is one number that probably we need to remember. There's at least about 96 to 98% of alpha 2 beta 2. HbA2 should be less than 3.5%, and then fetal hemoglobin should be less than 2%. Coming to a little into the genetics, because since this is an autosomal recessive disorder, so these are also single chromosome disorder. So the gene coding for the alpha globin chain is located on chromosome 16, and then for beta it is located on chromosome 11. And it is depicted by alpha globin is depicted by about 4 genes, and then beta by about 2 genes, carried 2 by each parent. So based on this, the classification, again these defects can be either the quantification defect, that is where the number of globin chains are reduced, or they can be qualitative where the number remains same. But then the structure, there is an alteration in the amino acid which leads to a structural abnormality, and thus it gives a picture of a iron deficiency anemia. So of the quantitative defects we have alpha thalassemia as well as beta thalassemia, which what exactly this alpha indicates, that is reduced alpha globin chains. So similarly beta indicates a reduced beta globin chains. Depending on the number of these gene deletions, so these can happen either a gene mutation or a gene deletion or a defect in the gene itself. So depending on the number of these gene deletions or the alteration that happens, they can either be a silent carrier. In alpha thalassemia silent carrier, as such they won't have any symptoms and it's very difficult to detect also, but may not even be required as well since they don't carry any major significance. But if there are 2 gene deletions, they will lead to thalassemia minor or trait, and if it is 3 gene deletions, which will be a major disease associated with the severe anemia. 4 gene deletions per se, they won't survive because alpha is a component of all type of hemoglobins. That's why it is only the intrauterine, and the majority of them will be diagnosing them as a non-immune hydrops. Similarly, in beta thalassemia, we categorize them as minor, intermediate as well as major. Coming to the important aspect, though the topic given to me is management of beta thalassemia in pregnancy, but then I felt this is more apt time for me to address this basic issue of screening for thalassemia. Because we know we are the OBGYN people are the one who come across a girl coming in the pubertal age group, girl coming in the premarital state, preconceptional state, and in the antenatal period as well. So we make a significant impact by implementing our screening, and then I'll be able to really convince you that it is must and should. So anytime when it comes to a screening, we need to be asking ourselves whom should we be screening and when we should screen and then how to screen. So the first aspect, whom to screen. With respect to thalassemia or hemoglobinopathies, is it selective only high risk screening or is it universal screening? And I am not quoting anything about the developed countries recommendations, either ECOG or Green Top guidelines, but then I am going to our own FOXY guideline. There's a GCPR in 2025. In fact, hemoglobinopathies are the first among genetic disorders for which a national policy for prevention and control has been framed. So 2025 GCPR on the universal antenatal thalassemia screening and diagnosis of thalassemia in India. But then the interesting fact here is this GCPR has taken a major data from what government has done that way back in 2016. So with the idea of elimination of sickle cell anemia and thalassemia major, they had conducted a huge studies and then came to a conclusion that screening is must. So what exactly the GCPR guideline says? Hemoglobinopathy carrier screening must be offered to all previously untested. So that also indicating that we have already missed them earlier. So previously untested women, irrespective of identifiable risk factors. So it is not risk factor based, it is universal. If preconception screening has not been performed, testing should be conducted early in pregnancy, preferably at the first antenatal. We all know we do a routine blood test in our first trimester. So this has to be a part and parcel of that. And other important thing is, since it's being autosomal recessive disorder, so both partners should preferably screen simultaneously. So the expert panel strongly recommends a strategy combining universal screening, accurate carrier identification, genetic counseling, and antenatal diagnosis to be an effective strategy to reduce thalassemia-related morbidity as well as mortality. And in fact, what is the ideal test? HPCL, that's a hemoglobin electrophoresis, is considered to be an ideal technique to screen. So now we very well know it's not just by FOXY, it's in fact by Government of India under Rural National Health Mission that universal screening is recommended. But then let me tell you why universal screening. So these are basically for 3 things. One, because of its autosomal inheritance, recessive nature, because any individual can be carrier and then may not be having any symptom at all. But then what is the impact of that in a successive offspring? And the second other thing is basically a burden of the disease that India is having with respect to hemoglobinopathies. And third important thing, regarding the cost benefit analysis, I'll just let you know. Since it is an autosomal recessive disorder, if husband and wife are carriers, there are 25% chances that baby can be a thalassemia major. And then treatment with thalassemia major is pretty much restricted, limited as of now. And then there are 50% chances that they can be a carriers. If an individual, obviously if a thalassemia major pregnant woman is there, we very well be knowing about the status. But then if at all, if she is married to a person whose status is not known, imagine a scenario. So if the other person is normal, then there are 100% chances the offspring will be thalassemia carrier. But if he is already a carrier and the status is not known, 50% chances that babies can be thalassemia major. Believe me, if at all, if you have delivered one baby whom later diagnosed with thalassemia major, you'll definitely feel for it for whole life, and I had one. So, coming to the disease burden in India. In fact, we are a major hub for thalassemia major. Across the globe, 1 every 8 thalassemia carriers reside in India. And we have about 1 to 1.5 lakh cases, which is about 100 times the developed world. And we have about 40 million carriers, and unfortunately, even today, every year, 10,000 to 15,000 thalassemia major babies are born. So what are we here for? Basically, we need to make this number zero, and that's practically possible only we as OBGYN people are committed towards screening of thalassemia major. So India is a world capital of thalassemia. Coming to the, I know, being OBGYN people, we are too bad at maths, but then I'm trying to just make it pretty much simple and then check. The cost of treatment of thalassemia major is simple. It is basically a blood transfusion. But then how simple is it? Blood transfusion happens right from their birth. Our requirement will be once every 2 to 4 weeks. And what is the impact of that? Huge load of iron in the body of a person who is receiving. So iron chelation is one of the also of the important part of treatment. So the cost of transfusion as well as chelating a child of 30 kg per year will account to about 2 crore. And then we all know about 10,000 to 15,000 babies are born with thalassemia major. So how much it costs will be about 200 crore. And Government of India looking at all these things, they have done a study way back in 2008 that was under NHM mission that was done in Uttarakhand, where they screened 1 lakh population, and what was the cost of that screening was 1 crore, which is about 200 times lesser than the treatment of for 1 year period. That's a very reason I reiterate want my point that please go ahead, at least if not universally, at least a person coming with iron deficiency anemia, make it a point to screen for thalassemia, so that we won't see a world where there will be thalassemia major babies. So when to screen? Again, at newborn, if there is a sickle cell major, we'll be able to diagnose. But then let us use the opportunities if anybody is coming in the pre-pubertal age group, and then now we are pretty much aware about the cervical cancer vaccination. So please use that opportunity in adolescent age group, preconceptional, and again premarital if there's somebody coming. As I told you, the very important information that we want to give to the couple, if somebody is a thalassemia major, screening a partner is must. It is like having a green card. Get married to a person who is normal, not a carrier, because 50% of your babies may not see their 20th birthday as well. So that's again the very important. And if it has not been done in any of these phases, at least let us use our first trimester to screen for thalassemia. So how to screen? I know I've been doing many things, but then of this recommended even by the Government of India is HP electrophoresis, that is high performance liquid chromatography. Coming to the management of pregnancy with thalassemia major, with respect to minor, it is nothing major. It is like treating a mild to moderate anemia patient and nothing different from that. But when it comes to thalassemia major, we divide for a management purpose, that is as a phenotypic classification of all these thalassemia people into transfusion dependent thalassemia and then non-transfusion dependent thalassemia. Transfusion dependent thalassemia are basically thal major as well as some of the thal intermedia come into that category. So what exactly is a concern? As I previously said, the huge amount of iron that gets deposited into their body because of once every 2 to 4 weeks of blood transfusion is a concern when somebody is planning for pregnancy. That's why it has to be a very well planned pregnancy. We all know any medical disorder for that matter, we want them to be in optimal health condition when they plan for pregnancy. But more so for thalassemia major, their optimal condition has to be 3 months prior to their pregnancy. They should be in ideal state of their health when they plan for pregnancy, not just prior, 3 months prior. That's simply for the reason this excessive accumulation of iron can get accumulated in majority of the organs, including hypothalamus pituitary. They may have a difficulty in conceiving, for which for conception they may even require a gonadotrophins. And other thing, it can get accumulated in thyroid, leading to significant hypothyroidism, accumulation in liver, leading to in fact hepatocellular failure as such or significant cirrhosis. And even the accumulation in cardia is a major issue where there are chances of cardiac failure during pregnancy, and even they'll be prone for a diabetes mellitus. So this management per se includes a multidisciplinary team, and who are all a part of this team? Basically a senior obstetrician, hematologist, cardiologist, diabetologist and an endocrinologist. So our purpose in the pre-pregnancy is, as I told you, to reach their optimal health, and important aspect there is basically a chelation. That's because, as I told you, all the iron accumulation is going to cause a major problem with respect to that. That's why we should ensure that either a zero iron in those particular organs, or at least the least possible reaching to a safety level. For thing being, we won't be able to do a chelation in the early pregnancy till 20 weeks because they are not considered to be safe, and then the associated complication they tend to have. So we will be basically screening for all the end organs, including thyroid, liver, cardia and islet cells, basically leading to diabetes screening as well. So the role of cardiologist is basically they'll be doing a baseline screening with respect to doing a ECG, echocardiography, and then to assess the amount of iron in cardia, they'll be doing a T2 cardiac MRI. And if there is a reduced ejection fraction, if they notice, it is a relative contraindication for the pregnancy. So there are various numbers that they give when you think of accumulation of iron with respect to in cardia. So value has to be less than 10 mm/s is associated with a pretty much increased risk of cardiac failure. So it has to be targeted more than T20 of 20 milliseconds. And similarly, we have for liver, we will be assessing in terms of milligram of iron present per gram of a dry weight of a liver, and then the target value has to be less than 7. So we will also be doing ultrasound of liver, gallbladder to rule out cirrhosis, and then like any other pregnancy we should be. So in a nutshell, what all the investigation that we want to do? The routine investigation that we do for any woman, plus basically a cardiac evaluation, liver evaluation including the ultrasound as well as the assessing the amount of iron that is present in all these organs. Vaccination again is an important aspect. Earlier days, especially if it is a sickle cell crisis, there will be autosplenectomy because of the very disease itself, and then it was a routine practice to even do a splenectomy. So we need to check that whether they have taken all these vaccines with respect to the disease. Just 5 minutes I would take. Coming to the iron chelation therapy, these are the drugs which basically combine with the iron and then help in their excretion. Of the three are the most common drugs used. Of these, only desferrioxamine is recommended in pregnancy. The others are absolutely contraindicated, and this also is not started. It should be stopped even 3 months prior to pregnancy, and it can be started only after 20 weeks of pregnancy. And this is a subcutaneous or an infusion injection. So there is no, and how often are we giving? It's like almost all the day patient is in a hospital. 5 days a week they should be on a chelation. Antenatal checkup with respect to the obstetrician, the frequency of checkup is like any other, except that they are at a higher risk for FGR. That's why 24 to 28 weeks and beyond, we need to be doing a regular scans to know their growth. Again, hemoglobin has, our transfusion level has to be such that HB has to be set at 10 and above. A role of thromboprophylaxis, yes, they do require. Coming to the intrapartum care, the only important difference I would say, patients in Thal major have to be on a IV infusion chelation throughout their labor. Is there a role of Cesarian? No, it's only indicated for obstetric reasons. Continuous electron monitoring like any other cases. And then yes, prophylaxis, thromboprophylaxis soon after vaginal delivery as well as Cesarian is pretty much recommended. And chelation can be started soon after delivery since it is safe during lactation. So to conclude, effectively implemented prevention and control program can successfully bring down the birth of children affected with thalassemia major to 0. So what are we aiming at? To number 0. Thal major 0. I mean carriers fine, but then at least the thalassemia major should become 0. Harder screening is essential, as I've already told you why we should be screening. Pre-pregnancy aggressive chelation is must for optimal outcome of pregnancy, and multidisciplinary team involvement is the backbone of management. Thalassemia warriors paint their own canvas of resilience, turning every challenge into a stroke of bravery, because we have many of them presently. Thalassemia is not the end of the story, it's the beginning of a narrative filled with strength, hope and triumph. So finally, I would like to close my talk with a saying by Steve Jobs: the people who are crazy enough to think they can change the world are the ones who do. And then I want all of them to be one amongst these, to reduce and then make our thalassemia major cases to a number 0. Thank you everyone.
Everybody. Thank you, Dr. Manjula, my friend, and it was an excellent talk and more information on the complex topic that is the thalassemia. Most of us are not doing this screening in our clinics, but I hope from this talk onwards, at least all of you are aware what is the burden of the thalassemia major in the society. So would request all of you to carry on the screening, and especially the guidelines what you have put up. So they are very useful for the day-to-day practice. Thank you.
And probably since it is there in the government guideline itself, we may have to take it forward through involvement of a local politician as well, that these can be implemented, because as per the government rule, every district hospital should have a facility for thalassemia screening. HB electrophoresis should be available in every district hospital. Forget about a medical college.
I think a wonderfully delivered talk, very short and very accurately given, so that there was less confusion for us.
Thank you.
And conferences like this will really remind us that where we are lacking, because I think a few years back nobody was doing TSH as a thyroid screening, and now every one of us is bent upon it. So thalassemia is such a sad disease for the parents, for the children, and losing children at 20 or 18 is sad, and we really need constant reminders like this. I think with this is a very well selected topic for the conference. Thank you very much for this lovely
Thank you, Ma'am, and Brin Society for that.
One more thing I wanted to add in this was, we are not screening the patients, but we are able to see that recurrent iron infusions are not helping the patients also. Such patients, I think, should be screened for HB electrophoresis for thalassemia.
Yeah, as I told, at least initially if they're mild iron deficiency anemia also, please make it a point to screen.
Yeah, and this is one of the things that repeated iron transfusion is not improving hemoglobin.
Yeah, it will worsen rather in them.
Yeah, can be a point wherein we have to think why, and thalassemia can be the cause of it. I feel this, at least at that point, we have to do for HB electro. It was a nice presentation. Thank you.
In rural places where I am practicing, patient coming with severe anemia, repeated, we started screening for thalassemia.
That's really nice to know.
Thank you, ma'am.
And CBC, I think all of us are doing. So at least see the RDW and Menzer index. If it is not given there, let us calculate and then go ahead. At least for those people, we can still think of going ahead with the thalassemia.
Sometimes the patient may be having the hydrops fetalis, non-immune. How many of us are screening for the thalassemia or alpha thalassemia for the cause as hydrops fetalis? So we just, after this pregnancy, we don't think that we need to screen, so that the next pregnancy, she can be treated, identified and treated. So I think even the hydrops fetalis also you have to think of, non-human especially, that that might be the one of the cause for hydrops fetalis.
Yes. Shula, madam, it was a wonderful talk and very informative.
Thank you, ma'am.
To tell you everybody, I am Dr. Ashrata Mallapur from SN Medical College, Bagalkot. We have Thalassemia Society and we have enrolled about 100 children who are suffering from thalassemia, and we give free treatment for these children. Our management gives about 60 lakhs per year for these patients, and I'm really very happy to tell all of you that we have Thalassemia Society. You can send if the children are there, we will enroll them and give free treatment. Thank you so much.
Yeah, many of the medical colleges, I mean, when I was preparing for this topic, I end up listening to people. I mean, the kids, they themselves come and say, give me whole blood, give me PRBC. I had too many reactions last time, please give me PRBC. And this is the state of affair. I thank Uma ma'am and their whole team for this wonderful conference and for giving me this opportunity. Thank you, ma'am.
Thank you, ma'am. May I now request our speaker and chairpersons to proceed to the gratitude desk for felicitation. I call upon Dr. Rajlakshmi Chanda ma'am and Dr. Rajashri Biradar to felicitate our speaker and chairperson.
Moving on to the next session, monitoring of Rh negative pregnancy. To guide us through this essential topic, we have with us Dr. Renuka Dolin. Let us warmly welcome ma'am to take us through the monitoring protocols in Rh negative pregnancies. I request Dr. Radha Sangvi, Dr. Rita D, and Dr. Prakash Korwar to chair the session. I call upon Dr. Sunanda Bacha to introduce our speaker and chairpersons.
Good afternoon, everyone. Our next speaker is Dr. Renuka Dolin. She is consultant obstetrician and gynecologist and menopause and fertility coach at ESIC Medical College, Bangalore. Madam is online certified menopause coach at IMS, trained in laparoscopy and fertility workup in 2006 from BACC Kamini Rao Fertility Center and B. Ramesh Laparoscopy Hospital, Bangalore. His expertise in using digital platforms to spread CME and women's health awareness. He is speaker at multiple public health forums and women's health panels. Madam is founder ACE Gynec Health and Healing Private Limited. She initiated Motion in Lotion campaign to promote muscle health in menopause. She developed simplified educational reels and trackers for women aged 35 to 60. This podcast host for perimenopause journey in English and Kannada. We welcome you. Our next chairperson, Dr. Prakash Korwar, sir, is Director and Senior Consultant at Ashwini Nursing Home, Bidar. Sir has more than 35 years of experience in the field of high-risk obstetrics and infertility and has innumerable gynecological surgery experience. Next chairperson is Dr. Radha Sangvi. Madam is Professor and HOD at Raichur Institute of Medical Science. Madam has done many national and international publications. Madam is involved in national and international clinical trials. Our next chairperson is Dr. Rita D. She is Professor and HOD at Navodaya Medical College, Raichur. Madam has more than 30 years experience in various medical colleges, training both UGs and PGs. Madam was awarded as COVID warrior. She is interested in high-risk pregnancy and emergency obstetrics. Madam is International Journal Advisor. I welcome you all, ma'am. Welcome you. Dr. Renuka Dolin, ma'am.
Yeah, Dr. Renu here. Let me begin with few simple questions. Have you ever seen perfectly healthy first pregnancy followed by an unexplained stillbirth in the second pregnancy? Did you know that only tiny D antigen can trigger a lifelong immune war between mother and her unborn child? And did you know that a simple injection, anti-D, given at the right time, can prevent this completely? Yes, welcome to the world of Rh negative pregnancy. I bring warm greetings from ESIC Medical College and Hospital. The world of Rh negative pregnancy. In 1940, Landsteiner and Weiner discovered this antigen. The antigen was found in rhesus monkey and hence named. The individuals with this antigen are called Rh positive, and if you are not, it's Rh negative. The incidence is around 5 to 10% in the Indian population. So monitoring of Rh negative pregnancy is a hope. This presentation outlines the essential aspects of monitoring Rh negative pregnancies, covering Rh incompatibility, potential fetal risks, recommended screening and management strategies. The presentation agenda is understanding Rh incompatibility, screening protocols, management strategies and postnatal care. The clinical importance of Rh incompatibility in pregnancy is the prevalence that complicates the pregnancy is 0.5% to 0.9%, and risk without anti-D prophylaxis is around 16%. So the chances of developing allo immunization if no anti-D is given is around 16%. If it is sensitized, the 2% of mothers are sensitized at delivery and 7% become sensitized within 6 months. The remaining 7% in the future pregnancies. If it is ABO incompatibility, then the risk drops to 2%. So what is this Rh negative pregnancy and the key concepts we should know? Before it was Rh negative or the rhesus monkey when the antigen was found, but the CDA method is now included in our topic, where it includes 5 red cell antigens as it is, and D antigen is the most potent immunoglobulin that appears early in the pregnancy. So father's genotype matters a lot here. If he is heterozygous, 50% chances of Rh negative child, and homogeneous it's 100%. So if D antigen is absent, we call it is Rh negative pregnancy. Why Rh? I told it's the current practice is the CDA method. So what is allo immunization? An immune response triggered in an individual of one species when exposed to allo antigens from another individual of the same species which the recipient lacks. The two key stages are here: sensitization and immunization. And common causes, we know that mismatched blood transfusion and pregnancy, where the Rh negative mother carries an Rh positive fetus. The early detection of Rh, the fetal Rh and blood grouping is, the antigen is detected as early as day 38th of post-conception, and the fetal grouping can be done as early as 9 weeks. The non-invasive testing, the gold standard, is cell-free fetal DNA in maternal plasma that offers safe and non-invasive the alternative. The pathophysiology of allo immunization is the ABO incompatibility and clearing of these red cells, fetal red cells, and maternal immune response. So if mother and fetus share the same ABO blood group, the Rh positive fetal cells that enters the mother circulation can trigger immune response in whole lifespan. But there is a clearance with our reticuloendothelial system, releasing the antigen during this breakdown. The maternal immune response happens when the production of antibodies against these red blood cells, and the antibodies can cross the placenta, destroying the fetal red cells, leading to hemolysis and fetal anemia. What are the factors that influence this allo immunization? So immunologically, non-responders are around 30%. So they do not mount an immune response, and there is a limited antigen antibody transfer. And if it is ABO incompatibility, there is a rapid removal of fetal red cells, preventing sufficient immune stimulation. And there is again a antigen variability. So differences in fetal antigen expression and the maternal immune response variability also. So differences how the maternal immune system reacts to the antigen. And we know the extent of feto-maternal hemorrhage. The amount of fetal blood mixing with the maternal blood matters a lot. So what are these sensitizing events? We know the antepartum events, first and second trimester miscarriages, ectopic pregnancy, and procedures like chorionic villus sampling, amniocentesis, fetal blood sampling, and the procedure like external cephalic version, and even in the abdominal trauma. So what are the investigations? The first visit of our patients, we do the grouping and typing. So the Rh negative grouping of husband is also done, where if he is Rh negative, the case is closed. And if he is positive, the further investigations are very much necessary, and detection whether the woman is already been immunized to Rh antigens is also detected, and we have to forecast the likely impact of this on the baby and anticipating the management, the potentially to know that whether a baby is affected or not. So what is about this father's Rh status? If he is positive, then we know how to manage, what titers has to be done in the pregnancy, and if he is negative, then no need to worry. What is this screening test? The antibody screening. In addition to determining the Rh status, an antibody screen, that is indirect Coombs test, is performed. This test detects the presence of pre-existing Rh antibodies in the mother's blood, and if antibodies are present, it indicates that the mother is being sensitized, and Rh is ICT positive and ICT negative matters here with the screening. So what is exactly this sensitization process? With the first exposure, the fetal Rh positive blood cells enter the maternal circulation during pregnancy or the delivery or any other procedures, and the antibody production. With the mother's immune system, there is anti-D antibodies, that is sensitization. With the subsequent pregnancy, the pre-formed antibodies cross the placenta and attack the fetal Rh red blood cells. So what are these consequences? The hemolytic disease of newborn, and why this first pregnancy is usually not affected? Because the sensitization takes long time. However, the subsequent pregnancies with Rh positive fetus face increased risk. So we have to know the hemolytic disease of fetus and newborn that occurs when maternal anti-D antibodies cross the placenta and attack fetal red cells and causing fetal anemia, jaundice, hydrops fetalis, and potentially fetal death in severe cases. And what the screening of Rh incompatibility is initiated in the first prenatal visit, and about antibody screening with ICT test, and we have to know about even the paternal Rh status, then fetal Rh genotyping. This is the one where the analysis of red cell-free fetal DNA in mother's blood to determine the fetal Rh status. The fetal RhD genotyping is a non-invasive test that analyzes the cell-free fetal DNA in maternal blood and can be performed as early as 10 weeks of gestation. And it determines the fetal Rh status with a high accuracy and allows a targeted management as early as possible. And we know this unsensitized, if it is Rh negative, if it is ICT negative, then primary goal is the prevention of Rh sensitization. It's a routine antenatal immunoglobulin, anti-D immunoglobulin, that is administered approximately around 28 weeks gestation, that provides passive immunity against fetal Rh positive cells. And postpartum, you know, within 72 hours after delivery, if baby is Rh positive, we prevent the sensitization from delivery related hemorrhages, and Rh immunoglobulins after sensitizing events of any antepartum hemorrhage, ectopic pregnancy, amniocentesis, abdominal trauma, all that is needed. What is this immunoglobulin? It is an passive immunity that prevents mother's immune system from recognizing and responding to the fetal Rh positive cells, so that may enter the circulation. The dosage depends on the estimated volume of feto-maternal hemorrhage and can be quantified using the Claire-Betke test. The sensitizing events require all like miscarriage, what I explained earlier, the invasive procedure, abdominal trauma, ectopic pregnancy, and antepartum hemorrhage. This Claire-Betke test is one quantitative test. It's a laboratory test that the amount of fetal blood is in the maternal circulation following the potential sensitizing events. So it determines the appropriate immunoglobulin dosage, and the standard dose covers around 30 ml of fetal blood, and if additional doses are needed, we do if there is a larger hemorrhage. So the management strategy followed here in sensitized Rh negative mothers, the initial antibody titer, the first visit, we consider her blood grouping, Rh typing, and ICT test. The serial monitoring is so crucial because regular checkups of antibody titers throughout the pregnancy and the gold standard, the MCA Doppler, non-invasive ultrasound test to detect the fetal anemia starting at 18 to 20 weeks. And intervention decisions has to be made according to the MCA Doppler. The antibody titers in sensitized mothers, if it is ICT positive, the increasing titer indicates higher risk of HDFN. The criteria, the titer typically are 1:16 or 1:32 depending on the lab, but rising titers warrant us the increased fetal surveillance. And however, the titers sometimes won't reveal that, they won't correlate directly to the disease severity, and sometimes necessity to have other monitoring methods. What is this middle cerebral artery and peak systolic velocity in a MCA? This MCA PSV indicates the fetal anemia, and it can be performed as early as 18 to 20 weeks, and it's a non-invasive ultrasound technique. And even we consider amniocentesis for fetal assessment, as it is a traditional method and it's invasive. It detects the bilirubin level in amniotic fluid and indicating the fetal hemolysis. Less commonly used, as we are considering and we are referring our patient to the fetal unit, MCA Doppler, as it is done and as it is introduced, we consider it as a gold standard, and it is a specific case where the MCA Doppler is inconclusive, then we do amniocentesis. But it carries the risk of pregnancy loss, infection and preterm labor. Regarding management, the intrauterine transfusion. So the procedure where we have considered there is an increased titer, there is fetal anemia, and we are shifting the in utero to the fetal unit. The procedure where the transfusion of Rh negative red blood cells directly into the fetal circulation, typically via umbilical vein, and it indicates the indications are mainly the severe fetal anemia when there is a MCA Doppler PSV is more than 1.5 multiples of median. The risks are, the relative risk of this procedure is mainly the fetal bradycardia, hematoma and sometimes preterm labor. So benefits, definitely it's a life saving, but severe anemia can be and it can be repeated after 2 to 3 weeks till we get into the maturity. But the fetal unit where we are referring, we need to talk and refer patient to the best. So what is the management? Depends on the severity of HDFN. If it is mild, then we definitely have the delivery at term, close monitoring and the Cesarian section, or if it is preterm, if it is severe and moderate. So early delivery may be necessary if intrauterine transfusion facilities not available in our setup or in the city or where. So the complications sometimes arise, and we do have a complete team to do that. When I was in resident in a Jipmer Medical College, I have witnessed a blood transfusion, intrauterine blood transfusion, and we had a good team work in the fetal unit that we could save, I feel, around 2 cases in my 2 years of residency. Management protocol is again, if it is preterm, if it is any indication, then Cesarian section. But for premature termination, we need to know about lung maturity and especially the obstetric indications. But what is do's and don'ts? The careful fetal monitoring during intrapartum, gentle handling of this uterus during Cesarian and delivery, and early cord clamping. What about don'ts? We know to avoid ergometrin and avoid manual removal of placenta. And postnatal management, we know the newborn is arrived and we do a direct womb test and cord, blood type and Rh status determination. This direct womb test detects the maternal antibody on baby's red cells. The assessment of anemia, jaundice and hepatosplenomegaly and monitoring of bilirubin level. So the treatment options, as we know, phototherapy, exchange transfusion, intravenous immunoglobulin and supportive care. So determining this dosage of Rh negative again depends upon the hemorrhage volume, clear Bedke test report and appropriate dosage. So should we have this administration? Definitely when the baby is Rh positive. And we know these all are the sensitizing events, monitoring antibody titer with a test in a negative pregnancy, the initial antibody titer, then serial monitoring and risk assessment, and again severity correlation. Which method to use? Again amniocentesis or MCA Doppler is again in our hand, and the factors influencing delivery is the fetal anemia, maternal health, the gestational age of fetus, and medical interventions. So management again it's action, monitoring and sensitizing mothers. So what this fetal anemia assessment has with the titers? The managing against early screening, RH immunoglobulin prophylaxis and fetal surveillance, and should we do intrauterine transfusion is again with the unit available fetal monitoring, all that. We do know that navigating this RH negative pregnancy is updated because we have in a era of prevention of this allo immunization, and we know the monitoring and management of this affected pregnancy. The crucial part is early screening and the postnatal care also. So rethink and why we should have this universal immunoglobulin. So there is a limitation. I read in many articles that there is a limitation of availability of this universal RH immunoglobulin. So it is costly and dependent on the donor blood. The blood product risks like virus transmission has administered even when the fetus is RH negative. So it's a thing to know like what next. And the non-invasive prenatal testing is a cell-free fetal DNA from maternal blood, and we know that accurately it screens about the RHD status and it reduces unnecessary immunoglobulin injection by 40%. So towards targeted immunoglobulin use, the universal NIPT adoption under the review of ACOG and continued use of cord blood typing for the postmortem. And I end with this, that I had a opportunity to present this and I am very thankful to the office bearers and for this opportunity. Thank you.
Over to the chairperson.
Collaborative. Thank you, madam. Thank you, Ksoga team, Bidar, for giving me the opportunity to chair this session.
An informative topic was RH negative was not much, but now all patients are aware of the RH negative and they will tell. And then the RH negative I3 ನಮ್ಮ husband ಏನೈತ್ರಿ ನೋಡ್ರಿ ಏನಾಗ್ತದೆ ಅಂತ they are aware, because nowadays because the incidence also increased RH negative nowadays. So we have to give the, because they will read before coming to the hospital, they will go through the Google and they will ask all the questions to us. So we should be able, anyhow you have covered all the information regarding the RH negative. Thank you. And I especially thank the Bidara Obstetric Society has given me this opportunity. Thank you very much.
I got two questions. First is that 20 of this prophylaxis should be one doses or one doses, 28 and 34.
Yes, sir.
So you have mentioned only 24.
Yes,
What is
sir.
your advice for common?
Yes, sir.
What we should give, 28, 34, two doses or one dose?
Sir, we in our hospital we consider 2 doses at 28 weeks and again at 30, 34. Yes,
and,
sir.
and the prophylaxis, the MTP before 12 weeks.
But we in Bangalore we have a fetal unit to be referred, and we do consider this MC and PSV. Then depending on that we manage.
Some say 12 weeks, 1 week, 6. When we should give NTD prophylaxis.
Anti it depends on the ICT test, sir. But prophylaxis we give at
immediately after abortion.
Abortion, sir. Immediately, sir. Immediately we give.
Weeks, cut off weeks.
So I'm not able.
In which patient we should give? 6 weeks,
Loud,
8
sir.
weeks. 6 weeks, 8 weeks, 10 weeks, cut off. You
Like
followed my
as
point.
early as possible, sir.
But I'm asking. 6 weeks, 8 weeks. When did you? You followed? Huh? What I am asking you, okay?
Yes, sir.
If the, what is the cutoff for giving NTD in an abortion case? Whether it is, if a patient is of 6 weeks, as per Google or as per books, 12 weeks, they say.
Yes, sir.
So what we should do, your advice? Cutoff?
Sir, cut off, I feel like six weeks, sir.
6 weeks.
Already the circulation has started.
6 weeks.
Yes, sir.
Less than 6 weeks, no need.
Sir?
Less than 6 weeks, no need of NTD.
Yes, sir.
The patient has got previous history also, we have to note that one, no?
Yes, sir.
Repeated previous recurrent abortions is there. Then we have to consider which week the patient had abortion, and then we have to consider that. Thank you.
Oh, madam. Actually, hello. Madam, can you hear me?
Yes.
Sir wants to ask whether before 12 weeks we need prophylaxis or after 12 weeks only we need prophylaxis. So, I think before 12 weeks 150 and after 12 weeks 300 we have to give.
The dosage I couldn't mention here. Yes, it is considered as 150 and 300.
Thank you, ma'am. A true life-saving protocol. I request speakers and chairpersons to proceed towards the gratitude desk for the felicitation. I request Dr. Lalitama ma'am to felicitate our speakers and chairpersons.
Lalitama is my PG friend and she is my relative also. That's why I request requested and asked.
We move on to the next topic, iron isomaltoside, by a game changer by Dr. P.K. Shah. To guide us through this science and clinical application of this noble iron preparation, we have with us Dr. P.K. Shah, sir. I request Dr. Aarti Sharma, Dr. Rekha Rajendra Kumar, and Dr. Nalini Namoshi to chair the session. I call upon Dr. Rajeshri Biradar to introduce our speaker and chairpersons.
Thank you. It's an honor to introduce Dr. P.K. Shah. Sir is Professor HOD Department OBG, Sudha Medical College Hospital, Kota, Rajasthan. He is Professor and Unit Head Department, LTM Medical College, LTMG Hospital, Sion, Mumbai from 1991 to 2008 and St. G.S. Medical College, KEM Hospital, Parel, Mumbai from 2008 to 2016. His achievements are, he was past president, FOXY, IAG, IFUMB, MOX and AFTT. He was past dean, Indian Medical College of Medical Ultrasound in 2015 to 2016. He was past chairman, Imaging Science Committee, FOXY. Past chairman, ISO PERP and West Zone. His Lifetime Achievement Award by FOXY in 2024. Lifetime Achievement Award by Mumbai Breastfeeding Promotion Committee 2014, Mumbai. So today's session's chairpersons are Dr. Aarti Sharma. She is a senior consultant, Sagar Maternity Home, Kalburgi, and honorary associate professor, MRMC, retired district family planning officer. And Dr. Rekha Rajendra Kumar. She is medical and clinical director at Chandana Hospital and Miracle IVF, Bangalore.
Thank you, Bidar Society, Uma Deshmukh Madam and the team for giving us this opportunity. We are chairing this session and chairing session of Dr. P.K. Shah, sir. Over to sir.
Thank you very much for your kind introduction. At the outset, let me thank the office bearers of Ksoga and Bidar OBGYN Society for having me here at BRIMS Bidar to talk to you on injection I3, a game changer. What is I3? The first I is intravenous, second I is iron, and third I is the salt isomaltoside. But when I tell you, I'm going to give you some hints of 5 important things at the end of my talk, you will remember and take it back home. The normal hemoglobin is not 10, it is 11. For getting our patients ready for operation, we give hemoglobin 10 to the anesthetist so that she is made fit. I think that is wrong because 10 to 10.9 is mild anemia. Please remember that. Lancet confirms that an international study of over 3 lakh women across 29 countries, including India, pregnant women with anemia are twice as likely to die during or shortly after pregnancy compared to those without anemia. How we diagnose? Very simple. Remember one thing, hemoglobin if it is less than 11, and the second thing which you must do in all cases of iron deficiency anemia is ferritin level. If the ferritin level is less than 30 microgram per liter, it is evidence of depleted iron stores. So just now you heard of beta thalassemia and all. Remember, they don't have depletion of iron stores. They are always more than 30. But here, when you talk about iron deficiency, this is the most important thing. How many of you do routinely levels of ferritin for anemia patient? Please raise hands. Let me see. 1, 2, 3, 4, 5. And maybe few here. I think that's very shocking. You must do ferritin level for any case of iron deficiency anemia. All of us know the low serum iron less than 60 mg per deciliter, elevated total iron binding capacity, microcytic anemia with MCV less than 80, and typical peripheral smears that we all know. Now, what is the choice of management of these cases of iron deficiency anemia? It all depends on severity of anemia and tolerance of the therapy chosen. It includes medical nutrition therapy, deworming, oral iron, parenteral iron, and blood transfusion if it is severe. Only 1 to 8% of iron is absorbed from available oral iron preparation and never go beyond 160 milligram of iron per day. What are the factors affecting oral iron absorption? The dose that you give, status of the patient's iron stores, the form administered, stability of gastric acids, elemental iron that is chosen, and the bioavailability. Now, if you are given oral iron to a patient with the hemoglobin response less than 1 gram per deciliter after 2 weeks of oral iron therapy should be considered for transition to intravenous iron. Don't change over to some other brand of iron. Please remember this very clearly. And we all know what are the problems with oral iron: GI side effects, poor absorption, non-adherence, and slow improvement in hemoglobin. Therefore, parenteral iron is seen to be an attractive option in treatment of iron deficiency anemia. So what are the indications for parenteral iron? Poor tolerance to oral iron, poor absorption, non-compliant patient, women with moderate to severe anemia near term, women on recombinant erythropoietin, and you must keep in mind contraindication. Now remember, if you want to give intravenous iron, please stop oral iron at least for 24 hours. Once you are given intravenous iron, you can start oral iron after 1 week. Ministry of Health and Family Welfare, Government of India says that there is no need to give oral iron after giving full dose of intravenous iron. What is most important is that when you're giving intravenous iron, your diagnosis of iron deficiency anemia must be 100%. No evidence on the use of IV iron in first trimester of pregnancy. Remember that. Don't give it in first trimester. How much do you give to a patient? 2.4 multiplied by the deficit, that is the actual hemoglobin of the patient and the hemoglobin you want to achieve. Suppose it is 9 grams and you want to bring 11, that means deficit is 2. So 2.4 multiplied by 2 is 4.8 multiplied by weight of the patient. Forget about pre-pregnancy. Whenever she comes, whatever is her weight in kg, suppose it is 50 kg. So 4.8 multiplied by 50 is 120 plus 1000 milligram of iron for replenishment. Remember when we were residents many years back, it was only 500 milligram. Now replenishment of the iron stores, you have to give at least 1000 milligram. So a patient with 9 grams, you want to bring it to 11, you will give at least 1120 milligram. There are 3 generations of parental iron. First generation iron dextran, we have given it, we have stopped giving it. Please do not give it anymore. Second generation iron sucrose, patients had deaths. And third generation, we have 2 ferric carboxymaltose and iron isomaltoside. The strong type of complex is ferric carboxymaltose and iron isomaltoside. I am showing you this slide to tell you that please do not ever give intramuscular iron. If the hemoglobin is more than 10 but less than 11, ferritin less than 100 nanograms, you start oral iron 100 milligram per day, give for 4 to 6 weeks. If the hemoglobin rises by 2 grams per deciliter, continue. If not, straightway go on to the intravenous iron. Now, we all know we are given so many irons like iron dextran. It has got carbohydrate shell in the form of low molecular weight dextran. Ferric gluconate has gluconate. Iron sucrose has sucrose. Ferric carboxymaltose has carboxymaltose. And this I3 has isomaltoside as carbohydrate shell. What is the importance of this carbohydrate shell in parental iron? Every parental iron is complex with carbohydrate moiety which holds the iron till iron complex reaches liver and spleen. Stronger the complex, safer is the parental iron because it will release less labile iron. What are these labile irons and how are they harmful? Labile irons are free ions released from iron complex after intravenous administration. Since these are free ions, they are responsible for effects like hypotension, during intravenous infusion, hypersensitivity reaction, oxidative stress and cytotoxicity. And this labile iron potential is least with iron isomaltoside, that is I3. As you can see on the left side is iron sucrose maximum labile iron, one on the right side moderate, whereas I3 has minimum amount of labile iron. Please look at the one which is highlighted in blue color. The maximum single dose that you can give of iron sucrose is 200 milligram. Ferric carboxymaltose maximum you can give is 1000 milligram, but I3 you can give up to 1500 milligram. Why I am saying this? Suppose the hemoglobin is 7, you want to bring it to 11, you will have to give 1480 milligram of iron to that patient. You can give in one shot whatever is required for that patient if you have I3 available. It was introduced in 2010 in Europe. DCGI approval came in 2013. It is approved by US FDA in January 2020. It is third generation intravenous iron. Now, what is the mechanism? Parental iron isomaltoside is absorbed by reticuloendothelial cells of liver and spleen. Splitting of this iron complex occurs by reticuloendothelial cells in liver. The iron binds protein and forms ferritin and replenishes iron stores. Now I'll just tell you a few minutes on iron sucrose versus iron isomaltoside. Iron isomaltoside you just require one visit, whereas iron sucrose patient will have to come multiple times. Hemoglobin increase from baseline for I3 is about 1.5 grams after 2 weeks, whereas it was found to be 1.2 grams for iron sucrose. Proportion of responders with hemoglobin increase more than 2 grams per deciliter was almost 30 to 33%, whereas it was only 21% with iron sucrose. 68.5% of patients had increase of hemoglobin more than 2 grams for I3, whereas it was 51% with iron sucrose, and it took 26 days for I3, whereas it took 37 days for iron sucrose. Iron sucrose can be given maximum 200 milligram, not more than 3 times per week. Doses must be at least 24 hours apart, whereas I3 can be given 20 milligram per kg for more than 1000 milligram in a single visit up to 1500 milligram. Now what about the one that we are using now, the ferric carboxymaltose, and compare it with I3? I don't know whether you've seen each one of these slides which I'm going to show you. Is publication is shown at the top. Drug safety, there is a high risk of hypophosphatemia with ferric carboxymaltose. Ferric carboxymaltose, even in one sitting, causes raised fibroblast growth factor, which leads to reduced phosphorus level, reduced vitamin D level, and reduced calcium absorption, leading to hypophosphatemia. Look at this, JAMA 2020, 10 times higher incidence of hypophosphatemia with ferric carboxymaltose compared to isomaltoside. 7.9%, 75%. No change was found in vitamin D and calcium homeostasis with iron isomaltoside compared to FCM, Journal of Nephrology 2012. Now, read the one which is in red. They compared isomaltoside versus ferric carboxymaltose, an indirect treatment comparison as far as cost is concerned. The objective was to use indirect treatment comparison finding to evaluate the cost effectiveness of I3 isomaltoside versus ferric carboxymaltose. Analysis showed that using iron isomaltoside rather than FCM in patients with iron deficiency anemia would reduce the number of iron infusions required to correct iron deficiency, thereby reducing the costs associated with IDA treatment. It is almost half of ferric carboxymaltose. It costs you 1700 milligram or 500 milligram vial. Please remember this, which is almost half of FCM. Iron deficiency anemia correction can be done in single visit with I3. It is not only used in obstetric and gynec but also in renal diseases, inflammatory bowel diseases, gastroenterology, oncology, cardiology, and perioperative care. Now what about IDA, whether it can be used during pregnancy or not? Yes, all three, whether it is isomaltoside, iron sucrose, carboxymaltose, all are category B, safe during pregnancy. The risk of serious or severe hypersensitivity reaction was lower with I3 compared to FCM and iron sucrose during pregnancy. The higher doses of 1500 milligram is safe in pregnancy as per the experts review hematology in 2020. International Journal of Transfusion Medicine result supports convenience, safety, efficacy of a single high dose up to 1500 milligram infusion of intravenous iron isomaltoside for iron deficiency anemia during pregnancy. What about postpartum period? A very good paper, if you have time, please read this. Journal of Maternal, Fetal and Neonatal Medicine 2019. Intravenous isomaltoside treatment for women suffering from severe fatigue after postpartum hemorrhage. A single dose of isomaltoside is associated with a statistically significant and clinically relevant reduction in aggregated physical fatigue within 12 weeks of pregnancy. When I was at KEM hospital before I retired, we used to do hemoglobin 24 hours after the delivery. If it was less than 10, each one of these patients was given 1000 milligram of either FCM or I3 and were sent home. This made a lot of difference in these patients' performance at home. I don't think we ever ask these patients when they come back, whether do you feel fatigued at home or not. We ask, by acha hai na? If she doesn't tell you any complaints, you take it for granted that she is absolutely all right. It is not actually right. This is a very good paper. Please read it if you have time. Now what about International Journal of Gynecology and Obstetrics? 2 times higher iron was found in the maternal milk when the mother was given injection I3 compared to any other iron preparation. Vox Sang 2017, postpartum anemia study shows intravenous iron could be an attractive alternative to RBC transfusion. Remember this, in severe postpartum anemia, if you are in a very remote place, you don't have a blood bank, by the time the relatives bring you blood, you can give injection I3 to this patient. Please remember what I am trying to tell you. The total dose per week should not exceed 20 milligram of iron per kg body weight. To evaluate the effect of intravenous iron treatment, hemoglobin level should be reassessed no earlier than 4 weeks. Repeat hemoglobin after intravenous I3 after 4 weeks. Please remember this. Isomaltoside should be infused either undiluted or, if you ask me, diluted in sterile 0.9% sodium chloride, 100 cc, if it is up to 1000 milligram. If you are going to give up to 1500 milligram, then 250 cc of normal saline, you can put this and give it to her because of the stability reasons. Now we all know when to give blood and what are the problems with the blood transfusions. So you can always give, instead of blood, injection I3. To summarize my talk, ladies and gentlemen, intravenous iron use in women of reproductive age has increased rapidly. I3 is the only intravenous iron that can be given up to 1500 milligram in a single visit. Faster and higher hemoglobin rise with iron isomaltoside compared to iron sucrose and even ferric carboxymaltose. No test dose is required. Possibility of providing full iron repletion in a single infusion in clinical observational studies. No acute anaphylactic shock or delayed allergic reaction. No deaths so far. Remember, that is very important. We have seen deaths because I worked 34 years in KEM hospital and Sion hospital in Mumbai. And we have seen deaths with iron sucrose and even with ferric carboxymaltose, they are reported. But I3, no deaths, very important for private practice. And it is safe, effective, convenient, and low immunogenic potential, low potential to release labile iron, doesn't appear to be associated with clinical significant hypophosphatemia, and overall the cost is half of that of ferric carboxymaltose. So to recapitulate what I said, up to 1500 milligram in one shot, no test dose. Number 2, give in 20 to 25 minutes. If you give up to 1000 milligram, dilute it in 100 cc of saline. Between 1000 to 1500, dilute it in 250 cc of saline. And don't give it for 5 hours and 6 hours and all. You finish it up in an hour or so. No test dose is required. No deaths so far. Very few anaphylactic reactions of ladies and gentlemen. Half the price of FCM. Now these are the things which this particular product carries with it. Try in your practice. If you find it is better, you can continue using it. Dr. Bellardo was with us in the morning. I think we are going to publish this paper. 40,000 plus cases where I3 was given, no deaths. That is very important according to me. The rest of the things don't matter. Thank you very much for your patient hearing.
One of the slides showed the calculation, so we can forget about the calculation part.
Oh, why?
Because we can give straight away the full dose, no sir?
No. Unless you calculate, how do you know how much you have to give?
But it comes in one dose, no sir, one strength.
No. It's not that you give every patient 1500 milligram. You have to calculate it. Don't over infuse the patient with iron. It is not required at all. If she's 7 grams, you want to bring it to 11, give 1480 milligram. If she's 9 grams, you want to bring it to 11, give her 1240 milligram. I hope it is clear. It's something very simple. It is the weight of the patient, the actual hemoglobin that she has, and what you want to bring it to. 11, obviously now, not 10. Please remember, 10 is given up. Normal hemoglobin is 11. Now again, that thing you will carry home, because we want our patients to be operated and we want anesthesia fitness. So according to us, 10 is good enough.
No, what I mean to say is, out of the full dose, you're going to discard in that case some amount. Is it so?
Yeah, obviously.
That's what.
Don't ever over infuse.
Okay.
I hope it is clear. So if it is 1480, you give 1500, fine. But if she requires 1240 and you give 1500, that is not correct.
Thank you very much, Dr. P. You have given very excellent presentation about the evolution of the parenteral iron therapy, its uses and side effects. Really, it is a boon. The addition of this new drug of isomaltoside, it is a real boon treatment of anemia. Anemia haunts women right from the puberty to the menopause.
Absolutely.
So
Absolutely.
WHO also warns that by 2030, 18 million more women will be added, will be diagnosed as anemia. So we have to concentrate on the women population, all attend our OPDs with the general symptoms also. We have to check their hemoglobin, and we should try to improve anemia so that we reduce many of the mortalities and morbidities in the women. Thank you very much, sir.
Thank you so much.
Can I please add
Please,
something?
please, please.
Sir, always a huge admirer of your talks, especially the ultrasonography initially. And this was a wonderful talk. I wanted to share my own experience about using iron isomaltoside. We call it iron 3. So this has become so convenient for us because for FCM it is very expensive and you have to make the patient spend a lot. For iron sucrose, I need her to come to me for 3 days or I have to admit her for 3 days. But iron 3 is really something which I can just dispense of in one. The only drawback right now is, of course, once we do a test dose, because test dose means in 100 ml when we put those ampules, we give for the first 30 minutes, we give it very slow at 2 to 4 drops. It acts like a sort of a test dose because some patients do react when we explain to them if you have any side effects, they do start reacting like that, कि हाँ कुछ तो हो रहा है. So this is one, and the only drawback is iron sucrose is only available IV in the government supply. Yeah. So once we get it, if we get iron 3 isomaltoside in government supply, it would be really nice because it will be very good for the patient.
You know, when I was president of POXI in 2012, I had a talk with Ministry of Health and Family Welfare, asking them to introduce at that time iron sucrose free of cost in all government hospitals in India.
Yes.
Imagine they have woken up now.
At least they are giving.
They have brought it now when it is outdated. Please do not use iron sucrose. I am sorry to say this, people who are manufacturing may not like my words, but you have now safer things available. In those days there was no other option. But now you have ferric carboxymaltose and I3 both. And I3, you can make it very safe, one shot, half the cost, and no deaths. This is very important. Private practice, one death because of any IV preparation, it will go against you. So this is something which we have to keep in mind.
Yes, sir, but as you said, no, don't use iron sucrose. Now, from private point of view, yes, definitely, I don't want to use a dangerous drug. But in government, I don't think we have an alternative. I cannot write anything for my patient. I have iron sucrose, I have to use it. And fortunately, we've never had a death with iron sucrose. We've really used a lot of doses. So we still
Let me
stick
tell
to
you,
iron sucrose.
who delivers these politicians' wives?
We do.
Very simple. At all places, I have been telling people that please tell them that what latest thing is available should be made available free of cost in government hospitals and not the ones which now nobody uses. Only GPs use iron sucrose. Why? Because the patient has to come 5, 6, 7 times. Every time she has to be given IV and every time she is charged. So the overall cost of giving iron sucrose by GP is more than giving IV I3 in one shot. If you really look at it. So the GPs give iron sucrose nowadays, we don't give.
Okay, sir. Thank you so much for a
Thank
wonderful
you.
talk.
Thank you, Shah sir, for your talk and lot of practical points in your slides. One request, I am Dr. Rekha Rajendra Kumar. I am the past president of Bangalore Obstetrics Gynecology Society. I have taken permission from Dr. Uma Deshmukh here just to show my slide. This applies to only the presidents and secretaries who are here in the hall. I am contesting for the chairperson, medical disorders in pregnancy, FOXI. The election is from 16th of August to 25th of August. Whoever presidents and secretaries are here, please vote for me, standing for Medical Disorders in Pregnancy Committee as chairperson, Rekha Rajendra Kumar. Thank you, one and all, for your attention.
Thank you, sir. Thank you for the powerful presentation, a real game changer indeed. I request our speaker, chairpersons to proceed towards the gratitude desk for the felicitation. I request Dr. Saroj Patil ma'am to felicitate the speaker and the chairpersons.
We will quickly move on to our next session. One of the most crucial aspects of antenatal care, the screening and treatment guidelines in gestational diabetes mellitus by Dr. Garima Jain. I request Dr. Shilpa Modi, Dr. Sushila Holkunde, Dr. Rekha Gante, Dr. Ratna Patil Madam, Dr. Kasturi Donimat Madam to chair the session. I now call upon Dr. Supriya Sulegaon to introduce our speaker and chairpersons. Dr. Girija has a small announcement for Ksoga Tumkur.
A very good afternoon, everybody. I am Dr. Girija Sanjay, President, Tumkur Society of Obstetrics and Gynecology. First of all, I would like to extend hearty congratulations to Dr. Uma ma'am, Dr. Savita, Dr. Shailaja, my friend, and the entire office bearer team of Bidar Obstetrics Society. You have done a very commendable zonal conference. You have set the bar so high, I couldn't sleep yesterday night. So, I take this opportunity on behalf of the organizing team of Ksoga 35th State Conference. We invite each and every one of you. Namma Kalpatanaru Nadu Tumkurge Banni Nadedadu Devaru Shri Shri Pujya Shivakumara Swamiji Nadadanta Nadige Nimgellargu Swagata. Please block your dates. It's on October 31st, November 1st, and November 2nd under the able leadership of our President Ksoga, Dr. Durgadas Asrana, and the Ksoga office bearers. We invite you to 35th Ksoga State Conference. Please block your dates. Why you have to come to Tumkur? What's so special? The first day we have the workshops. The workshops are the one which are in the trend. The microwave ablation, CTG, Cesarian section workshop. Ultrasound is a hands-on workshop about ultrasound in gynec and infertility. So that is done by Dr. Supriya Sheshadri and Dr. Pratima Radhakrishnan. And for the postgraduates, we have the paper and poster presentation and quiz competition. We have a scientific extravaganza, academic feast for continuously 3 days. So we request Uma madam ಹೇಳಿದ್ದೆ ನಾನು madam ಅಂದ್ರು ನೀನ್ ಫಸ್ಟ್ ಇಲ್ ಬಾ ಹಂಗಿದ್ರೆ ನಾವು ಮ್ಯಾಕ್ಸಿಮಮ್ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಕೊಡಿಸ್ತೀವಿ ಅಂತ. So we want to see you all there. So ma'am is giving a thumbs up. ನಂದು ತವ್ರ ಮನೆ ಗುಲ್ಬರ್ಗ, ಕೊಟ್ಟಿರೋದು ತುಮಕೂರ್ಗೆ. ಸೊ ಈಗ ನನ್ನ ಗಂಡನ ಮನೆಯವ್ರಿಗೆಲ್ಲ ಹೇಳಿ ಬಂದಿದ್ದೀನಿ, ನಂದೆಲ್ಲರನ್ನೂ ಕರ್ಕೊಂಬರ್ತೀನಿ. ದೆಲ್ ಬಿ ಮ್ಯಾಕ್ಸಿಮಮ್ ರಿಜಿಸ್ಟ್ರೇಷನ್ಸ್ ಫ್ರಮ್ ತವ್ರ ಮನೆ ಅಂತ. ಸೊ ನಾನು ಮರ್ಯಾದೆ ಉಳಿಸ್ಬೇಕು ನೀವು. I request everyone to please register as early as possible for 35th State Conference. Thank you.
Good afternoon, everyone. It is my honor to introduce today's speaker, Dr. Garima Jain Madam. She is a senior consultant at Apollo Cradle and Children's Hospital, Bangalore. She is a certified menopause practitioner and a certified genetic counselor. She is a certified genetic diabetes practitioner. She is a senior consultant at Apollo Cradle and Children's Hospital. She is a co-author for chapter Hypertensive Disorders of Pregnancy and its Effects on Neonates and Newborn in Cloherty and Stark's Manual of Neonatal Care. Thank you, madam. Now I introduce today's chairpersons, Dr. Sushila Holkunde, madam. She is a senior director and gynecologist at Holkunde Hospital, Basav Kalyan. She is the best Taluka Health Officer and IMA Lifetime Achievement Award in 2023. She worked as a district surgeon at Basav Kalyan, Brims, Bidar, Raichur and Kalburgi. Dr. Rekha Gante, madam. She is a MD OBGY. She is consultant at Dr. Gante Hospital, Hubli. And Dr. Shilpa Modi, madam, she is a consultant obstetrician and gynecologist at Dr. Sarojini Modi Hospital, Kalburgi. She is practicing maternal and fetal medicine. She is trained in fetal medicine and Adi's Advanced Fetal Medicine Center, Bangalore, and she is a former associate professor at KBN Hospital, Kalburgi. And today's last chairperson, Dr. Ratna Patil, madam, she is MBBS MD General Medicine. She is a postdoctoral fellowship in diabetes MRCP, and she is practicing physician at Bidar, and she managed n number of GDM mothers of Bidar. Dr. Garima Jain, madam, now stage is over to you.
Thank you for the kind introduction. With the permissions of the chair, I would like to start. Thank you, Bidar Society of OBGYNs and BRIMS for inviting me for this talk. At the outset, it is my pleasure to be here. I have been asked to speak on screening and treatment guidelines for gestational diabetes mellitus. Now, it's a huge topic with lots of controversies, hardly any consensus on it, and I've been asked to brief up in 15 minutes. I'm not going to be talking much with academic orientation. It's going to be more of practical, what we use, being more of a private practitioner. It is not the definitions or what we are going to, what we read in the textbooks. What my talk will be based upon how we can practice as guidelines help us to practice better. So what is GDM? The agenda for today's talk is going to be what is GDM? What does GDM do to us? Whom should we test for GDM? How do we test for GDM? When should we test for GDM? And finally, how to manage once we have diagnosed that we have gestational diabetes. So gestational diabetes mellitus is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset or first being recognized during the pregnancy. Therefore, it could be a diabetes mellitus which was existing before the pregnancy but was not known. This definition therefore includes all diabetic women, whether it happened during the pregnancy or prior to the pregnancy, and therefore there is a consensus that maybe we should change it from gestational diabetes to hyperglycemia in pregnancy rather than sticking to the term of gestational diabetes. However, for today's discussion, we will still stick to the term of gestational diabetes mellitus. So what does GDM do to us? We as obstetricians, we are aware of it that we have two lives to handle, the mother and the unborn baby. And with the fetal origin of adulthood diseases, it is not just the unborn baby, it is the next generation also which we have an onus on. So when we don't take care of the gestational diabetes, we would probably bring out an unhealthy future generation, and therefore we have a huge responsibility on ourselves to take care of gestational diabetes. Like we are all aware of it that gestational diabetes in the mother increases the risk of polyhydramnios, increases the risk of preeclampsia, prolonged labor, obstructed labor, increases cesarean section rates, and therefore all other complications which we have been hearing from morning, uterine atony, PPH, infections, neuropathies, nephropathies if not taken care of. In the fetus, it can increase the risk of spontaneous abortions, intrauterine deaths, stillbirths, congenital malformations, and most importantly, shoulder dystocia, birth injuries, neonatal hypoglycemia, respiratory distress syndrome, and so on and forth. And in the future, the next generation would be diabetic, obese, hypertensive, younger if the mother's sugars are not under control. Therefore, it is very important that we keep the sugars under control. Now, is it something that we should worry about? Yes, gestational diabetes is something we should worry about. The statistics say that the incidence of gestational diabetes can be as high as 20 to 30% in the Southeast Asian countries. And in our country, probably if we start screening everybody at the right time in the right way, we might pick up 50% of our women are going to be gestational diabetic. Therefore, there is nothing, though we learned in our textbooks that it is age, parity, previous history of gestational diabetes, previous bad obstetric history, macrosmic babies, family history. If we look at it, probably in our country, it has to be a universal screening that should be strongly recommended for everybody for gestational diabetes. So the testing for gestational diabetes mellitus started very early as in the 1960s, and there is a lot of confusion in every textbook, every edition that comes in. There is a new guidelines, there is a new statistics, there is a new way. Initially, it was a two-step screening where you do an OGCT and then you change over to a GTT. Then there was a confusion whether it has to be a 75-gram GTT, 100-gram GTT, whether it has to be fasting, 1 hour, 2 hour, 3 hour, everything. However, WHO came to a consensus that let's make it a 75-gram GTT universally for everybody, whether the person is pregnant or not pregnant, to reduce half of the confusion. So one of the confusions which got sorted out about doing gestational diabetes screening or a GTT in pregnancy is as same as non-pregnancy. It is a GTT with a 75 grams glucose load. So it is a fasting glucose. Then you go ahead and give a 75 grams glucose load, which is 75 grams glucose dissolved in a glass of water, 200 ml or so, sipped over 15 to 20 minutes, and then the samples are taken 1 hour and 2 hours later. However, then again there is a confusion. Who should do, when should we do, what all stages of the pregnancy should we do it? So 75 grams GTT was accepted universally by the international practicing diabetes physicians. It was accepted by WHO, ACOG, and almost every other guideline that it was accepted. How did this acceptance come was basically by the HAPO trial. The HAPO trial is the biggest trial that has happened for screening for gestational diabetes, which is basically hyperglycemia and adverse outcome, pregnancy outcomes. This was one of the best trials which was done, which includes about 26,000 women, run over 6 years in 9 different countries. So there was a huge spectrum of patients who was taken in. In this trial, the GTT was done for every pregnant woman, primi gravida to be secure, between 24 to 28 weeks of pregnancy at what they had chosen. How they ran the trial is the graphical representations of the statistics was looked at when they took a fasting cutoff at 85, 90, 95, 100, 105, and similarly for a 1 hour, 2 hour values. And then the outcome of the pregnancy was looked into. The primary outcome that they looked into was the incidence of macrosmia, Cesarian rates, neonatal hypoglycemia, and cord blood C-peptide rather than looking at the cord blood sugars or HbA. The secondary outcome was to look at preterm births, shoulder dystocia, birth injuries, obesity, and neonatal jaundice and preeclampsia incidence. After this trial, then they came to the conclusion that when a 75 grams glucose tolerance test is being done, a cutoff of a fasting at around 92 and a post 1 hour 180 and a 2 hour 153, because the trial was done in millimoles. That's why we don't have those in like 9500. But for us to remember, probably we can just make it as a 95, 180 and a 150 to make it easier for us to practice in our country. Now, even though the HAPO trial has said that we should be doing a 75 gram GTT, but then the definition says that it is first diagnosed in pregnancy. So those who are pre-diabetic, those who are diabetic prior to the pregnancy would get missed out when we do a GTT only at a 24 to 28 weeks of pregnancy. And then in our country, with the resources that we are deficient in, we have the largest number of diabetic trials happening in our country, and therefore the FOXI and DIPSI guidelines say that it has to be a single step test to make it easy for everybody to be. So it says a single step 75 grams of glucose is given to the woman irrespective of her last meal, and a 2 hour PPBS is looked into by using a glucometer to make it easy for everybody to be able to do it. A cutoff of 140 or above is treated as gestational diabetes. The advantage of this is it is done first at booking and then again repeated at 24 to 28 weeks if the booking values were normal. But the FIGO and the WHO guidelines still stick to a 75 gram GTT, which they insist and say that it should be done first at the first visit. If there are no other risk factors, then, and if it is negative, repeat it at 24 to 28 weeks, and they do insist on repeating it once more between 32 to 34 weeks of the pregnancy. So with the DIPSI guidelines, the advantage is that it is a universal screening, it's a one-step method, anybody can perform it, it is cheap, screening at multiple stages is happening, and it is very cost-effective. However, the disadvantages are, especially in a private practice like what we do, a patient made to wait for 2 hours becomes difficult. In the first trimester, when we ask them to take a 75 grams glucose load, they'll end up with a lot of nausea, vomiting, and don't want to take the glucose. We miss out the fasting values. A high on the fasting values is definitely known to increase the risk of macrosmia. So when we are not doing a fasting value, we are probably missing out if there is only a fasting sugars that are going up. And we have not looked into the HbA1c, so we do not know what her status was prior to the pregnancy, and therefore we might miss out congenital anomalies in the babies. We may not be picking up all of them because the congenital anomalies are definitely higher if there is diabetes prior to the pregnancy. Therefore, the FIGO guidelines is saying that we should do a 75 gram GTT at booking, again at 24 weeks and again at 32 weeks. The advantage is it is very uniform, universal, in the sense that whether you are pregnant or not pregnant, the GTT values are the same kind of thing. It is lesser miss outs, and we will identify the fasting highs also. but it is expensive and difficult in tolerating the 75 grams glucose in the first trimester is always there. Even in the second trimester, in the third trimester when we do it, many of our pregnant women say that I can't wait fasting for 8 hours, I can't do that 75 grams glucose, I vomited out, I'm not able to do the test. So these are the disadvantages. With the DIPSI being an easy method, there are lots more countries which are now trying to adopt the DIPSI guidelines and do the one-step method. In fact, now Australia is trying to change over from a 75 grams GTT to going back to the Indian FOXI DIPSI guidelines, because that is what they are finding is very effective. Now what happens is, once we have agreed, okay, we have done it, whether we do it by the DIPSI guidelines or we do it by the FIGO or the WHO guidelines, we have realized that we have classified our woman as positive for gestational diabetes whenever we have picked her to be gestational diabetes, whether it be in the starting of the pregnancy, whether it be at 24 weeks or whether it be later on. So there is a huge role of medical management of medical nutrition therapy in managing gestational diabetes. When we do by the Indian guidelines, what does medical nutrition therapy say is we put the woman on a correct carbohydrate diet so that she is not deficient in the carbohydrates and nutrition, but is still able to take care of the sufficient amounts that she needs to be keeping her sugars under control. Along with that, physical exercises is also an important thing. By the DIPSI guidelines, once you have picked up a woman for gestational diabetes positive and you have put her through the medical nutrition therapy, 2 weeks later, you repeat a 2-hour PPBS. So you don't need to do a daily sugars. 2 weeks later, you do a 2-hour PPBS, and any value which is coming more than 120 at any point of time is then considered that the control is not there. We need to add more treatment at this point. So every 2 weeks, you get this woman monitoring her PPBS by using a glucometer. A 2-hour PPBS is what needs to be done by the FOXI and the DIPSI guidelines. However, what does FIGO and WHO guidelines say? FIGO and WHO guidelines says that once you have picked up on your GTT positive, you do a 7-point sugars initially. That is, you do a fasting, a 1 hour after breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and a 2 o'clock midnight values. That's the typical 7-point sugars that we do. And based on the 7-point sugars is how you cater to the patient's requirements of adjusting her diet and insulins or her medical management. However, once you have done 2 weeks of 7-point sugars, then you can, which is practically impossible, so we have changed over, or even the FIGO guidelines say that you can change over to a 4-point sugars, wherein you just do a fasting, a 1 hour after breakfast, 1 hour after lunch, and a 1 hour after dinner. The cutoff values being the fasting should be less than 95, and your 1 hour values all should be less than 140, or if you are doing a 2-hour value, it should be less than 120. These are the values that we are trying to target. One thing for sure, whether we go by the FOXI or the FIGO guidelines, both of them insist and say that there is a huge role of medical nutrition. So whether we do this guidelines or that guidelines to diagnose our woman, the first thing is to go on to a medical nutrition. So what is medical nutrition therapy is healthy eating during the pregnancy, a carbohydrate controlled balanced meal plan which promotes optimal nutrition for the mother and the fetus, adequate energy for appropriate weight gain, maintaining normoglycemic standards. Individualized nutrition assessment should be done, and the calorie adjustment should be done based on the BMI of the mother. So what does ICMR say? ICMR says that every woman should be gaining about 10 to 12 kgs during the pregnancy. If she is not on the obesity side, her BMI is normal. Then for adding that, we should be adding a 350 kilocalories every day in her diet extra to gain that 10 to 12 kgs. A woman who has a sedentary lifestyle needs 1900 calories with 350. A woman who has a moderate working lifestyle needs about 2230, and those plus 350 for the pregnancy, and those who are heavy workers need much more on the calories. So how do we tell a woman what is medical nutrition therapy? That's why I said mine is going to be more of a practical thing rather than thing. It's as simple as this, that we tell a woman to split her meals and have her food in split proportions. So it is split the meals into 3 minor meals and 3 major snacks. So when we tell a woman you need to have a plate full of a meal, then somebody will say this much plate, somebody will say this much plate. So to say it is an 8-inch plate, so a plate which is about this size in hand, a hand size plate, that is what is the meal size portion that she should be having, of which 50% of it is with carbohydrates, 30% of it is with proteins, and 20% of it is everything else added into it, including the fats and the fibers and the vitamins and the fruits and everything. Again, when we look at the carbohydrates, it should be something which is on the low glycemic index. So we go for more complex things like millets or wheat or multigrain attas rather than just more of rice and simpler things. Simple things like stopping sugar. Then when we say stop sugar, they say, but can I have jaggery or honey? I'm pregnant, madam, I need to eat extra. My mother-in-law is saying, how can you cut down food when you are pregnant? You have to eat more. So we have to make them to understand what are the complications. Have it. Stop the sugars, stop the jaggery, stop the honey. Limit the fruits, limit the dry fruits intake. Reduce your carbohydrate intake. So simple as this, the dry fruit intake should be only a closed handful of dry fruit should be taken. The sweeter dry fruit should be avoided. Fruit should be only one helping of a fruit, skipping off all the juices and everything else. The more sweeter the fruit, the lesser the amount of fruit that the woman can take. There is a definite role of exercises to control the gestational diabetes. 15 to 20 minutes of exercise after every meal is something which is advised to the woman. A brisk walking or an upper body exercise that would also help to get her sugars under control. However, there are certain contraindications to allowing a woman to exercise. Suppose she's got a twin pregnancy, a threatened preterm, threatened abortion, then it becomes difficult, or major cardiac diseases. So we can even ask them to just sit on the bed and do an upper body exercises. That also helps to burn off the calories so that we can have them having their gestational diabetes. So once we have started doing this, how do we monitor this woman? By the FOXY guidelines, 2-hour PPBS after 2 weeks and every 2 weeks, maintaining a target of 120 milligrams per deciliter. By the FIGO guidelines, they do the 4-point sugars every day with the targets of 95, 140 if 1 hour or 120 if it is a 2-hour one. Monitoring on it, daily monitoring is what is needed by the FIGO guidelines. Once we see that with the medical nutrition therapy or at any point of time as we are monitoring, we find that the sugars are going up high, then we need to add medicines for them or we need to add the other medical management, which we could add oral hypoglycemic agents or we could add insulin. So insulin is always the drug of choice, but then again very difficult to convince patients to take onto insulins, and with lots of trials coming in, definitely oral hypoglycemic agents like metformin can be safely used in pregnancy. Earlier there were doubts whether we should use metformin earlier in the pregnancy. Yes, the safety of using metformin even in the first trimester is now proven. So metformin can be prescribed through the pregnancy. When you are prescribing metformin, the dose should not exceed grams per day. It should be given in 2 to 3 split doses and preferably give a sustained release composition rather than a plain metformin, because it decreases the gastritis when we give a sustained release. The complications, the advantages of metformin: gets the sugars under control, ease of using it, lesser hypoglycemic events in the mother, lesser weight gain in the mother. Side effects, we are all aware of it, the gastric side effects can happen, and very rarely we can have the woman going in for hypoglycemia. When it comes to, suppose we have not managed to get it under control with metformin, then we have to add insulin at some stage or other, or if the woman is having very high sugars despite of our medical nutrition. When we monitor if the 1-hour PPBSs are going up till 200s and all that, definitely even just adding metformin, we may be losing time and we should be changing over to adding insulin. So insulins, like we are all aware of it, it has to be given in split doses. If we are following the FIGO guidelines and monitoring all the 4 sugars, so it is very easy to adjust the insulin doses. Suppose you have your fasting sugars which are going up high, you give a long-acting insulin in the night so that the fasting sugars are under control. Suppose you have only a post-breakfast going up high, especially for working women, they say we can't go for an exercise after our breakfast. We are tied up for time. So that is where you add a short-acting insulin for them. The main thing when we give insulin is what we are worried about, this woman going in for hypoglycemia. Hypoglycemia is when the sugars go less than 70. The early symptoms could be tremors of the hands, sweating, palpitations, EC fatiguability, hunger, confusion. Hypoglycemia events are more harmful than hyperglycemic. So we need to warn the woman when we are putting her on insulins about hypoglycemic events, and the management for hypoglycemia should be taught to the family when we are putting a woman on insulin. So what we need to do when we have realized that the woman is having gestational diabetes, it is good to do a detailed anomaly scan, not just a level 1, a level 2 anomaly scan if the diabetes is picked up early enough, a growth scan to be done at 28 to 30 weeks and repeated again after a 4 weeks gap around 34 weeks. If we find that the AC is exceeding 75th centile, it means to say the sugars are not under control. A fetal echo, if it is possible, 2 minutes. And a preconceptional care has to be with a good multidisciplinary approach. We know that women who have diabetes also have thyroid issues and can be associated with thyroid, so thyroid testing and probably adding aspirin helps in decreasing the vasculopathies if it is. Fetal surveillance by using NT scan, anomaly scan, fetal echoes, growth scan, Dopplers and NST, though we know that Dopplers may not be the best thing to monitoring when it comes for GDM mothers alone, but if there is a growth retardation because of onset of PET along with it, then the Dopplers do. Labor and delivery, labor if the sugars are well controlled like normal, we can manage this. Only indication for doing cesarean should be obstetric indications, not because she's gestational diabetes. But yes, if on your 36-week scan you find that the AC is more than 90th centile, you better be prepared that this woman will land up with shoulder dystocia. So you warn this woman about the shoulder and talk to them about it and then take your decision whether you still want to go ahead and help her out with a normal delivery or change. Explaining to them that shoulder dystocia complications can happen even in cesareans, though lesser. Neutralizing drip needs to be given. We need to remember that post-delivery, these women can still become diabetic. So we need to do their sugars after 6 weeks. Contraception should not be forgotten. There is no contraindication for using intrauterine contraceptive devices in diabetic mothers. Those days are gone when we would say diabetes increases the risk of infections and therefore we can't use intrauterine devices. Planning her next pregnancy should be counseled to this woman so that she knows that the next pregnancy, again, she is at a high risk of becoming gestational diabetic and the risk of becoming diabetic younger is there, so she needs early monitoring. So what we do in a low resource setup, follow our DIPSI guidelines, do a 2-hour GCT, monitor at 24 weeks and again at 32 weeks after the first visit, monitor the PPBS every 2 weeks, and if it is exceeding 120, change over to more treatment. In the private sector, we can go ahead and probably do a random blood sugar and an HbA1c at booking to pick up pre-diabetic statuses and also then follow it by the 75 grams GT. So what we all agree, despite of all the confusions, GDM is common and has complications. Universal screening is a must. Medical nutrition therapy and exercises definitely do work. There is a role of oral hypoglycemic agents and insulins which are safe in the pregnancy. Antenatal steroids are not contraindicated just because the woman is gestational diabetic. You will just need to monitor her sugars a little carefully if you are giving the antenatal steroids at any age. Insulins usually can be stopped post-delivery. Insulins can be safely taken on the abdomen and preferably deliver in an inch. So what I would say, my references have been from the FOXY and the DIPSI guidelines, FIGO guidelines, WHO, NICE, ACOG, Australian guidelines, and the HAPO study is something which everybody should be reading when we are practicing. Everybody.
Thank you, madam, for your elaborate sessions regarding this topic. And we had so many new things to be observed at interior places of our districts, especially in rural areas. At the government sector, we have to make some arrangements to supply some this investigation things like GGT and so many other things. We have elaborated so many things, but it's very difficult at the government sector. Because I have worked in 35 years of government service, I know the problems in the government sector. So if it is improved at that level, so this problem will be reduced very nicely. So I hope so. You do help for the government level also.
Definitely,
to do this.
There is a role, that's why with the DIPSI guidelines using the glucometer. In fact, when I started my private practice 25 years back, it was difficult to get women to start using the glucometers regularly. So what we had done in our institute is we had bought 10 glucometers, which we used to rent out to patients. You pay a deposit, take it, buy only the strips, when your pregnancy is done, return back the glucometer, I'll give it to somebody else. So refund the full money. So it made it easier for us to make them monitor their sugars, though now buying glucometers, at least in a place like Bangalore, is, I think after COVID, everybody has a pulse oximeter, glucometer, BP apparatus, everything at home, which we may not have in the hospital.
It's nice to treat it.
It was a really informative talk. Yeah, since we are seeing a large number of GDM patients nowadays in our day-to-day practice, large number of PCOS cases also, pre-diabetic population. So have to be really geared up to manage GDM for a future practice. Yes, I would like to know what is your take on high level of HbA1c in early pregnancy?
HbA1c in early pregnancy, definitely the higher the levels are, the more is the risk of anomalies in the baby. But a high HbA1c is not an indication to terminate the pregnancy. We need to tell the women, you need to get your sugars quickly under control. There is a probability that you can have abnormalities in the baby. So we need to be monitoring you more carefully during the pregnancy. It is very important that we do a detailed nuchal scan on these women, and we also get a level 2 or a level 3 anomaly scan, and if possible a fetal echo also on these women who have an high HbA1c. There is a role of starting metformin early enough if the HbA1c is high. And in fact, when you touched upon PCOS, yes, the role of inositol in the pregnancy is also being studied, and it is coming that inositol can also be safely prescribed in the first trimester in women with PCOS proven to be on the higher side.
BMI, as we all know, is one of the reasons for our most dreaded nightmares for obstetricians, that is sudden train demise. So yeah, thank you so much for all that information. Thank you.
Thank you, ma'am, for that informative session. I now request our speaker and chairpersons to move towards the gratitude desk for felicitation. I request Dr. Shantadurge ma'am to felicitate the speaker and chairpersons. Since we are running short of time, questions can be asked in lunch break. Next, we move on to our next topic, newer guidelines in management of epilepsy in pregnancy. To lead us through this highly relevant topic, we are privileged to welcome Dr. Raghunandan Nadik sir. I request Dr. Girija Sanjay, Dr. Mangala Rudravadi, Dr. Harsha Ramdurg to chair the session. We call upon Dr. Shivgeeta to introduce our speaker and chairpersons.
Good afternoon, everyone. Let me introduce today's speaker, Dr. Raghunandan Nadik sir. Sir is Professor and Head, Department of Neurology at St. John's Medical College, Bengaluru. Sir's achievements: Sir got seven gold medals in MBBS, gold medal in MD General Medicine, Honorary Secretary of Bengaluru Neurological Association, Founder Trustee of Karnataka Stroke Association. Such areas of interest are stroke, neuroimmunology, epilepsy, neuro-ophthalmology, neuromuscular disorders. Now I introduce the chairpersons for the session. Dr. Mangala Rudravadi ma'am, Professor OBG Department at SSMC Tumkur, 28 years of teaching experience, served as President and Vice President of Gulbarga OBG Society. Now I introduce the next chairperson, Dr. Harsha Ramdurg, Associate Professor at ESIC Medical College, Kalburgi, currently experienced and practicing fetal medicine. And the next chairperson, Dr. Girija Sanjay, Consultant OBG at Dr. Mahadevappa Hospital, Tumkur, President Tumkur Society of Obstetric Gynec Society, Vice President IMA Tumkur. Welcome you all, ma'am.
Good afternoon, everyone.
Respected chairpersons and delegates, all the faculty here. At the outset, I thank the Conference Scientific Committee for choosing me to give a talk, because we come across many patients with having seizures and in the obstetrics ward, and they will be frantically calling either a medicine or neurology to come. I just want to give few clarifications, concepts in my talk. So I think I'll just go through definitions first, because seizure, epilepsy, convulsion, all will be used interchange by all of us. So actually both are all different. A seizure is actually a transient neurological symptom due to a synchronous discharge which is paroxysmal and which is abnormal. Somebody who has got there is something called as a provoked and unprovoked seizure. For the classical example for an obstetrician will be an eclampsia. It's a provoked seizure. So whereas an unprovoked seizure means somebody does not have any risk factor. Somebody has got a hypoglycemia or a hyponatremia, developed a fever or a stroke, they develop a seizure. So that is called as a provoked seizure. We don't label them as epilepsy. So who has got epilepsy? Epilepsy is the person who has got more than 2 unprovoked seizures. That means if somebody has got a hypoglycemia and they have a seizure, you don't label them as having an epilepsy. So epilepsy means somebody should have more than 2 unprovoked seizures. So in that way, eclampsia patients will not be diagnosed as an epilepsy, because the implications are there. They don't require long-term anti-seizure medications. So the other definition is, if somebody has got a seizure, you evaluate and found out that there is a higher chance for them to have another seizure, like 60%. Somebody has got a scar in their brain or EEG is abnormal. Even though they have one seizure, we label them to have epilepsy. So what is convulsion? Convulsion is basically a motor manifestation of a seizure. Somebody just staring at you, somebody just laughing, somebody just having a fall could be a seizure. Convulsion is actually a motor manifestation, and always remember, when a patient comes with you, is it a first unprovoked seizure, means is their first seizure of their lifetime. So as we all know, nearly lot of prevalence of epilepsy is there in our population. So in the worldwide, more than 50 million people are affected. So majority, about 0.3 to 0.8% of all gestations, people can have epilepsy. So it is, all of us should know what to do, what not to do, how to manage these patients who is pregnant with epilepsy. So the term has been changed. This is no longer called as anti-epileptic medicines. We don't want to label the patient as an epileptic. We should call them as person with epilepsy or woman with epilepsy, and these are all not anti-epileptic no longer, because this is not going to cure epilepsy. So these are all called anti-seizure medication. That is a new terminology which we should be start using it, rather than calling it as a AED, as anti-seizure medication. The problem with having a seizure or an epilepsy, there are various factors on the maternal as well as in the fetal. So what has been noticed is, person with epilepsy, woman with epilepsy on the medication ASM, they can have major congenital malformations and adverse perinatal outcomes and adverse neurodevelopmental outcomes. These are the most important thing which I am going to highlight. All this data has come by registries. This has been registered from the European registry, from the Australian registry and US data. Even in India we have a registry more, that work is done by the Kerala group. But as an India whole, we don't have much registry. I think we should start doing it. And most of this data, what we are going to present, is from these studies. And so the first important thing is, when a patient is an epilepsy, who is having an epilepsy, as a neurologist, or if they have come to an obstetrician, or it's a preconception counseling is most important thing. And one should know they should have an adequate seizure control. It has been known that if somebody has got a seizure control for about 9 months, then their seizures during the pregnancies is also less. So preconception counseling is very important. In that we highlight on minimal drugs, polytherapy, because you should always remember, many patients will be on 3-4 drugs, may not be required. So one should actually minimize it as minimal as possible. Always remember this, going on repeating this, patient should not be on valproate or valtopiramate. So those are the definite no, until unless you are pushed to the corner, don't use valproate. If the patient is on valproate, if they want to conceive, you may have to change the anti-epileptic, anti-seizure medication, and you can tell them. And avoid if clinically feasible until unless it is very controlled, and strict pregnancy prevention program if they are on valproate. So another important thing is, we as a neurologist or any physicians who prescribe anti-epileptic or anti-seizure medication should also prescribe folic acid. So all women of childbearing, they should be on folic acid supplementation. It is beyond doubt. There were few papers recently came, those children born who have taken folic acid develops lymphoma and all, but that is not true. But all the patients who are on anti-seizure medication should take at least 3 months before the conception, because many times most of the time it is unplanned, we don't know, so it is better to put them, and always discuss the risk of the fetal malformation, neurodevelopment. It is basically, I think you heard, it's the communication, because no drugs are safe. You have to communicate and then document it that you have explained all this. So what are the anti-seizure medication choice? So over a period of, like, traditionally we used to use phenobarbital, phenytoin, carbamazepine, valproate, and these are the 4 drugs, and all the drugs which came after that are called newer anti-epileptic drugs or newer anti-seizure medications. So right now what has been observed, the safest medicines are lamotrigine, levetiracetam and oxcarbazepine. So these are the very safe drug for patients or children to have lesser neurodevelopmental abnormalities. So the important choices are, as I told earlier, valproate should not be used, because it is found that using a valproate has found the child will also develop ADHD, their IQ will be low. So suppose if the patient has become pregnant, if they are on valproate, so you have to counsel them and you change over the valproate even at 2nd trimester or 3rd trimester. So it is better to do that, because valproate can found to have reduced the IQ, and same with the phenobarbital. So, and another important thing that which is written in the last, it has been done by many of the obstetrician, they said to stop the drug. When the patient is an epilepsy patient who goes to an obstetrician, they say they are on anti-epileptic medicine, they say stop abruptly. So don't ever stop the anti-epileptic medicine. You may have to consult or you may have to change the drug. That is the most important, because if they develop seizure, that also has got deleterious effects on the patient as well as the child. So what has been found is neurodevelopmental, same thing, the same drugs have less. So if somebody lamotrigine, levetiracetam, carbamazepine, phenytoin, topiramate, they have lesser neurodevelopmental abnormality as compared to the valproate and phenobarbital. And what really happens, why this is most important, is there are certain physiological changes which takes place with a woman when they become pregnant, increase in the plasma volume. So actually the drug concentration may come down, and altered protein binding will be there. So we should know about little pharmacodynamic kinetic of the medications what the patients are using, and reduced bioavailability because of that. And then there is lot of hepatic enzyme induction due to rising sex steroid hormone. So this will cause glucuronidation. So if the drugs are metabolized by this one, they can be metabolized more. So these are just a diagrammatic representation what all things can happen. So especially renal blood flow will be more, so patients, the drugs which are excreted through the kidneys like zonisamide, levetiracetam, pregabalin, you may have to increase the dose, and many times non-physiological nausea, vomiting in the first trimester. The patients may not take the medication or it may not have much efficacy, and many times patient will only stop. Even though the doctors advise, they think some adverse effect would have happened. Non-adherence is the most important thing. The other important thing one should know is hepatic oxidizing induction, so that concentration of lamotrigine. So we don't use much lamotrigine in the Western world. Lot of lamotrigine is used for juvenile myoclonic epilepsy, which is the common genetic epilepsy, which we also have. We give more of levetiracetam. People are on lamotrigine. Lamotrigine is more safer, but the problem is that in pregnancy the lamotrigine level will go down, so you may have to through the dose certification. So this is just to, in a study it was found that there is no change in the frequency of seizure in a person with epilepsy when they become pregnant. But however, when they have increased the dose, there will be but change in the drug. That is because you have to therapeutically monitor these drugs. So we don't have facility to do all the drugs except for carbamazepine, phenobarbital, phenytoin, which we will not use. But ideally we should have a therapeutic monitoring for lamotrigine, levetiracetam. Maybe in tier 1 cities may be done, but even in Bangalore we are not doing it. One of the important thing is therapeutic drug monitoring is important, because we may have to increase the dose, especially lamotrigine and levetiracetam you may have to increase even in the first trimester. And this is what the projected decrease of anti-seizure medications which has been found. If you see, lamotrigine goes down by 70%, oxcarbazepine, but as carbamazepine, valproate, they will not go down. So if these patients are on this, many of your patients would have been on either oxcarbazepine, levetiracetam, lacosamide. These are the newer drugs what most of the physicians are using, but in the women set of patient may be still on phenobarbital, phenytoin. This is what will go into the structure. And this is in general a table, how much reduction, so that much amount of dose you have to increase. Say phenobarbital goes up by 55%. So you may have to increase the dose. If they are on 90 mg, you may have to give it 120 mg. So one should know this and how much to increase, especially oxcarbazepine, you may have to go to double the dose, especially in second trimester. If they are on 600 mg, you may have to go to 900 or 1200 mg. And this is what is in pregnancy. The important is preferred anti-seizure medications. I am repeatedly telling lamotrigine, levetiracetam, oxcarbazepine as of clinical evidence now, which has got lesser major congenital malformations. And always remember, valproate should be avoided and folic acid supplementation to be given. So this is in the preconception period. In the period, one should all remember that. So in the antenatal management, monitoring of the TDM, that is a dose, and then it's a teamwork. It's a physician or a neurophysician with a gynecologist. So always ensure that patient is taking the drug properly. Adherence to the AEDs, risk factors for the seizure, especially sleep deprivation, stress. So that is one of the important things. Sleep deprivation, it can provoke seizure. Remember to give folic acid, the 5 mg. And always there are some guidelines, they say maternally in the third trimester you can supplement vitamin K if they are on these drugs like phenobarbital, phenytoin and all. And neonate born to these patients can also receive vitamin K. So antenatal, there are not much fetal surveillance. As we do it 18 to 20 weeks, you have to do the obstetric scan to see any malformation. So that is the most important thing. What your neural tube defects like spina bifida, orofacial clefts and palate will be known. And when they are on phenobarbital, fetal echocardiography will give us echo. So this is most important thing. And alpha fetoprotein monitoring, especially will give you rising titers, will tell you there is a spina bifida. And prenatal screening and counseling is mandatory. So this is a study which found that most of the time adherence will be abnormal because of the patient may not take the drug properly. So this is just a graph to show the prevalences of with various 3 studies what I told, European, North American and all. If you see, levetiracetam has got the least 2.9%, oxcarbazepine has around 3%, lamotrigine around 2.6%. So when the patient comes, we can say, I don't know, in general, there is 1 to 2% of a normal pregnancy to have an abnormal neurodevelopment. So whereas if you on the anti-epileptic or anti-seizure, it may just go up by 2% in with lamotrigine and all. But if valproate, it is as high as 10.3%. So one should be very, very careful when we are on valproate. And the same thing just to demonstrate that. And which has been found that number of exposures, if you look various type of cardiac effects are more on phenobarbital. Barbiturates has got the highest cardiac defects as compared to valproic acid can cause all type of neurological deficits. So intrapartum, there is no different management. Vaginal birth is typically recommended unless obstetrician indication arises. So epilepsy is not an indication to do Cesarian section, but if the patient has got seizures during the pregnancy or during the labor, one should take for a Cesarian section or a previous Cesarian section. So postpartum management, increased risk of seizures in the immediate due to sleep deprivation, stress, and always remember AED changes can happen in the immediate postpartum period. So you may have to hike the dose or you may have to reduce, and always remember to do the dose adjustment. Some drugs may require, some patients if they are on high dose lamotrigine within 2-3 weeks, they may develop toxicity. One should be very careful on these things. Sleep and rest, that's the most important thing. Sleep is the strongest trigger for having seizure, and always take care of the baby, because if the patient has got recurrent seizure, they may baby may get hurt. One should counsel this and then somebody has to monitor it. And breastfeeding, as of now there are no contraindication. One should always encourage breastfeeding because it can cause other positive effects for the baby, and the excretion of these drugs are very minimal, especially if they are on barbiturates or benzodiazepines. You should watch the baby because they may become drowsy. Otherwise, relatively safer. The recommendation is all mothers pregnant mothers who are delivered has to be encouraged if they are on the ASM to breastfeed the baby. And always remember, contraception is another important thing. One should go through this, and I think this is beyond. So most important thing is the IUD is the best one, because many of the enzyme induction drugs may not have significant effect, lamotrigine and LN cause. So the same thing about it. So what is the gap? There is a gap because in our country we don't have a data. I think many of you have treated, I also treated, but we don't have a data to talk how much malformation happened, what is not there. I have one or two have malformation happen on 3-4 medication when they are on 4 medication, but we don't have a data. So registry has to be done, I think, with the use of all the with the obstetrician and gynecologists. So key takeaway for obstetrician is preconception counseling is essential, because early identification and guidance for women with epilepsy is critical. Avoid valproate and topiramate wherever possible. Opt for a safer anti-epileptic drug. Administer high dose of folic acid, and there is a multidisciplinary approach. Personalized management. Each patient has to be managed in an individual way, and always education and reassurance that you will not have increased seizure, your baby will be okay. So this counseling one needs to do. And last but not the least, don't stop the medicines abruptly. The danger of uncontrolled seizure generally outweighs the risk at the most AEDs. And these are the few references which you can go through. So, thank you.
Thank you, sir. It's a wonderful talk. You have made it easy to understand between the seizure, convulsion, and epilepsy. And then you are elaborated very nicely about the anti-seizure drugs, which drug should be given, which should not be given from the antenatal to postpartum, sir. It's a wonderful talk, and it's very informative. Thank you, sir. Thank you.
For delivering this wonderful talk, sir. Definitely it was very informative, and I think most of us would agree on what you said. So should not abruptly stop. And yes, the drugs, the changes that we need to do, yes, definitely it's a very important take-home point for all of us. And yes, sir, only in the government setup that should be, as you said, is a problem because of the availability of phenobarbs is there. That is the only thing. But otherwise, I think levetiracetam is quite well taken now.
So usually on levetiracetam, we increase by 25% to 50. Suppose they are on 500 mg twice a day, can go up to 750 mg twice a day. I think levetiracetam is being used left, right and center by all the doctors. It is one of the blockbuster because it is a broad spectrum anti-epileptic. It works across the type of seizure. So it safely can be given, and it was as late as 5 years, it was 0% congenital malformation, but now registries have shown about 2%. But it's a good medication.
One question I had, sir. Do you suggest the use of IV levetiracetam if the patient goes and we are giving a trial for vaginal delivery? Should we shift her to IV levetiracetam in active labor?
That is the advantage of levetiracetam is if the patient is nil orally, if they cannot take orally, if they are vomiting, we can shift over to the intravenous. The same dose can be, if they are on 500 mg oral, can be shifted to IV oral. It is relatively safe. You can do that. If your practice, it is not that no, but you can do that.
Thank you, sir.
Thank you so much, sir. You covered from preconception to contraception, every aspect. It was really very crisp, and it was an honor to chair this session. Thank you.
Thank you.
The patient will become free from seizure, sir, after taking treatment, regular treatment.
Okay. So basically when somebody has got a seizure or epilepsy, it is not a diagnosis. It is like fever. We have to know why this patient had a seizure. Suppose if there is a scar in the brain, like a post-stroke or a post-head injury or a granuloma, there is a scar, there is always a chance to have a seizure. Suppose there are clinical syndromes like a juvenile myoclonic epilepsy, which is common genetic epilepsy, where they may have to take long term, 30 years, 40 years, maybe lifetime. But most of the time, usually we start an anti-seizure medication, give 2 to 3 years. If they are seizure free, we do an EEG and see it is normal, imaging is normal. We counsel them that we can reduce the medicine. And if they don't get seizure, when you say epilepsy cured, by the definition, they should be seizure free for 10 years and 5 years off medications. Somebody, that is what the ILE definition of a cured epilepsy is, that no seizures for 10 years from the last episode, and in that 5 years is off medicine. So that means if somebody has stopped medicine today, if they are seizure free from past 3 years, next 7 years we can say still they are the active this one, but that we should counsel like that. So that is what is the definition, current definition. See, always we counsel the patient that we don't abruptly stop any anti-seizure medication. So suppose if they have taken for 3 years, it may take 6 months to 8 months to reduce the dose. Say suppose if 500 mg twice a day is there, 250 every month we reduce. And then we say the highest risk is in the first year. So that we counsel the patient, if you get any further seizure, please come back. So otherwise, after 6 months, I usually call them to come back and the counsel. Many times you can give a try, and once they burn their hand, they will not agree to stop. They will only continue it. It's basically discussion between the patient, and first of all, we should know what is the diagnosis. If somebody has got a juvenile myoclonic epilepsy, they come and sit with me and tell, I want to stop, I will never counsel them. So because it is a lifetime treatment. Genetic epilepsies, there are syndromes we have to know what we are dealing with.
Thank you, sir. I now request our speaker and chairpersons to proceed to the gratitude desk for felicitation. I call upon Dr. Savita Badiger to felicitate our speaker and chairpersons.
Moving to the next session, How to Reduce Maternal Mortality by Dr. Savita Malakreddy. To shed light on the strategies, innovation, policy-driven changes to reduce maternal mortality, we are privileged to have with us Dr. Savita Malakreddy. We request Dr. Shashikala Patil, Dr. Prema Kaujalgi, and Dr. Padma Salimat to chair the session. I call upon Dr. Hemlata Patil to introduce our speakers and the chairpersons.
Good afternoon. It's my privilege to introduce the speaker and the chairpersons because two amongst them are my close friends. We'll start with the speaker, Dr. Savita Malakreddy, HOD Department of OBG, Bangalore Medical College, from 2017 to 2024, Medical Superintendent, Vani Vilas Hospital, and more than 25 publications in both national and international, and the most prestigious Lancet also, and DNP examiner, and she is an ex-RGHS syndicate member. And something other than this, she has reached a very top level, no shortcuts, no godfathers, just hard work and brilliance. She has built her own legacy because she is a solid proof that hard work, talent and integrity can even climb ladders even in metro cities. She has saluted her duty and not polluted it. So very simple, humble lady with lot of moral values. Please welcome Dr. Savita Malakreddy, ma'am. Now, coming to the chairpersons, Dr. Prema Kaujalgi, ma'am. 30 years of experience. She is a visiting consultant at Chinmay Mission Hospital, Indiranagar, Bangalore, and consultant at Lotus Diagnostics at Motherhood Hospitals. Dr. Prema Salipat, ma'am, she is a consultant at Salimat Hospital, Somnabad. And coming to the Dr. Shashikala Patil, So she has not sent her CV because she is one of my close friends. I'll introduce myself without CV. She is alumni of MRMC Gulbarga, and she had 1 year of experience in working in Kidwai Hospital, Bangalore, and since I think probably 22 to 23 years of experience, and something like about her hard skills, few points about her hard skills. She is one of the best surgeons. I'm speaking to the juniors, and I think minimum time for her section is the time we consume in seeing the OPDs, that is 6 minutes, 6 minutes to 10 minutes skin to skin. And yeah, so organized she is, her OT, her staff, herself, very organized person, both at home and the hospital also. She's one of the, like, I think you should say to believe this. She started with a single OPD, single room as a single person, and now she has built her own empire. Chetna Hospitals, Raichur. Okay, and coming to her soft skills, she is very much calm, composed, she speaks very less, and without losing her composure, without getting angry on everybody, anybody, she is taking work from her subordinates, something I think juniors should learn from it. And I think she has very minimum mortalities, minimum morbidities, and minimum complications. I keep on asking her, how come you don't have any complications? How come you don't have any complications? And she was like, Nana stage hoglike bidadilla anta. It only means that such meticulous supervision and examination, I think. So we are very honored to have such persons as our chairpersons. So thank you.
Ellargu namaskara. I'm sorry I am between your lunch and yourself. So I hope to complete it whatever the assigned time, which was 15, now it is 13. So I thank the BS Society B of Bidar for giving me this opportunity to come and address you people, especially Hemalata Patil. She said she is a close friend of mine. So, and she has given a topic which is very dear to my heart, and I being in a public servant, striving to reduce the maternal mortality, because most of you might have experienced the more number of deaths are in the public sector hospital compared to the private. So my topic, I'll be talking under these headings. So to define the maternal death, it is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So when we define maternal mortality ratio, the number of maternal deaths during a given period of time per lakh live births during the same time period. And SDG goal set by the United Nations aims at reducing the global maternal death ratio to less than 70 per lakh live births. So this is a SRS bulletin which shows that the MMR in India, which declined from 130 to 88, 130 in 2014-16 to in 2022 it declined to 88. And according to that SRS 2022, the Karnataka data says it is 58. So the global causes of maternal mortality, so the major chunk is from the hemorrhage, hypertension and the indirect causes. So talking about the Indian scenario, the major shareholders of maternal mortality are hemorrhage, hypertensive disorder and the sepsis. So there are some of the underlying, the root causes are, there is something direct obstetric causes and indirect causes. Direct causes like eclampsia, infection, hemorrhage, preeclampsia, they contribute, and also the complications of unsafe abortion contribute, and the indirect causes like anemia, heart disease, then something like socio-economic factors like poverty, lack of education and limited access to the resources, and the systemic issues like weak healthcare infrastructure and shortage of skilled birth attendants and inadequate emergency obstetric care. So what are the tips for solving the unsolved enigma of the maternal death? So these are the WHO recommendations, steps to accelerate the progress towards reducing maternal mortality. Reorientation of the health systems towards a primary healthcare approach, scale up evidence-based cost-effective interventions, promote access to affordable, high quality and respectful care for normal births and obstetric complications. enable access to essential, safe, quality medicines, establish networks of care with strong referral mechanisms, facilitate universal access to SRH services, invest in country-led health information management systems and the healthcare workforce. So what is the role of healthcare professionals? So early identification of high-risk pregnancies, providing proper antenatal, intranatal and postnatal care, ensuring timely referrals without any delay and providing emergency management. So prenatal care is one of the most effective ways to reduce maternal mortality because it identifies the complications or high risks before the emergency situation arises. So we all know prevention is better than cure. So during the antenatal care, the regular antenatal checkups to be emphasized to the patient and to the attenders, and all the high risk conditions should be screened as early as possible. And proper nutrition and supplementation advice and education of the mother about the danger signals that has to be done. During the intrapartum care, every deliveries should be attended by a skilled birth attendant and managing the labor complications effectively, use of WHO safe childbirth checklist and emergency obstetric care. In the postnatal care, monitoring for PPH, infections and mental health, and family planning and birth spacing should be advised, and breastfeeding support and nutrition advice. So I won't be going in detail. I will be touching only the 3 to 4 major causes. In the hypertensive disorders, morning Dr. Shobha Gudi has spoken about the Gestosis score. I think all of us can put this chart in the OPD so that we start grading the patients whether they are high risk or low risk. And this chart can be put so that when we screen positive, like this flow chart can be utilized for putting them whether they should be started on low dose aspirin, heparin, whatever it is. So low dose aspirin used for prevention of preeclampsia is not widely practiced in India. So awareness and ongoing CMEs for the postgraduate students and obstetric practitioners needs to be done. Pregnant women with Gestosis score more than 3 should be advised 75 to 150 milligram of aspirin. And as per the ISSHP guidelines 2021, even the ART pregnancies are risk factors and they should be started with 150 milligram aspirin. So wherever there is a dietary intake of calcium less than 600 milligram, they should be advised 1200 milligram of calcium. Secondary prevention is early diagnosis and treatment. So once the hypertension of more than or equal to 140/90 is confirmed, so they should be checked for proteinuria, and once the preeclampsia is diagnosed, these women should be seen by an obstetrician or for the assessment of severity and triaging and referring them to a tertiary care center for the multidisciplinary approach. So on diagnosis of preeclampsia, ideally these women should be admitted and evaluated, following which decision can be taken whether they can be managed as a outpatient basis. And whatever the necessary investigations that have to be done, and what is to be emphasized is the prophylactic MAXELF in severe preeclampsia, where most of the times it is not practiced. So coming to this next thing, it is the postpartum hemorrhage. So all the women should be screened and for the anemia, and anemia should be corrected. Screening for other risk factors like hypertension, GDM or a twin pregnancy, all those things. Then judicious induction and augmentation of labor to be done, and AMTSL should be strictly practiced, and presence of a skilled healthcare worker at the time of delivery of every mother is very important. Timely management of postpartum hemorrhage at the site of occurrence, resuscitate first and then refer. So use of balloon tamponade and NASG, that is anti-shock garment, before referring is very, very important, because see, if the patient is not handled, the primary care is not given, and we have seen patient being shifted from hospital to hospital without treating the PPH, and by the time she reaches the tertiary care, she is already dead almost. So these things can be utilized, and referral protocols should be strictly followed. You please arrange the transport facility, 108 is available, and refer to a nearest tertiary care center rather than, in search of the public sector tertiary care center. They can be referred to a nearest tertiary care center. It could be a private sector or private setup also. because the government is taking initiative to have an MOU with the even private medical colleges so that they can receive such moribund patients. And communication with the referral center, that's prior communication, is very, very important so that they will receive your patient and treat them effectively. And auditing of the complications, near miss cases and deaths, they will improve and strengthen the services. So this chart also can be put in the labor room so that everyone, whenever they see, they will be aware. And this is the PPH emergency response. These charts should be utilized effectively in the labor room so that everyone is educated about what to do and what not to do. And this is again a chart of the balloon tamponade. And what is this SR cannula also? I think many of us are using this SR cannula for PPH. So it is a wonderful thing, like we are also using in our institute, and many institutes are being used and have got the feedback, and it's a very good thing to stop the PPH. So when these things fail, like we can go for the stepwise devascularization. So uterine artery and the internal iliac artery ligation. So the third point about the nowadays we are seeing lot of patients, especially in a tertiary care setup, we are seeing lot of placenta accreta spectrum disorder. So this needs a multidisciplinary approach, and Cesarian should be planned electively, and most of the points are being told by Dr. Bellat sir in the morning. So it is a multidisciplinary, and what extra thing I just want to tell is whenever you are planning this, you can put a vertical abdominal incision and classical Cesarian, and you can go ahead with the Cesarian hysterectomy to reduce the blood loss. See, iotic clamp can be used, which we are using it very regularly, and it reduces the blood loss to a great extent. So one word about the sepsis. So the physiological changes of pregnancy they mimic sepsis and they complicate the clinical diagnosis. So fever is not at all a indication for the sepsis. So some of the tests like CRP, procalcitonin, lactate and ferritin may help in diagnosis. And the Muir's chart and SOFA score and Q-SOFA score also can help to diagnose. So what is important is initiation of the early management, like fluid resuscitation and use of vasopressors. It has to be addressed immediately, and empiric broad spectrum antibiotics to be started immediately, and once the culture comes we can narrow down to the sensitive one, and it again needs a multidisciplinary team. And nowadays we are seeing more cardiac diseases because of the advanced treatment. Women are surviving for the cardiac disease, women are surviving till the reproductive age group. So we are seeing more of these cardiac diseases. So we thought like what should be done. So routine echo for everyone is a cumbersome procedure, and every setup may not have that. So simple, the junior consultants, like nowadays, because ours being a PG institute, I have seen none of our PGs auscultate the chest of the woman. So at least once, if they auscultate the chest of the woman, that will be very good, that we may pick up many things. That is very important, and all the high risk women should be evaluated for the cardiac disease, and ECG and 2D echo is compulsory in a woman with a hypertensive disorder of pregnancy. So what are the interventions or key interventions of the government? So all of you know about JSY, JSSK, all those things. There is something called PMSMA and extended PMSMA, and Lakshya, which is a quality improvement initiative of the labor room and maternity OTs. The extra thing what I want to tell is there is something called introduction of the midwifery in Government of India, which is come to Government of Karnataka also. So Vanivilas Hospital being it's a national midwifery training institute, we have got a midwifery led care unit where the midwives attend to the lowest risk mothers, and they deliver. We are practicing alternate birthing positions. They give that compassionate one-to-one care, and our mothers are benefited. So this is going to extend all over Karnataka slowly, and there is a SMT, a State Midwifery Training Institute also in Vanivilas, which has produced the national nurse practitioner midwives. Now the SMT has started in Belgaum and Mysore, and ours is one center. And these people who have trained in NPMs have gone to Tumkur, Belgaum, and they are lending their services, even to Davangere also. So this is the initiative is to reduce the Cesarian sections and to provide respectful maternity care for our mothers. So the other thing is about the vital registration of data, that is births and deaths has to be mandatorily entered in the portal, and all the death analysis have to be done, that is as per the MDSR, and whatever the gaps are identified should be closed, and this data can be utilized to strengthen our services. So just a few words about the we had a Karnataka death audit of 2024 following the this endotoxin. All of you must have read it in the newspaper. So in this, most of the deaths belonged to the Cesarian section group, and the cause of death for all these deaths were, the major things were hypertensive disorder of pregnancy, then hemorrhage and sepsis. They were the major chunk of it. So in the death audit, our observations were the poor antenatal screening for high risk factors, inadequate correction of anemia, hypertension and thyroid disorders. Induction protocols were not followed, liberal decision for Cesarian deliveries, poor adherence to infection control practices. Referral protocols were not followed, inadequate preparedness of the health facilities like many of the hospitals didn't have the blood storage unit, blood bank. So for the want of blood, patients were made to roam around, all these things. And lack of SOPs for the antenatal, intranatal and postnatal care. And significant number of maternal deaths, around 10% have occurred in the transit zone, either from home to hospital or hospital to hospital, indicating that the patients were not stabilized before referral to the higher hospitals. And lack of awareness regarding Meo's chart, modified shock index, Gestosis score, no birth planning for many pregnant women, and unmet needs of contraception, which ended in unwanted pregnancies and unsafe abortions. So what are the recommendations of the committee? Improving the quality of antenatal care by screening all the pregnant women starting from the first trimester, good history elicitation from the patient and the attendants about the current and the past obstetric and medical surgical history, proper documentation of the history and antenatal details in the Thai card, or there is something called RCH portal, providing the iron and calcium in adequate dosage according to the guidelines. Then correction of anemia, blood pressure and blood glucose need to be emphasized. Detection of infections and treatment of the same. Unnecessary induction of labor should not be done contrary to the guidelines issued by the government. Unnecessary sections should not be resorted to suit the convenience of the service provider and the mother or the family. Orientation of OBGYNs for massive transfusion protocols. Implementation of Gestosis scoring for screening the HDP and providing the prophylaxis, heparin prophylaxis in high-risk cases of VTE. Orientation of all the practitioners regarding the causes of maternal death and standard treatment. Compulsory admission for pregnant women with blood pressure more than 140/90 for evaluation. Making post-mortem examination mandatory for all such scenarios where there is no definite cause for a maternal death was found. When in doubt, always seek second opinion from the experts. So maternal mortality health is a very sensitive indicator. All you need to look at is a country's maternal mortality rate. That is a surrogate for whether the country's health system is functioning. If it works for women, I am sure it will work for men too. So it's better to ask, let's work together to prevent maternal morbidity and mortality. Thank you very much. And thank you for whoever is staying back. Thank you very much for that.
Told everything in depth about how to reduce the mortality and what are the precautions we have to take. Thank you for.
Thank you.
Thank you very much for the enlightenment. Now I know the very thin crowd.
but every life is precious. I think the journey should start in a girl from her childhood, like you said, the preparation, anemia correction, nutrition, even these pockets have to be identified. And the mobile unit, you know, if somebody can go with the mobile unit, identify these pockets and motivate them to come to hospital. I am from Bangalore, you are from the same place. So we always look forward to Vani Vilas Hospital, go to Vani Vilas. So I think it has to be started from there, the education, motivation and the efficiency and the skill care personnel will probably bring down, I think Karnataka will beat the other neighboring states very soon in all this. Thank you very much, Dr. Savita.
If you control the major contributors, no, so they are preventable. Hemorrhage and HDP, they are preventable. If we tackle those things, we can reduce. Thank you very much.
Together, we can and must ensure that every mother not only gives life but lives. Thank you, ma'am. I request the speaker and the chairperson to proceed to the gratitude desk for the felicitation. I request Dr. Hemlata Patil madam and Dr. Vijaya Patil madam to felicitate our speaker and the chairperson.
Quickly, we will move on to our next session, the panel discussion on thyroid disorders in pregnancy. This session will be moderated by Dr. Fani Josna, whose expertise in both clinical and academic domains promises to keep this discussion rich and insightful. We are honored to have with us a distinguished panel, Dr. Pradeep Indalkar, Dr. Vijay Chandra, Dr. Manpreet Kaur, Dr. Shivleela Desai, Dr. Shailaja Shamsundar. I request Dr. Sumaya Kulsum to introduce the moderator and panelists.
Thank you, Shilpa ma'am, and a very warm good afternoon to all the beautiful ladies and very well-dressed gentlemen present in the hall and of course outside the hall. And what do you think? From where our beauty comes? Any guesses? From the parlor wonder before the occasion? From our makeup? From our dressing? Or from our jewelry? What do you think? No, it comes from our hormones. Hormones are disturbed, feminism is disturbed, hormones are gone, beauty is gone. So today we have got an opportunity to listen about a very important hormone with which many of the adolescent girls and pregnant ladies are battling with, and that is thyroid hormone disorders in the pregnancy. So now we'll listen from a very beautiful lady, Dr. Fani Josna, who is a consultant obstetrician and gynecologist and laparoscopic surgeon from Ankura Hospital, Hyderabad, and she is having areas of interest like minimal access gynecological surgeries and high risk pregnancy. And she is also a general secretary, ISOPARP Hyderabad chapter. And our respectable panelists are Dr. Vijay C.R. Reddy, who is practicing as a consultant surgeon in Bangalore, and he is a general and gastrosurgeon with 26 years of experience, proficient in both emergency and elective surgical procedures with expertise in laparoscopy and laser surgery. Trained under eminent surgeon in the UK and worked as locum consultant surgeon at Kanthapura, UK, studied from reputed government college in Karnataka. His expertise are laparoscopy and laser surgeries and highest in preventive and social medicine, distinction in ophthalmology, All India rank 32 in UPSC medical exam selection. Great, that is. Then Dr. Manpreet Kaur, she is our panelist, former HOD DNB OBG District Hospital, Vijaypura, Karnataka, former professor and HOD OBG, Alamin Medical College, Vijaypura, and she is a former professor BLD University and Medical College, now working as a professor and HOD at TMMC and RCUP. She is trained in advanced OB USG from Mediscan Chennai 2018, certification in GDM management, certified Indian Menopause Society practitioner, teaching experience of 25 years, completed MBBS in 1994, Government Medical College, Patiala, and she has completed her MD from Government Medical College, Amritsar. Our next panelist will be Dr. Pradeep Indalkar, who is MBBS from TN Medical College, Nair Hospital, Mumbai, Diabetology Department of Endocrinology, St. G.S. Medical College and KM Hospital, Mumbai, Royal College of Physicians, UK, 1819, American Thyroid Association Certificate Course in Advanced in Management of Thyroid Disorder in 2019. Worked as Registrar in Department of Endocrinology, KM Hospital, Mumbai, between 19 and 20. Worked as Assistant at Diabetic Food Clinic, Dr. Tushar Rege, Diabetic Food Clinic, Dadar, Mumbai. Practicing as a consultant diabetes thyroid obesity specialist since 2020 in Dr. Indalkar Diabetes Thyroid Obesity Clinic, Latur. Speaker at District and Regional Conference on Metabolic Disorders. Conducted various camps in rural areas for awareness of diabetes, thyroid and metabolic disorder. It will be great to hear from Dr. Fani Jyotsna Madam. I welcome you and all the panelists. Thank you.
Thank you, Doctor, for that introduction. I thank all the people who are still sitting in the hall. I hope we'll have a good discussion. At the outset, I'd like to thank Ksoga office bearers, especially the organizing team, Dr. Uma and Dr. Jyotsna especially, who have been in constant touch and made arrangements for me to reach here. I thank all my panelists to have been sitting here patiently for this discussion. Hopefully we'll rouse the audience from their post-lunch slumber. Okay, so we'll start this discussion on thyroid disease in pregnancy. It's very vast. When I started reading, I realized you can't really cover everything, but we are going to give the audience a message. Keep your answers really precise, to the point, with the intention of giving them something to take back and practice. All right? Thank you. To introduce, yes, thyroid metabolism in pregnancy changes. There is an increased metabolic demand due to the pregnancy, and this leads to some alteration in the tests that we normally perform for thyroid evaluation. So the increased thyroid binding globulin by 2 to 3 times causes an increase in the total T3 and T4 up to 50% in pregnancy, but not the free T3 and free T4. Stimulation of the thyrotropin receptor by human chorionic gonadotropin, because of the common alpha subunit but considerable homology in the beta subunits, causes this stimulation of the thyrotropin receptor, and there is increased T3 and T4, subsequently suppressing the TSH as well. So to introduce, hypothyroidism is 11 to 9.5% in some cases in the pregnancy. This is according to a meta-analysis in 2021. It's 5 to 8 times more common in women, so we as obstetricians should be concerned about it. And we definitely use trimester specific cutoffs. Do we not? All of us use trimester specific cutoffs and not a general single cutoff value for non-pregnant persons. Hyperthyroidism is much less common, 0.1 to 0.4%. So we'll discuss hypothyroidism and hyperthyroidism. Under hypothyroidism, we'll look at cases, scenarios where it's subclinical and overt. So to begin with, this is the first case, 28-year-old primary gravida at 7 weeks, 3 days of pregnancy. She had previous regular cycles and a normal BMI, no complaints except the amenorrhea. She came with a report of an intrauterine pregnancy with good cardiac activity. Everything else is normal. On routine investigation, she was found to have a TSH of 4.3, and those were her values of free T4 and T3, which we normally don't do, but I've given you the values. So the question to the obstetrician, how are we screening pregnant women for thyroid disease?
At my institution, we are doing a universal screening for all pregnant patients. Whenever they come, preferably we want to do it in the first trimester because that is when it is going to be most effective.
Absolutely.
Treatment. But whenever they come, we do a screening with TSH first, and then if there is any abnormality with the TSH, we might go ahead with the free, we do go ahead with the free T4. And if needed, if we feel it's a dicey, it's discordant reports, then we do go for TPO antibody.
Yes, you look at the history. Here it's a primary, but if somebody's had miscarriages, somebody's had some history or symptoms, yes, you must have a high index of suspicion. Correct. Yes. So there is still a debate about universal screening for thyroid in pregnancy or not, or should we just do a risk-based screening? So there are arguments that improved outcomes due to early intervention, and it is cost effective to do risk-based targeting. If you do universal, risk-based targeting may miss cases. But then there are countries which use public health systems, and they say it will put a strain on the healthcare infrastructure. So we don't know, we may be over-diagnosing and over-treating every other woman with a thyroxine supplement. So these are all the risk factors for wherever they use risk-based screening for thyroid disease in pregnancy. These are all the risk factors, especially you look at the history and if they are above 30 years of age for us. So these are all the recommendations. Would any of the endocrinologists, would you please want to talk about the recommendations in our country? What are we following? Is that mic working?
So in our country, we follow the Indian Thyroid Society policy guidelines. First visit, you should do TSH and look at the values of the TSH. If the TSH value is less than 2.5, it's normal. First trimester, first visit. If it is between 2.5 to 4, you should do for TPO antibodies. And if the value is more than 4, you should start treatment.
So are we, what are all the tests that you're advising? Are we doing all the T3, T4, TSH, or are we just doing a TSH and then going as a stepwise manner?
If the TSH is normal, don't go for FT4. The TSH is suppressed, then go for FT4 and TSH.
Yes. So anti-TPO antibodies, how are we going to advise? Who are the women you are going to advise anti-TPO antibodies?
So if the patient has history of previous miscarriage, or a patient value is between 2.5 to 4, or we in dilemma whether to start a treatment or not, we can go for antibody testing.
Okay. So euthyroid women with TPO antibodies also are at risk for developing subclinical hypothyroidism in the first trimester and thyroiditis postpartum. So have a high index of suspicion for and do TPO antibodies wherever you think you can. But then I come from Hyderabad where TPO antibodies are easily available in many labs. I should not have such a guideline as to do TPO antibodies for rural areas, right? So in rural areas, you have a higher, lower threshold to start prescribing thyroxine. Is that what you would say, doctor, endocrinologist?
In rural area, again, we have to monitor the TSH values.
Yes. So because this TPO antibodies are associated with all these complications like increased fetal loss, perinatal mortality, large infants and higher pregnancy loss, especially in IVF cycles, we should be able to advise and get it done. So we are all using the pregnancy specific, trimester specific ranges for diagnosis of hypothyroidism in pregnancy. So between the ranges of 2.5 and 4, you are advising TPO antibodies and then making the decision, right? So we move on to the second case. Third gravida, previous one live issue and one miscarriage. It's now comes to us at 6 weeks. She's a known hypothyroid. She's already on 50 microgram levothyroxine, but she's on irregular follow-up. She came with a positive pregnancy test and an ultrasound showing a viable gestation. Her TSH now in first trimester is 10.6. Physician, doctor, would you want to comment, Dr. Shailja? What could be the, what are all the reasons for hypothyroidism?
You're pregnant, comes to you first and then you, previously hypothyroid and their TSH is high. Any TSH above 10 is considered as overt hypothyroidism and we go ahead and treat. And with pregnancy, there is a sudden need for more than 25 to 50% of the previous thyroid dose. So if she is on 50, maybe we should make it into 75 and follow up with every 2 to 4 weeks. I would prefer 2 weeks with a TSH and an FT4.
So with this TSH of 10, you would
yes,
increase from 50 to 75, or would you like to do more? Would you be trying to overcorrect and then go back, or would you go a gradual correction?
See, even if the TSH was normal, the pregnancy would ask you for an increase in thyroxine.
Yes.
So 25 to 30%
would be high, but would be the increase. So with an overt TSH, yes, we would go ahead with increasing, and you can monitor it. Or you can overcorrect and bring it back, or you can just go ahead.
So what are all the causes of hypothyroidism, just to recapitulate?
Yeah, in early pregnancy, it is the HCG. HCG can receptor stimulation will be there, and even the thyroid globulin antibodies also will be increased. So this can cause hypothyroidism. There may be a transient gestational toxicosis because of the HCG. We can wait. We need to monitor. We need to keep it at like the general thing is to keep it at 2.5.
Would it be safe to say that in early first trimester you may actually get a lower TSH value, and if you don't do anything about it, it may be higher later on?
TSH value may be a little, I mean, it may be increased with an FT4, which is normal. Then if it is beyond 10, if your TSH is beyond 10, you need to start the medication.
Okay. So the commonest cause of hypothyroidism is chronic Hashimoto's. Would you say that? Yes. Tell me,
I wanted to say that have a simpler increase in dose, because first taking out your calculator and saying she's taking 75, let me increase this.
Correct.
So a rule of thumb would be that if she's taking a dose which is less than 100 micrograms before pregnancy, we increase the dose by 25. But anyway, after 4 to 6 weeks, you're going to repeat it. And if she's taking a dose above 100, we increase the dose by 50. Okay. So that will be simpler, and then we can go on to...
Okay, that's one way. So should we worry about iodine deficiency, Dr. Shailaja?
Iodine?
I mean, we know we are all using iodized salt, but still in India, not in cities maybe, but should be a worry.
For a pregnant, around 150 microgram per day.
Yes.
We have iodized, iodized salt, but still we should look at it because there is an increased excretion of iodine during pregnancy. We need to look at the iodine and correct it.
So because of this panel, I came to know there is something called, there is some person called Salt Commissioner of India who looks at whether we are delivering iodized salt to the whole country. And it has, they have shown that over past many decades that the iodized salt consumption has increased 76.3% from somewhere in the 30s. So still there are households which don't use iodized salt. And all these Instagram reels about using Himalayan pink salt, would the endocrinologist comment on that?
Actually, in our area, we use the potable salts also. We don't see using Himalayan salts at our periphery.
Correct. So a lot of people don't understand the importance of that iodized salt. Everything is a fad nowadays. But as doctors, I think as obstetricians, we still should insist on mention that please use normal iodized salt.
And most of the, I think, multivitamin tablets contains iodine also.
Yes, obstetrician.
Again, because of this panel, I got to know that 200 million people in India are iodine deficient. That means 20 crore.
That's a
and
lot.
Also because we are a salt producing country, the standards of adding iodine are not maintained everywhere. Even though I say, okay, Tata salt and this salt, and they may not be having what they have on the packet. So literally, we really have to worry about iodinization of...
So this is a preventable cause of hypothyroidism, and we must do our bit to tell patients. So what should an obstetrician know about Hashimoto's, doctor?
So Hashimoto is an autoimmune disorder of the thyroid gland, and most of the it is one of the commonest cause of hypothyroidism, and it is a cell and antibody mediated destruction of thyroid gland. It's antibody mediated destruction of thyroid gland, and we should do anti-TPO antibody testing in a case where there is a recurrent history of abortion, or the female who has a irregular menstrual cycle with goiter in her neck. And also those women who are going for the ART techniques, reduce the chance of failure.
Yeah, so not only Hashimoto's, you are looking at the autoimmune status of the thyroid, you should always keep a high index of testing for other autoimmune diseases. That's what I wanted to bring out in this point, because we are dealing with very high risk pregnancies nowadays, recurrent pregnancy losses, IVF failures. So we shouldn't hesitate to advise for lupus antigens and antibodies and ANA profiler. To the surgeon, I had to search for questions for the surgeon in this panel. So, first of all, what are the indications to do a thyroidectomy in an individual? And if I have a young woman who's had a thyroidectomy, what should I, as an obstetrician, think of, be prepared for?
Thyroidectomy nowadays, most common cause is cancer. As much as possible, surgery is being taken as a second line of therapy. Nobody wants surgery, and some great person, I forgot his name, he said that surgery is the failure of medicine, because we never leave a person same. We always damage them some way or the other. So the whole drive is towards non-surgical. So even in cancers, so if you see a very well differentiated cancer, and if a person is pregnant, can postpone. And nowadays, even we think of if it is papillary carcinoma or follicular carcinoma, if you are operating, if it's a single focus, hemithyroidectomy is enough. Unless until it is multifocal disease, or if it is associated with local spread or distant spread, then we will go for complete thyroidectomy. So most common cause for surgery is cancer. But having said that, Graves' disease is, and of course, as you have written there, the large goiters and everything, they are a tricky situation. So if a person is so symptomatic, then there are things what we call as alcohol therapy and everything, we can reduce and push the date of surgery beyond the delivery.
Okay.
But Graves' disease becomes a tricky situation. Because
we will discuss this.
Yes, because the medical treatment is also very risky. And what I find nowadays, the pregnancy also is a bit different, because the pregnancy is much later. People are coming, a lot of people are there with what we call as a precious baby, where they are having kids, or they are pregnant much later in life or much later after marriage.
Yes. We are seeing women getting cancers very young, and we are seeing women getting pregnant much later. So we have to know about malignancy and offering fertility to post malignancy women.
This situation, especially in Graves' disease, even if a person is not pregnant and she is planning, I would suggest, rather than radioiodine, which can have systemic effects, we do not know if there is any other effect anywhere else, because ovaries do take up iodine also. So I would suggest definitely before pregnancy for Graves' disease, go ahead and get a thyroidectomy done. But once you are pregnant, it becomes a tricky situation. There is no universal black and white what do you call
So it's
guidelines.
a very situation-based, case-based decision that you're going to take.
We have to see how, whether it's a precious baby, how old the person is, how many
and
pregnancies,
the function of the thyroid is.
how the function of the thyroid, how well it is controlled. And because both the thyroid drugs, anti-thyroid drugs, cause teratogenesis, how many people are really accepting it, and how well can we actually explain it? It becomes a very tricky situation. So it will be more case based, how well the educated they are, how much they can understand. Based on that, we will have to take a call whether we can operate, or we just have to continue with the
So this is the one situation where I think the preconception check will really help women, especially with focus on thyroid disease, right?
I just want to add
Dr.
two
Shailaja, yes.
points, that any surgery during the thyroid surgery, the main indication is it compressing the thyroid, is it life threatening. In that case, you go ahead and do it. And the preferable time is, I think, between 14 to 22nd week, when can go, provided especially in graves, if there is anti-thyroid drugs cannot be used either because of allergy or any other reason, then you have to go. Otherwise, you wait. If you undergo a surgery for thyroid, you have to wait for at least 6 to 1 year before you conceive.
Excellent. That's a great point. Yes. So, clinical features of overt hypothyroidism, would the endocrinologist care to tell us?
So the overt hypothyroid weight gain, lethargy, irregular menses, hair fall, goiter, and failure of conception, and recurrent pregnancy loss, sometimes menorrhagia also. Patient might go. Also severe forms like Bedlam coma, altered mentation, petechial effusion, cardiac failure.
In a very severe case, right? So, is it safe to say that I think gynecologists diagnose more hypothyroidism than anybody else, because more women,
Yes.
because they'll come to us for hair fall, for acne, because you have some hormonal issue, they come to us. So, we are the people diagnosing more hypothyroidism than anyone else.
True.
Preconception check becomes important, and being able to diagnose early is also important. So, why are we so worried about hypothyroidism in pregnancy? Obstetrician.
Hypothyroidism in pregnancy is associated with a lot of complications right from the first trimester to delivery. In the first trimester, we have increased recurrent pregnancy losses, you can say, increased abortions, and if treated, any thyroid disease, if treated in the first trimester, can lead to again teratogenesis and all. Then, sorry, we are talking about hypo. And in the second and third trimester, we have found that there is an increased incidence of preeclampsia, that is pregnancy-induced hypertension. Preterm labor is there. PROM also in some studies has been. Finally, when we are monitoring a baby of hypothyroidism during labor, you have more of fetal distress because of fetal bradycardia and because of non-reactive CTGs. And after delivery, we find low birth weight babies, and we have, because of all these problems, we tend to have more cesarean sections because of fetal distress, or because they being small for gestational age babies and having more of more decompressed, compromised. And then finally PPH, because number one, patients have more incidence of anemia because associated with hypothyroidism, and number two, because of inability of the uterus also to contract properly, because
myocontractility is musculoskeletal effects
because of
hypothyroidism.
increased creatine kinase, but that is, we have to face the PPH, whatever the biochemical problem.
So, even with respect to assisted reproduction, the fertility outcomes are worse in hypothyroid women. So, it is important for us to do a preconception workup. So, what about the fetus and neonate of a hypothyroid mother, to the neonatologist?
The fetal and the neonates.
What is happening to the fetal thyroid?
Yes.
All the time we are talking about maternal thyroid.
Yes, we were talking about basically, I would say screening of the lady should be done even before she conceives, because the thyroid hormone is one of the hormone which is very necessary for the overall development of the fetus, starting from the energy metabolism, fetal growth, fetal brain development particularly. And it has been found that there are thyroid receptors present in the fetus even as early as 8 weeks. And the fetal thyroid is still in the process of organogenesis. There's hardly any secretion. The fetus is entirely dependent on the mother during the first and the second trimester.
Yes.
Especially what is very important is the intellectual development, which can take a back seat if the thyroid hormone is not adequate during the periconceptional period and immediately after the conception. So that is
this neurocognitive development or intellectual development that you're talking about. Suppose somebody with subclinical hypothyroidism has a child and she has not been detected, and you find out at term that she was hypothyroid. What difference, how much difference would it make to the intellect?
Sorry, you told me.
How much difference would it make to the intellectual development of that baby?
Yeah, see, we do not have any structured studies to show about that. But of late, we are seeing a lot of children having autism spectrum disorders, having cognitive disorders, and most of the time the reasons are unexplained. We need to go in detail and see, even in a thyroid mother, hypothyroid mother who was diagnosed during the pregnancy, and subsequently how are the intellectual development of these babies. It is important for us to look into this aspect of it. Like you told, thyroid disorder is something which has not been taken very seriously. The pre-counseling thing before the wedding, before the conception, I think the thyroid hormone needs to be looked very seriously in the women, because it is during the initial 8 to 10 weeks, which is very important for the fetus, since the fetus has got no backup.
So, to the endocrinologist, who are the women we will treat? I think you already said that with the subclinical scenario. Now, we'll just recapitulate that. Can you recapitulate it for us?
Subclinical hypothyroidism, right?
Yes, hypothyroidism. Who are the women we are going to treat if we find a high TSH?
Okay, if a TSH is more than 10, we should treat a mother.
Yes.
And in a TSH between 2.5 to 4, we should do antibodies. If they are found antipositive, we should treat.
So you individualize.
Yes,
yes.
if they are not negative, we don't treat.
So there is this TSH which is normal but low free T4. What is this condition? Do we treat it? Low T4 with normal TSH.
No, we should observe the mother. We should repeat
so that is maternal hypothyroxemia.
Yes.
We just observe.
Yes.
This is a flow chart. If you have an up-to-date subscription, you can go through and keep the chart in your clinic to help you out. All the discussion that we've had is recapitulated in that. One question to the endocrinologist. So how are the maternal and fetal outcomes related to subclinical versus overt hypothyroidism? Should we, is there any difference really?
So it depends on the value of TSH, madam. There is not much difference between the subclinical and overt. There are no specific data as of now available, but as per the ATA guidelines or as per the Indian Thyroid Society guidelines, the side effect profile are more or less similar.
So as the neonatologist rightly said, there are a lot of changes in the fetus even in mothers with subclinical hypothyroidism, but there isn't enough data to actually put a pin on it and say this is what happens.
Yes.
Similarly, in the mothers, from all the meta-analysis that I've gone through, what came out was overt hypothyroidism definitely has a deleterious effect on the mother, but even in subclinical hypothyroidism, all those complications you mentioned earlier, preeclampsia or labor complications through the pregnancy, they are slightly higher in the subclinical group as well. It is not the same. So we don't really look at intellectual ability alone, but the mother's pregnancy as such becomes a high risk pregnancy.
Can I put in a
Yes.
It is not only the thyroid hormone levels which are low, it is even the autoantibodies which are crossing across to the placenta.
Exactly.
That
Yes.
also can have a deleterious
Yes.
effect on the growing fetus.
Exactly, yes. So how are we treating this hypothyroidism? What is the goal of our treatment? What is the dosage and how often will you monitor?
So initially we should monitor the mother at 4 weeks after starting treatment, and till 20 weeks of gestations, and again at around 30 weeks of gestations, midterm pregnancy.
Okay.
So to begin with, if the patient is taking tablet, for example 50 microgram per day, if you don't have any lab values in your OPD, you can go ahead with the 9 tablets per week. That is, you can double the dose at 2 times per week.
2 times per day as well?
Yes, yes. If you don't have any values, or if you have values, we can go for the pregnancy specific data. For example, in first trimester, the target range is 0.1 to 2.5, and again second trimester 0.2 to 3, and third 0.3 to 3. So we should keep the this values in our mind after starting of treatment.
Okay. So you will monitor once in every trimester, you're saying?
Yes.
That's what you said, 24 weeks and 30. So what care during delivery of this hypothyroid mother would you take, doctor? Obstetric?
As far as delivery of the hypothyroid mother is concerned, we can give her a normal vaginal delivery as long as there are no obstetric indications for cesarean section. So hypothyroidism is not an indication for an elective cesarean. However, we have to know that when I deliver this patient, she will be a chronic anemic. So any amount of blood loss could be PPH for her, which is normal for a normal patient. Then anticoagulation factors also, the amount is affected because of hypothyroidism, because the metabolism of all anticoagulant factors is slowed down. Hence, we can have PPH because of that also. Then after I have delivered the patient, and if it is by cesarean section, because the gut motility also slows down in a case of hypothyroidism, we need to be on the lookout for ileus. We need to be on the lookout for decreased lactation or failing lactation, again because of hypothyroidism, which we are not generally doing because we don't correlate one to the other, but we have to do that. And wound healing could be an issue in a patient who is hypothyroid. Then others would be anesthetic complications, which
Since
they
we don't
manage
have
on
an
the
anesthetist on panel, you'll have to take up that question.
yeah. So as such, I think per se, unlike hyperthyroidism, we don't have any acute complications, during
yes.
a surgery with spinal or with GA. But then we have to be on, the anesthetist has to be on his toes all the time, because there could be hypometabolic, all electrolyte imbalance would be there. The patient might be hypoventilating. The patient may not be having adequate oxygen saturation levels. So not only we have to look at the PPH part, we also have to keep hearing the monitor, and whenever that beep goes to 2 and it goes down, we have to know, we have to ask the anesthetist कि saturation क्यों जा रहा है, hypo क्यों हो रहा है patient को. And other things would be that drug clearance is reduced in a patient.
That's the main thing. I think if a well-monitored hypothyroid individual with well-controlled thyroid should not have too much of complications with anesthesia. So the goal of our treatment is to keep her fit for delivery and reduce the complications.
But we might not have the luxury if we have emergency patients. So we need to be on the.
If you have done a good job as an obstetrician, the anesthetist should not have any complications. So, and any advice regarding the thyroid medications after delivery, Dr. Shailaja?
Yeah. After delivery, if they are already a known hypothyroid and their thyroid was under control with a dose, post-thyroid, post-delivery, we continue the same. But if they were a subclinical or only during hypothyroid during the pregnancy, we stop it after birth or 2 weeks after the birth, and then recheck them after 6 to 8 weeks. 6 to 8 weeks, and then we decide on that. Suppose they are normal after that, we ask them to annually check, monitor their TSH so that they don't become hypothyroid at a later.
So, any note on postpartum thyroiditis? Sometimes we stop thyroxine for subclinical immediately after delivery.
Yeah.
Should we still be watching out for something?
Postpartum thyroiditis, again, it is a self-limiting. Wait for 2 to 4 weeks, you recheck it and then take a decision.
Thank you. So, if somebody has been on a mild case of Hashimoto's, that exacerbation can occur, so we should keep that in mind. And if any exacerbation, watch out and call them back for follow-up. That's why the 6 weeks follow-up for any antenatal is important, because the moment you do a 1 week follow-up or 2 weeks follow-up, we are going to our mother's place, we may not come back now. They tell us all these things, but make sure that you impress upon them that they meet an obstetrician wherever they are, if not you, somebody else. How will the neonate be monitored after delivery?
In our setup, we have screening programs for all our babies get a screening. We do the screening program for our congenital hypothyroid, congenital adrenal hyperplasia, G6 galactosemia, and PK. We started this.
Is it universal?
It is not yet universal.
Not yet
but
universal.
Most of the institutes in the private sector, in the medical colleges, have undertaken. I wish it could go to the Anganwadi levels, where when the Anganwadi workers are screening the mothers, they screen them. It is going to do a lot good. The sampling time, ideally the sampling should be done between 5 to 7 days, ideally, because in the first week we have the TSH surge, might get falsely positive. The ideal time is between 5 to 7 days. But in case we are doing it earlier, then the values different. And yes, we are going to the samples if we get abnormal values, number one, or in a preterm.
In a preterm, yes.
Yes, in a preterm we are going.
When will you repeat that?
Yes, in a preterm baby, ideally we do it once the baby is relatively stable, say about a week. But then again in a preterm baby, the TSH surge is relatively on the lower side and T3 levels are also relatively on the lower side. We now have specific gestation values. So what is recommended is if it's the extreme preterm, we repeat the values again after 2 weeks, and definitely again if the baby has not reached the post-term age of 30.
Okay.
So that is what we have to do.
So now we'll move on from hypothyroidism. We've covered everything from subclinical to overt and treatment and follow-up. We move to the case 3. This is a 29-year-old para-1 live one, came for a preconception check. He just came for some check, routine check, and last child was normal, no problem, no complications, but now she has slightly irregular cycles and her LMP was 10 days ago. There was no illness. She was thin built, otherwise no red flags on examination. We asked for a routine investigation. She had a thyroid of TSH of 0.01 and she was advised to do a T3, T4 and repeat a TSH for good measure because we have the luxury of asking in private sector. We asked for a repeat TSH, but then she never came back for follow-up. Now I have the same woman who came to me after 6 months with a pregnancy at 20 weeks and irregular antenatal care. She came with palpitations, fatigue, tremors and weight loss. On examination, she's thin built, tachycardia with the hypertension and a mild thyromegaly. The abdomen is soft, uterus 20 weeks. There is a fetal heart, but it's irritable and no bleeding PV at the moment. She was anemic. Her TSH was 0.005 and that was her FT4. We'll come to this vein index and all later, but to the surgeon before we go on to this whole discussion of hyperthyroidism. So what about a thyromegaly? Should I do something, any imaging along with all other investigations?
Imaging and that is very clearly a Graves' disease. It's
yes.
Extreme case of hyperthyroidism. It needs to be managed very carefully. But as far as imaging is concerned, ultrasound is the safest mode of imaging the...
Suppose she didn't have all those metabolic issues and she came only with a thyroid enlargement.
That's right.
What can I advise in pregnancy?
In pregnancy, of course, ultrasound is the golden standard. But sometimes going beyond that particular case, if you see that actually there is a suspicion of cancer or you have found a nodule or something where you want to assess the lymph nodes, then MRI of the neck is the next safest thing, not the CT scan. So for imaging, either it is ultrasound or an MRI. Nothing else.
Okay. And would I want to advise a biopsy if needed? Is that safe?
If it all depends upon the ultrasound. If it indicates high suspicion of malignancy, yes.
Only then. So you keep your reserved.
Yes.
That.
Otherwise, not necessary.
So what investigations would we advise, Dr. Shailaja? We already did the TSH and FT3, FT4. Are the other investigations possible for us?
Yes, we can do a TRAB and thyroid receptor, that is a thyroid receptor antibodies, which is very specific for the Graves, and an FT4 or FT3. Usually FT3 is increased in Graves. So this will, is it a gestational induced thyrotoxicosis or is it Graves? So in this, in gestational induced, the TRABs will be low and the FT3 will be normal. So these things that will help us to do. Ultrasound, again, sir has already told that it is not a contraindication. You can go ahead. And I think biopsy also, if you want to do, if there is an indication, you can do an ultrasound guided biopsy. You are not doing it unless you are really worried about. Usually the thyroid biopsies are done once we treat them and bring them down to the euthyroid level so that the vascularity is bleeding and other issues. So I think if you can postpone it, or you can do it if it is indicated ultrasound. And cardiac evaluation, yes, the tachycardia and ECG and an echo is indicated because they can go into failure. And
Preeclampsia profile.
Oh, that is P is preeclampsia profile. I think it's always good to do
Yeah,
a
that's
test and
logical. We are going to do that.
I mean, pre-armed is.
So what we will not do is a radionuclide scan,
Yes,
even if we
yes,
think it
yes,
is great.
yes.
Yes. So hyperthyroidism in pregnancy can be gestational hyperthyroidism, as ma'am said, subclinical or overt. So it is important for us to distinguish between gestational transient thyrotoxicosis and Graves' disease because the course and the treatment options differ. So what are the causes of hyperthyroidism that we see, doctor?
So causes of hyperthyroidism, grave disease, toxic maternal goiter, toxic adenoma, cases secreting pituitary adenoma, and molar pregnancy also choriocarcinoma. So in
Yeah,
this,
as obstetricians, that would be my first thing when I see a thyrotoxicity. Is it a mole? Is it choriocarcinoma? Is it a twin pregnancy? That is what will trigger my thought process. So we see low TSH, elevated free T4, T3, and all these antibodies which ma'am has said. So clinical features, just can you summarize quickly?
weight loss is there, palpitation, tremors, anxiety, increased frequency of defecation, thyromegaly, again, goiter is common, higher orbitopathy is common.
So even if there is no thyromegaly and the symptoms are there, we have to keep that in mind. Thyromegaly is not necessarily there always. So as I said, we will see all these symptoms with patients coming to us for loss of hair. That is the first thing that they come to us for, and we will have to keep an eye out for these symptoms. So what is thyroid storm? Why should I be worried about it as an obstetrician?
So it's a rare but life-threatening emergency in endocrinology. So in this patient present with a very high features of hyperthyroid symptoms.
Yeah. So it is a rare condition, but it is life-threatening. So as an obstetrician in my labor room, any day a patient can come with a thyroid storm. So I should know what to do about that. And these are all the symptoms: agitation, delirium, tachycardia, hypotension sometimes, cardiac failure, collapse if the hypotension because cardiac failure, otherwise hypertension as well, hyperpyrexia, pulmonary edema, vomiting, abdominal pain. So there is a way to assess the severity of this condition, the severe hyperthyroid symptoms. Do you use this vein index and Birch-Watowski scoring system in your clinical practice?
We often use this index, but as I said, it is very rare disorder. So during my PG, I have not seen a single case of thyroid emergency because of the early detection of these patients.
Just for completion's sake, I just, out of curiosity, I put it on the slide that there are scoring systems to assess this. So what are the maternal complications of hyperthyroidism, Dr. Manpreet?
In hyperthyroid patients are also more prone to have more pregnancy losses than preterm labor, as in both all thyroid disorders. Preeclampsia is very much higher compared to the general population, 3 to 6%, and heart failure because of the tachycardia and all patients are more prone to have congestive cardiac failure. And finally, in case she's under anesthesia, she might go into thyroid storm if
when
not
she delivers.
precautions.
Even if she delivers
Even if
vaginally,
delivers,
it can trigger a thyroid storm. So we should be aware of that. And preeclampsia, in our practice, since thyroid storm is such a rare condition, our practice, we have to remember preeclampsia mainly. Because even in your Gestosis score, you have seen that plays a part in the score. So what is the effect of hyperthyroidism on the fetus and the neonate, Dr. Shiv?
Like already told, I haven't seen either a case of hyperthyroidism, but yes, have to keep my eyes
Mild
open.
cases we do see, no, every now and then.
In my setup. Yeah, either have, yes, we have seen hypo, but not.
Yeah, in a year, 1 or 2 patients we do see those who are on treatment, on methimazole, and be converted.
So again, if you give me a chance, I would always prefer a hypo rather than hyper, looking at the complications.
Even we would love a hypo over hyper,
Yes, looking at the way things can be managed beautifully with a hypothyroidism, you have a clear-cut protocol. whereas with hyperthyroidism, they are just unpredictable. So there's so many factors acting on. So we have all the complications, you can name it, in the fetus and in the newborn. The mortality and the morbidity are extremely high. The baby is faced with situation of having too much of thyroid hormones, too many antibodies, autoantibodies, and at times hypothyroid also. So it's a difficult situation for the fetus coming from a very stormy course. So must be prepared for everything which can go wrong.
Yes. So we have to think of the disease per se and the drugs which are being used for the treatment of hyperthyroidism.
They say
So
it's
would you
better-
want to say something about this congenital hypothyroidism, because we are going to, I mean, I just brought the slide in because we are going to put the mother on hyperthyroid medication.
Yeah, congenital hypothyroidism. Okay, now this is only hypothyroidism, not secondary hyper. Okay,
just to touch upon it and go.
Yeah,
quickly.
I want to bring a case scenario. We had a late preterm, 1.7 kilo, delivering, got the newborn screen done, and the lady came to me within 1 week with TSH values very high. Okay, this lady was not thyroid patient, not ready to accept it. This was just a screening confirmatory, the TSH 100. We immediately put on thyrox. The child was started at 10 to 15. So this is the beauty of newborn screening, because we can catch it early and the telltale effects of hypothyroidism is taken care of.
Yeah.
So if according to the protocol of whatever set by the Indian Society of Pediatric and Adolescent, at any point of time, if you such values more than 40 less than 2 weeks of age, and more than 20 less than 2 weeks of age, and more than 10 after 2 weeks of age, these children need to be confirmed with a confirmatory test, which is more often than not again a TSH along with T4 values.
T4 value.
Yes.
Okay. Thank you, doctor. So how do we plan treatment for the hypothyroidism? I think we're short of time. We'll do this quickly to the endocrinologist. Hyperthyroidism, how do we treat?
In the first trimester, we should go for propylthiouracil.
Yeah.
And in the second trimester and third trimester, we can go for methimazole, carbimazole.
Yeah. So we will avoid methimazole in the first trimester because
of hypertoxicity.
Yes. So and switch to methimazole in the second and third trimester.
Yeah,
we do TFTs every 4 to 6 weeks. We can use beta blockers if they have severe symptoms. And the goal is to maintain persistent but mild hyperthyroidism to prevent fetal hypothyroidism. So that is the goal. Total T4 should be 1.5 times the non-pregnant reference range, and TSH below 0.08 with the lowest possible dose. So these are the drugs we use: propylthiouracil and methimazole and propranolol. Can we do thyroidectomy in pregnancy? Surgeon. We don't use radioactive thyroid iodine, but is there any rare scenario?
Definitely, thyroidectomy can be done in pregnancy. It sounds very big, but it is reasonably a simple operation. We can do it, but it is always best to do in the second trimester. Most of the times 14 to 22 weeks.
Yes.
So if surgery is definitely necessary, we can do it. But I would also say that if somebody is hyperthyroid and if you are seeing them in the first trimester, you should counsel them for surgery in the second trimester.
Because you don't want a complication in the delivery.
Because there are so many uncertainties with the mother, with the results, with the neonatal management.
So have a
and
multidisciplinary meeting, call, make sure she sees the right specialist and gets a full counseling.
And definitely suggest and discuss this, because surgery during pregnancy people may be afraid of, but it is right for us to counsel them and give them all the options.
Correct.
It is for them to decide.
It is for them to decide. Thank you. That's a very good point. Yes. So again, anesthesia complications, the physician will get a referral saying fit for surgery, fit for delivery, what to look for. Dr. Shailja, would you want to tell us what we should be looking for? Or
So nowadays, I think risk consents are very, very important. Like the
Yes, so
we had
it's
a
a
previous.
high risk consent
It's
that
a
I'm
high
going to
risk
take.
consent. One is
Yeah.
because it's a hyperthyroid and the cardiac arrhythmia, like you have already told, thyroid storm, though very rare, is a possibility. You don't know if that patient is going to develop. So it is definitely going to be a high risk and with close monitoring. Post-operatively, it has to be very closely monitored. Cardiac and may require, I mean, will definitely require an ICU.
So we will
setup.
try to do in regional anesthesia and try to avoid general anesthesia, right? As
I don't
obstetricians,
know.
we
Can
only
they do it
want
under regional? Thyroid,
spinal
I think so.
epidural. Yes.
Epidural also, I don't know because it is high up, no?
Epidural.
Delivery, I mean, you're talking about delivery.
anesthesia,
Okay,
yeah,
delivery
yeah.
is fine. Yeah,
Yeah,
I'm talking
yeah.
about the thyroid surgery.
Right. So what are the delivery considerations? Quickly, Dr. Raman.
In hyperthyroidism, not an indication for elective cesarean section, only obstetric indications.
Yes.
And during delivery process also, I have to be worried that she could land up into thyroid storm. So I have to be prepared with my drugs and be ready to recognize the signs earlier and
So
manage
is this a
those.
lady you will deliver in a small nursing home setup?
She should
Do you
not,
think you
yes.
can manage?
No, best
No. So
it has to be
a
a tertiary.
hypothyroid, well controlled, you could probably take care of in nursing homes, but a hyperthyroid, preferably deliver in a tertiary level. So all panelists, I would request one practice pointer you would like to give the obstetricians today, and we end this panel. We'll start with the endocrinologist.
So at first ANC visit, do TSH, normal, no, nothing to worry. If case is more than 4, you should start treatment with levothyroxine. The TSH is suppressed, you do FT4 level. If the FT4 level is normal and TSH is still suppressed, you just observe after 1 month.
Okay.
It can be gestational transient thyroid
Yes,
toxicosis.
so observe, yeah.
Don't start treatment with
Individualized
PT or
treatment, yes.
carbimazole.
So early screening, you are definitely recommending screening at the first visit.
Yes.
Yes, Dr. Manpreet.
Critical point that I would like to bring to everybody's notice, because this is a mistake that I made for a very long time. If the patient came with a TSH of 20, I used to say, हाँ 150 start कर दो. And if she used to come with a TSH of 7 or 8, I used to say, let us start with 25 or 50. It has nothing to do with the TSH levels. We have to give a dose. If it is subclinical, we start with 1.1 to 1.2 per kilogram body weight. So it's not the TSH level, it is the body weight of the patient also, which I need to consider before I start giving her doses. And if she is above her TSH is above 10 milli international units, then I start with 1.6 minimum per kilogram body weight, and that is how we bring their thyroid levels to normal. Otherwise, we are going wrong.
Excellent. Dr. Shivleela.
I would insist on newborn screening.
Newborn screening for all. So we hope the public
insist.
sector will make it available,
Yes.
and we hope everyone
and it's
has
a very
access
simple,
to this. Yes.
very cost effective, but would go a long way in doing good to the mothers and the babies.
Absolutely preventable causes of
Totally preventable
intellectual disability. So
yes.
we must insist on newborn screening.
To the,
yes.
and to the lady in the periconceptional period.
Yes. Dr. Shailaja.
I would prefer the postpartum screen.
Yes.
After 6 weeks, that you can transfer the case
So
to the physician.
if you've delivered a hypothyroid or hyperthyroid, it's not enough. After 6 weeks, she wants to
make
see
sure.
that patient. So send her to Dr. Shailaja. Dr. Vijay, yes.
Things. One, for a surgeon and kind of case, thyroid problems, it's cancer. So if it is a very well differentiated cancer and you've done your screening, everything, it is very localized in one particular lobe or one particular somewhere. If she is later in her pregnancy, don't worry, you can postpone. The results are not at all very different if you postpone the treatment for few months in time. So if it is extremely well differentiated cancer, very localized, don't worry, you can postpone. If they are 22, 26 weeks, please postpone the surgery or
Surgery till
treatment
after the delivery.
After
Yes.
the delivery.
So
But
early, if we diagnose 14 to 22 weeks, you think you can still do a surgery?
yes, if it is
If
early,
we diagnose late, we'll do it after
yes,
delivery. Okay.
because cancer has got a certain what you call psychological things. If it is early, please give them an option.
Yes.
And surgery is reasonably safe between 14 and 22 weeks. Okay, as far as there are two more things in Graves' disease, again, there are a lot of uncertainties with the baby and everything. Please take care of a lot of things. If it is a precious baby,
the
how
medical
old is
aspect
things,
has to be
a
well
lot
taken
of
care
things.
of. Yes.
If it is necessary, we can do Graves also surgery. As far as hypothyroidism and large goiters and everything, if they are colloid goiters and if there is a pressure symptoms,
Only then you would advise.
no, not surgery. You can use alcohol injection.
Alcohol injection to reduce the size.
To reduce the
Yes.
size.
Oh,
And
that's a
again, we
great.
can postpone the surgery. If it is not working, yes, we can always do.
Okay, thank you. Thank you so much to all the panelists for covering the topic comprehensively. I hope we all got good points to take home today to our practice. Thank the organizers for having us here. I'll take leave now. Thank you.
Thank you, the organizing committee, for having such a wonderful brainstorming sessions and mind-blowing hospitality. Thank you, each one of you.
Yeah, again, I ditto
Thank you,
what
everyone.
ma'am says, and it's been a privilege for us to be here. And secondly, it has been really enlightening. There are so many things that we did not know, or probably we have forgotten, that we got, revised, probably, highlighted.
Thank you. This was a wonderfully prepared slideshow, ma'am, because it brought out all aspects. And thank you for the organizers. Thank you so much.
Thank you all our panelists and moderator for this session. I request the moderator and panelists to proceed to the gratitude desk for felicitation. I call upon Dr. Rajalakshmi Chanda ma'am and Dr. Aarti Raghu ma'am for felicitation.
We'll move on to the next session. Behind every loss is not just a missed heartbeat, but a silent scream for answers. Now I call upon Dr. Mahesh Korigal to share his clinical expertise on recurrent pregnancy loss treatment. I request Dr. Gangambika Nishti ma'am, Dr. Umesh Chandra ma'am, and Dr. Asharani Kanaki to chair the session. I call upon Dr. Sharda Gudge to introduce our speakers and chairpersons.
Good afternoon, everyone. Our speaker is Dr. Mahesh Koregol. He is a Our speaker is Dr. Mahesh Koregol. He is exclusive infertility and IVF practitioner more than 17 years across India and Africa. He is a consultant at Nova Fertility Center at Bangalore. He is member of KISAR, ISAR, IFS, ICOG, IAGE. He is a reviewer of a journal and International Journal of Infertility and Fetal Medicine. He published 5 research papers at international level. Sir name is in infertility and IVF specialist at Bangalore very well. Our chair, warm welcome to our chairperson, Dr. Gangambika Nishti ma'am. She is retired professor and HOD of MRMC Kalburgi. She is the founder and chancellor of Sharan Baswa University, Now she is HOD and professor of LMC Nepal. She is a life member of ACOI and KSC Association of Gynecologists of India. Dr. Asha Rani Kanki, she is assistant professor at ESIC Kalburgi, Gulbarga. She is executive body member of Foxy Kalburgi. Her area of interest in high-risk obstetric. Dr. Suman Umesh Chandra, she is professor at MRMC at Kalburgi. She is a consulting endoscopic gynecologist and laparoscopic hospital at Kalburgi. Thank you, ma'am.
Good afternoon, everyone, and I thank Bidar OB Society and Ksoga for inviting me for a lecture here. And I understand it's a post-dinner session, and after a long session of a panel, I am doing it. So kindly bear with me. I hope your time will be worthwhile, because I see a lot of RPL cases. I do have an infertility study group. If you are not in my group, please send me a message on this number, WhatsApp number. I will add you. My basic small talk is on RPL. So as you all know, the RPL is lot of questions patient asks. Why did it happen, and how do I manage this, and what are the things I can change? And they go to a lot of religious places, temples, Swamijis. Before they visit you, they go to a lot of quacks also. They go for Ayurveda and other things. So RPL, you know that 3 or more consecutive losses that occur. Don't want to go into too much into definition. You all know it. So lot of conceptions do undergo miscarriage. So anybody you ask, even normal pregnancy, whoever have delivered, majority of them will say that they had experienced some kind of a biochemical pregnancy, some kind of a miscarriage or something like that. It is not uncommon. They can have a live birth after a certain stage, but then they will give you a history that I have had a miscarriage. So even among your own friends, if you ask, 2 to 3 at least will tell you that they had some kind of a miscarriage before they had a birth, or even after second time they had a problem. So there are actually 3 types: primary, secondary and tertiary. Primary, generally there is no pregnancy experienced. Secondary, there is some kind of viable pregnancy but followed by losses. Third, pregnancy losses, in between there are some viable pregnancies. So these are different types. So initially it can happen in an embryonic pregnancy or a fetal demise, or that is embryonic or fetal demise can happen where an embryonic pole more than 5 mm without cardiac activity. So these are the typical cases which are likely because of any aneuploidy embryos. Aneuploid embryos wherein genetically abnormal embryos are possibly leading to this kind of a picture. So what are the ultrasound criteria when you decide the pregnancy is failing? 20 mm without yolk sac, 25 mm without embryo. An abdominal scan, it is very difficult to identify, but then anembryonic pregnancy can be seen. But then always ask for a transvaginal ultrasound if you are sending it to a radiologist. And it is important to understand what are the risk factors here. Main risk factors is maternal age. Now since the age of maternal age, by the time they had a first pregnancy or they are trying for a second pregnancy, it is always above 30. So whenever maternal age is higher, there is a possibility of low quality eggs and aneuploid embryo. Previous miscarriages also increase the history. If there is a previous miscarriage, almost 40% after 3 consecutive pregnancy losses. Obesity increases the risk of both sporadic and recurrent miscarriage. Environmental factors like smoking, caffeine and alcohol consumption, along with this new endocrine disruptors are also added now. Lot of pollution, plastic and other things are also responsible for the RPL. So guidelines used in the definition are 2 or more miscarriages. Earlier investigations can indicate fetal cardiac loss was identified. Woman older more than 35 years, couple had difficulty in conceiving, previous product of conception having a normal karyotype. So whether to do a POC, if yes, then what kind of a POC? So conventional karyotyping, then the culture failure is quite possible, fish or array CGH. And one of the most important thing before all this is if a patient is having a multiple miscarriages, it is ideal to undergo a pre-implantation genetic testing of the embryo, what we call as a PGS of the embryo, which is more prudent before, because what happens is once they undergo miscarriage, they have a lot of mental trauma, physical trauma, financial loss, because they have to undergo repeated miscarriage. There is a hope, then again it undergoes miscarriage. To prevent this, always it's better to identify a pre-implantation genetic screening of the embryos, that is PGS of the embryos. At least I do 4 to 5 PGS in at least in a fortnight, that is in 15 days, and I see lot of embryos coming as abnormal. So this is important, because you see there are a lot of factors wherein there could be thermophila related, genetic factors, anatomical factors, autoimmune factors. So what you can change is anatomical factors. You can help them by correcting anatomical factors and endocrine factors. Chromosome is something you can identify but you can't change. So there is always a immunological angle, thermophilias and infections, which are still not into a concrete evidence based reasons. So ANA is possible but not confirmed, and other immunological causes are there, which is a possibility. So repetitive first trimester losses are because of the genetic factors, unembryonic pregnancies, history of malformations or mental retardation, advanced maternal age. So this has the least risk of RPL between 20 to 35 years of in the female's partner's age. As the age advances, there is a higher possibility of having an abnormal baby. So parental chromosomal abnormalities, one of the partners carries either the balanced structural chromosomal anomalies, most common is a balanced reciprocal or Robertsonian translocations, anembryonic or embryonic chromosome abnormalities because of the monosomy 45XO or triploidy, or male responsible for the sporadic miscarriage. So you can do a genetic counseling, you can do assisted reproductive technology like PGD, use of a donor oocyte or donor sperm, which is not easy to accept, but then that can be tried. So I'll show you a small example of how I do this. See, this is a common Hamilton thorn is what is used for doing embryo biopsy. So let me tell you once, let me stop this. See, what you are seeing is a day 3 embryo by doing a IVF and ICSI. We create an embryo. Once the day 3 embryo is formed, we take a small piece of the embryo, that is a biopsy of the embryo is done to assess the aneuploidy. What is the reason for miscarriage here? So if you see, we are using a laser here. Can you see the laser? So we are opening the trophectoder, that's the wall of the embryo. Now we are going to take out one piece of the cell, one cell from here we take. This is a biopsy of this embryo. This particular cell represents the embryo. If any aneuploidy is there, reason for miscarriage is there, we will come to know. So what I am doing is I am taking a single piece, single cell of this, and I am sending biopsy to understand whether this is an aneuploid embryo, whether chromosomal incompetence is there, any chromosomal abnormality is there. I can identify doing. Can you see now? Smoothly I can take one piece of it and I send this particular piece for the testing. So this is one of the finest examples of how a embryo biopsy is done. I do at least 4 to 5 biopsies in 15 days and I see lot of aneuploidy. Can you see now? This is not affected. No, I am saying send this cell for embryo biopsy and then I get an idea. So I'll show you some of the pictures of my own patients wherein we have done. This is my patient. She is a young lady, 26-year-old girl with 8 miscarriages. So when we do a pre-implantation genetic testing, can you see all the embryos are abnormal? Can you see there is complete complex abnormality, or there is chromosome 7, there is a grain, there is no DNA, there is again there are different abnormalities. There is not a single embryo you can transfer. There are so many embryos, but then you cannot transfer a single embryo. So this is importance of doing a pre-implantation genetic testing of the embryos, wherein you can identify whether this is a good embryo to transfer, whether this is the reason for miscarriage. Though the lady is young, so many embryos are there. It is like you are sitting in sea, there is so much water, but you cannot drink that water because it's not work consuming. In the same way, so many embryos are there, but you cannot use the embryo. This is my own patient. So I do lot of cases like this. So let me show you one more. See, this is another lady. So she had come from United States, 3 miscarriages. When we did a PGS, these both embryos were actually looking good by embryology standards. They were saying these are very beautiful embryos. But then what happened? You see, they are chromosomally abnormal embryos. When we transferred these 2 embryos, patient conceived with twins and patient had a healthy pregnancy and she could deliver. So what I am saying is these are the examples wherein it is possible to identify a genetic reason, a chromosomal aneuploidy or an abnormal embryo before we transfer, and this is a blessing for a lot of women who are struggling with infertility or the recurrent pregnancy loss, RPL. So this is about a genetic cause or a chromosomal cause wherein you can counsel, you can use a pre-implantation genetic testing and you can rule out. So I do lot of these cases and we find lot of good result. Easier to clear is anatomical factors, uterine factors. So in my group I keep sharing lot of cases where I do hysteroscopic septal resection, polypectomy. You must, so many of you are there, you must have seen. So septate uterus accounts for almost 65% of the cases. It is one of the simplest surgeries that can be performed without doing a laparoscopy also. Just put a scope and you can clear a septum, which is easier to be done. And there are other causes which are difficult to treat, but then yes, they can be cleared. Then acquired like uterine leiomyoma, polyps, intrauterine adhesions, Asherman's and incompetent cervix, these are the other things that can be corrected. So luckily most of these problems can be corrected and a patient can conceive normally, especially septum, which is common and then which is easily correctable. So HSG also give you a greater idea, and SSG also. I have a separate class on HSG sometimes I will take, but then HSG will give you a greater idea about a uterine anomalies, any anatomical defects. So laparoscopy and hysteroscopy can be done. 3D ultrasound if you have will give you a greater idea regarding the septum. 2D ultrasound and MRI will help you. Precornate uterus, there is nothing much you can do, but yes, there is a possibility that you can do a lateral metroplasty and increase the uterine volume to a certain extent if there is a miscarriage. So we have done quite a few cases of lateral metroplasty, and then we could do the embryo transfer and then followed by a cervical encerclage, patient have conceived and delivered well. So these are the type of cases where if unicornate uterus is a reason, lateral metroplasty can be tried. Septate uterus is very common. So miscarriage is one of the most common reasons for miscarriages and one of the easiest to operate. Just use a simple scissor. You don't even need a bipolar electric source for this. You don't need anything. You just need a simple scissors and you can clear this. So diadelphys is one of the difficult procedures, especially unification is difficult, but then if the one horn is bigger, you can do the embryo transfer in one of the horns and patient can deliver. So bicornate also is same thing. And leiomyoma, suppose if there is a fibroid, all the fibroid doesn't need surgery. Please keep in mind, there are 2 things I would like to tell. All the endometrioma don't need a surgery. All the fibroids don't need a surgery. There is lot of unnecessary endometrioma excision happening because of some WhatsApp groups and other things. Please don't operate endometrioma because you will end up losing the ovarian reserve. So do not operate an endometrioma unless and until it is British fertility guidelines published this year says that there are only 2 indications for operating endometrioma. Number 1, very painful life, yes. If not painful, you just see an ultrasound. If fertility is a concern, don't operate. Second, if oocyte pickup is very difficult and it's coming on the way. Otherwise, left and right, opening endometrioma, doing endometrioma surgery or doing a bowel pull through for all, after 2 years, their life will become more miserable. They will have a frozen pelvis. So most of the endometrioma surgery are not required. What I request is, there are a lot of heroic efforts in many WhatsApp group, lot of young surgeons are trying to operate and do it. Their life will be ruined and their ovarian reserve will come down. Never ever operate endometrioma unless for these 2 indications. So my request, because I see the cases after 2 years when they are damaged, they come to us and see you can't do much about it. So these are not, because endometrioma is like a Rakta Bijasura. Everywhere there is a drop of devil, the devil comes. So same way it will again come back. So there is not a permanent solution. So please keep it in mind. Same with the fibroids. I see so many senior surgeons here. While doing cesarean, you have seen fibroids, isn't it? So many fibroids you have seen. You are still, that lady got pregnant. All the fibroids doesn't need a myomectomy. So only those fibroids which are in the mucous part, that is abutting the endometrium, only those you might need to operate. Among them also, the smaller ones you don't have to operate, they will conceive normally. So lot of people who have done a new laparoscopy surgery are trying to operate left and right. Please desist from that practice, and you do not need surgery for most of the leiomyoma and most of the endometrioma surgery. And Asherman's is something we see a lot, especially this part of Karnataka, and I also belong here, and I see a lot of cases of tuberculosis in olden days, now a lot of chlamydia cases and a lot of other cases, and a lot of patients who have undergone repeated miscarriages and D&C, we see a lot of Asherman's. In these cases, we can't do, when this is just, we know that these patients will not have a very great menstrual flow, they will have a scanty menstrual flow. If you see mid-cycle endometrium, it is hardly a good endometrium, and lot of adhesions you see in the ultrasound. So these are the cases you can treat by doing a hysteroscopic correction followed by antibiotics, and if needed other anti-adhesive measures. Cervical incompetence is there. You have to make a differentiation between whether you want to do a abdominal cerclage or you want to do a transvaginal cerclage. So you have to differentiate based on the cervical length and other factors, and you have to make a decision on the route of surgery, whether Shirodkar, McDonald's, abdominal, or any of these. I am doing little hurry because I have only 15 minutes, and these are the few complications that can happen: slipping, cutting through the suture, chorioamnionitis, rupture of membranes, or preterm labor or abortion. So bed rest is advisable, and operative tocolysis is something that is to be given but not compulsory if you are good at your surgery. And endocrine factors, just as discussed in previous panel about thyroid, diabetes mellitus, PCOS, luteal phase deficiency, all you need to take care, and thyroid is discussed just now. So these are endocrine factors, you know that it's easier to control and treat them. PCOS and luteal phase deficiency has been overfed, and all the times luteal phase deficiency, you don't need too much progesterone. Sometimes if you see a IVF center prescriptions, they are run into 2 pages. It's not always required. All you need is a 400 milligram macronal progesterone vaginally is good enough. And so I don't want to go into why I say transvaginal is, it will have a local effect also along with the systemic effect, because local quiescence of the uterus is more important. So it will have a quiescent action if there is a luteal phase defect. One more simple is hydroxyprogesterone capiate injection once in 15 days. So it's a simple injection, acts in the depot format. In luteal phase deficiency, it acts well. So most of the times infections are quite common, especially in rural places. You see that there is some broad spectrum antibiotics are given, sometimes only treating an infection, because you see that there are many situations we see when you do a hysteroscopy, we see lot of areas of infection. We see micropolyps, we see small strawberry spots. So all they will say it's a chronic infection is already there. So once you treat with the 14 days of doxymetro, most of these infections are taken care. So autoimmune factors and other factors, autoimmune factors are not really well studied other than APLA. There are few studies that is ANA positive. The best you can do is to supplement them with a low molecular heparin injections. So nothing much is required other than that. So heparin, the most cheapest one is the aspirin. Aspirin 150 milligram is a more advisable than heparin. And heparin, though there is no much evidence, as soon as you see a heartbeat, you can start with a heparin injection, 40 milligram per daily. So other coagulation factors like fibrinogen, factor 7, 8, 10 can be tested, and accordingly treatment can be done. Yeah, I am done. So how do you manage? So have normal BMI if they are obese, folic acid, vitamin B12, glycine, correct nutritional deficiencies, empiric antibiotics for chronic endometritis, luteal support, quit smoking, limit alcohol and other lifestyle factors. If they are conceived, assure them TLC is more important because stress is one of the killing is more than other things. Prophylactic aspirin, prophylactic cervical encerclage, steroids for pulmonary maturity, monitor closely near the term, and no low of LIT, IVIG, intralipid, GCF. Please remember this. Lot of IVF centers and newcomers are doing these unnecessary treatments like LIT, IV hemoglobin, intralipid and GCSF and PRP. They have no role. So empiric treatment with the care will help more than other things. So thank you all for giving me opportunity again. If you are not in my WhatsApp group, please send me a message on this number. I will add you to my group and we will have some discussion. Thank you again for Bidar Society for having me.
Great and informative talk, Mahesh. I know you since many years in your infertility workup. And about recurrent pregnancy loss, what is the role of HLA transfusion?
That's what I told you just now. Yeah. Most of them have no role. LA, LIT, PRP, none of them have any role, no proven role. More than that, 90% of the reasons are because of some kind of a chromosomal aneuploidy. That we need to find out. So most of these things have no evidence till today.
Yeah, and because most of the people are uneducated in our country, and before we refer it to you, it's because so much of our workup should be done, and it's costly also. I think I have seen many cases by giving simple blood transfusion in recurrent pregnancy loss. It has helped many of the patients. Because I have treated them empirically. I'm not treated about the HLA transfusion and all like that.
No,
so
I agree, but because what I told you, even the chronic endometritis will just need a 14 days of doxymetro and we see that it is cured. So most of the times these are simple treatment can also work. Suppose if they have tuberculosis, some kind of AKT, if they have chlamydia or some kind of endometritis, it gets cured.
No, I'm not talking about the antibiotics and all, because as immunotherapy, immunomodulation is not, you are not studied and there are no elaborate studies about that also. So what I have seen many recurrent pregnancy losses which have come to me from 3 to 9 pregnancy losses. I've just given blood transfusion. So it has helped them to conceive. I don't know what is the mechanism of immunomodulation in that patients. Okay.
Good evening, Dr. Mahesh Koregal, sir. Very clear. You gave us very clear and crisp advice regarding etiology and management of recurrent pregnancy loss. Especially your video on blastomy or biopsy is very well appreciated, sir.
Thank you.
Your remarks on IVF.
That's what I told you. There is no role of IVF in RPL unless you are doing a pre-implantation genetic testing and embryo biopsy. If you do embryo biopsy with PGTA, if you have majority of those RPL, the pregnancy losses happening in the first trimester, yes, there is a role of doing a PGTA. And I showed you, even this young girl had so many embryos, but all of them are abnormal. So this will definitely identify a chromosomal reason.
What is the cost of PGTA?
One embryo will cost 15,000 for a PGTA, madam.
And role of progesterone in unexplained RPL.
Progesterone in luteal phase defect is over-studied, over-sponsored talks are there. I don't think it is such a big thing. Most of the luteal phase defects are not there. It's only 1% among all RPL causes a luteal phase defect. But is most of the time sponsored talks are more, we feel it is a big problem. They don't need a bigger lot of progesterone pumping in. They just need a basic, whatever affordable progesterone you have is good enough. One single corpus luteum can take care of whole pregnancy. Then imagine how much progesterone do you need really? You don't need much. So either a oral route of dydrogesterone or a vaginal microprogesterone, one dose good enough. It is overstudied, over-sponsored talks, so we feel that's a big problem. It's just 1% of all the problems. Genetic causes are main, more than that.
Audience. Thank the organizers of either Obedience Society and Zonal Ksoga people for the elaborate, for the opportunity given to us.
Thank you
for sharing this session.
Thank you, sir, for the meaningful discussion on RPL and its treatment. I request our speakers and chairpersons to proceed towards the gratitude desk for the felicitation. I call upon Dr. Sunanda Bacha and Vaishali Jadhav to felicitate our speaker and the chairpersons.
Sorry to interrupt, Dr. Jyoti. Since the valedictory function will take some time, and now since our website people who have been communicating us, who have been helping us right from 3 months till date, every second whenever we call, they have been responding to us in due respect to their service. We are honoring them. I request John, Martin and Arun to please come onto the dais. Please accept a token of appreciation and a lot of love from our Ksoga, Box Society, for helping us frame each and every step of this Ksoga conference. Please encourage them. Please give a big round of applause for Arun, Martin and John. A very great work from their side, helping us in every moment of our association to Ksoga. Request Uma Madam to please come and do this honor. Uma Madam, please come. Can I have the photographer please here? Thank you, John. Thank you, Martin. Thank you, Arun. So John is not here, but he was in association with us for every moment till this event got finished. Thank you. Thank you. Thank you, Jyoti, and sorry to interrupt you.
We'll start with the next session, fluid management in antenatal, intranatal and postnatal period. To guide us through this important discussion, we are honored to have with us Dr. Deepak Dhumansure, and I request Dr. Hema Simhasane ma'am, Dr. Savita Konin and Dr. Lakshmi Sandeep to chair the session. I call upon Dr. Sandeep Gaikwad to introduce our speaker and the chairpersons.
Good evening, ladies and gentlemen. So now we are for the next session. We have with us Dr. Deepak Dhumansure sir. Sir is Prof and HOD, ESIC Medical College and PG Institute, Rajaji Nagar, Bangalore. Sir is a BLS and ACLS instructor. Sir also is in charge for workshop and scientific committee in state conferences. Sir has got immense contribution in the articles for national and international journals. Sir also has a social service side by the name Smile Mission Program. Sir has specific areas of interest like obstetrics and pediatric anesthesia. Now about the chair. Now coming to the chairpersons, we have with us Dr. Hema Simhasane ma'am. She is a director for Basavashantana Maternity Home with 24 years of experience in the field. She has been also past president of COGS. Next with us is ma'am Dr. Savita Konin. Ma'am is professor at MRMC Kalbogi. Ma'am has 25 years of immense experience of teaching as well as clinical in this particular field. Ma'am has got special interest in high-risk obstetrics. The third with us is Dr. Lakshmi Sandeep. Ma'am is Prof at Department of Obs and Gynae, MRMC Kalbogi. Ma'am is also consultant at Ashirvad Maternity and Child Hospital Kalbogi. Ma'am has been awarded with Matoshri Garutia Award to 2022. Ma'am is member of Menopause Committee as well as Minimal Accessive Surgery and Indian Society of Assisted Reproduction. Thank you, ma'am. Over to you, sir.
Thank you, sir, for the brief introduction. I bring greetings from my place of work, ESIC Medical College, PG Institute, Rajajinagar, Bangalore, the place where I am working now. And I am in depth with the BRIMS and the Bidar Association Obstetrics and Gynecologist, where I have started my early career and my practice. I know most of the seniors here. I have a part of my soul here in Bidar, even though still I am working in Bangalore. So thank you for giving me an opportunity to talk, give a platform for me to talk on this topic, fluid management in obstetrics. It's actually fluid management in antepartum, intrapartum and the postpartum actually. So I have put it in a concise way here. So to start with this topic, I'll just start with some basics of the fluids. It's very important to understand some basics here. As you all know, the earth's surface is covered by 2/3 of the water and just 1/3 of the land. Similarly, the water is in our human body is just 2/3 of the water. It's so important, and the other 1/3 is the solids. And among them again it's divided into intra and extracellular, 2/3 and 1/3. And the most important thing what we want to know here is the extracellular space, which is again divided into 80% of interstitial and 20% of plasma, which is nothing but the intravascular space. So in this 20% of plasma, which is the intravascular space, if there is an imbalance within this intravascular space, it can have a oliguria if there is a renal predisposing renal damage, or if there is a excess water here in the interstitial space, it can lead to a pulmonary edema. So most of us either are worried about the oliguria or the pulmonary edema. So it has to be balanced in this ECF of 80 and 20% here. This is very basic to understand us. I put this slide to highlight the importance of water content in the neonate, which is 80%, and the most of the others is adult males is 50 and 60. Even though the patient looks obese, still the water content in the body is again 50% only, because the adipose tissue has hardly water content. It's important for us to have a balance in life. As we all seen, balance in our professional and personal work is important. And we have seen the yesterday's kit, so nicely it was done to have a balance of everything. So here I would just like to take this slide to tell water input and output has to be in a balanced way. So if there is a decrease in the input, the output will be decreasing and there will be a oliguria. And we need to keep a watch always on the output so that the input is again maintained very well. And there is always an insensible loss from the skin, lungs and the feces, which is almost most of the time ignored. So that comes somewhere around 700 ml, which has to be added over the urine output. This has to be kept in mind whenever we are doing a good clinical practice. So coming to the topic, has such fluid management, it's one of the most important cornerstone of patient care in all departments, almost all the departments. So it becomes a vital for the patient to be taken care. In obstetrics, it does a more vital role here, because we are dealing with the mother and the child, where the amniotic fluid being a crucial for fetal development. So I was told to speak on why the fluid is given, when the fluid is given, which fluid, and how to be very precise, so that it could be a shortcut understanding. So I'll just like to talk one by one among this why. So why the fluid is to be given? To maintain the intravascular volume state. This is very important, very straightforward answer. Once the volume status is maintained, there is adequate cardiac output. Once there is a cardiac output is good, the blood pressure and the oxygen delivery will be very well maintained, and thereby causing a good tissue perfusion and a oxygen perfusion, which is the basic requirement for all the organ perfusion to happen. Here in the obstetrics, we are concerned more because we are dealing with the uteroplacental flow. So the more is the hydration very well maintained, the uteroplacental flow is very well maintained, and a placental perfusion is very well maintained. And to also combat the physiological changes, which adaptations which happens in the pregnancy with the increase in the volume and all those things. So when the fluid has to be given, this is like basic indications of the fluid is very, very important to understand. Of course, the first is the resuscitation. Whenever the patient is in a severe dehydration or in a shock-like state, any kind of shock, it could be a hemorrhagic or an anaphylactic shock, the resuscitation should start with the fluid, and it could be a life-saving. Yeah. definitely. And after the resuscitation, replacement has to be done before doing any maintenance part. So replace whatever the patient has lost the fluid, like vomiting, diarrhea, or severe in case of burns or dehydration. The replacement has to be done, and then the maintenance part has to be usually done. And the fluid is also used in not only just giving the water, also used in the correction of electrolytes, which forms a very basic entity. Not just the fluids, electrolytes has to be balanced for maintenance of the homeostasis and acid-base disorders. The fluids can be given as a vehicle for any antibiotics or any drugs to be given. Most of the time we use oxytocin as a vehicle, the fluid is used, and also to monitor the hemodynamic functions, to assess the response of the cardiac activity through the fluids. We can give small boluses and then assess the monitoring of this fluid. Which fluid has to be given? Of course, we all know this is either the colloids or the crystalloids. The colloids are the semi-synthetic starch material which do not cross the semi-permeable membrane. They are retained in the intravascular space and preferred. But still, our favorite choice is always the crystalloids, easily available, inexpensive, and easy to administer also. Among that, the balanced crystalloids are the preferred one because they are isotonic to our plasma. We have to choose the isotonic one so as to the crystalloid whatever we are giving will be retained in the intravascular space. And next choice is the dextrose with the sodium chloride solution. I would advise, please do not give only the dextrose solutions, which will be again a hypotonic and which would go into the intracellular space and causes swelling. Basically, it would happen in the pre-eclampsia patients and all. So isotonic preferred, balanced solution which would be RL or the NS most of the times. And if there is a electrolyte deficiency, then we choose the fluid which has got a more of an specified electrolyte solutions like isolate P, M or G. How much to give is based on the again calculation. I have got a simple shortcut to remember this, rule of 10 and rule of 4. The rule of 10 is very basic, simple to understand. If we have planned to give 2 liters of fluid in a day, then start the patient with 20 drops per minute. That's it. It's very, if you have plans to start with 3 liters in a day, we can start it with 30 drops per minute. And if you want to do it in a per hour base calculation, if you want to give 60 ml in an hour, so then divide by 4, then it will become a 15 drops per minute. So why I have come down with the drops per minute is, this is what we have to understand to have a correct volume of fluid infusion to the patient, rather than just starting the drip as and how and we want. It is important to know how much drops per minute has to be started, so that we avoid pulmonary edema and so that even the oliguria can cause the renal damage. So we all know the basics of some maternal physiology in the antenatal period. If you want to know the fluid management in the antenatal period, we have to know that in the antenatal period there is 6 to 8 liters of extra fluid the mother has to accommodate. Along with this water, the mother also accommodates somewhere around 800 to 1000 milliequivalents of extra sodium with the water. So this is the weight gain which would happen, and which would increase the size of the uterus, breast and the blood volume. And there is a lot of hemodynamic changes and cardiovascular changes for the optimal growth of the fetus, which helps to even prevent the blood loss during the delivery. So understanding these changes is very important for a fluid management in the antenatal period. So I will just quickly run through this. There are so many changes which is happening in the cardiovascular system. To highlight more, the plasma volume is increased to 50%, the red cell is increased to 20%, and which by cardiac output is 40%. You all know the dilutional dilutional anemia which will happen here. So this physiological change in the antenatal period during the labor is also very important. Each cardiac output increases by 50% with each contractions. With each contractions, there is a increase in the 300 to 500 ml of blood volume into the circulation. So overall, there is a 75% above the baseline. There is an increase in the intravascular volume. So much of the heart has to take up. So increased cardiac output protects against the blood loss during the vaginal delivery. So with these basics of the antenatal period, the most important thing is the hyperemesis gravidarium. There is so much of, whenever there is massive weight loss of more than 5% than the prenatal period, ketoacidosis, and even in this hyperemesis gravidarum, there is not only the fluid which is deficit, the patient will also be deficit with the vitamins, especially the thiamine deficiency, and she may require hospitalization only when the persistent vomiting is more than 3 times per 24 hour and more than 5% of the weight loss with abnormal clinical presentations also. So whether it is an outpatient or an inpatient, RL is the preferred fluid for an aggressive rehydration if the patient has come with the dehydration and a severe shock. After RL, then only the NS has to be given as a slow maintenance. This is an important key point to note. We should start with RL and then followed by NS. Based on the sugar levels, only the dextrose containing fluids should be given. Dextrose should be avoided in the initial, and it also aggravates the neurological damage, so it should supplement with the multivitamins here. During the labor, unless and until it is an indication to give the fluids, I would suggest let the patient take the clear oral fluids recommended in low risk women and avoid NBL policy which is followed in the traditional practice. As long as patient can take orally, please continue to take until unless it is a high risk for a preeclampsia patient. The fluids is indicated during the labor only in the high risk patients going in a chances for Cesarian section, or the patient is given labor analgesia where the fluid management can be given, or has a fluid to be given as a vehicle for a oxytocin for as an induction. So these are some of the important indications. You should have a indication to start the fluid until unless, or else the patient can be managed with the oral fluid. So this is an article, latest article I have taken in the 2024, which would suggest 250 ml of fluid per hour has got a better outcome rather than 125 ml per hour, and which would reduce the duration of the labor better than 125 ml per hour. During the Cesarian section, there are two concepts, preloading and co-loading. Preloading is 10 to 15 minutes before the start of the spinal anesthesia. We give some 15 to 20 ml per kg body weight of the fluid. Co-loading is something like after spinal anesthesia, we can again load the same as a 15 to 20 ml. Now the latest trend is the co-loading. We don't have to waste the time before giving spinal anesthesia, load the fluid. The perfect is the co-loading, which would stay the fluid would stay in the intravascular space and prevent the hypotension. Prevention of hypotension during the Cesarian section is very important to have. We can, if not with the fluids, then we go ahead with the inotropes like phenylephrine, ephedrine or mephentermine. In the post-operative period, we usually follow this enhanced recovery after the surgery, which would suggest to start the fluid as early as possible. In the traditional concept, we keep the patient nil by mouth, maybe some more hours, 12 hours or 18 hours, most of them, or we wait till the bowel, patient has the bowel sounds or passes the flatus. We don't have to wait until unless it is a complicated case. In an uncomplicated case, we can start the fluid in 4 to 6 hours orally, so that it would enhance the patient's bowel functions by stimulating the gastrocolic reflex, which would also help in the early ambulation and reducing the IV fluid administration, and also decreases the risk of sepsis. So unnecessarily IV fluids should not be given, which would again cause a fluid overload and feeding issues due to a large volume of IV fluid infusions. We know recently this incident in Ballari, which has happened in the post-operative patient. Routine IV infusions were started and a substandard IV infusions were given, which has caused a mortality. So I would suggest routinely should not be given until and unless it is an indicated in a high risk cases. And here the problem is not with the IV fluids, it was the quality of the IV fluids. So please see to that you are giving a good quality of the IV fluids here. So I just quickly run through some slides with the preeclampsia to tell preeclampsia. Here it should be a balanced fluid which has to be given. See to that the patient over fluid giving will cause the pulmonary edema, and maintaining the circulatory volume is very important here. This slide I would just tell. So even the oxytocin, if you are giving, you have to give it in a higher concentration so as to give less of the volume of the fluid. In the preeclampsia, it is suggested 80 ml per hour or 1 ml per kg per hour of the fluid is the recommended, and the fluid of choice is the Ringer's lactate. So if we give pulmonary edema kills, but oliguria and renal failure do not kill, so administer fluid cautiously in the preeclampsia. This is the important take-home message which I would like to tell here. And in the recent article with the intrafluid therapy in adults, which was done, so in preeclampsia and eclampsia cases, there is a recommendation of restricted oral fluid or the IV fluid, including oral and IV. It should be 80 ml per hour or 1 ml per kg per hour. So I will just quickly run through which has to be done in a replacement. Finally, the fluid management would be an individualized approach based on the clinical condition of the patient, based on the gestational age, and based on the complications, whether it's a preeclampsia or eclampsia. Monitoring each case, monitoring vitals, the urine output, and the electrolytes level is very basic in the management of the overall case. Risk of fluid overload is very much there, especially which can cause pulmonary edema, and fetal well-being is to have a paramount important when decision regarding the fluid management. And ultimately, it is a multidisciplinary care including all the specialties. To have a conclusion, fluids play a critical role in maintaining the health and well-being of both mother and fetus throughout the pregnancy and childbirth. Careful and individualized fluid management guided by clinical assessment and monitoring is crucial for optimal outcome in the pediatrics. I thanks for the obstetric team for giving me this platform, and thank you.
Dr. Deepak, very comprehensive talk on fluid management. I would like to ask, when we use the fluid as a vehicle, when we are giving drugs or any medications as a vehicle, which fluid is ideal, a regular lactate or a sodium chloride, and why?
When the fluid is used as a vehicle, it could be isotonic to the plasma. So either you can use a ringer lactate or a normal saline. Because we are using vehicle, the fluid which will be giving not more, it will be less. We are concentrating more on the drug. So isotonic fluid, preferably RL, or if the patient is having more history of vomiting and all, if you are worried about the sodium and if you are not worried of sodium and chloride, then only NS can be given.
Like we are using antibiotics also, sir, sometimes, antibiotics or say inotropes. So any difference in using ringer lactate and sodium chloride?
Isotonic fluid can be used, man. Either NS is most of the time it is preferred. But avoid sole dextrose has to be avoided because it causes hypotonia, because the dextrose gets metabolized and the water just remains in the intravascular space. So this just water will go inside the cell, intracellular space, and it will cause cell swelling, especially in the preeclampsia and eclampsia patient. So please prefer isotonic fluids.
Thank you, sir.
You told very precisely about the antenatal and the intranatal and during the labor fluid management.
Yes.
Sir, what about the drugs used, the fluids used in the preeclampsia? They told don't use the DNS.
Yes, ma'am.
For the preeclampsia patients. Use only the ringer lactate and the sodium. What is your opinion to use the DNS in the water?
That's what, ma'am. The dextrose containing solutions can be of 2 to 3 types, ma'am. 5% dextrose, 10% dextrose, or dextrose with sodium chloride. In DNS, it is again DNS of 0.9% or 0.45%. If we are using DNS, which will become a hypertonic again. The hypertonic will cause intravascular shrinking, which is again not good. We have to keep a balance on isotonic fluid so that the intravascular space is maintained. Sometimes if we need dextrose, we can use dextrose with 0.45% sodium chloride, which would be a bit of isotonic. But preferred is again same, ma'am. Isotonic is good so that the fluid stays into the intravascular space. That is our main concept.
Says half DNS. William textbook says half DNS, half the strength of DNS you can use for preeclampsia.
Yes, ma'am. That's what 0.45% can be preferred, but preferably isotonic. Yes, ma'am.
Preloading in preeclampsia patients, we should be very careful. Intraoperative pulmonary edema is very common in these patients.
Preloading is, yes, ma'am. It is avoided, ma'am. Nowadays, it is not. It should not be a fixed like before you have to give preloading. Better now followed is the co-loading after spinal anesthesia. We need to load it based on the response of the patient, ma'am.
Very good, sir. Precise. Thank you.
Thank you so much.
This session has reminded us the importance of vigilant, individualized and physiology-driven fluid therapy across every phase of pregnancy. Thank you, sir. I request the speaker and the chairperson to proceed to the gratitude desk for the felicitation. I request Dr. Suman Bhalke to felicitate our speaker and the chairpersons.
Let us move on to the next session, Assessment and Treatment of PPH. From bleeding to stability, today we anchor our focus on critical steps in assessing and managing PPH. It gives me immense pleasure to call upon Dr. Rajeshri Baladi ma'am to share her clinical expertise on assessment and treatment of PPH. Welcome ma'am. I request Dr. Uma Andola ma'am, Dr. Nirmala Hiremat ma'am and Dr. Asha Mallapure ma'am to chair the session. Now I call upon Dr. Vinayak Jante to introduce the speaker and chairpersons.
Good evening, everyone. Good evening, everyone. Dr. Rajeshri Baladi ma'am is a President-elect Ksoga. She is Secretary General of Ksoga 2325, Chairperson of Fetal Medicine and Genetics Committee Ksoga 2123. Ma'am is Director and Consultant in OBG, Aditya Multispeciality Hospital, Kalburgi. Now I would like to introduce our chairpersons for this session, Dr. Uma Andola madam. She is a medical superintendent at Raja Rajeshwari Institute of Medical Sciences. Dr. Nirmala Hiremat, consultant gynecologist and obstetrician at Panchakshari Hiremat Memorial Maternity Home, Kalburgi. Dr. Asha Mallapure madam, professor and head of the department OBG, S. Nijalingappa Medical College, Bagalkot. She is a PCPNT District Advisory Committee member, and ma'am has got Academic Excellence Award in 2015 and District Rajyotsava Award in 2015.
My pranamams to everybody. Heartfelt gratitude to Bidar Obstetrics Society, Dr. Uma Deshmukh, and all the members of the Bidar Obstetrics and Gynec Society. Words fails to express the amount of bonhomie, the amount of efforts, and the amount of hard work that has gone into the making of this conference. Hearty congratulations to the entire team, and thank you for the kind words of introduction. I think heavens are also showering their blessings in the form of heavy rains now towards the end of the conference, and this is a very, very good sign that there was no disturbance at any point of time for the conduct of the conference. Every woman who participates in the creation of this nature by choosing to become a mother has a right to live comfortably, to live healthy, and to not have any kind of complications in the process of creation that she has chosen to be part of. And herein we have this important component of PPH, the postpartum hemorrhage, which is a great contributor towards the woman's mortality. And we have seen that in the slides, in the understanding that of the 4 major contributing factors for the maternal mortality, the second most important is the PPH, the first leading to be the preeclampsia. And we are more concerned about the PPH because to a large extent this is preventable, and herein we would like to have a review of how we can do best to prevent the complications and to manage and to assess, because many a woman, many promising senior practitioners who have dropped in their career as obstetric practice being shattered by the amount of blood they see in the labor room and have taken up other branches of medicine like infertility and so on. And we also know that the famous Taj Mahal is being built only to commemorate the death of this beautiful woman. So ever since, we still are in that phase, although many generations have passed through, yet we are not able to curtail this problem of PPH. So 25% of the global maternal deaths are because of PPH, and in India it contributes to more than 38% to 34% of the maternal deaths. And in India the maternal mortality rate, although has decreased largely, but still it persists, and it is to a range of 86 to 380 in different states depending upon the resources and depending upon the availability and the facilities which are there. But PPH deaths are preventable, and herein lies our expertise, our chosen profession as an obstetrician who have pledged to serve their lives to save the mothers. So the confidential inquiry into the maternal deaths revealed that why this is occurring is because very less is being done, that is too little, and either it is being done very late, too little in the form of administering and giving the resuscitative measures like fluids, oxytocic, blood or clotting factors, or too late because the resuscitation in the form of blood replacement or decision to get transfer or to get a senior surgeon or anesthetist involved is very late. And we know the more common factors are the tone, which atonicity is 70 to 90% the contributing factor, the trauma to the genital organs, the tissue that is a retained placenta, and the coagulation failure like thrombin disturbances. So triaging of the PPH is very, very significant when we choose the line of management, and having defined it as an atonic PPH, then we can direct our management protocols accordingly. So traumatic PPH, there is a direct indication for surgical intervention, wherein for the atonic PPH lies in the skill to detect, to identify and to treat. So management of PPH is the mainstay of treatment, is medical, failing which the mechanical or surgical interventions will follow. So atonic PPH, because the volume of the blood which is circulating in the uterus can go up to liters of blood in every minute, and even the small loss of blood in the patients who are anemic or who are having a low BMI or who are already having a shrunken intravascular compartment in the preeclampsia can lead to death within few minutes after PPH has set in. So assessment of the blood loss in PPH, we are in this madness of conducting the delivery, having the baby, resuscitating the baby, and then the amount of blood which is there along surrounding the table or around the patient. Sometimes we fail to even identify to what extent this could have been occurred. So, but assessing the blood loss will definitely help in our management protocol, because it helps in early diagnosis, it helps in timely resuscitation, it helps in minimizing the risk of the hemorrhagic shock which sets in, and definitely the maternal mortality, morbidity can be reduced. I am just presenting a very basic concept which we have to deal with in our day-to-day practice. We have heard of many exemplary things of pre-implantation genetic diagnosis or blastomere analysis, but we are dealing with the lives day in and day out, wherein we need to save this mother. So assessing the blood loss on a daily basis in our in the labor ward is very important. It could be either by visual estimation or standard visualized estimation, direct estimation by seeing the amount of blood which is there in the bedpan, the bucket, or more significant or easy or good method would be the brass bead drape, which is shown in the picture. There could be gravitometric estimation or the photometric analysis of the blood loss. Now, to assess the amount of blood loss by the clinical presentation is very important, because once she goes into the class 4, wherein there is a severe collapse because of the blood loss has occurred more than 2000 ml, therein sets the challenge to save the mother, although you have done the treatment adequately, but there would be irrevocable changes in the form of coagulopathy. So when there is a blood loss of 500 to 1000 ml, then the pulse could be normal, the BP could be normal, but the mean arterial pressure is reduced and postural hypotension will set in. In class 2, we all know that 1000 to 1500 ml of blood loss, pulse tachycardia sets in, BP could still be normal because there is a compensatory mechanism. The mean arterial pressure could also be normal, but the peripheries start getting cold. So because of vasoconstriction, there could be cold, clammy peripheries. In class 3, wherein there is a moderate amount of blood loss to the tune of 1/3 or more than 1/3 of the blood being lost, 1.5 to 2 liters, then definitely the tachycardia is more significant. Pulse rate is 120. So when we know that your monitor which is recording as 120, then definitely significant amount of changes or blood loss has been taking place, and the mean arterial pressure falls down, the systolic blood pressure falls down, pallor sets in, there could be restlessness and oliguria, and when the blood loss is more than 2000 ml, definitely it is a severe wherein the patient could collapse, anuria, air hunger can set in. These are the broad landmarks which we all should be aware of to see physically what are the presentation of the patient, so that we can have arbitrary judgment. Suppose the ayah, the sister, or whoever your junior staff has conducted the labor and they mop it off completely by the time you arrive, you wouldn't have an actual judgment of what or how much blood loss has occurred. So clinical assessment of the patient is very important. The guidelines for the visual estimation of blood loss say there is a small swab which has been soaked, then about 60 ml of blood loss, a medium 30 by 30 ml, 140 roughly. This we can assess more so in the Cesarian section when the mop is soaked in, and a large mop like 45 by 45 centimeters, 350 ml of blood loss. If there is a 50 centimeter spill on the ground, then about 500 ml of blood loss, 75 diameter, 1000 blood loss, 100 centimeters diameter, then 1500 blood loss. So blood which is limited only to the blood bed, that is only the bed has been soaked, about 1000 ml of blood loss, but spilling over from the blood to the floor, definitely it would exceed about 1 liter. So this quantified blood loss can be assessed by seeing the gauze piece and which is kept under the buttock, and about soaking of the gauze piece is an arbitrary description which has been given in this picture. In the laparotomy, if about 18 by 18 inch, that is about 45 centimeter gauze has been soaked completely, that means it is about 160 ml blood loss. So just by seeing the amount of soakage, then we can definitely have an anticipation of how much we are going to replace it. So what is the problem of identifying the delay in the PPH is that it was seen that the delays were because of either of decision to seek the emergency obstetric care, delay in reaching the healthcare facility, or delaying obtaining the treatment at the healthcare facility. So these were the three major delays or the problems of getting the optimum outcome of saving the mothers. The third delay, which is very detrimental, that is delay in optimum getting the treatment. Like we heard Dr. Savita, who said that don't wait to refer to a tertiary care center or to a government hospital, refer her to the nearest tertiary care center or to the nearest higher center wherein the optimum care can be given to the patient, because the golden hour should not be lost. So unavailability of the skilled person, the equipment or the drugs are another problems which could accentuate the amount of mortality which is there. So every minute counts in the decision making, in the diagnosis, in the referral when PPH is identified. Although it could be an uneventful delivery, but lo behold, we have that after 4 hours, that 1 hour, that is the fourth stage of labor, is so critical in identifying the PPH. So severe maternal acute mortality, morbidity are near miss cases which could lead to maternal death can be missed in that 1 hour period. And most of us senior obstetricians who have worked for more than 10 years would have noticed in their career that everything perfectly normal, oxytocin given, everything normal, but you'll examine her after half an hour, there would be a big clot which would have been passed from the vagina. So let us not underestimate the guidelines or the principles which have been set in. Following these simple procedures itself can save the mothers. So how do we deal with this? Is we can predict, we can prepare, and we can handle, as the word PPH says. So predict is before the delivery itself you can anticipate, especially if the history suggests that she has a previous history of PPH, or she could be anemic, or there could be a multifetal gestation, polyhydramnios, APH, coagulation disorders. Prepare the kit in the labor room. Each one of us should have this kit, and on admission check the hemoglobin levels, and at delivery follow the AMTSL. Active management of third stage of labor. I needn't repeat all the steps because each one of us are aware of the active management of third stage of labor. One of the important component of dealing the PPH would be shouting out for help, because this is very, very significant in coordinating the staff and the skilled person. Just not shouting out for help. Call by names, call the sister's name, call the aya's name, call the doctor's name, and say that please be available for this case because this is an emergency situation, and calling for help. As we are calling, also do the uterine massage, the fluids, the uterotonics and tranexamic acid. This was shown in the slides by Dr. Savita. And when there is a refractory PPH, do the compression, do the balloon tamponade, and anti-shock garment management can be done. Supportive measures like transfusion, referral, and make the preparation for surgery. So the golden hour of resuscitation is follows by the rule of 30. If the BP falls by 30, the heart rate rises by 30, the respiratory rate is 30 beats per minute, or the hematocrit drops by 30%, urine output less than 30, she is likely to have a 30% loss of her blood volume, and better indicator for acute blood loss. So the golden hour is very critical. The treatment initiated very early goes on to save a lot of mothers. So to resuscitate the ABC, continue the uterine massage and repeat the oxytocins and the oxygen by face mask, and definitely start the 2 IV lines and get more help, get saline, get blood transfusion. And WHO recommendation says that if there are no skilled birth attendants, then misoprostol 400 or 600 milligrams can be safely given to any mother who has had PPH. And if there is a cold chain transport available, oxytocin can be given. And in the absence of the cold chain maintenance, that the heat, the room stable thermometer regulated, that is the carbitocin which is being prescribed now, although still it is not come in the national recommendation, but then carbitocin has definitely shown us to be of the beneficial effect. It could be supplemented either by the misoprostol or give ergometrin or give fixed dose of oxytocin, ergometrin, do something but save the mother and prevent the atonicity. Role of tranexamic acid, yes, 1 gram IV within 3 hours of PPH episode and repeat 1 gram if bleeding persists. This has been shown by the women trial and it is safe to give to prevent the PPH. When do we give transfusion? Is assist by stabilizing the blood volume, for which we give the crystalloids and colloids which have a short half-life, improve the tissue oxygenation by giving the RBCs, and ensure that she has effective adequate hemostasis by giving the FFPs, the platelets and the cryoprecipitates. So when do we transfer and what do we transfer? Is you can give either the fresh whole blood, the bank blood, the RBCs, the fresh frozen plasma, the platelets, the single donor and the random donor, the cryoprecipitate, etc. What are the advantages of giving the component therapy is that rather than giving the whole blood, give the components because it helps in the optimum preservation of the blood component function, prevents the unwanted side effects because of the transfusion, and it rationalizes the utilization of scarce resources because one whole blood can have components which can be divided to many patients. When we give a fresh whole blood which is drawn 6 hours and less, then it contains all the elements of blood and plasma and anticoagulant and preservative. But if the blood has been drawn more than 6 hours, then only the RBCs and some platelet and anticoagulant preservatives are there. So how urgent is the blood required? When the estimated blood loss is 500 to 1000, then keep it standby and keep 2 standard cross match of 2 units blood ready. When the loss is 1000 to 1500, then urgent blood within 1 hour or 30 minutes and urgent cross-matching of 6 more units to be ordered and kept in the blood bank. And when the loss is between 1000 to 1500, very urgent, that is within 30 minutes, you should have at least 6 units of type-specific uncrossed blood available. And if it is more than 2500, then emergency, then straight off, just make a call to the blood bank, and 2 to 4 units of O negative given straight away in the absence of the required or the desired blood group, and then give the type specific blood. So when do we transfuse the FFP, the platelets, the cryoprecipitate is based on the laboratory evidence. When the FFP is prolonged and the APTT is 1.5 times more than the normal bleeding, the cryoprecipitate, can I take few minutes more? Yeah. If the cryoprecipitate has a fibrinogen content of less than 100 milligram per deciliter and the platelet count is less than 50,000, then definitely go for giving the platelet concentrates and cryoprecipitate. The adequate dose of FFP is 10 to 15 milligrams ml of per kg, which causes an increment of 8 to 10% in the coagulation factors. The cryoprecipitate 1 unit per 10 kg increases 10 milligram of fibrinogen, and packed cells 1 unit is equivalent to 500 to 1000 ml of blood loss. So massive color code to be used, especially in an emergency. Be aware of this color code that blue is O, yellow is A, white is AB, and pink is group B. So massive hemorrhage, loss of 1 blood volume within 24 hours is called massive hemorrhage, and the loss of 50% of the blood volume within 3 hours is called massive hemorrhage, and loss of blood rate at the rate of more than 150 ml per minute is called massive blood loss. So when there is a massive blood loss, resuscitate her by giving the fluids, restore the normal volume, that is crystalloids maximum of 2 liters, that is 4 bottles of crystalloids can be pumped in immediately by the time the blood is available. The colloids about 1.5 liters. Transfuse red cells as soon as possible after you have given the crystalloids, and use the coagulation screening, that is the prothrombin, the fibrinogen level, the platelet count to go and monitor the components which are given. Now what is assured when you call in for a massive transfusion protocols means that you need to have 4 units of O negative, 4 negative or O positive, and 4 units of platelets. FFP will be needed, which have to be set into thaw immediately as soon as these 4 units are being available, and at the time when MTB is activated, the blood bank will also thaw 4 units of AB group FFP or group specific FFP if blood group is not known by then. So the RBCs and platelets are initially sent, followed by FFP. So preventing the development of coagulopathy is the mainstay when you recognize a massive hemorrhage, because once the coagulopathy has set in and the bleeding is in like water, then you have lost the battle, half. So what is the ideal ratio is 1 RBC to 1 FFP to 1 platelet, and other measures meanwhile to be set in to arrest the bleeding are within the golden hour. Try for sutures if there is scope, like you are doing the Cesarian. Do a tamponade, do the packing, do the NSAG, that is the life wrap when you're trying to transfer, and also sutures, tamponade, packing. conservative surgery and radical surgery while she's in the OT. Surgical interventions are many. This has also been described by Dr. Savita. That is the cervical vaginal laceration suturing, the uterine artery, ovarian artery ligation, internal iliac artery ligation, uterine artery embolization. Final resort would be hysterectomy, but do not delay the hysterectomy when the decision has been taken, because saving the mother before the coagulopathy sets in is very important. Transfer is very important, that we all deal with day in and day out, that many patients who are brought to us from the peripheries, from the PHCs, referral centers, is clinical assessment is very important, and resuscitate the mother before the transfer is done. And even while transferring from the OT to labor room, you should have a protocol, and requisites for transfer, very important. Have an informed consent, make sure that she has a NSAG, availability of bed in the referral hospital. You have sent the patient to the tertiary care center, but there is no availability of bed, then definitely it is not. So communication is most important, and have a teamwork to communicate and to each designated work, that you have a drill, the PPH drill, and rehearse it every time so that these follow seamlessly. Even one mother saved per year by atonic PPH is a job justified and well done. So indwelling catheter with Urosac, vaginal pack in traumatic PPH, tamponade in PPH, and record the presence of tamponade and document everything and tell them that we have done this, and package is kept, tamponade is kept until she reaches the final destination. And in the documents, have the records, the antenatal records, the intranatal events, what have been occurring and what all has been given, the delivery notes, the time of delivery, the episiotomy, laceration, tear, etc. The investigation results, enclose it and send, because you don't have time to Xerox and note it down and send it. Sequence of events to be recorded, what all has been done, medication administered with the time and dosage, fluid administration and condition on transfer. So on transfer, keep the nasal flow on, 2 IV lines with 16 and 18 bore intracats, and a nurse or a doctor and a patient's able attender to accompany the patient when you are doing the transfusion. So PPH is an assessment, and the treatment focuses on early identification and management of cause while maintaining the patient's hemodynamic stability. The treatment progresses from less to more invasive methods, which includes the uterine, from the uterine massage to medications to procedures like balloon tamponade to surgical interventions or uterine artery embolization, and finally hysterectomy. Effective PPH management relies on prompt recognition, appropriate resuscitation, and addressing the underlying cause. This was, I tried to concise it within 15 minutes or 13 minutes, whatever was possible. An entire day can be spent on the management of PPH, and we pray that none of us encounter a PPH in our practice henceforth. Thank you all for the patient hearing and for the opportunity given.
Excellent presentation, elaborative talk given by Dr. Rajeshri. He has covered from A to Z. How to assess the blood loss, what is the medical management, how to transport the patients, and all of you all, I think every obstetricians in the hall must have faced this problem of postpartum hemorrhage. Though you say that all these protocols, you know that how we become panic when you see the excess amount of blood loss. What Rajeshri has told rightly is call the help. Most important is you have to call for help. You should be train our own paramedical people, nursing staff, whoever is available. They should be made aware of what is the PPH, what is the amount of blood loss, how they are going to estimate the amount of blood loss. And they should be taught. They are the most important informer for us, because most of the times we are not available. They are the informer for us, what is the amount of blood loss. So they have to be taught about all these first basic things. 1 minute of treatment also, we are going to lose one of the life of the patient. So very much informative and excellent presentation by Dr. Rajeshri.
Thank you so much, ma'am. It means a lot coming from my teachers, under whom I have studied, learned, got inspired. Thank you so much.
Thank you. Also, I thank organizers, Dr. Uma and Ksoga team, for excellent organizing the conference. We are very, very happy. She has arranged so excellent. Okay, we are all very, very happy for starting from the land, food arrangements, transport, everything has been taken care by the Bidar team. Thank you so much.
Hello, as usual, Rajeshri, very well delivered lecture.
Thank you.
And from starting from clinical assessment and visual, everything you have covered so well. It takes days to manage the PPH, but you have concised it in 15 minutes. Very well done.
Thank you, ma'am.
Thank you, Dr. Rajeshri, for a very lucid and comprehensive presentation on a critically important topic, PPH. Every time, day in, day out, we come across this, and after looking at your, after hearing your talk, we feel that it is easy now, isn't it? So, as she prayed, we also pray God not to get many PPH cases. Let them be fine, and we also will be fine.
Thank you so
and
much.
I want to tell here, Madam told about carbitocin injection. I was part of that carbitocin trial, multi-country trial, and we used carbitocin 100 micrograms immediately after delivery as we give oxytocin.
Yes.
It was double-blind study, oxytocin and carbitocin. We didn't know, and results have come out that carbitocin is a very good, safe drug which can be kept without at the room temperature. It doesn't need refrigeration. And I, from my college, SN Medical College, I gave 1,000 women participated from my college. Overall, 30,000 women had enrolled into this trial. Thank you so much.
Yes, carbitocin we have been using extensively for the past 5 years now, and every patient, even in Cesarian and normal delivery, we have almost replaced it by oxytocin, but not to quote it on a platform because still it has to come in the guidelines. But yes, studies have been very, very promising, and I have encouraged all my postgraduates and my staff in the unit to use carbitocin, and we have seen excellent. We have never had the usage of a second, actually it is only single dose, but we didn't have to supplement it with any other oxytocics like, you know, cytosinon or misoprostol. It's been a wonder drug. One of the best happenings of the century is carbitocin, I can say. Thank you all for the patient hearing. Thank you, ma'am.
Thank you, ma'am, for making us understand that the right tools, timely hands, and sound protocols can help prevent PPH. Now I request speakers and chairpersons to move towards the gratitude desk of felicitation. I request Dr. Minal Vardhan ma'am and Hirul Chand Shetty ma'am to come and felicitate their guests.
Moving on to our next session, jaundice in pregnancy. Jaundice in pregnancy is not just a lab finding, it could be the tip of a dangerous iceberg. To guide us through this complex scenario, we have with us Dr. Anita Gaura Konin ma'am, an expert in maternal fetal medicine. We request Dr. Sanjana Talur ma'am, Dr. Anna Saheb Birajdar sir, and Dr. Sudha Kerur ma'am to chair the session. Now I call upon Dr. Rameshwari Malshetty ma'am to introduce the speakers and chairpersons.
Good afternoon, everyone. About Dr. Anita Gaura Konin, working as an assistant professor MRMC Kalburgi. She is the author of book Clinics in Ops and Gynae, editor of IP Publications, New Delhi, developed and designed an app called Matra Suraksha for high-risk pregnancies, and has presented many papers and posters. Regarding chairpersons, Dr. Sanjana Talur ma'am, associate professor MRMC Kalburgi and North Zone EC member Ksoga. Anna Saheb Birajdar sir, director at GG Birajdar Memorial Hospital and Nirmiti Test Tube Baby Center Latur, expert in basics to advanced endoscopic surgeries. Dr. Sudha Kerur ma'am, professor at ESI Medical College Kalburgi, have 19 years of teaching experiences with many publications nationally and internationally. Thank you.
Good evening, everyone. Coming to the end of the two-day conference, wonderful time being at Bidar, and I thank the organizers to give me this wonderful opportunity to talk on jaundice on pregnancy. Till now, we have just listened to Paladi ma'am, PPH in pregnancy. Another to add to that, adding another mortality to the pregnant woman, that is jaundice in pregnancy. I'll not be taking much of your time, and I'll try to finish it as fast as possible. Bringing blessings from Lord Basavanna and Shri Shan Basaveshwar Temple, Kalburgi, and my alma mater, Mahadevappa Rampure Medical College, with whose blessings I could author a book, Clinics in Obstetrics and Gynae, and develop a Matra Suraksha app for maternal health to reduce maternal mortality and morbidity, taking ASHA workers into the work. To moving on to the physiological changes in pregnancy, even though sex steroid hormones change do lot of changes in mother, but still histological impact on the liver is not seen. To know some of the things that decrease in pregnancy are aspartate aminotransferase and albumin. The alanine aminotransferase, gamma glutamate transferase, 5-nucleotidase and bilirubin, there is no change. Whereas there is increase in alkaline phosphatase to almost double the times, and there is increase in alpha and beta globulin and again fall in gamma globulin. Definition: jaundice is yellowish discoloration of skin and mucous membrane due to hyperbilirubinemia and deposition of bile pigments. So to categorize it, specific to pregnancy, acute hepatic disorders and chronic liver diseases. Diseases which cause jaundice in pregnancy can be classified as unrelated to pregnancy and pregnancy specific. Things which are unrelated to pregnancy are hepatic causes: acute viral hepatitis, drug-induced hepatitis, chronic viral hepatitis, chronic autoimmune hepatitis, Wilson's disease, cirrhosis of liver, Budd-Chiari syndrome. Prehepatic causes which includes hemolytic anemia, post-hepatic causes like common bile duct stone and strictures, and biliary parasitosis. Pregnancy specific are hyperemesis gravidarum, ICP, that is intrahepatic cholestasis of pregnancy, preeclampsia, eclampsia, HELP syndrome, and acute fatty liver of pregnancy. Hyperemesis gravidarum etiology, HCG, because of increasing hormones, that is HCG, estrogen, progesterone, placental growth hormone, prolactin, thyroxine, ghrelin, leptin, nespatin 1. Lab investigation, there is slight presence of jaundice. Along with that, there is elevated liver enzymes. Serum amylase and lipase concentration is almost 5 times. Electrolyte abnormality like hypokalemia, hyponatremia and alkalosis. Complications which include both maternal like dehydration, acute kidney injury and fetal complications. Management: dietary management with ginger extract, vitamin B6, diphenhydramine or dimenhydrinate. When there is moderate hyperemesis, promethazine, chlorchlorpromazine, metclopramide, ondansetron and trimethylbenzamide. When there is severe, we go for intravenous hydration with thiamine, parenteral, metclopramide, ondansetron and promethazine. In severe intractable, we can even add methylprednisolone. Most common cause of jaundice in pregnancy: intrahepatic cholestasis of pregnancy, which is also called as recurrent jaundice of pregnancy. The incidence is 0.02 to 2.4%. Etiology: because of rise in sex steroid hormones which cause cholestasis, and also bile acid receptor uptake is reduced. The most common symptom is pruritus of the palms and the sole, and especially in the night time. Jaundice, conjugated hyperbilirubinemia for 4 to 5 mg per deciliter. ALP and GGT are moderately elevated. Transaminases can be elevated or can be normal. There is significant presence of bile acids, which is the main cause for pruritus, and depending on the concentration of the bile acids, we are going to classify and treat it. Recurrence is 60 to 80%. So if the bile acid level is less than 10 micromole per liter, it is called as pruritus gravidarum. Mild ICP 10 to 39 micromole per liter. Moderate ICP 40 to 99 micromole per liter, and severe more than 100 micromole per liter. So in pruritus gravidarum, the risk of stillbirth, timing on mode of delivery and rate of preterm birth are not changed. Mild ICP, the risk of stillbirth is 0.13% and risk of preterm is 16%, and we have to plan delivery by 40 weeks. Moderate ICP, the risk of stillbirth is 0.28% and rate of preterm birth is 19%, and planned delivery by 38 to 39 weeks. Severe ICP, the risk of stillbirth is more, which is 3.4%, and rate of preterm birth is 30%. So we have to plan delivery by 36 to 37 weeks of gestation, as quoted by Society of Maternal and Fetal Medicine 2024 guidelines. Treatment: to reduce the symptoms of pruritus, you can give local emollient calamine lotion or antihistaminic like chlorpheniramine maleate and fexofenadine. Ursodeoxycholic acid, which is a hydrophilic bile, which will replace the hydrophobic endogenous bile and help in bile excretion, so that the pruritus symptoms are reduced. Starting with 10 to 15 mg per kg body weight daily, it can be raised up to 2 gram per day. So vitamin K, wherever there is change in prothrombin time, it can be added as 5 to 10 mg per day. Next cause for jaundice in pregnancy is acute fatty liver of pregnancy, which is seen in 1 to 10,000 to 1 in 20,000 pregnancy, where the maternal mortality and perinatal mortality is high, which is 10 to 15% and 15 to 20% respectively. Risk factors include primigravidas, multigestational, male fetus and prior AFLP. So the most common symptoms are nausea, vomiting, abdominal pain, anorexia and jaundice. Swansea criteria, which is 100% sensitive and 100% with 100% negative predictive value, which has clinical features of vomiting, abdominal pain, encephalopathy, polydipsia and polyuria. USG shows ascites or echogenic liver. Histology, there is microvesicular steatosis. Lab findings, there is raise in bilirubin, that is more than 0.8 milligram per deciliter. There is hypoglycemia, there is leukocytosis. Transaminases level is more than 42 international units per liter. Creatinine 1.7, more than 1.7 milligram per deciliter. Increase in ammonia, that is coagulation in terms of prothrombin time is deranged. And urea, which is more than 340 micromole per liter. So there is liver dysfunction, hypoalbuminemia, hyperfibrinogenemia, hypocholesterolemia, prolonged clotting times, profound endothelial cell act deficient leading to hemoconcentration, acute kidney injury, ascites, pulmonary edema, severe hemoconcentration leading to reduced uteroplacental perfusion, maternal acidosis, fetal acidemia, and high LSCS rate. So treatment, multiple disciplinary approach with ICU setup, monitor PT-ANR, APTT, RBS, platelets, RFT and LFT, fetal monitoring, and plan for termination of the pregnancy with when there is deranged prothrombin time, plan with blood and blood products. General anesthesia is used, oxytocics can be continued, multisystem failure which should include dialysis and ventilation. Another cause for jaundice, hemolysis, elevated liver enzymes and low platelet count, that is HELP syndrome, which is always associated with preeclampsia, most of the times associated with eclampsia, preeclampsia syndrome. There is microangiopathic hemolytic anemia, presence of schizocytes, burst cells, compensatory reticulocytes, increase in LDH, again because of microangiopathic hemolysis, fall in haptoglobin, unconjugated hyperbilirubinemia. So serum transaminases are 10 to 20-fold, and there is thrombocytopenia due to platelet aggregation. The most common complication is DIC. Coming to viral hepatitis, so beginning with there are A, B, C, D, E. So hepatitis A virus transmission is most common transmission is fecal-oral route. Lower the socioeconomic status of a country, more is the prevalence of hepatitis A virus. In diagnosis is by IgM anti-HIV antibody, that is acute infection. Pregnancy, it is self-limiting, again the neonate may be infected again by fecal-oral route, and treatment is give immunoglobulin at 0.02 ml per kg and vaccinate at 0 and 6 months. Hepatitis B virus most commonly encountered, which is most commonly encountered in the chronic form rather than acute form. But there can be vertical transmission and horizontal transmission. Vertical transmission is maximum, that is 90% in third trimester, and intrapartum 95%. And these neonates are going to carry the hepatitis B antibody throughout. They are going to become chronically positive for hepatitis B. Diagnosis, again antibody to anti-HBsAg. HBeAg always denotes acute infection, and whenever HBeAg is positive, we have to go for DNA viral load. Pregnancy, once the mother is HBsAg positive, test for immunize the neonate with immunoglobulin and vaccinate at 0, 4 and 24 weeks. Prevention, universal screening, universal precaution. Antiviral therapy when there is acute infection using tenofovir desoprosil fumarate at 300 milligram per orally every day. But we have to look for creatine clearance before that. If it is 30 to 49 ml per minute, you have to reduce the tenofovir dose to 300 milligram once in 48 hours. 10 to 20 creatine clearance of 10 to 29 ml per minute. The dose should be 300 milligram every 3 days, and less than 10 ml per minute we have to consider dialysis, then administering the tenofovir. Hepatitis C virus, the transmission is parental, mostly in the blood and blood products. Diagnosis is HCV antibody. Nucleic acid testing should be done for HCV RNA once HCV antibody is positive. Pregnancy, there is vertical transmission and which is very high. Treatment again with sofosbuvir and velpatasvir should be considered. So when we are dealing with hepatitis C virus and pregnancy and you test HCV antibody, if HCV antibody is not detected, there is no need of further screening. If HCV antibody is detected, go for HCV RNA. If HCV RNA is not detected, again retest after 2 weeks with LFT. If HCV RNA is detected, it is a current infection. You can start treatment in the second trimester with the antiviral drugs. Childbirth, if your neonate is tested positive for HCV antibody, then at 2 months to 6 months, it is transmitted from the mother and it is not an infection in the neonate per se. So if it is at 2 months, you have to consider HCV RNA positivity. If that is not detected, then there is repeat testing should be done. If HCV RNA is positive, it is what it is a fact point that there is vertical transmission. Wait for spontaneous clearance or treat the child after 3 years of age. Whereas at 18 months, it should be again HCV antibody titers. Again, if it is tested positive, go for HCV RNA testing. Next is the hepatitis E virus, where transmission is again fecal-oral route. This is most common, whenever there is an outbreak, it's an endemic disease. So here again, IgM anti-HEV antibody should be positive when hepatitis E virus is to be screened. Pregnancy, it's only endemic, not going to cause any. Excuse me. So hepatitis E virus, it diagnosis is by IgM anti-HEV antibody. Again, pregnancy, there is a high mortality rate with hepatitis E virus positivity. Treatment again is UDCA and symptomatic treatment with ICU management. To summarize the acute viral hepatitis, hepatitis A and E are fecal-oral route, whereas hepatitis B, C, D are transmitted by parenteral route. Clinical course, everything is same. All the acute viral hepatitis have flu-like symptoms, then they are followed by jaundice, then liver involvement, then they remain asymptomatic or become chronically chronic. Acute versus chronic, hepatitis A and hepatitis E usually are acute infections, whereas hepatitis B, C, D go for chronic infections. Vaccination, hepatitis A and B, there is vaccination and those are recommended. Hepatitis C, D, E don't have any vaccination. Mortality rate is very high in hepatitis E, especially with pregnancy. Carrier state is seen in hepatitis B, C and D. Extrahepatic involvement, it is rare in hepatitis A and hepatitis E. Genome, except for hepatitis B, all other hepatitis viruses are single-stranded DNA, whereas hepatitis B is a double-stranded DNA. Laboratory testing as discussed earlier. Coming to overall, summarize the overall jaundice in pregnancy causes. That is, first one is acute viral hepatitis. Second one is ICP, that is intrahepatic cholestasis of pregnancy. Third is HELP. Last is acute fatty liver of pregnancy. So trimester wise, viral hepatitis can occur in any trimester, whereas all of ICP, HELP and AFLP are seen in third trimester. Incidence varies based on etiology, whereas intrahepatic cholestasis of pregnancy incidence is 0.02 to 2.4%, HELP is 0.5 to 0.9%, and AFLP is 1 in 10,000 to 1 in 20,000 of the pregnancies. Presenting symptoms are fever and jaundice in viral hepatitis, ICP pruritus, HELP is associated with eclampsia and pre-eclampsia and eclampsia. Again, AFLP, nausea, vomiting and abdominal pain. Hepatic synthetic function is normal in ICP, whereas it is deranged in all other diseases. Serum transaminases is markedly high in viral hepatitis. It is normal to mild raise in ICP, moderately high in HELP and moderately high in AFLP. Serum ALP is normal to mild raise in AVH, ICP it is high, HELP normal and AFLP normal. Platelet count is reduced in HELP, whereas it is normal in all other conditions. Fetal complications, transmission of viral hepatitis is vertical transmission is seen, whereas ICP there is a fetal growth restriction and stillbirths. HELP, FGR and prematurity, AFLP premature delivery. To summarize for the diagnosis, so we look if there is jaundice in pregnancy. If it is early, then it is hyperemesis gravidarum or acute viral hepatitis. If it is late in pregnancy, see if there is pruritus. If yes, then it is ICP. If no, go for testing serum bilirubin testing. More than 10, again acute viral hepatitis. Less than 10, look for liver transaminases. Less than 200, it is ICP. More than 200, look for hypocholesterolemia and hypoglycemia. If these are there, then it is AFLP. If hypocholesterolemia, hypoglycemia is not there, then it falls under HELP. I tried to cover as much as possible because jaundice in pregnancy is a very vast topic, because jaundice in pregnancy is just next to the, whenever we tell jaundice in pregnancy, it comes liver disease in pregnancy, and itself is a very big topic with a very high mortality rate. So thank you Bidar Institute of Medical Sciences and BOGS for giving me this wonderful opportunity.
Thank you, Anita madam. So definitely, as you said, jaundice in pregnancy is very difficult topic to manage, as well as you don't get that much of time when your patient lands into HELP syndrome. Have you come across some atypical HELP syndrome patients and how you have diagnosed it? There are some case reports where the patient is not a hypertensive case, platelet is normal to low, and the patient is having death within 24 hours. Have you come across some cases?
Actually, we had one patient where it was not associated with preeclampsia and eclampsia. She had come with isolated HELP syndrome. She had only features of thrombocytopenia, elevated liver enzymes, and she was not fitting into any other diagnosis. We could terminate the pregnancy because she was around 35-36 weeks of gestation, and with falling platelets, every 24 hours there was fall in platelet. We could, with blood and blood products, we terminated the pregnancy and she recovered within 72 hours. So that was one case we could do. So I think
Unclassified damage in the pre.
so now
We
that
have
end
treated that
organ damage
patient.
has come into the newer diagnostic criteria of pre-eclampsia.
Many a times HELP syndrome is like having confusing lab reports with ITP.
Yes,
so
sir.
how you are going to differentiate?
So in between the pregnancies also we need we need the platelet count to have a proper diagnosis of ITP, whereas HELP, I think once we deliver we get a rise in the platelet counts.
And classify according to
Because it's very difficult to diagnose as well as manage. Best is early to refer to or shift the patient to ICU.
I had ITP with
Yes.
confusing with HELP because at term we diagnosed, I remember her name, she was my, she was our patient.
Our patient.
Sanjana ma'am was there, where we diagnosed her as HELP, but in between pregnancy when she came out with follow-up, we found out that she is ITP. Again she came to us with second pregnancy where we treated her as ITP.
Right. Thank you. Thank you, madam.
As in other conditions also, here also I feel early diagnosis and early identification is important so that we prevent the complications during delivery and labor.
First, I would like to congratulate and thank Uma Madam and the Bidar Obstetric and Gynec Society for a wonderful, excellent and a successful conference, ma'am. And 3 cheers to you. Hip hip hooray, and hip hip hooray. So thank you, ma'am. Thank you. Second thing, brief about the post-exposure prophylaxis for HbSAg positive patient for health workers. With 1 or 2 lines, you brief it out.
Okay, whenever we are dealing with the chronic hepatitis HbSAg positive, we come very frequently. So first, whether you are vaccinated or you are not vaccinated. If you are not vaccinated, immediate dose of immunoglobulin should be given. Followed by that, you have to give vaccination. Okay, immunoglobulin is 0.06 ml per kg body weight. So you have to initiate vaccination full dose. It should be initiated. If we are vaccinated, still we have a needle prick or exposure to blood and blood product, that time you have to do anti-HBs titer levels. So if they are well in the normal range, then it can be left out, or you can give a booster dose, or you can give 2 doses of immunoglobulin, 1 stat, 1 followed by 1 month. That is 4 weeks apart. Thank you, chairpersons, for chairing the session, and thank you Bidar BOGS and Bidar Institute of Medical Sciences. Thank you.
Thank you, ma'am.
A heartfelt thank you, ma'am, for a focused and informative session. Now I call upon Dr. Pallavi and Dr. Preeti ma'am to felicitate our speakers and chairperson, and I request speakers and chairperson to proceed towards the gratitude desk for felicitation. Moving on for the last session of the day, approach to positive soft markers on scan. When soft markers appear on a scan, uncertainty follows and clarity becomes our clinical responsibility. Today we have Dr. Chinmay Ratha ma'am to decode the subtle signs and who will be telling us how to approach to positive soft markers on scan. We request Dr. Shanta Durgi ma'am, Dr. Megha Kamlapurkar ma'am, Dr. Prajakta Garude ma'am to chair the session. We call upon Dr. Vaishali Zadav ma'am to introduce our speakers and chairperson.
Good afternoon, everyone. I would like to welcome Dr. Chinmay Ratha ma'am, who is our next speaker. Ma'am is a director and lead consultant at Resolution Center of Fetal Medicine, Hyderabad. She is senior consultant fetal medicine and obs gynec Kim Sunshine Hospital, Begumpet, Hyderabad. She is visiting consultant. Welcome, ma'am. Okay. Ma'am, okay, ma'am. I would like to introduce our next chairpersons, Dr. Shanta Durge ma'am. She is clinical director at Durge Clinic and Fertility Center, recipient of Korean Award Foxy, nominated member to Karnataka State Assembly Revisory Board PCPNDT Cell 2023 and 25. I would like to invite Dr. Megha Kamlapurkar ma'am. Ma'am is director at Devta Hospital, Kalburgi, founder president of Isopub Kalburgi chapter, member of Foxy Fetal Medicine and Genetics Committee 2025 and 27. Welcome all of you.
So the good news is this is the last lecture of this conference. So all of you who are planning to go, the other good news is I think the rain has stopped. So in case you want to go, this is your window. This is the pre-test counseling, you can opt out of this lecture if you want to. In case you don't opt out, listen to this till the end, because otherwise there will be no clarity in whatever confusions we have. So at the outset, I thank the Bidar Obs and Gynae Society, Uma Madam, Jyotsna Madam, and the entire Ksoga team for this invitation. And I'm sure it's been 2 days of hectic, deliberations. And the last match, when the match has already been won, we are having the India-England Test Series, and when the match is already won, how you have to tolerate that last over, because it has to be complete for the match to be complete. Please tolerate this lecture. So soft markers are nothing but when you do scans, you pick up some points, and these are not abnormalities. They are variations of normal anatomy. Unless there is an associated aneuploidy, this can be considered as a normal thing. So the patient says, is it normal? You don't know whether it is normal. Is it abnormal? No, it is certainly not abnormal. So it's something in between, and that is the confusion. So each marker has its own sensitivity of detecting the aneuploidy that we are concerned about, and we are mostly concerned about Down syndrome. So a soft marker can be a part of normal anatomy, but when you see the marker, it becomes an indication to test more for that particular aneuploidy. So in the era of NIPT, now we have NIPT, and that can tell us 99.9% about Down syndrome. Shall we forget about soft markers? I mean, you can do NIPT and it's all over. But still, why are we discussing these soft markers is for you to understand that there are a lot of these soft markers. And if you see the pictures there from the head to toe, from ventriculomegaly to choroid plexus cyst to absent nasal bone to nuchal edema, echogenic focus in the heart, pelviectasis, echogenic bowel, short femur and humerus, everything can be considered as a soft marker. In earlier times, I have a picture there of the iliac bones, winging of the iliac bones, even so much so as sandal gap in the feet were considered as markers. Over a period of time, we have started not looking at those markers and concentrating on the other ones, and gradually we will lose focus on some particularly. Now, this is the commonest marker that we come across, that is the intracardiac echogenic focus. So when you do a scan, you see that focus. So for that, what do you need? You need a good machine. Over the years, the machines are getting better. So the clarity is getting better, and that is why we are detecting more of these. You need a good machine and you need a good sonographer who can look at a good 4-chamber view. Both are increasing. The incidence of good sonographers is increasing. The incidence of good machines is increasing. Hence, the incidence of intracardiac echogenic foci is increasing. As of today, we see an echogenic focus in 1 in 20 normal scans. But is that the incidence of Down syndrome? That is not the incidence of Down syndrome. And that is why you may have an echogenic focus in many more people as compared to the number of people who have Down syndrome. So that is something which we can see. It is definitely a marker for Down syndrome, but it is a very, very weak marker. And therefore, if it is an isolated marker, that means you look at all other markers and you don't find anything else, and she's had first trimester screening, then reassure her. If there is no first trimester screening, then offer some screening now so that you can rule out Down syndrome. Other than that, the echogenic focus has no role in the function of the heart or in the structure of the heart. This is not an indication for echocardiography. This is not an indication for any intervention postnatally. So an echogenic intracardiac focus, if it is an isolated marker, can be left as such. But to call it isolated, she must have had some screening and you must have ruled out all other markers in the scan. Then comes renal pelviectasis. Renal pelviectasis is again a common thing because the antero-posterior diameter of the renal pelvis is what we measure, and the antero-posterior diameter of the pelvis being more than 7 mm in the second trimester scan is considered as renal pelviectasis. If she has had screening for Down syndrome, don't worry. If she has not had any screening for Down syndrome, look for all other markers. If it is an isolated finding, again, it does not really increase the risk for Down syndrome. Offer screening for Down syndrome, and otherwise, just keep her on a follow-up for those pelviectasis, because as you see in the two pictures, something that can start as mild pelviectasis can become hydronephrosis in the third trimester. Possible, because lower urinary tract obstruction is sometimes an evolving condition. Can you do something? Should you terminate that pregnancy? No. All you need to do is keep her on follow-up so that if it turns to be hydronephrosis, you have already alerted the patient, and the treatment for all these conditions is postnatal. So again, something that you really need not worry, just take care and be aware. Echogenic bowel. Again, another noose in the neck. 2% of people have echogenic bowel in normal pregnancy. And again, the incidence increases with a good sonographer and a machine which can have variety of settings. So the thing about echogenic bowel is you keep changing the brightness of your machine and ensure that the bowel is as bright as the bone. If the bowel is not as bright as the bone, don't consider it echogenic bowel. Only if it is as bright as the bone, then you decide what to do with it. And for that, again, like I said, multiple times look at it, keep increasing and decreasing the gain of the machine, and ensure that it has appropriate gain settings. Now, why does the bowel appear bright? So many reasons. Hypoperistalsis is important because in Down syndrome, that's what happens. There is hypotonia, that is why you have mild pelviectasis. But there is hypoperistalsis, that is why the bowel contents can be stuck at one place, and if they are stuck at one place, they may appear echogenic. Decreased fluid content like cystic fibrosis, that's a genetic condition. Abdominal calcifications in cases of infections. If the woman has had early pregnancy bleeding, and how common is early pregnancy bleeding? Very common. So the fetus can swallow that blood mixed fluid intra-amniotically, and that is when she develops what is known as echogenic bowel because of the echogenic content of that blood mixed fluid. Then you have chronic gut ischemia, which can happen in cases of growth restriction. Now, whenever there is any of these things where the fetus has swallowed blood or there is hypoperistalsis, as the fetus starts swallowing clear water, then the hyperechogenicity will reduce. So the incidence of hyperechogenicity at 20 weeks is more than the incidence of hyperechogenicity at 36 weeks. However, if it is something that is confirmed hypoperistalsis, confirmed gut, less fluid in the bowel contents, then it will increase. So as it slowly resolves, you can reassure your patient. So what do you do? Whenever there is echogenic, look at it whether it is isolated or not isolated. If isolated, then you see whether she's had screening for Down syndrome. And if she's not had screening for Down syndrome, then her risk increases mildly. 1.2 is the likelihood ratio. And look for other abnormalities, growth restriction, other things, and move on. So the workup of echogenic bowel would be to establish the cause, to prognosticate, and to plan specific management. Now, cystic fibrosis. Should you check anybody and everybody for cystic fibrosis? Does not make sense. We have a very low incidence of cystic fibrosis in this country. So get a detailed family history. If they are consanguineous, there is a possibility. Now, less invasive is to get a maternal carrier testing done. Get her a carrier testing. If she's not a carrier, the child will not have cystic fibrosis. It has to be, both parents have to be carriers. Sonographic fetal survey, serial ultrasound assessments, and whatever you can do for the fetus. Should you do an invasive? Should you not do an invasive? This is a condition where the decision to not do an invasive should be the patient's. So give them a choice. Give them a choice that I am worried not only about Down syndrome, but also about many other things that can cause cystic fibrosis, that can cause echogenic bowel. So if you want, I will do a torch profile check for the infections. But by the time you see this, suppose it's 22 weeks, you don't have that much time. So if she opts for an invasive, she can have a torch PCR and she can have a microarray. It's not a crime to offer this. Don't push for it if you think it's not necessary. But you know how to, make it simple for the patient is an art that you have to learn while counseling your patients. And if you can't counsel your patients, stop your practice, because there is no need to practice if you cannot impart the information that you have to your patient in a way that they understand that better. So the causes of echogenic bowel are all this, and we need to rule them out as we have just decided. Increased nuchal fold thickness. Again, this is a marker with a non-specific attachment to Down syndrome as well as many other things. The risk factor for Down syndrome increases a lot if the nuchal fold is more than or equal to 6 millimeter in the second trimester. So again, look for the previous history, and if she has had first trimester screening, you're not looking at Down syndrome, but there could be many other things, and in this case it's more important to check the fetal heart because there could be cardiac abnormalities and other structural abnormalities. Ventriculomegaly, it's not just a soft marker for Down syndrome. So if there is ventriculomegaly, I have no apologies in saying that I will offer an invasive test looking for microarray, and if necessary for even associated genetic syndrome, suppose they are consanguineous, but I have to be sure that the ventriculomegaly is correctly measured, that we have not underestimated or overestimated it, and we should at least do a basic neurosonogram in all cases of mild ventriculomegaly. Short femur, short humerus, very common in our settings. Look at all the bones, look at the family in general, and look at the thoracic diameter. So you will know whether you are dealing with skeletal dysplasia or just an isolated short femur or short bone. Choroid plexus cysts are not markers for Down syndrome. If you see them, look for an open hand, check the growth of the baby, check the overall anatomy. If everything is good, the likelihood of trisomy 18 is very less, so do not worry about it. Aberrant right subclavian artery, again something that we have started doing on a routine thing. In a 3-vessel trachea view, you tilt your probe, you will be able to see the vessel whether it's going in front of the trachea or behind the trachea. It is a normal variation as long as it is not associated with Down syndrome. So if she has had good screening for Down syndrome, need not worry. Absent nasal bone is an important marker because not only it's a marker for Down syndrome, it's also a marker for many other abnormalities. And therefore, if the child has absent nasal bone, make sure that you test appropriately. Just doing an NIPT will not suffice in this case because you are worried about things beyond Down syndrome, and therefore an invasive test has to be offered. So whenever we do risk calculation, we multiply the a priori risk with likelihood ratio. And here you need to understand the importance of likelihood ratio. Likelihood ratio is a ratio. What is the likelihood of finding the marker in an affected population versus the normal population? So there are two markers here. Marker 1 is found in many people, even in the normal case, even in the abnormal case. So the likelihood ratio is only 1.05. That is not a strong marker. But in the other case, you see the likelihood ratio is 2.1. That means the chance of having the problem becomes twice the normal if that is there. So that is a stronger marker. And therefore, anything which has a higher likelihood ratio has a high chance. So this is the last meta-analysis that was done on minor markers. And I don't think there'll be any other meta-analysis because with NIPT, the role of minor markers for Down syndrome has definitely come down. Why we are discussing this here is, where is NIPT sufficient and where is it not sufficient? So if you see there are these 4 markers where the risk of Down syndrome will increase very high, almost 3 to 6 times the normal if you have those markers like absent nasal bone, aberrant right subclavian artery, ventriculomegaly, or increased nuchal fold. Whereas for the others, Down syndrome is not such an important cause. So what you should do is, in case you have, so these are just, I had done these exercises to see how things increase, but let's go to a real life situation. So Mrs. B is 35-year-old, gravida 2, para 1, L1, no history of aneuploidy, and she's had a combined screening test with a risk of 1 in 1667. That is considered as a low risk result. But suppose she went for an anomaly scan, and somebody who's just trained in fetal medicine and does very good scans has now reported that there is aberrant right subclavian artery. So what do you think now? What happens to the risk of Down syndrome? Her initial risk was 1 in 1667. So we go back to that slide of likelihood ratio, and it says the likelihood ratio of isolated aberrant right subclavian artery is 1 in 3.94. Let us consider it as 4 for the time being. So how is the final risk calculated? You don't go back to her 35 years and age of 1 in 270. What you do is, you give her the advantage of that first trimester screening she has. So her risk is not 1 in 270 into 4, but it is 1 in 1667 into 4, which is 1 in 416. That brings her to the intermediate risk group. So these risk calculators are available freely online, and one has to remember that whenever you do a marker, you should know the likelihood ratio of that marker, and you can then combine it with whatever you have and find the final risk. If there is a high risk, then you need to confirm the diagnosis of Down syndrome. And for a long time, confirmation of Down syndrome was by invasive testing. However, now we have this other test which is called as NIPT, that is non-invasive prenatal test or cell-free fetal DNA, which has a sensitivity of more than 99% for Down syndrome. So if I have an isolated marker, I want to rule out Down syndrome by NIPT. Is that a reasonable plan? Yes, in many cases, but not every time. And that not every time is what we have to understand. So if it is an isolated ARSA, I'm doing an NIPT, I'm okay. If it is an isolated echogenic focus, I'm doing an NIPT, I'm okay. But in some cases, I'm not. However, if you are dealing with only Down syndrome, then the role of all these minor markers goes to the background if you have done an NIPT. So I want you to just stay with me for some more time to understand this. Because she has had NIPT in the first trimester, if you find an ARSA in the second trimester scan, you need not do anything else. Because she is low risk for Down syndrome. But what if you found absent nasal bone? What if you found ventriculomegaly? Is it enough? It is not enough. So you will still do an invasive test, but you are not particularly looking at Down syndrome. Down syndrome will just come as a package deal. You are looking at it for all other chromosomes. So the soft markers are important because you have to understand that for Down syndrome, you've sorted out. Once you've done all the NIPT, all your Down syndrome is ruled out, and you need not worry about these soft markers for Down syndrome. But you cannot forget them for other things. So if I do a 20-week single intrauterine fetus with intracardiac echogenic focus, now are you worried? Tomorrow you have a report. You go Monday morning after this conference, the first patient who comes to you brings you the report. 20 weeks anomaly scan, intracardiac echogenic focus. Are you worried? Not worried. Not worried. So everything else is normal. Are you worried or not worried? I'm asking again and again. Is there something which will make you worried? So what is written there? Asking the right questions is sometimes more important than answering them. You have to ask me a question. And what is that question? Has she had screening? Yes. Has she had screening? And what are the other markers? This conference has been a huge success because the entire Bidar team worked as a team. Together you all achieve much more. So individual markers versus combination of markers. If there is an intracardiac echogenic focus and the scan says everything else is normal, is there a pelvic ectasis? Is there an aberrant right subclavian artery? Is there a echogenic bowel? That is the first question. Secondly, has she had previous screening or not? So we have to see, are there any other markers? Did she have first trimester screening? Is the rest of the scan normal? Is there any early onset IUGR or polyhydramnios? If any suspicion, then we have to rule out other aneuploidies. If no screening has been done, we must counsel accordingly. Because somebody has reported saying echogenic focus, unless he has reported the absence of other markers, absence of evidence is not evidence of absence. So that has to be mentioned. So the first thing to take home is, when you get a report of soft marker, do not only mention the one which is present, please mention the ones which are absent. Because all the absentees are also important. So all those who are absent need also to be mentioned there, because they did. So the role of soft markers after the patient has had NIPT, echogenic intracardiac focus, no need to any follow-up. Pelvic ectasis, only structural follow-up. Short long bones, just look at the long bones and look at the growth. Aberrant right subclavian artery, do a fetal echo and then structural follow-up. But if you have ventriculomegaly, nuchal edema, absent or hypoplastic nasal bone or echogenic bowel, you may still need an invasive test, not for Down syndrome, but for things other than Down syndrome, which are associated with this. So if you see just one finding, you know that she's had NIPT, should you still report the echogenic intracardiac focus? Patient has had NIPT. I just told you no need for follow-up. There is an echogenic intracardiac focus. Should you report it or should you not report it? You should always report it, because every finding is a finding. You do not conceal or hide anything, but you mention it with reference to the context. You say that there is an EIF, but she's had NIPT and this does not need any further follow-up. How do you counsel patients without scaring them? Medicine is a science of probability and an art of a science of uncertainty and an art of probability. So uncertainty and probability are part of the job which we have chosen. So if we don't know how this baby is going to be after birth, is not because we are stupid, but because there is no evidence to tell us how this baby will behave after birth. So when patients ask me, is the baby going to be mentally normal? I said, if that we knew, we would not be having interviews. We would not be having so many entrance tests. We could just ask everybody to submit a CT scan of their brain and choose the people we want in the unit. We don't do that. So just by looking at the structure of the brain, you cannot decide anything. And what I have done today is only looking at the structure of the brain. When we counsel, we think that we are counseling everything and the jigsaw puzzle in their mind will get sorted out like that. But what happens is we are counseling with our brain and they are listening with their heart. And that is why they are so emotional that they have not understood anything. The moment you said heart, they started thinking of their uncle's bypass surgery. The moment you said pelviectasis, they started thinking of dialysis. So bring them to your level and talk to them clearly. They may not be able to grasp it at that time. Give them time. Tell them, go have a cup of coffee, come back. That will give you time to sort out things in your unit. And that is why don't complain if they take more time in a scan unit because it takes a while to counsel them. So tell them that if the doctor says, wait, wait, because in a hurry, you cannot counsel them. You tell them that come back after 2 hours, I will sit quietly and explain to you properly. But explain properly because counseling is a multi-step process. And the only problems we are having with soft markers is inadequate counseling. Diagnosis is not a problem. The workup is a bit of a problem because doctors also want to do different things based on where they are working and why they are working. But what has to be done is pretty clear after the guidelines. How it has to be done is an art which we all have to develop. So tomorrow, if our patients are still having confusion, I think the fault is ours. We should be clear in what we have to do because the only fact that is never going to change in prenatal counseling is you have to keep balancing the odds and do no harm. So with respect to soft markers, do your best until you know better. And when you know better, start doing better. Thank you very much for sitting through this last lecture.
Yeah, Chinmay, you told yours will be the last session and last lecture of this conference. And any musical concert ends with Bhairavi. And, and if Bhairavi is, impressive, the notes of the Bhairavi will be taken by the audience in their heart home. And today, I'm sure the delegates will be very clear about how these markers should be taken seriously, what should be done, what should not be done. And if not, I'm sure, if they are not very clear, I'm sure Bidar Society will again call you for a detailed session on this. I'm impressed and lovely presentation. I'm also very much thankful to Dr. Uma Deshmukh Madam and Bidar Obstetric Gynec Society, which is very dear to me. It's a society, vibrant society, and each event they celebrate it as a celebration. So thank you very much.
It was an elaborative session and she has explained, Dr. Chinmaya Ratha has explained it as usual in a very nice manner. Even the non-radiologist or the non-sonologist, they can understand the things. Secondly, for the BOGS, this is a proud moment to host successfully the zonal conference, which is the first of its own kind in North Karnataka. So I congratulate, hearty congratulations to BOGS and the leaders of the BOGS and the entire team of the BOGS who has taken very, very sincere and sincere efforts and the arrangements, food and the gala dinner as well as the cultural events. Really, really, truly remarkable. And once again, I congratulate them. And I take this opportunity. I don't know how many voters are there in the audience, but still I want to appeal. I am contesting for the Public Awareness Committee Chairperson Foxy, and the voters are the society's presidents and secretaries. So whoever are present in this audience today, please vote for me to serve in the Foxy. Thank you all.
From clinical significance to patient counseling, you have connected every dot with precision and empathy, ma'am. Thank you. I now request the speakers and chairperson to proceed to gratitude desk for felicitation. And now I call upon Dr. Sarita Badbade, ma'am, to felicitate our chairpersons and speaker.
Ladies and gentlemen, as we draw this remarkable event to a close, it is time for the valedictory session, a moment to reflect, to appreciate, and to bid farewell with gratitude. To do this, I call upon Dr. Sangeeta ma'am.
Good evening, everyone. Before moving to before moving to the valedictory function, one important note, there is a zonal conference hosted by Nanded Obstetric and Gynecological Society on Human Reproduction and Fertility, October 11th and 12th. Request everyone to register and participate in this event. So, now we will move to end of our conference, the valedictory function. I know we all are tired since 2 days, and we will spend another half an hour to 1 hour to cherish our moments since yesterday, and we will at this end of brainstorming scientific section, and after enriching journey filled with knowledge, sharing thoughts and provoking discussions, meaningful interactions, and we have now arrived at the final and the formal segment of this grand academic event, valedictory function of the zonal Ksoga conference. This platform has brought many brilliant minds, experienced, skilled surgeons, passionate postgraduates as visionary leaders in the field of obstetrics and gynecology. And it is indeed heartening to witness this overwhelming response and active participation throughout the sessions. As we prepare to draw the curtains on this wonderful event, let us take a moment to reflect on the accomplishments and also acknowledge the efforts of the organizing team and express our heartfelt gratitude to everyone who made this conference a grand success. So I request Chief Guest for this valedictory functions, Dr. Rajshri Paladi Madam, to come over the dais. Dr. Sanjana Madam, Dr. Asha Mallapure madam to come over the dais. Dr. Premlata Patil madam, Dr. Vijayshri Bashetti madam, Vijaya Patil madam, please come over the dais. I request Prakash Korwar sir to come over the dais for the valedictory function. Since we are short of time and our winners for paper presentation and poster presentation, they want to go to their work back earliest. So we will first go with the prize distribution for the winners. So winners for the consultant for paper presentation, we had totally 28 paper presentation and poster 55. First prize for consultant paper presentation goes to Dr. Rameshwari Malshetty, Brims, Bidar. I request Rashri Paladi madam to distribute the prize. Second prize goes to Savita Badkar madam, Brims, Bidar. Request Sanjana madam to hand over the trophy. Third prize, Dr. Maheshwari, Brims, Bidar. She is not there. So, next consultant for the poster presentation. First prize goes to Dr. Ashwini Kollur, KLE, Hubli. Madam is here. Second prize goes to Dr. Rameshwari Malshetty, Brims, Bidar. I request Dr. Premlata Patil to hand over the trophy. Third prize goes to Dr. Aarti Raghu madam. I request Ashalata Mallapure madam to hand over the trophy. Winners for poster presentation PGs. First prize goes to Dr. Devika Shetty, Kims, Hubballi. I request Vijayshri madam to hand over the trophy. Second prize goes to Dr. Soumya Singh, JJM Medical College, Davangere. Request Vijaya madam to hand over the trophy. Third prize goes to Dr. Shravani Patil, MRMC, Kalburgi. request Korwar sir to hand over the. Next, we'll move on to winners for paper presentation PGs. First prize goes to Vachana Shri, Grants Medical College, Mumbai. I request Uma ma'am to hand over the trophy to Vachana. She is our student. Second, Dr. Humaira Sultana, Koppal Institute of Medical Sciences. I request Meenal madam to hand over the trophy to. Third prize goes to Dr. Diksha Biradar, ESI Medical College, Bangalore. I request Kalavati madam to distribute the trophy to Dr. Diksha. Next is quiz winners. First prize goes to Dr. Pujita, MRMC, Kalburgi, along with Dr. Sumana, James, Kalburgi. I request Pratibha Patil madam to hand over the trophies to the first prize winners. Second prize winners Dr. Charitria Brims, Bengaluru, Dr. Shravani Patil, MRMC, Kalburgi. I request Vinayak Janti sir to hand over the trophies to them. Winners, please come fast. Third prize, Dr. Harshita, JJMC, Davangere, Dr. Shweta, MRMC, Kalburgi. Dr. Rameshwari, please hand over the trophies to the winners. I thank the quiz committee, paper poster presentation committee for their excellent work. We now begin the valedictory ceremony. I am sure you all have been benefited by attending this conference. I now call upon our organizing secretary, Dr. Savita Bedger, to give a brief review of the event for 2 days.
Thank you, Sangeeta. Without wasting much time, I am here to give a report of the conference that is being held since 2 days, that is August 2nd and 3rd. With immense pride and gratitude, I take this opportunity to present the valedictory report of the Zonal Ksoga conference held in our institution, BRIMS Bidar. This conference was a grand academic endeavor aimed at enriching the knowledge and the clinical skills of our fellow obstetricians and gynecologists, especially in addressing the most important topic of our life, that is the high-risk pregnancy. To state, we had a pre-conference activity also. We had a live demonstration of the laparoscopic surgery, which was being relayed on the first day. Also on the second day, we had a workshop. We had a very renowned skilled surgeons along with us who very efficiently moderated and performed the surgeries in the operation theatre. Then in the evening, we had an inaugural ceremony which was attended and which was graciously, we had the esteemed presence of our ministers, especially Shri Ishwar Khandre sir, Shri Sagar Khandre sir, Shri Rahim Khan sir. Also, we had our Directorate Medical Education, Dr. Sujata Rathod ma'am, who witnessed this ceremony. We had with us as a backbone our Ksoga President, Dr. Durgadas sir, Chief Patron, Dr. M.G. Hiramat sir, Patron, Dr. Nagraj sir, President-elect, Dr. Paladi madam, who is also there with us continuously since 2 days. She is there without moving aside, supporting us, telling us line by line to do it. Thank you so much, ma'am. Also, dynamic secretary of Ksoga, though madam had to leave, that is Dr. Shobha Gudi ma'am. Our administrators, most importantly our director sir, for helping us all out here, that Shukumar sir, Shatkar sir, and the dynamic lady sitting here, our own Uma ma'am, without whom this wouldn't have been possible. So because of her dedication, her dream, this day is seen by all of us. Then we had a scientific sessions very properly executed by our two dynamic international anchorers. That level they have spoken, Dr. Shilpa and Dr. Jyoti. Thank you so much for executing it. You very meticulously have done your job. And behind this selection of all the topics, beta thalassemia, Rh negative, pregnancy, then jaundice in pregnancy, diabetes, all the topics were very, very meticulously and absolutely it was selected by Dr. Jyotsna and her team, Dr. Aarti, Dr. Pallavi. Big kudos for them. Then we had panel discussions, we had paper and poster presentations also along with this. To say we had a registration of total 532 registration done, which is a significant registration in this, what I feel is, and thank you all the EC members who have supported us, guided us in doing this conference. Now, in the evening, that is on 2nd August, we had a cultural gala night dinner banquet where our doctors, they showed their talent, exhibited their hidden talent. What I would like to say is hidden talent, and I should really thank them for doing this, coming out of their busy schedule. At the last, I would thank the Ksoga office bearers, President, Chief Patron, President-elect, EC members, Secretary, our Director, Principal, MS, DS, all our sponsors, and the organizing team, volunteers and delegate who made this event. From this, I sign off saying the report of the 2 days of the function. Thank you so much. Request Sangeeta to please come and carry out the valedictory function.
I request Rashri Paladi Madam to share her experience about the conference.
Respected members on the dais and off the dais, the delegates, the pharma, and all the members who have waited till the last moment, heartfelt gratitude. And I would say that this has been a commemoration of an event which was thought of way back, maybe 1 year back, and we have witnessed excellent programs being conducted by the Bidar Obstetric and Gynec Society, the enthusiasm, the involvement, the bonhomie, the friendship, the fellowship, and then it always came to the mind that why not host a conference in Bidar, and this was a preliminary. I think you have scored with brilliant marks, 100 out of 100. And this sets in a tempo wherein you are so now equipped to host bigger challenges in the form of doing a state conference or maybe a national conference very soon. Yes, it is a possibility because the president gives conferences to various districts and towns also. So there would be presidential conferences and vice president conferences which occur in Foxy, which could be designated. We have Rambas, we have Urvashis, we have Menakas, we have Apsaras, we have brilliance, we have talent, we have intelligence, and everything which was brought in and fine-tuned, and it was beaded so well by our dynamic leader, Dr. Uma Deshmukh. I think she's a heartthrob of everybody, and then she has her own way and charm and excellence, and the way she gets the things done and executes. I think it's with joy that we get involved in her work. It's the respect and love we have for her that we get involved in her work. She has a way to get it done, but then yes, we all admire for her ways and how beautifully she has reaped in, brought in the best out of everybody. And I feel so happy and proud that just now Dr. Premlata was asking me that how do you feel? I said, I feel very proud because this was a concept that we all dreamt of together to make it happen. And to see such beautiful results is so overwhelming and such a pride moment that it gives in more confidence that actually, don't tell Dr. Shobha Gudi. She said, my God, I would not like to compete with them to do the conference. I'll do in my own ways. I can't do with them. I don't want to compare with them. That is the kind of set standard and, the kind of aura that has been created by the lavish amount of hospitality that has been showered on everybody. This was like a marriage wherein everybody was involved and conducted in all the glory and all the hospitality and the Nizam pride that we all can flaunt off and say, yes, this is how we are. We don't calculate or we don't count upon when it comes to treating somebody with our whole hearts. Very, very proud of Kalyan Karnataka and the crown of Karnataka, Bidar. You have done extremely well. And yes, this is really a very joyful moment for all of us. Very nicely. I mean, there is no words or adjectives which fail to describe all that has been happening here. I'm sure all of us will go back home, sleep very well with the contentment. Yes, we have done something very nice for the society and a historical landmark in the OBG Association of Bidar. You agree? Yes. So coming further is then, yes, we are going to meet in Tumkur, but I would like to invite all of you to Mandya because then it is going to be the Yuva Ksoga conference wherein we all have to represent in greater amounts so that the next year from April onwards that we will have a tenure which will have more meaningful implications and focus more upon the activities. These conferences are not just meant to spread in the academics. Yes, we have learned a lot, but what is it that we are going to reap it out and then, apply it to in our daily lives and the society that we are in? This is something we are doing way out of passion. Herein there is no job that we are fulfilling or we are doing our duties that 9 to 5 we have to do such job or do the practice that we earn so much of money or contribute to the, this is something we are doing out of passion that, this is something extra. We are not rewarded in terms of monetary benefits, but this is a joy that we are giving for ourselves for doing the greater good for the society and helping us to reach out to the social causes. I request you all to think more about how we can do the social implications of all the knowledge and expertise that we have to help the women, the girls, the adolescent, the menopausal and the menopausal. 50% of the life of the woman now, which starts from 35 years till 70, 75 is gone in menopause. What are we doing? Nothing much in terms of preventing the preventive health that we are doing. So these are a few things which I would like to bring upon to the notice of all the consultants, the practitioners, that let us think more beyond what we can and stretch ourselves. Yes, we have the AI and yes, we have the bottom line of delivering the, having the normal delivery, which has become such a precious thing nowadays, They flaunt, I have had normal delivery. They feel so proud, which is something supposed to be very physiological and normal. So moving on from there, then we go to the conference in Mandya, and yes, I have the mandate, I have the support, I have the thing to say from my society and my executive members that yes, maybe next year we are going to host the state conference in Gulbarga. With all your best wishes and support, we see to it that we bring in much more glory to the North Karnataka, and looking forwards for the same amount of involvement that you have had here, that we are sisters in the neighbor. And yes, we can hold each other's hand and be there as a friend, as a sister, as a guide, as a mentor for each other. We have had such glorious, wonderful demonstration of seniority by seniors like Dr. Bashetti ma'am, who was so sweet yesterday. The way she joyfully performed, apart from doing and whatever services that she has given, and she's been a mentor for so many of us. And we see that system of hierarchy. Those in the 20s, the 30s, respecting the 70s is something which is very, very, very lost human values, which is being retained and upheld and kept up so well in Bidar. Proud of you guys. Hearty congratulations once again, and all the very best for the future. Thank you so much for allowing to share my words, talks, feelings, emotions. Thank you.
Thank you so much, ma'am, for your such kind and encouraging words. It is very inspiring, and we would like to continue to work under your guidance in future too. Now I would request our beloved Uma ma'am, our leader, to speak a few words.
ಈ ಶ್ರಾವಣ ಮಾಸದಲ್ಲಿ ಶರಣರನ್ನು ನೆನೆಸಿ ಈ ಕೊನೆಯ ಅಂತಿಮ ಕಾನ್ಫರೆನ್ಸ್ ಏನು ಸಮ್ಮೇಳನ ಅಂತ ಇದನ್ನು ಹೇಳ್ತೇನೆ ನಾನು. ಇದು ತೊಗೊಂಡಿದ್ದೆ, ನಾನು ಯಾವಾಗೂ ಹೇಳ್ತಿದ್ದೆ ಇವ್ರಿಗೆ ಇದು ಡಿವೈನ್ ಪ್ಲ್ಯಾನ್ ಆಯ್ತಂತ. ಯಾಕಂದ್ರೆ ನಾನು ಪ್ರೆಸಿಡೆಂಟ್ಶಿಪ್ ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡ್ತಾಯಿದ್ದೆ. ಅದು ಪ್ರೇಮಲತಾ ಪಾಟೀಲ್ ಮೈಯಾಗೆ ಏನು ದೇವ್ರು ಹೊಕ್ಕಿದಂಗೆ ಬಂದರವ್ರು. ಉಮಾ ನೀ ಕಾನ್ಫರೆನ್ಸ್ ತೊಗೊಂಡು ಬರೋದಿದ್ರೆ ನೀ ಪ್ರೆಸಿಡೆಂಟ್ ಇರು, ಯಾಕಂದ್ರೆ ಕಾಲೇಜ್ ಒಳಗೆ ನೀ ಇರ್ತಿ, ನೀ ಬೇರೆಯವ್ರಿಗೆ ಯಾರಿಗೂ ಔಟ್ಸೈಡರ್ಸ್ಗೆ ಇದು ಕೊಡೋಕ್ಕಾಗೋದಿಲ್ಲ, ಇದು ಮಾಡೋಕ್ಕಾಗೋದಿಲ್ಲ ಅಂತ ಹೇಳಿದ್ರು. ಅವ್ರದ್ದು ವರ್ಡ್ ನಾ ಬಾಯಿ ಮುಚ್ಕೊಂಡು ಮಾತಾಡ್ಲಿಕ್ಕೆ ಆಗಲಿಲ್ಲ. ಎಲ್ಲನೂ ಒಂದು 6 ತಿಂಗಳಿಂದ ಎಲ್ಲರ ಮೈಂಡ್ ಸೆಟ್ ಮಾಡಿ ಬಂದಿದ್ದೆ, ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡೋಣ, ಇನ್ನು 2 ವರ್ಷ ಆಗೈತಿ ಸಾಕಂತ. ಇದು ನೀ ಈಗ ಕಾನ್ಫರೆನ್ಸ್ ತೊಗೊಂಡು ಬರೋದಿತ್ತಂದ್ರೆ ನೀನೇ ಕಂಟಿನ್ಯೂ ಮಾಡಂತ ಹೇಳಿದ್ರೆ ಅದು ಒಂದು ಡಿವೈನ್ ಪ್ಲ್ಯಾನ್. ಯಾಕಂದ್ರೆ ಅವ್ರ ಮೈಯಾಗ ಹಿಂಗೆ ಬಂದಿತ್ತಲ್ಲ, ಎದುರಿನವ್ರು ಏನೂ ಹೇಳಿದ್ರೆ ಕೇಳೋ ಥರ ಇರಲಿಲ್ಲ, ಆ ಸ್ಟೇಜ್ ಒಳಗೆ ಬಂದಿದ್ರು. ನನಗೆ ಅನ್ನಿಸ್ತಿದ್ದೆ, ಯಾಕಂದ್ರೆ ನಾ ಮೂರ್ತಾಗಿರ್ತಾ ನೋಡ್ಕೊಂಡೆ ಬಂದಿದ್ದೆ ಅವತ್ತಿನ ದಿವಸ ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡ್ಬೇಕಂತ. ಅಂದ್ರೆ ಚಲೋ ಟೈಮಿಗೆ ನಾ ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡೋಣ ಅಂತ ಫಾದರ್ ಮನೆಯಲ್ಲಿದ್ದರೆ ನಾ ಮೂರ್ತ ನೋಡ್ಕೊಂಡೆ ಬಂದಿದ್ದೆ. ಇವತ್ತು ಪುಷ್ಪ ಇದ್ರದ್ದೇನೋ ನಕ್ಷತ್ರ ಚಲೋ ಐತಿ ಇದಂತ ಗಣೇಶ್ ಪೂಜಾ ಮಾಡಿ ನಾವು ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡೋಕ್ಕೆ ಲಾಸ್ಟ್ ಇದಕ್ಕೆ ಅವ್ರಿಗೆ ಕರೆಸಿದ್ವಿ. ಅವ್ರ ಮೈಯಾಗ ದೇವ್ರು ಬಂದಂಗೆ ಹಿಂಗೆ ಬಂದು ಏನೂ ಯಾರ್ದು ಏನೂ ಮಾತು ಕೇಳಿಲ್ಲ. ಇವು ಕಂಟಿನ್ಯೂ ನೀ ಕಾನ್ಫರೆನ್ಸ್ ತರೋದಿತ್ತಂದ್ರೆ ಮಾತೇ ಬಂದಿಲ್ಲ ನನಗೆ. ಆಮೇಲೆ ಎಲ್ಲರೂ ಅಂದ್ರೆ ಕೊಡಕ್ಕೆ ಬಂದಕ್ಕೆ ಹೆಂಗೆ ಇಟ್ಕೊಂಡು ಅಂತ ನನಗೆ ಕಮೆಂಟ್ಸು ಬಂದು. ಖರೆ ನಾನು ಅವ್ರದ್ದು ರೆಸ್ಪೆಕ್ಟ್ ಕೊಡ್ಬೇಕು, ಸೀನಿಯರ್ಸ್ಗೆ ರೆಸ್ಪೆಕ್ಟ್ ಕೊಡ್ಬೇಕಂತ ನಾನು ಅದು ಕಂಟಿನ್ಯೂ ಮಾಡಿದೆ. ಅವಾಗ ಏನಾರ ನಾನು ತಪ್ಪಾಗಿತ್ತಂದ್ರು, ನಮ್ಗೆ ಏನಾರ ಇಂಟರ್ನಲ್ ಅನ್ಸಿತ್ತಂದ್ರು ನಾ ಇದು ಕೇಳ್ತೀನಿ. ಅದಕ್ಕೆ ನಾವು ಪ್ರೆಸಿಡೆಂಟ್ ಇಲೆಕ್ಟ್ ಯಾರಿಗೆ ಅಂದ್ಕೊಂಡಿದ್ದೆ ನಾ ಇಲೆಕ್ಟ್ ಅಂತೂ ಡಿಕ್ಲೇರ್ ಮಾಡಿದ್ವಿ ನಾವು. ಅದು ಫಸ್ಟ್ ಡಿವೈನ್ ಪ್ಲ್ಯಾನ್ ಅಂತ ಅವಾಗ ಅನ್ನಿಸ್ತು ನನಗೆ. ಇದು ಅವ್ರು ಅಂದಿದ್ದು ಖರೆ ಅದ. ಯಾಕಂದ್ರೆ ನಾವು ಕಾಲೇಜಲ್ಲಿ ಮಾಡಬೇಕಂದ್ರೆ ಹೊರಗಡೆ ನಾವು ಮಾಡ್ಬೋದು, ಕಾಲೇಜಲ್ಲಿ ಇಲ್ಲಿ ಇದ್ದವ್ರದ್ದೇ ಮಾತು ಕೇಳ್ತಾರ ಅಂತ ಅದು ಸರ್ ಮಾಡಮ್ದು ಖರೆ ಅನ್ನಿಸ್ತು. ಆಮೇಲೆ ನಾವು ಮಾಡ್ತಾ ಹೋದ್ವಿ. ಈಚ್ ಒನ್ ನಾವು 77 ಮೆಂಬರ್ಸ್ ಇದ್ದೀವಿ, 75 ರಿಜಿಸ್ಟರ್ಡ್. ಇಬ್ಬರಿಗೆ ನಮಗೆ ಕಮ್ಯುನಿಕೇಟ್ ಮಾಡೋಕ್ಕಾಗಿಲ್ಲ, ಯಾಕಂದ್ರೆ ನಮ್ಮ ಮೆಂಬರ್ಸ್ ದೇ ಆರ್ ಫ್ರಮ್ ಜೈರಾಬಾದವರು ಅದಾರ, ಹುಮ್ನಾಬಾದವ್ರು ಅದಾರ, ಈವನ್ ಚಿಂಚೋಳಿಯವ್ರು ಅದಾರ. ಎಲ್ಲರೂ ಕೂಡಿ ನಾವು 77 ಮೆಂಬರ್ಸ್ ಇದ್ದೀವಿ. ಆ್ಯಕ್ಚುಲಿ ಬಸವ ಕಲ್ಯಾಣದವರು ನಮ್ಮ ಜೊತೆಗೆ ಇದ್ದರು, ಮೇಡಮ್ ಇದು ಮಾಡಿದರು. ಖರೆ ಬೀದರ್ ಡಿಸ್ಟಿಕ್ಕಿಂದ ಅವರು ಎಲ್ಲರೂ ರಿಜಿಸ್ಟರ್ ಆಗ್ಯಾರ, ಮೇಡಮು ಎಲ್ಲರೂ ರಿಜಿಸ್ಟರ್ ಆಗ್ಯಾರ. ಅದಕ್ಕೆ ನಿಯರ್ಲಿ ನಾವು 100 ಮೆಂಬರ್ಸ್ ನಾವೇ ಮಾಡಿದ್ದೆವು, 97 ಏನು 100 ಒಬ್ಬರನ್ನೂ ಬಿಟ್ಟಿಲ್ಲ. ಈಚ್ ಒನ್ ರಿಜಿಸ್ಟರ್ಡ್ ಫಸ್ಟ್ ಅದು ಮಾಡಿ. ಮತ್ತು ನಾವು ಗುಲ್ಬರ್ಗಾಕ್ಕೂ ಹೋಗಿದ್ವಿ. ನಮ್ಗಿಂತ ಜಾಸ್ತಿ ಅವ್ರು 300 ಅದಾರ, ನಮ್ಗಿಂತ ಜಾಸ್ತಿ ಅವ್ರು ಮಾಡಿದಾರೆ ಅನ್ನಿಸ್ತೈತಿ. ಅಂದ್ರೆ ಅವ್ರದ್ದು 300 ಮೆಂಬರ್ಸ್ ಇದ್ದಾರೆ, ಅವರು ಮಾಡಿದರು. ಎಲ್ಲರದ್ದು ಕೋಆಪ್ರೇಷನ್ದಿಂದ ಇದು ಸಾಧ್ಯ ಇದೆ. ಈಚ್ ಕಮಿಟಿ ಇಷ್ಟು ಇದರಲ್ಲಿ 100% ದೇ ಹ್ಯಾವ್ ಗಿವನ್ ದ ಬೆಸ್ಟ್. ಈಚ್ ಒನ್ ನಾವು ನಿಮ್ಮದು ಕಮಿಟಿ ಮೆಂಬರ್ಸ್ ನೀವು ನೋಡಿರಬೇಕು. ಎಲ್ಲ ಕಮಿಟಿ ಒಳಗೂ ಎಲ್ಲರದು ಹೆಸರು ಕವರ್ ಮಾಡಿದ್ದೇವೆ. ಅಷ್ಟೇ ನೀವು ನಂಬರ್ ಎಣಿಸಿದ್ರೆ ಅದ್ರಲ್ಲಿ 70 ಮೆಂಬರ್ಸ್ ಇದ್ದಾರಲ್ಲಿ, ಎಲ್ಲರಿಗೂ ಕವರ್ ಮಾಡಿದ್ದೇವೆ. ಅಲ್ಲಿ ಒಬ್ಬರದ್ದು ಹೆಸರು ಬಿಟ್ಟಿಲ್ಲ, ನಾವು ಎಲ್ಲರದೊಳಗೂ ಹಾಕಿದ್ದೇವೆ. ಅಂದ್ರೆ ಅವರಿಗೂ ಇದಾಗಬೇಕಂತ ಎಲ್ಲರೂ ಕೂಡಿ ಭಾಲ್ಕಿದವರು ಪೂರ್ತಿ ಟೀಮೇ ಭಾಲ್ಕಿದ ಅವರು ಅಲ್ಲಿ ಕುಂತೂ ಇದು ಮಾಡಿದ್ದಾರೆ. ಆಮೇಲೆ ಫೈನಾನ್ಸಲ್ಲಿ ಮೇನ್ ಇದಕ್ಕೆ ಪ್ರಕಾಶ್ ಕೋರ್ವಾರ್ ಸರ್ ಇದಕ್ಕೆ ವಾಲಂಟ್ರಲಿ ಹ್ಯಾಸ್ ಕಮ್. ಅವ್ರು ಯಾವುದೂ ಇದಕ್ಕೆ ಮೊದಲೇ ಅಷ್ಟು ಇದು ತೊಗೋತಿರ್ಲಿಲ್ಲ. ಯಾವಾಗ ಪ್ರಕಾಶ್ ಕೋರ್ವಾರ್ ಸರ್ ಬಂದಾರಂದ್ರೆ ಎಲ್ಲರೂ ಆ್ಯಕ್ಟಿವೇಟ್ ಆದರು, ಎಲ್ಲರೂ ಅವರು ಹೀಸ್ ಅವರ್ ಲೀಡರ್, ಗುರು ಅನ್ಬೋದು. ಯಾಕಂದ್ರೆ ಫಸ್ಟ್ ಗ್ಯಾನಕಲಾಜಿಸ್ಟ್, ಸೀನಿಯರ್ ಗ್ಯಾನಕಲಾಜಿಸ್ಟ್, ವಿ ಹ್ಯಾವ್ ಲರ್ನ್ಡ್ ಮೆನಿ ಥಿಂಗ್ಸ್ ಫ್ರಾಮ್ ಹಿಮ್. ನಾವು ಅಪೆಕ್ಸ್ ಹಾಸ್ಪಿಟ್ಲ್ ಆದಾಗೂ ಯಾವಾಗೂ ಅವ್ರು ಮತ್ತು ಅಕಾಡೆಮಿಕ್ ಎಕ್ಸಲೆನ್ಸ್ ಈಸ್ ಹ್ಯಾವಿಂಗ್. ಎಲ್ಲ ಕಾನ್ಫರೆನ್ಸ್, ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ ಹಿ ವಿಲ್ ಅಟೆಂಡ್ ಎಲ್ಲ ಕಡೆ. ಮತ್ತು ಮದ್ವಿದ ಆಮೇಲೆ ಊಟದವ್ರು ವಾಲಂಟ್ರಿ ಅಂದ್ರೆ ವಾಲಂಟ್ರಿಲಿ ಹ್ಯಾಸ್ ಟೇಕನ್. ನಾವು ಊಟದ ನಾನೇ ಅರೇಂಜ್ಮೆಂಟ್ ತೊಗೋತೀನಿ. ಏನು ಎಲ್ಲ ಇದ್ರೊಳಗೆ ಅವ್ರು ಏನೂ ಕಾಂಪ್ರಮೈಸ್ ಮಾಡೋದಿಲ್ಲ. ಮತ್ತು 2 ಮದುವೆ ಮಾಡಾರೆ, ಇದು 3ನೇ ಮದುವೆ ಆಗ್ಯದ ಅವ್ರಿಗೆ, ಅವ್ರದ್ದು ಹೆಣ್ಮಕ್ಳದ್ದು 2. ಹಂಗೆ ಊಟದವ್ರಿಗೆ ಬಿಟ್ಟೇವಿ. ಅವ್ರು ಅಂದರು ಯಾರದೇ ಎಲ್ಲೇ ಹೋಗ್ರಿ ನೀವು ಮೊದಲೇ ಊಟ ನೋಡ್ತಾರೆ ಹೆಂಗೆ ಮಾಡಿರಿ ಅದನ್ನು ಅವರಿಗೆ ಬಿಟ್ಟಿದ್ವಿ ನಾವು. ಮತ್ತು ಅವ್ರು ಇದೆಲ್ಲ ಫಾರ್ಮಾ ಕಂಪನಿಗೆ ಶಾರದಾ ಗುದ್ಗೆ, ಶೈಲಜಾ ತಳವಾಡೆ, ಮಹೇಶ್ ಚಂದ್ಶೆಟ್ಟಿ ಸರ್ 4 ಮಂದಿ ಕುಂತು ಎಲ್ಲರೂ ಫಾರ್ಮಾದವ್ರಿಗೆ ಕರೆಸಿ ಎಷ್ಟು ಸಿಸ್ಟಮ್ಯಾಟಿಕ್ ಆಗಿ ಮಾಡಿದ್ದಾರೆ ಅಂದ್ರೆ ಇದು ಎಲ್ಲರೂ ವಾಲಂಟ್ರಿಲಿ 108 ಫಾರ್ಮ ಪೀಪಲ್ ಆರ್ ದೇರ್. ಇಟ್ ಈಸ್ ನಾಟ್ ಎ ಜೋಕ್. ಅವ್ರು ಅಷ್ಟು ಮೆಂಬರ್ಸ್ ಇದ್ದಾರೆ ಅವ್ರು, ಅಂದ್ರೆ ಬಹುಶಃ 60 ಇರ್ಬೋದು ಅಂದ್ರೆ ಟುಗೆದರ್. ಇಬ್ಬಿಬ್ರು ಹಿಡಿದ್ರೆ ಹೇಳಕತ್ತೀನಿ 108. ಹಾಂ, ಅಷ್ಟು ಮಂದಿ ಬಂದು ಕೋಆಪ್ರೇಷನ್ ಅವ್ರದ್ದು ಎಲ್ಲರದ್ದು ಕೋಆಪ್ರೇಷನ್ ನೋಡಿದ್ರೆ ಭಾಳ ಇದಾಕೈತಿ. ಈಚ್ ಒನ್ ಜ್ಯೋತ್ಸ್ನಾ ಮತ್ತು ಆರತಿ, ಪಲ್ಲವಿ ಆ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ ತೊಗೊಂಡ್ರೆ ಈ ಎಲ್ಲನೂ ಎಷ್ಟು ಅವು ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ ಒಳಗಿಂದ ಟಾಪಿಕ್ಸ್ ಎಷ್ಟು ಇಂಟ್ರೆಸ್ಟೆಡ್ ಅದಾವ. ಮತ್ತು ಲ್ಯಾಪ್ರೋಸ್ಕೋಪಿ ವರ್ಕ್ಶಾಪ್ ಜ್ಯೋತ್ಸ್ನಾ ಮತ್ತು ಸುಮಯ್ಯ ಎಲ್ಲರೂ ಈಚ್ ಒನ್, ಲಾವಣ್ಯ ರಿಜಿಸ್ಟ್ರೇಷನ್ನಲ್ಲಿ ಸರಿತಾ ಮೇಡಮ್ ಜೊತೆ ನಾವೇನು ಮಾಡಿದ್ವಿ, ಎಲ್ಲರೂ ಹೊರಗಿನವ್ರಿಗೆ ಕೊಟ್ಟೇವಿ. ನಾವು ಒಬ್ಬಕಿನೇ ಅದೇನೆಲ್ಲ ಅನ್ನಕತ್ತಾರ ಅವ್ರು ಬೀದರಲ್ಲಿ. ಖರೆ ನಾವು ಡಿಸ್ಟ್ರಿಬ್ಯೂಟ್ ಹೆಂಗೆ ಮಾಡಿದ್ವಿ ಅಂದ್ರೆ, ಯೋಗಿರಾಜನು ಅದಾರ ನಮ್ಮ ಮಹಾರಾಷ್ಟ್ರದ, ಜೈರಾಬಾದವ್ರು ಅದಾರ, ಶಿವಗೀತಾ ಅದಾರ, ಎಲ್ಲರದು ಒಬ್ಬೊಬ್ಬರಿಗೆ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಕಮಿಟಿದು ಮಾಡಿದ್ವಿ ನಾವು ಇಲ್ಲಿ. ಎಲ್ಲರೂ ಅವ್ರವ್ರ ವರ್ಕ್. ಇವನ್ ಕೃತಿಕಾ, ಶಿ ಈಸ್ ಪ್ರೆಗ್ನೆಂಟ್ ಆ್ಯಂಡ್ ಶಿ ವಾಸ್ ನಾಟ್ ವೆಲ್, ಬಟ್ ಸ್ಟಿಲ್ ಅವ್ರು ಅಲ್ಲಿ ಕುಂತೆ ಮಾಡಿದ್ರು. ಮತ್ತು ವೈಶಾಲಿ ಆ್ಯಂಡ್ ಕವಿತಾ ಭಾಲ್ಕಿಯಲ್ಲಿ ಕುಂತೆನೇ ಅವ್ರು ರಿಜಿಸ್ಟ್ರೇಷನ್ ಮಾಡಿದ್ರು. ಆಮೇಲೆ ಸುಜಾತ ಹರ್ ಕೂಡ ಹುಮ್ನಾಬಾದಲ್ಲಿ ಕುಂತು ರಿಜಿಸ್ಟ್ರೇಷನ್ ಮಾಡಿಸಿದ್ರು. ಅವ್ರು ಇದು ಅಷ್ಟೇ ಅಲ್ಲ, ಇವ್ರು ಯಾರ್ಯಾರು ಈಚ್ ಅದಾರ ಅವ್ರ ಜೊತೆ ಜೋಡಿಗಳು ಅದಾರ. ಅವ್ರು ಒಬ್ಬರೇ ಮಾಡಿಲ್ಲ, ಅವ್ರ ಹಸ್ಬೆಂಡ್ ಬಿಹಾಫ್ ಅವ್ರ ಹಸ್ಬೆಂಡು ವರ್ಕ್ ಮಾಡೈತಾರೆ. ನಮ್ಮ 3 ತಿಂಗಳು ಆಯ್ತು ಎಲ್ಲರೂ ಅವ್ರ ಜೊತೆಗೆ, ಅವ್ರು ಹೆಂಡತಿ ಜೊತೆಗೆ ಅವ್ರ ಗಂಡದೇರು ವರ್ಕ್ ಮಾಡ್ಯಾರಿದ್ದಾರೆ ಒಳಗೆ. 100% ಅವರು ಇದು ಕೊಟ್ಟಾರ. ಯಾಕಂದ್ರೆ ಎಲ್ಲ ಒಂದರೆ ಅವ್ರ ಮಕ್ಕಳಿಗೆ ನೋಡ್ಕೋಬೇಕು. ಇವ್ರು ನಮ್ಮ ಜೊತೆ ಇದ್ದಾಗ, ಮೀಟಿಂಗಲ್ಲಿ ಇದ್ದಾಗ ಅವರೆಲ್ಲ ನೋಡ್ಕೊಂಡಾರ. ಖರೇನಾ? ನೋಡ್ಯಾರಿಲ್ರಿ? ಹಾಂ, ಫ್ಯಾಮ್ಲಿ ಮೆಂಬರ್ಸ್ ಎಲ್ಲರೂ ಇದ್ರೊಳಗೆ ಇನ್ವಾಲ್ವ್ ಆಗ್ಯಾರ. ಅಷ್ಟು ಇದು ಮನಿ ಫಂಕ್ಷನ್ ಹಂಗೆ ಇದಾಗಿದೆ ಆ್ಯಕ್ಚುಲಿ. ನಮಗೆ ನೋಡಿದ್ರೆ ಅಷ್ಟು ಆಕೈತಿ. ಇದು ಒಂದು ಡಿವೈನ್ ಪ್ಲಾನೇ. ನಾವು ಮಾಡ್ತೇವಂತ ಹೋದಾಗ ಆಗೋದಿಲ್ಲ. ಎಲ್ಲರೂ ಇಷ್ಟು ಆ್ಯಕ್ಟಿವ್ಲಿ, ಸುನಂದ ಆ್ಯಂಡ್ ಸಂದೀಪ್ ಆ್ಯಂಡ್ ಸುಮನ್ ಇಷ್ಟು ಅಕಾಮಿಡೇಷನ್ ಇದ್ರೊಳಗೆ ಇಷ್ಟು ಚೆನ್ನಾಗಿ ಮಾಡಿದಾರಲ್ಲ, ಎಲ್ಲರೂ ಅಪ್ರಿಷಿಯೇಟ್ ಮಾಡ್ಬೇಕು. ಅವ್ರಿಗೆ ಕಮ್ಯುನಿಕೇಟ್ ಮಾಡೋದು, ಈಚ್ ಒನ್ ಎಲ್ಲಿಂದ ಬರಾಕತ್ತಾರ, ಏನು ಮಾಡಕತ್ತಾರ, ಅದನ್ನು ಅವರಿಗೆ ಸರ್ವಿಸ್ ಕೊಡೋ, ಟ್ರಾವೆಲ್ ಸರ್ವಿಸ್ ಕೊಡೋದು, ರೂಮ್ ಅರೇಂಜ್ ಮಾಡೋದು. ಅಂದ್ರೆ ಇದು ನೀವು ಸ್ವತಃ ಮಾಡ್ತೇವಂದ್ರೆ ಆಗೋದಿಲ್ಲ. ಈಗ ನಾ ಮಾಡ್ತೇನಂದ್ರೆ ಆಗೋದಿಲ್ಲ. ಇದು ಡಿವೈನ್ ಪ್ಲಾನ್ ಅಂತ ಅದಕ್ಕೆ ಈಗ ಅನಿಸ್ತೈತಿ. ಯಾಕಂದ್ರೆ ಪ್ರತಿಯೊಂದು ಸ್ಟಾರ್ಟಿಂಗ್ ವಿತ್ ದಿಸ್ ಹೆಂಗೆ ಇದು ಚಾಲು ಆಗ್ಯದಂತ. ನಾವು ಟೀಮ್ ವರ್ಕ್ದಿಂದ ಇದು ಅದು ಯಾವಾಗ ಈಗ ನಾವು ಇದುವರೆ ಡಿಸೈಡ್ ಆಗಿತ್ತು ನಮ್ದು. ಕಾನ್ಫರೆನ್ಸ್ ಇದಕ್ಕೆ ಹೋದ್ವಿ, ಮಾಡ್ಬೇಕಂತ ಮಾಡಮ್ಮಂದ್ರು. ನಾವು ಹೋಗಿ ತರಬೇಕಲ್ಲ. ಈಗ ಚಿತ್ರದುರ್ಗ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಹೋಗ್ಬೇಕಾಯ್ತು. ಅದು ಎಲ್ಲದ, ಅದು ಸೀದಾ ಅಪ್ರೋಚ್ ಆಗಕ್ಕೆ ಬರಂಗಿಲ್ಲ ನಮಗೆ ಅಂತ ಒಂದು ಇದ್ರೊಳಗದ. ಡೈರೆಕ್ಟ್ ಕನೆಕ್ಟಿವಿಟಿನೂ ಇಲ್ಲ ಅಂಥ ಜಾಗದಾಗ ಹೋಯ್ತಿ. ಅಲ್ಲಿಂದ ಹೋಗಿ ನಾವು ಕಾನ್ಫರೆನ್ಸ್ ಕೇಳ್ಕೊಂಡು ಬರ್ಬೇಕು. ಅದು ಅಲ್ಲಿ ಮೀಟಿಂಗ್ ಅಟೆಂಡ್ ಆದ್ರೆ ನಮಗೆ ಕಾನ್ಫರೆನ್ಸ್ ಕೊಡ್ತಾರೆ. ಇಲ್ಲಿ ಕುಂತು ಫೋನ್ ಮಾಡಿದ್ರು ಕೊಡೋದಿಲ್ಲ ಅವ್ರು. ಅದಕ್ಕೆ ಈಗ ಅವ್ರ ಸೆಕ್ರೆಟ್ರಿ ಇಬ್ರಿಗೂ ಕರ್ಕೊಂಡು ಅಲ್ಲಿ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಹೋದ್ವಿ. ನಾವು ಅಲ್ಲಿ ಹೋಗಿ ಮೊದ್ಲಿಕ್ಕೆ ಅವ್ರಿಗೆ ಅಡ್ವಾನ್ಸೇ ಮೇಲ್ ಹಾಕಿದ್ವಿ, ನಾವು ಬಂದು ಕಾನ್ಫರೆನ್ಸ್ ತೊಗೋತೀವಿ ಅಂತ ಹೇಳಿ. ಆಮೇಲೆ ನೀವು ಬರಬೇಕಾಕೈತಂದ್ರೆ ಅವ್ರು ಅಟೆಂಡ್ ಆದರೆ ಕೊಡ್ತಾರಂಥದ್ದು, ಅದು ಗೊತ್ತಾಯ್ತು. ಆಮೇಲೆ ಅದಕ್ಕೆ ಹೋದ್ವಿ. ಅದಕ್ಕೆ ಹೋಗಿ ಅದು ಕಾನ್ಫರೆನ್ಸ್ ಇದು ಮಾಡಿದ್ರೆ ನಮ್ದು ಅಪ್ರೂವ್ ಆಯಿತು. ತೊಗೊಂಡು ಬಂದ ಮ್ಯಾಗಿಂದ ಮೀಟಿಂಗ್ ಏನು ಸ್ಟಾರ್ಟ್ ಮಾಡೀವಿ, ಎಲ್ಲರದು ಇನ್ಪುಟ್ಸ್ ಐತಿ. ಈಚ್ ಒನ್ ಹ್ಯಾವ್ ಗಿವನ್ ದ ಇನ್ಪುಟ್ಸ್. ಮತ್ತು ಅಷ್ಟೇ ಅಲ್ಲ, ಇವರೆಲ್ಲ ಮತ್ತು ಆಫೀಸ್ ಬೇರೆಯವ್ರು. ಪ್ರೆಸಿಡೆಂಟ್ ಇಲೆಕ್ಟ್ ರಾಜಶ್ರೀ ಪಾಲೆಡಿ ನಂದು PG ಕ್ಲಾಸ್ಮೇಟ್. ಮತ್ತು ಯಾವಾಗೂ ನಮ್ದು ಇದಿದ್ರೆ ಸಜೆಷನ್, ನಂದು ಏನಾರ ಇತ್ತಂದ್ರೆ ಸಜೆಷನ್ ಮಾಡ್ಯಾರ. ನಂದು ಲೈಫ್ ಒಳಗೆ, ನಂದು ಕರಿಯರ್ ಒಳಗೆ ಶಿ ಹ್ಯಾಸ್ ಸಜೆಸ್ಟೆಡ್ ಆ್ಯಂಡ್ ಐ ಹ್ಯಾವ್ ಟೇಕನ್ ಹರ್ ಒಪಿನಿಯನ್. ಯಾವಾಗೂ ಸಜೆಷನ್ ಇದ್ರ ಒಳಗೂ ತೊಗೊಂಡೇನಿ. ಎಲ್ಲರೂ ಆಫೀಸ್ ಬೇರೆಯವ್ರು, ಇನ್ಕ್ಲೂಡಿಂಗ್ ಪ್ರೆಸಿಡೆಂಟ್, ಸೆಕ್ರೆಟ್ರಿ, ಪ್ಯಾಟ್ರನ್ ಎಲ್ಲರಿಗೂ ಕೇಳಿನೇ ಮಾಡ್ತಿದ್ವಿ. ನನಗೆ ಡೈನಾಮಿಕ್ ಸೆಕ್ರೆಟ್ರಿ ಸಿಕ್ಕಿದ್ದಕ್ಕೆ ಇದು ಒಂದು ಎಷ್ಟು ಚಂದ. ಇವರು ಈಗ ಆರ್ಗನೈಸಿಂಗ್ ಸೆಕ್ರೆಟ್ರೀಸ್ 3 ಮಂದಿ, ಹೇಮಲತಾ ಪಾಟೀಲ್, ಸಂಗೀತಾ ಆ್ಯಂಡ್ ಸವಿತಾ, 3 ಜನನೂ ಹೆಂಗೆ ಅದಾರ ಹೇಳ್ರಿ. ಮತ್ತು ನಮ್ದು ಇದು ಒಂದರದ್ದು ಇದು ಅಂದರೆ ಎಲ್ಲ ಇದ್ರೊಳಗೆ ಕಮಿಟಿ ಒಳಗೆ 3 ಜನನೇ ಇದ್ದಾರೆ. ತ್ರಿಮೂರ್ತೀಸ್. ನಮ್ಮ ಸ್ಟಾರ್ಟಿಂಗ್ ವಿತ್ ದಟ್ ಆಲ್ಸೋ ದ ಡಿವೈನ್ ಪ್ಲಾನ್. ತ್ರಿಮೂರ್ತಿ ನಮ್ದು ಇದು ಸೃಷ್ಟಿ, ನಮ್ದು ಇದಕ್ಕೆ ಹೆಂಗೆ ಬ್ರಹ್ಮ ವಿಷ್ಣು ಮಹೇಶ್ ಅದಾರ, ಹಿಂಗೆ ಎಲ್ಲ ಇದ್ರೊಳಗೆ ತ್ರಿಮೂರ್ತಿ. ನಿನ್ನೇನು ನೋಡ್ರಿ, ನಾವು 4 ಮಂದಿ ನಾವು ಇನ್ವೈಟ್ ಮಾಡಿದ್ರು 3 ಮಂದಿ ಅದರಲ್ಲಿ. ಅಂದರೆ ಅಟ್ ದ ಎಂಡ್ ಎಲ್ಲ ತ್ರಿಮೂರ್ತೀಸ್ ಅದ. ನೀವು ಆ ಕಮಿಟಿದು ನಮ್ದು ಬ್ರೋಚರ್ ತೆಗೆದು ನೋಡ್ರಿ, ಎಲ್ಲ ಕಮಿಟಿ ಒಳಗೆ ತ್ರಿಮೂರ್ತೀಸೇ ಅದಾರ. ಇವನ್ ದ ಆರ್ಗನೈಸಿಂಗ್ ಪ್ರೆಸಿಡೆಂಟ್ ಯಾವ ಕಾನ್ಫರೆನ್ಸ್ ಒಳಗೂ ಹಿಂದೂ ಇರಾಕಿಲ್ಲ, ಮುಂದೂ ಇರಾಕಿಲ್ಲ. ಬಟ್ ಅವರ್ ಕಾನ್ಫರೆನ್ಸ್ ನಾವು ಹಿಂದಿಂದ ಯಾಕೆ ನೋಡಿ ಮಾಡ್ಬೇಕು? ನಮ್ದೇನೋ ಡಿವೈನ್ ಪ್ಲಾನ್ ಐತಿ, ನಾವು ಮೂರೇ ಮಾಡೋದು ಅಂತ ಹೇಳಿದೆ ನಾನು. ಯಾಕಂದ್ರೆ ದೇ ಆರ್ ಐ ಆಮ್ ಪ್ರೆಸಿಡೆಂಟ್, ನಾವು ಒಂದೇ ತೊಗೊಂಡು ಕೊಡೋದಿಲ್ಲ. ದೇ ಆರ್ ಸೀನಿಯರ್ಸ್ ಬಿಕಾಸ್ ದ ಪ್ರೇಮಲತಾ ಪಾಟೀಲ್ ಮೇಡಮ್ ಇವ್ರ ಸ್ವತಃ ಅವರು ಪ್ರಕಾಶ್ ಕೋರರ್ ಸರ್ ಇದ್ರೊಳಗೆ ಅವ್ರ ಮನೆಯವ್ರು ರೆಡ್ಡಿ ಸರ್ ಕುಂತು ಇದು ಬಾಕ್ಸ್ ಇದು ಮಾಡಕ್ಕೆ ನಮ್ಮ ಸೊಸೈಟಿ ಮಾಡಕ್ಕೆ ಸಪ್ರೇಟ್. ಇಲ್ಕರ್ ನಾವು ಇದರಲ್ಲಿ ಗುಲ್ಬರ್ಗಾದಲ್ಲಿ ಇದ್ವಿ, ನಾವು ಅವ್ರ ಜೊತೆಗೆ ಅಟ್ಯಾಚ್ ಇದ್ವಿ. 3 ಮಂದಿ ಇಷ್ಟು ಮೆಹನತ್ ಮಾಡಿ ಇದು ಮಾಡಾರಲ್ಲ, ಇದು ನಮ್ಮದು ಸೊಸೈಟಿ, ಅದಕ್ಕೆ ಅವ್ರಿಗೆ ಬಿಡೋದಿಲ್ಲ. ಸೀನಿಯರ್ ಮೋಸ್ಟ್ ನಮ್ದು ಇವ್ರ ವಿಜಯೇಶ್ವರ ಶೆಟ್ಟಿ ಮೇಡಮ್ ಬಿಡೋದಿಲ್ಲ. ನಾವು ಇಲ್ಲಿ 3 ಮಂದಿದಾಯ್ತು. ಆ್ಯಸ್ ಎ ಪ್ರೆಸಿಡೆಂಟ್ ನನಗಲ್ಲ ಪ್ರೆಸಿಡೆಂಟ್ ಆರ್ಗನೈಸಿಂಗ್ ಪ್ರೆಸಿಡೆಂಟ್ ಇರಬೇಕಾಗಿತ್ತು, ಇದು 3 ಮಂದಿ. ನೆಕ್ಸ್ಟ್ ಸೀನಿಯರ್ ಮೋಸ್ಟ್ ಮತ್ತು ಪ್ರಕಾಶ್ ಕೋರರ್ ಸರ್ ಮತ್ತು ಇವ್ರ ಲಲಿತಮ್ಮ ಮೇಡಮ್ ಮತ್ತು ಈಗ ಪ್ರೆಸಿಡೆಂಟ್ ಇಲೆಕ್ಟ್ ಆಲ್ರೆಡಿ ಡಿಕ್ಲೇರ್ಡ್ ವಿ ಹ್ಯಾವ್, ಅವ್ರಿಗೆ ಕೋ ಚೇರ್ಪರ್ಸನ್ ಇಲ್ಲಿ 3 ಮಂದಿ. ಅಡ್ವೈಸರ್ ಇದ್ರೊಳಗೆ ಮತ್ತು 3 ಮಂದಿ ಅದಾರ. ಮೇಡಮ್ ಇಲ್ಲಿ ಇರ್ತಿರ್ಲಿಲ್ಲ, ಅದಕ್ಕೆ ಅವ್ರ ಅಡ್ವೈಸರ್ ವಿಜಯ ಪಾಟೀಲ್ ಮೇಡಮ್ಗೆ ಅಡ್ವೈಸರ್ ಒಳಗೆ ಹಾಕಿದ್ವಿ. ಆಶಾ ಮೇಡಮ್ಮ ಮತ್ತು ಸರಿತಾ ಕಾಮ್ತಿಗರ್ ಪ್ರತಿಯೊಂದು ಇದ್ರೊಳಗೆ 3 ಮಂದಿನೇ ಇದ್ದಾರೆ. ಅದು ತ್ರಿಮೂರ್ತಿದ. ಮತ್ತು ನಮ್ದು ಇದಕ್ಕೂ ಗೆಸ್ಟ್ ಆಗಿನೂ ಬಂದರು ಪೊಲಿಟಿಷಿಯನ್, ಅವರು 3 ಮಂದಿನೇ. 4 ಮಂದಿ ಕರೆದ್ರು ಮತ್ತು ಅದು 1 ಮಿಸ್ ಆಯ್ತು, ಮತ್ತು 3 ಮಂದಿನೇ ಬಂದಾರ ನೋಡ್ರಿ. ಅಂದ್ರೆ ದಟ್ ಈಸ್ ದ ಡಿವೈನ್ ಪ್ಲಾನ್. ಬಹುಶಃ ಅವ್ರು ಶರಣ ಪ್ರಕಾಶ್ ನಾವು ಅವ್ರ ಮೆಸೇಜ್ಗೂ ಕರಿತಿದ್ದು, ಅವ್ರಿಬ್ರು ಕೂಡಿ ಇನ್ನೂ ಒಂದು ಒಕೇಶನ್ ಆಗೋದು ಇರ್ಬೋದು. ಅದಕ್ಕೆ ಅದು ಹಿಂಗೆ ಇದು ಎಲ್ಲ ಡಿವೈನ್ ಪ್ಲಾನಿಂದಾಗ್ಯದ, ನಾವು ಒಬ್ಬರೇ ಮಾಡಿಲ್ಲ. ಪ್ರತಿಯೊಂದು ಇದರೊಳಗೆ ದೇವ್ರು ಹೊಕ್ಕಿಸಿ ಎಲ್ಲ ಕರೆಕ್ಟಾಗಿ ಮಾಡಿದ್ದೈತಿ. ಅದಕ್ಕೆ ನಾನು ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ತೀನಿ ನಿಮ್ಗೆಲ್ಲರಿಗೂ, ಪ್ರತಿಯೊಬ್ಬರಿಗೂ ಥ್ಯಾಂಕ್ಸು. ಮತ್ತು ಎಲ್ಲ ಫಾರ್ಮಾ ಕಂಪ್ನಿಗಳಿಗೂ ನೀವು ಎದರಂತೆ ನಾವೆಲ್ಲ ಇದು ಮಾಡೋಕ್ಕಾಗೈತಿ. ಫಾರ್ಮಾದ ಏನು ನಮ್ದು ಸಪೋರ್ಟ್ ಸಿಕ್ಕಿದೆ ಅದರಿಂದ ನಾವೆಲ್ಲ ಮಾಡೇವಿ. ಯಾರು ಹಾಸ್ಪಿಟಲ್ಗೆ ಹೋಗಿಲ್ಲ, ಇದಕ್ಕೆ ಹೋಗಿಲ್ಲ, ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಎಲ್ಲೂ ದುಡ್ಡು ಕೇಳಕ್ಕೆ ಹೋಗಿಲ್ಲ. ಇದೆಲ್ಲ ಕೊಟ್ಟಿದ್ದಾಗ ತುಂಬ ಥ್ಯಾಂಕ್ಸ್. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್. ಪೇಪರ್ ಆ್ಯಂಡ್ ಪೋಸ್ಟ್ ಪ್ರೆಸೆಂಟೇಷನ್ನು ಮೀನಲ್ ಮೇಡಮ್, ಕಲಾವತಿ ಮೇಡಮ್ ಇಷ್ಟು ಚೆಂದಾಗೆ ಕಂಡಕ್ಟ್ ಮಾಡಾರಲ್ಲ. ಪ್ರತಿಭಾ ಆ್ಯಂಡ್ ಆಲ್ ದೇ ಹ್ಯಾವ್ ಸಪೋರ್ಟೆಡ್. ವಿನಾಯಕ್ ಜಾಂತೆ, ನಮಗೆ ವಿನಾಯಕ್ ಜಾಂತೆ ಪ್ರಮೋದ್ ಅಂತ ಅದು ರೈಟ್ ಹ್ಯಾಂಡ್ ಲೆಫ್ಟ್ ಹ್ಯಾಂಡ್ ಇದ್ದಂಗೆ ಅವರಿಬ್ಬರೇ ನಮ್ದು ಹುಡುಗರು ಇದ್ದದಕ್ಕೆ ಇದನ್ನು ಸಾಧ್ಯ ಆಗ್ಯದ. 3ನೇದವ್ರು ಅಂದ್ರೆ ಈಗ ಸಂದೀಪ್, ಇವ್ರು 3 ಜನ ಚೆನ್ನಾಗಿ ಇದರಲ್ಲಿ ಪಾರ್ಟಿಸಿಪೇಟ್ ಮಾಡಿದರು. ಆಮೇಲೆ ಇದು ಸ್ಟೇಜ್ ತೊಗೊಂಡಿದ್ದು ಶಿಲ್ಪಾ, ಜ್ಯೋತಿ, ಪ್ರಾಚಿ ಆ್ಯಂಡ್ ಮಯೂರಿ. ಎಷ್ಟು ಚಂದ ತೊಗೊಂಡು ಹೋಗ್ಯಾರ ಅವರು. ಆ ಕನ್ನಡ ವರ್ಡಿಂಗ್ಸ್ ಅದು ಎಲ್ಲರದು ಮನ ಮುಟ್ಟಿದಂಗೆ, ಅದು ವಚನದ ಅದು ಎಲಾಬ್ರೇಟ್ ಮಾಡಿ ಇದು ಮಾಡಿ ಅದು ಟಚಿಂಗ್. ನೀವೊಂದು ಎಲ್ಲ ಯೂಟ್ಯೂಬ್ ನಾವು ಮಾಡಿದ್ದೀವಿ. ಆಮೇಲೆ ಇದನ್ನು ಭಾಳ ಚಲೋ ಇದು ಆಗಿದೆ. ನಮ್ಮ ಸಾಂಗ್ಲಿದ ಟೀಮ್ನು ಭಾಳ ಚಲೋ ಮಾಡಿದ್ದಾರೆ. ಅದಕ್ಕೆ ಚಲೋ ಸೆಲೆಕ್ಟ್ ಮಾಡಿರಿ, ಭಾಳ ಚಂದ ಮಾಡಿರಿ. ಅದು ಮನ ಮುಟ್ಟಿಸಂಗಾಗೈತಿ. ನೀವು ಅದು ಎಲ್ಲ ನಾವು ಇದು ಲಿಂಕ್ ಕೊಟ್ಟಿದ್ದೈತಿ, ನೀವು ಎಲ್ಲ ಒಂದು ಸತಿ ಕುಂತು ನೋಡ್ರಿ. ಇದು ಲೈಫ್ ಲಾಂಗ್ ಮೆಮೊರೇಬಲ್ ಐತಿ. ನಮಗೆ ನೋಡಿದ್ರೆ ನಾವು ಹಿಂಗೆ ಮಾಡವೇನಂತ ಆಶ್ಚರ್ಯ ಅನ್ನಿಸ್ತದೆ. ಖರೇನು ಭಾಳ ಚಂದ ನಡೆಸ್ಕೊಂಡು ಹೋದ್ರಿ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್. ಆಮೇಲೆ ಮಹೇಶ್ ಆ್ಯಂಡ್ ಇಬ್ಬರು ದಂಪತಿಗಳು, ಮಹೇಶ್ ಆ್ಯಂಡ್ ಹೀರಲ್, ನಿಮ್ಮದು ಸಪೋರ್ಟ್, ಭಾಲ್ಕಿ ಟೀಮ್ ಸಪೋರ್ಟ್, ಎಲ್ಲರದ್ದು ನಾವು ಒಬ್ಬೊಬ್ಬರದ್ದು ಹೆಂಗೆ ಹೇಳಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ ಅಷ್ಟು ನಿಮ್ದೆಲ್ಲ ಸಪೋರ್ಟ್ ಐತಿ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
Thank you so much, ma'am. I think you spoke your heart out today. And madam has taken each and everyone's name. She will never leave behind anyone. This is a quality of the leader. We are falling short of time, so we will move further with the felicitation program conducted by Savita ma'am.
Thank you, Dr. Sangeeta. I would like to thank all the delegates and all the dignitaries on the dais. Felicitation is a way of expressing gratitude towards the person who has done for us. So this is the stage and the platform where we are showing our gratitude to all the people who have supported us. To begin with, I thank Dr. Durgadas sir, President Ksoga, for giving us this opportunity for hosting the zonal conference at Bidar. I thank Dr. M.G. Hiramat sir, Dr. Nagraj sir, who has also motivated us to take this conference. I thank Dr. Rajeshri Paladi ma'am and Dr. Sanjana Patil ma'am who was very keen in giving us this zonal conference. A big round of applause. Without their support, we wouldn't have got this conference at Bidar. Thank you so much, ma'am. I thank Dr. Shobha Gudi ma'am, Dr. Shobha Bembalgi ma'am, Dr. Vidya Tobi ma'am, Dr. Ashalata ma'am, and Dr. Bellet sir for also coming and gracing the occasion and making this event a grand success. I thank our director sir, MS sir, Dr. Shivoge Bali, Dr. Ahmaduddin sir, Dr. Rajesh Para sir for helping us out to do the things at this venue at BRIMS Bidar. To begin with, the felicitation, I request all the dignitaries being seated there to felicitate the person who has done all these things for us, that is our event manager, whom we have named him here right now. We extend our deepest gratitude to him, whose steady dedication, sharp eye for detail, and tireless efforts played a pivotal role in the success of this conference. From planning every session with precision to handling the smallest of the logistics with grace, he was behind the scene, working hard, tirelessly, nights together, and executing this event. I request Mr. Ajay Mane to come onto the dais and accept this token of gratitude as an event manager for doing it as for us. I request Dr. Sharda Gudge and all the dignitaries on the dais to please felicitate Mr. Ajay Mane. Thank you all the dignitaries. Thank you Ajay for doing it as for this event. You have really done a very good job in our venue and also in the gala dinner. Thank you so much, or else we had to stand here day and night working for this. Thank you so much. Yeah. I now request the voice of mine would be heard to your ears only by this team, that is the audio visual. They have been here since past 5 days working day and night, arranging each bit of this conference, the lights, the voice, the music, everything is meticulously done. I request Praveen and his team, also sir, Pramod sir, to please come out of the dais and accept this token of gratitude for your very, very great work. Thank you so much, sir. I request the dignitaries to please felicitate our all supporters with due respect and gratitude. His sharp vision from Sangli, Shri Pramod and Praveen and team. Thank you so much, sir. The sharp vision, responsible for audio vision. Our beautiful movements will be captured forever and ever, and this could have been happen only by the Rishi Films. I request the representative from Rishi Films to please come on, Rishi Photography, to please come on to the dais. Please do come on to the dais. KGF photographer is helping us for this. Thank you so much, sir. That shows the team spirit and not competition. Thank you so much, Rishi Films. Very beautifully picturized in front of the screen. Thank you. I now request the most exciting stall from where we started our journey, who captured all our moments with beautiful saris, with all makeups, with all lipsticks, with all smiles, with all groups, and with all, selfies, with all single photos. And that is none other than Syscon Pharma. I request Mr. Santosh and Manjuna Shetty, CAES head, to please come on to the dais. A big round of applause. They have magnificently supported us in making this event, and very wholeheartedly they have come to support us. Thank you so much, sir. I request all the team members to please come. I request all the team members of Sysca Pharma to please come onto the dais. This is the effort of the team, the mind of all the others who have helped us in supporting this. Thank you so much, Sysca Pharma. A photo session, please, Sysca Pharma, please. Shailaja ma'am. Without you, this wouldn't have happened. Please come. She's here, ma'am. Madam, welcome. Yes, yes. The next, who has been taking care of our refreshments when we had a headache or we had a sleep, they made us a rose. That is none other than Aristo Pharma. Kept on 24 hours, 24 into 7 like that, with a chai, coffee, biscuits. I request Aristo team, Mr. Sandeep and Mr. Ramesh, on to the dais. Sir, thank you so much. Thank you all. Thank you. Please do come. Thank you. Thank you. Thank you so much. Aristo Pharma, the in charge of our chai, coffee, refreshments. A big thanks to them. I request the dignitaries to please felicitate them with a token of warm welcome and a token of respect to the team. The next pharma which I would like to call is the Healthier Meditech Limited, Suture India, Mr. Devendra J. from Gulbarga and Mr. Sachin Kulkarni, on to the dais. You have taught us so many skills on table only, so it was a very nice skill experience for the postgraduate. Thank you so much, Healthium. Yes, Devendra is here. Thank you, Devendra. The next one, the Amsters. They are the person who are ready to sponsor anything. Whatever you say, yes ma'am. Whatever you say, yes ma'am. I really thank you. You added colors to the hands of all the participants. Thank you so much. Thank you. You also did all the ups and downs, pick and drops. Thank you so much, Amster and Pharma. I request all the team members to please come onto the dais and accept this token of gratitude. Digambar, Mr. Digambar, Mr. Praveen Kumar Kote, please do come to the dais. Dinesh Pharma, who helped us in leaving Ajay for working for us, is none other than Mayors. I request Umesh Chauhan, Ravi Kumar and Ajay Mane to please come onto the dais. I request Dr. Lalitama ma'am to please felicitate the Mayor Organics Pharma for helping us out. The next, please do come. I have announced. Be fast. That is why it is. So many of you are having the buses, it seems. So I'll be very fast in this. The next pharma who has helped us is Amor Pharmaceuticals, Dhaneshwar and Praveen Kulkarni. Please come onto the dais and accept this token of appreciation and gratitude. Please, I request all the pharma people or the delegates who have been sitting here to please encourage them, because without their support, we wouldn't have done this event at all. A great support from all these pharma peoples. These words fall short in appreciation for these pharma peoples who have wholeheartedly come forward to support us. Thank you so much. The first person to help us in this event, who readily came forward and supported us and said that, ma'am, you go ahead, we are with you. And that is none other than Sandwich Pharma. Srinivas sir and Anand Kumar sir, please come onto the dais. I request Dr. Sandeep Gaikwad sir to please come onto the dais and please hand over this token of appreciation to Sandwich Pharma. I request please all the pharma peoples to come fast so that we can finish it and you can reach your destination at time. The next pharma companies very near to Dr. Prakash Korwar sir, the Blissons, right from Maharashtra. They have come all over for doing this sponsorship for us and helping us and supporting in all ways. Ashwin Prahlad and Shrikant Jadhav sir to please come onto the dais. I request all the box members to please come onto the dais, because without your support, this wouldn't have happened. It is not the effort of only one doctor, it is the effort of all the box members sitting over there who have been communicating, instrumenting in convincing all these pharma companies. I request the next pharma company, that is Pharmanova, Santosh and Shivkumar sir to please come onto the dais. Mr. Santosh and Mr. Shivkumar to please come onto the dais. I request Santosh and please to come onto the dais. Young people, be fast. The next pharma to help us is TMS India. I request Abdul Mukim and Azimuddin Zahid Hussain, the team TMS India, to come onto the dais. The next pharma company who has stolen our moment by a Bollywood look, and that is none other than Saligenics. I request Baswaraj and Yunus Qazi to please come on to the dais. I request Baswaraj and Yunus Qazi to please come on to the dais. Thank you. I request the pharma company supporters to please be fast so that we can finish it on time. I request the EVO Pharma team to please come onto the dais. The next pharma who has supported us is the MacLeod's Pharmaceuticals, Mahadev, Pratik and Vinay Kumar. Mr. Mahadev, Mr. Pratik and Mr. Vinay Kumar, please come onto the dais. Okay. The next company, Corona Remedies, I request Mahesh, Mr. Balbhim Rao, Mr. Mahantesh to come onto the dais. And Mr. Aravind. Corona Remedies, please be fast. Mr. Mahesh, Mr. Balbhim Rao, Mr. Mahantesh and Mr. Aravind. Please come onto the dais. The next pharma who has helped in accommodating, that is Mr. Ravi Kumar and Mr. Sanjay Swami from Rhombus Pharma. Thank you so much for accommodating our guests. I request the next pharma, Zulivin Life Sciences, Biradar Deepak and Pavar Kumar Kulkarni onto the dais. Please accept our token of appreciation. Thank you. since our whole Bollywood, since our box, Bollywood is coming into my mouth, because all are very beautifully seen here, and I just wanted to say that all of box members who are here, so I would like to call the person who made us dance, who made us go through his voice, that is none other than our choreographer, Mr. Sunil. Mr. Sunil, please come onto the dais. I request all of them to give a big round of applause. Without him, the gala dinner wouldn't have been so colorful and lightful. I request Dr. Vinayak Janti, sir, to please give a token of love and appreciation and a gratitude to our choreographer, Mr. Sunil, sir. I request all the box members to please felicitate him. Come forward to felicitate him. Munna Bhai is going to felicitate him. A big round of applause to him. Thank you so much, sir. You made all of us dance. You made that everyone feel that they also can dance and make it very beautiful. Thank you so much. Anybody can dance. The next pharma here to come over the stage is Richfield. I request Mubin to please come onto the dais. Richfield Mubin, sir, to please come onto the dais. When visiting so many stalls, we were so much of this because of this hot summer. We were struggling so much. In between that, we had a small game over there, fishing, and which was a light entertainment. I request the Ma Pharmaceuticals. Oh, they have left already? Okay, done. Anyways, please pass on the message. We have congratulated them. Next to come is the Alembic Pharma, Sai Kiran and Sandeep. Mr. Sai Kiran and Mr. Sandeep, please come onto the dais. Mr. Sai Kiran and Mr. Sandeep. And Vishnu, the person behind this, who made us the picks and drops of the delegates, also was sponsored by them. Thank you so much, Alembic Pharma. I request Marthan Kulkarni sir, Ravi Hegde sir from Torrent. Right, they have already left. Please pass on the message. Thank you so much, and ask them to collect the token of love from us. I next request MCure Pharma, Mr. Kishan Savle and Mr. Sharan Irmani to come onto the dais. I request Microlabs, Mr. Pavit Kumar and Irfan sir to come onto the dais. Pavit has been instrumental in helping us in all the stage activity, and he has been there working for us for 2 days continuously. Thank you so much, Pavit. The next pharma, Eurozen Pharma. I request Chandrakant Izare and Ismail to please come onto the dais. Next pharma, Oni International. I request Oni International Pharma to please come onto the dais. Channabaswa sir from Oni, please come on to the dais. The next pharma to be felicitated is Shimata Pharma. I request Prabhakar Biradar, Pramod Yadav and Nitish to come on to the dais. Rishi Films, I hope please catch the moment, because for them every photo is important, every click is important. Thank you so much, Rishi Films. The next pharma to come on to the dais is Bioremedies, Bajar Shubham and Arif Basha. Please come on to the dais. Rishi Films, please take everyone's photo. Every pharma companies. Bioremedies, Bajar Shubham and Arif Basha. Yes. The next pharma to come on is KO Pharma, Shrikant and Srinivas. Mr. Shrikant and Mr. Srinivas, please come on to the dais.
I request the pharma companies to be very fast so that you can reach your destination in time. The next pharma companies to come on the dais is Serum Institute, Mr. Prakash Kulkarni and Mr. Sadanand, to please come onto the dais. The next pharma company to be felicitated is Zydus. I request Veeresh, Mr. Pramod, Mr. Shashikant and Mr. Kumar Wali to please come onto the dais. I request the pharma people to please be very fast. The next pharma company to be felicitated is Overseas, Mr. Arun Dhage and Mr. Partha to please come on the dais. The next pharma company to be felicitated is Ilka. I request Mr. Rajkumar Chandapure and Dilip Kumar to come on to the dais. The next pharma company to be felicitated is Cadomate Pharma. I request Guru Prasad and Shamappa to please come on to the dais. I now request the BRIM staff who has helped us tirelessly working for us here day and night and making us all the arrangements. Now I call upon Mr. Omkar. I request Mr. Omkar from BRIMS. Can anyone please pass on the message? Mr. Omkar, Mr. Tazuddin, Mr. Omkar, Mr. Tazuddin, Mr. Vijay Kumar, Mr. Rahul, Mr. Sangaya Swami, Mr. Akhilesh. I request all of them to please come onto the dais. Tazuddin, Omkar, Vijay Kumar, Rahul, Sangaya Swami and Akhilesh. They have been... Mallaya Swami, I am sorry. Please come onto the dais. Without you, this venue wouldn't have been so beautiful and clean. Thank you so much for making all the arrangements and responding to our calls. I also request Veeresh and Arun also. Veeresh, Arun from BRIMS. Veeresh and Arun. Veeresh, Arun. Ajay, can you please help Veeresh and Arun? The next pharma to be felicitated is Indikemi, Sunil Kumar and Piyush. Thank you, BRIM staff, for helping us out, for all the venues you've been helping us, for all the functions you're helping us. Thank you so much. Now I request Indikemi, Sunil Kumar and Piyush to come out to the dais. Cadomet people have come. The next pharma to be invited here is the East Coast Healthcare, Sagar. East Coast Healthcare, Sagar, please come onto the dais. Next pharma, Janini Medico Surgical Enterprises, Ashish and Dharmendra Gupta. Ashish and Dharmendra Gupta. Janini Medico Surgical Enterprises. The next pharma to be invited. The next pharma to be invited is the Spectra Vision. The next pharma, Endocare Surgical. Yogesh Bhave, onto the dais, please. The next pharma, Zuventus Healthcare, Nagaya Swami. I request Zuventus Healthcare, Nagaya Swami. Oh, okay, all of them have left. Okay. The next pharma is a Sun Pharma, Mohsin and Ganapati. Mohsin and Ganapati, please come onto the dais. The next pharma, Biomicron, Jagannath Swami and Prabhuling Swami. Prabhu, sorry. We have been calling him Prabhu only, but here someone has written it. The next pharma is Sai Meera. Mohan, are you here? No. Rajesh from Biodesert. Rajesh from Biodesert, please come onto the dais. Reddy Labs, the pharma from the Reddy Labs. Prabhu, are you here? Please come onto the dais. Allen County. Mankind Pharma. Vishnukant, please come onto the dais. Allen County Pharma, anyone is here? Crisco? Right. Have I left anyone? Thank you so much. All these pharma sponsors, thank you for supporting us. I also thank our in-house system engineer, Mr. Sandeep. And now it's time that all our box members to be felicitated for their tremendous work, for executing every minute of their 2 months into this program, making this event a grand success. So we thought that this is a surprise gift from our President, Madam. She decided that she's going to felicitate each one of us with a token of love, appreciation. All are like gold, so she wanted also to give gold. So this gift is for them. I request all the box members to please collect this token from our President, ma'am. Emma, ma'am, can you please help me? Sorry, I'm very sorry. The Alchem Pharma, please come on to the dais. Anyone, if I have left, please apologize. Please come forward. Alchem Pharma. First, oh, ma'am want to speak something. Anyone I have left? Please. Trading. MediPoint Equipments, please come on to the dais. And I sorry, I couldn't take your name here. Anyone from IKSS over here? They are the main pillar of our thing, doing everything for us, right from the badges to the QR codes to the bags, everything they have done for us. Thank you so much, IKSS. I request Dr. Prakash Korwar sir to please hand over. Madam, head. Anyone I have left, please come on to the dais. Any pharma sponsors, if I have left, please come on to the dais. Right. Thank you. Thank you so much. And sir, Don't think that we have forgotten you. You're always in our hearts. Thank you so much. To begin this, I request Prakash Korwar sir, the man behind this vision who made this event come true, to please, yes, ma'am? Yes, ma'am. Thank you, ma'am. Thank you so much. Thank you. Our office bearers wants to leave because they have to reach their home in time. Thank you so much, ma'am. But we just would like to continue with your permission because we want to felicitate our box members. Right. I request Sangeeta to please help me out in doing this. The first person, Dr. Premlata Patil ma'am, please, I request Prakash Korwar sir to please hand over this token of love, appreciation, gratitude with due respect. I request all the members to please give a big round of applause to her. Next, I request Dr. Vijayashree Bashatti madam. I request Prakash Korwar sir to please give on the gifts to our members. Vijayashree Bashatti ma'am. I request next, I request Lalitama ma'am. I request Lalitama ma'am, the beautiful lady who was always ready 24/7 for anything you call, she'll be tip on her toes. I request Prakash Korwar sir, Uma ma'am and Vijay Patil madam to please hand over the token of love and appreciation to her. Thank you so much, ma'am. I request Uma ma'am to please give the token of love and appreciation to Vijaya Patil ma'am. To Vijaya Patil ma'am. I request Prakash Korwar sir and Uma madam to please hand over the token of love and appreciation to Dr. Rajalakshmi Chanda ma'am. I now request Dr. Sarita madam to please come on to the dais. And now I request Meenal madam to come on to the dais and please I request Hema ma'am to please come on to the dais. I request Dr. Sangeeta. To please accept this token of appreciation and love for supporting us constantly, helping us out in doing BRIMS workshop efficiently. I request Dr. Jyotsna. I request Dr. Jyotsna, the lady behind this mind, this all event, this all brochure, this all sign classes. She has done an excellent job. Thank you, Jyotsna. Next to be felicitated is Dr. Shilpa. I request Dr. Shilpa. She is with us. The beautiful, tall, young lady, slim, trim lady who has been working on this day and night. Very efficiently, she has carried out the anchoring. Thank you so much, Dr. Shilpa. Now the lady doctor, though far apart from us, staying in Bhalki, but her vision, her support constantly with us. I request Dr. Shailaja Talwade ma'am to please come on and accept this love of appreciation from our side. A huge round of applause from her to her, because it is because of her support also for getting this all sponsored for us. I request please encourage our participants with your clap so that they'll be motivated. Now, I request Dr. Sharda Gudge ma'am, the lady who is ready to do the job instantly. At any moment she is responding the calls. Take it anything, logistics, gifts, anything you tell, she is ready. She is the excellent performer she has done in this conference. Thank you, Dr. Sharda Gudge ma'am. You have done the job very, very efficiently. I request Dr. Mahesh Chanshetty sir. On behalf of him, I request Hiral madam to accept 2 gifts, yours and Mahesh sir. I request Prakash sir and Uma madam to please give 2 gifts to Hiral madam, one for her, one for Mahesh sir. I request Lalitama madam to please do the honor. I now request Dr. Pratibha Patil madam. Dr. Pratibha Patil madam to please come and accept this token of appreciation. The lady behind quizzing. She is always behind quizzing, asking so many questions. Efficiently she has done her job. Thank you so much, Pratibha. I request the next beautiful girl, 24/7, working day and night, comparing for 2 days continuously. I request Jyoti Nimbur, Dr. Jyoti Nimbur ma'am, the beautiful girl who has done her job very efficiently along with Dr. Shilpa. Both of you kept us awake all the time. The moment the session ends, we were waiting for your talk to listen. What next Vachana they are going to tell us. The next young dynamic lady, she has done her poster, paper, she has won also. I don't know whether it is a match fixing or what, but still, I would like to appreciate her vigor of doing it. Dr. Rameshwari, where is she? Again she is fixing? No, it was a joke, don't take it seriously. She has done it very beautifully, her presentations. Rameshwari, the young lady who has been instrumental in doing all these paper posters, communicating with all the interns and volunteers. I now request Dr. Aarti Raghu ma'am. Is she here with us? Yes. I now request Dr. Pallavi ma'am, the lady behind the scientific sessions, who has been instrumental in getting all these speakers, sending all the mails, receiving them, responding to them. Thank you, Dr. Pallavi. Now I request our Munna Bhai, Dr. Vinayak Janti, to please come onto the dais. A huge round of applause. He has been helping us in all the events which has been happening here. Pramod is here. Pramod is here. I request now Dr. Prachi is here. Prachi is not there. Sir will be taking her gift. Dr. Prachi and Dr. Mayuri have tirelessly been supporting to our audio-visual team. They have been doing a nice comparing. A huge, bigger round of applause to both of them. Though young girls, but they have done it very efficiently. Ma'am, could you please hand over the gift to sir only? ಕೊಡ್ತೀವಿ ಸರ್ ಮನ್ಗೆ ನಿಮ್ಗೆ ಇಬ್ಬರಿಗೂ ಕೊಡ್ತೀವಿ. Anjali Kamtikar madam is here. Rashri Biradar ma'am. I now request Dr. Sumaya ma'am, who has been very instrumental in carrying out the workshop. She has been doing it very nicely. She has seen doing all the works at the OT. Thank you so much, ma'am. And your way of anchoring was also too good. Thank you so much. Hope you'll host the next conference. Dr. Sujata Harkod is here. Dr. Bhuvaneshwari. I request Dr. Bhuvaneshwari. I request Lalitama madam and Meenal madam to please felicitate Dr. Bhuvaneshwari. Rishi Films, please catch every moment. I request Sujata Harkod ma'am. Yes, she has been helping us and she got so many registration done for us from Humnabad. A big round of applause to her. Thank you so much ma'am, you helped the registration team. I request Dr. Jayashree ma'am, Dr. Rajalakshmi Chanda ma'am, Dr. Sheila Wagmare ma'am. They are not there, but our love, appreciation are there with them. I now request Dr. Suman Balki ma'am, the beautiful lady here, onto the stage for helping us out in accommodation and picks and drops of the delegates. Thank you so much ma'am. To do this honor, I request Dr. Sarita ma'am and Dr. Sharda along with Dr. Uma and Dr. Prakash sir to please do the honor. Dr. Sarita ma'am, please. I now request Dr. Sunanda Bacha ma'am. Sunanda Bacha, really you have helped us a lot. You did not allow any phone calls to be diverted to us. You have handled it very efficiently. Thank you so much. Personally, she has given her own vehicle for the delegates. Thank you for such a big-hearted sponsorship. I now request Dr. Sandeep Gayawat sir, the man behind all this accommodation, tours and travels, his plan, his execution, his messages excellently done. Thank you so much sir. A big round of applause to sir. All the girls, beautiful girls, please cheer him up. Dr. Diksha is here. I now request Dr. Kalavati Biradar ma'am, the lady who has been very much instrumental in getting conducted all the paper poster presentations. Yes, yes. I request Dr. Madhumati ma'am. Madhumati ma'am? No. Dr. Swati Talwade. Please accept this gratitude from our side for Dr. Swati. Still coming, ma'am. I'm coming by committee wise. Please bear with me. Dr. Prerna, Dr. Mayuri. Right. I now request Dr. Preeti Biradar. Dr. Preeti Biradar. Yes, the lady who made us full of satiety and all. Thank you so much. The food was very deliciously arranged. Along with Prakash Korwar sir, you have done a great job. Thank you so much, Dr. Preeti. Dr. Supriya Sulega ma'am, please come out of the dais and accept this token of appreciation. Dr. Vijay Sagar, Dr. Shiv Shankar Lasune sir, Dr. Vijay Sagar. Now, the doctors who made so many delegates come to Bidar city, none other than Dr. Vaishali Jadhav and Dr. Kavita Patil. Please come on to the dais. Dr. Vaishali Jadhav, Dr. Kavita Patil, thank you so much for getting the registrations done. A huge number. Thank you for your effort. Thank you so much. I request all the dignitaries, Meenal ma'am, Sarita ma'am, Lalitama ma'am, please go and felicitate. Ma'am. request Uma Madam to please felicitate Subhaya Ma'am. Sharda Madam, please felicitate Sumaya Ma'am. She is from Humnabad. Thank you so much, ma'am. Now I request Premlata Ma'am, Vijayashri Bhattacharya Ma'am to please felicitate Dr. Prakash Korwar Sir, the man who of the match of today's event. Give him a big round of applause. No words to explain your involvement in pharmas, in sport and all. Thank you so much. I request all the box members to please come here for the photo session with the sir. Request all the people to please assemble here near sir. I request Uma Madam to please felicitate Dr. Supriya Ma'am, Supriya Patil Ma'am from Bhalki. I request Uma Ma'am. If any of the box members, if I have left, please come forward. By any chance, if I have left anyone, please come forward. Let me bring it to my notice. Now, I request all the box members to felicitate the lady.
Now, it's a time to felicitate the most colorful, the most vibrant, the most base for all our buildings, the heartthrob of all our activities. Guess who? Guess who? Dr. Savita Padige, Bollywood queen of our box.
It's really great to honor both our president and secretary together. We have a very best combination of president and secretary. It was powerful combination, dynamic, energetic. Both together they had a synergistic effect.
Hip hip hooray! Om Shanti Om.
I just want to say that it is the dream of our Uma ma'am. Some 2 years back, she said that we will bring Ksoga here, and it is her dream that has come true today. Thank you so much, Uma ma'am. You are the lady of a distant vision who made everything possible here. Thank you, Uma ma'am. A big round of applause to her for her magnificent execution of the work. Very commendable job. Everyone appreciated your involvement. And I sincerely apologize any of the box members if we have hurted knowingly, unknowingly during our sessions of meetings, during our sessions of any discussions. And I apologize all of them. No hard thoughts. This is only for the good work to come out so that the team will be seen with a colorful and lightful. So I thank all the box members for supporting Uma ma'am and her team for making this a grand success. I request Uma ma'am and all the box members to please give this token of appreciation to our Shanta Durge ma'am. She is being the national figure now. So before she is winning, we are declaring that she will be our national figure at Foxy. So we wholeheartedly wish you for that, ma'am. Thank you so much. You have been here till this time supporting us and our feelings. Thank you so much, Shanta Durge ma'am. And last not but the least, our volunteers, our interns, our PGs, our students, thank you Sandeep, our students who have helped us in doing all this groundwork. So a big round of applause to all our volunteers. We will give you the gift later after 1 week. Sorry, huh? Thank you so much. Thank you all. Yeah, there is a small refreshment at the end. Sandeep has arranged. Again, he is taking care of us in spite of being felicitated. Thank you so much. Pramod sir, thank you so much. You made our voice very clear. Thank you. Right.
I take this opportunity to thank Dr. Uma ma'am. Because of her, I could exhibit my artwork today, and that was called Madness by my husband, because I have done so much of artwork and just hidden it in my house and never exhibited or shown it to anyone. And I am overwhelmed. Uma ma'am, I'm overwhelmed, thankful to you, because of all the compliments I got today. I'm motivated to do more madness, and thanks for realizing what I'm doing and making me shine today for my artwork. And thank you, thanks. I thank all the box members for appreciating it and giving a new lease of my life to my artwork. Thank you.